Welcome back. Welcome to day two of Low Carb All Stars 2021. We hope you've had a great day one, and we can't wait to get stuck into day two. Now we're starting. Paul, you've pulled off the recruiting coup of the year. You've got the man himself, the type 1 diabetes solution man, Richard Bernstein, to speak. I can't wait to hear it.
Well, this guy's got a fantastic story. So what a lot of people don't realize is that having type 1 diabetes on average can shorten the lifespan by about 20 years. And the doctor who's about to speak to you is currently 83 years old. He's been a type 1 diabetic since he was a very, very young man. And he actually became a medical doctor after he figured out how to manage his own type 1 diabetes, and he wanted to share it with other people, and the doctors he was speaking to simply weren't listening. So he simply became a doctor himself. It's an amazing story, and it's an amazing privilege to have him present. So let's hear what he's got to say.
Hi, this is Dr. Richard Bernstein, proprietor of Dr. Bernstein's Diabetes University. You can see our free videos on the World Wide Web, also called the Internet, through your search engine or by going to YouTube. I'm going to talk today about 19 important facts that your doctor probably does not know. The first one relates to target blood sugars for type 1 diabetics. The American Diabetes Association currently recommends that type 1 diabetics keep their blood sugars in a range from 70 milligrams per deciliter to 180 milligrams per deciliter 70% of the time. And they can go beyond this range 30% of the time. Well, that means that they're recommending a diabetic can have a blood sugar of 179, which about 70% of the time, and go about that, above that or below it, much below 70 the rest of the time. Now, a normal blood sugar for an adult is about 83 milligrams per deciliter, which most doctors do not realize. And normal blood sugars for kids, preteens and early teens would be 65 to 75 milligrams per deciliter, based upon the blood sugars of slim, non-diabetic children from families that do not have diabetes. Item number 2 on our list, glucose is toxic to beta cells. I neglected to mention in number 1 that with such high blood sugars recommended by the American Diabetes Association, these type 1 diabetics are certain to get long-term complications of diabetes. And this has been shown over and over. Glucose is toxic to beta cells. Doctors are frequently recommending to newly diagnosed diabetics that, especially those that require insulin, type 1 diabetics, they tell them if their blood sugars are reasonably mild or fitting the ADA guidelines, you don't need insulin until you burn out all your beta cells. So let's just burn out your beta cells, and when they're all gone, we'll prescribe insulin. Now, it happens that it's a lot easier to keep blood sugars normal if you're making insulin. And over the years, I've seen many diabetics, including one I've been treating since 1985, who we gave normal blood sugars to with the help of diet and multiple insulin doses. And with the normal blood sugars, more beta cells did not get burned out. The doctors call this a honeymoon period when they are still making insulin, and we preserve the honeymoon period. But by advocating high blood sugars and withholding insulin until all the beta cells are destroyed is just the opposite of what you should be doing. You should be bending over backwards to preserve beta cells, because it's so much easier to treat your diabetes, to keep your blood sugars normal if you're making insulin. So I covered our third topic is that we can prolong the honeymoon period. The fourth, the long-term complications of diabetes are not a coin toss, as is advocated by many doctors. Especially some endocrinologists tell their patients that it's just a coin toss whether you're going to go blind or get kidney disease or have an early heart attack. They don't tell the patient that the complications of diabetes are related to a product of blood sugar times time. The longer you have, the more years you have high blood sugars, the more likely you're going to develop the long-term complications of diabetes. So that's a fiction, that it's just a matter of chance. The next fact, number 5, that many doctors are not aware of, is that starting after about 3 months of pregnancy, that's called the first trimester, possibly even earlier, blood sugars in normal non-diabetic women tend to be lower than the non-pregnancy blood sugars, typically around 65 milligram per deciliter versus the, let's say, 83 milligram per deciliter in non-obese, non-overeating, non-diabetic women. So it should be a guide to diabetic women to match the blood sugars of non-diabetic women. And of course, not have severe hypoglycemia. Again, helps would be my book, Diabetes Solution, and also watching the videos in Dr. Bernstein's Diabetes University. But blood sugar should be as close to those of non-diabetic women as possible, and that's in the vicinity of 65 milligrams per deciliter once pregnancy has really gone underway. Another myth that has been perpetuated for years by the American Diabetes Association is that there is subcutaneous fat on the anterior or front of your thighs and on the side of your thighs. And they, for years, have been publishing pictures of kids giving themselves injections of insulin in their thighs. Well, this would be okay if you want to give an intramuscular shot, which will make the insulin work much faster. But the ADA is recommending this for all insulins, and the long-acting insulins you want to last as long as possible, not be sped up and made as rapidly as possible. So you certainly should not inject long-acting insulin into your thighs. And if you're having low-carbohydrate meals, you certainly should not be injecting your mealtime insulin into your thighs, because the insulin will work faster than the food. So yet another myth. Number 7, gastroparesis, which is a paralysis of the stomach and digestive system, which, by the way, can be mild to severe in diabetes, is almost universal in long-standing diabetes, whether it's type 1 or type 2. And doctors don't realize this. When they're attempting to control blood sugars, especially with the help of insulin and diet, they don't take into account the fact that this particular patient may have gastroparesis. Mild cases will just show low blood sugars after some meals and higher blood sugars many hours later when the food's finally digested. In severe gastroparesis, which is quite rare, the patient may be vomiting all day long. I call that end-stage gastroparesis. The next lack of information has to do with how do you diagnose gastroparesis. The conventional wisdom is to have the patient take a gastric emptying study where they swallow a meal, usually it's eggs, spiked with a radioactive substance. It used to be technetium, I don't know what they're currently using, and a gamma ray image is taken of the stomach and digestive system every half hour or so to see how far this radioactive meal has moved in the GI tract. Now, it happens that gastroparesis, the hallmark of gastroparesis, is its unpredictability. One day you may have normal stomach emptying, another day it may be at a standstill. And this is, the milder the gastroparesis, the more intermittent or uncertain it is. In my experience with patients who were given gastric emptying studies in the days when it was experimental and the investigator got funded by the government to do multiple studies on the same person, we typically would have to do 4 studies before we got one abnormal one, even though the blood sugar data showed that the patient had gastroparesis. I eventually went to a more reliable study, which is called the RR interval study, which is a test for autonomic neuropathy in general and measures changes in the heart rate with deep breathing. And this variation of heart rate can be impaired if you have autonomic neuropathy, as can gastroparesis. So this is a natural test for gastroparesis, but the powers that be are not recommending it. The gastroenterologists who know about it don't even talk about it, and most gastroenterologists don't even know about it. The fact that should be obvious but isn't, that carbohydrate is not the only dietary element that raises blood sugar. Here we have many type 1 diabetics being told to base their mealtime insulin dose on the amount of carbohydrate they're eating and ignore all the other elements of the meal. With the net result, of course, that most type 1 diabetics do not have consistent or normal blood sugars after meals. The reason that carbohydrate is not the only element that affects blood sugar, main reason, is the production of hormones by the intestines whenever you eat a meal. And the elements of a meal that cause the production of these hormones, the most studied one is called GLP-1. The elements that affect the secretion of GLP-1 are carbohydrate, fat, protein, and bulk. The bigger the size of the meal, no matter what it's made of, the more GLP-1 you're going to produce. And GLP-1 has a variety of effects upon blood sugar. So if you took a non-diabetic and had him eat a handful of pebbles, he would make enough insulin to offset some of the effects of the GLP-1 that his blood sugar wouldn't go up. But you take a diabetic who cannot make insulin and feed him a handful of pebbles, just the distension of the digestive tract from the pebbles will raise his blood sugar. Number 8. Weight loss ketosis, which is similar to fasting ketosis, is not diabetic ketoacidosis. We have the confusion that permeates the medical profession probably came about with Dr. Robert Atkins many years ago, I believe back in the late 60s, maybe even late 50s, where he was telling people who were on low carbohydrate diets to test their urine for ketones to see if they're losing weight, see if they're digesting fat. Ketones are a byproduct of the digestion of fat. And if you're metabolizing your body fat, you're going to make ketones. Well, he got into trouble with the rest of the medical profession because they thought that fasting or dietary weight loss ketosis was equivalent to diabetic ketoacidosis, which it wasn't. And if I had been Atkins, I would have told people to have a scale and see if they're losing weight, not to test their urine for ketones. So that started a wave of terror if you ever had ketones in your urine. And of course, when people are not eating overnight, many people, when they wake up in the morning, have ketones in their urine. When there's a famine, you're certainly going to have ketones in your urine if you're not eating, and that is not diabetic ketoacidosis. It's a way by which humans survived famine because the brain can live off of ketones, and that's how they kept their brains alive in the old days when there were frequent famines. Number 9, humans need protein. There are many people taking diets, especially those who like the ketone diets, because they think that it's going to be more healthy. And in order to have show ketones in your blood or your urine, you have to be metabolizing a lot of fat to show the high ketones many of these people want. And to do that, you not only have to cut way back or eliminate carbohydrate, which gets metabolized at first before the fat, but you also have to eliminate protein, because protein can get converted to carbohydrate by the liver if there's not enough glucose around. So these people are being deprived of protein in order to raise the ketones in the urine, and they need protein for many functions of the body. Many hormones are called peptide hormones, which means chains of amino acids, and the amino acids are derived from proteins, which are made of amino acids. There's muscle mass, which will deteriorate. That's made of protein. So there are many substances that are probably protein neurotransmitters. So the body needs protein. And if you're going to put them on a diet that really shows a lot of ketones in the urine, you're likely to be depriving them of proteins. And indeed, many of these people who have come to see me as patients, when in spite of their low carbohydrate diet, they still had high blood sugars. They were following these keto diets, not getting enough protein, and they were in pretty sad shape. The next item on our list is the dawn phenomenon. The dawn phenomenon is a situation that affects diabetics but not non-diabetics, where they may go to sleep with a normal blood sugar and wake up in the morning with an elevated blood sugar. Or at their usual wake-up time, their blood sugar is okay, but an hour or two later, it may have gone up even though they did not eat any breakfast. Now, doctors, especially endocrinologists, have invented all kinds of explanations for why this occurs. And all of the explanations but one are fantasies. The one true explanation I have never heard from a physician or seen on the internet. And how do I know about it? Because I've been reading the scientific literature since I got out of medical school, which was in 1983. And back around 1985, a study was done of the dawn phenomenon. And they did it on diabetics. And whoever thought of the study was I don't remember who it was a pretty smart person. He speculated that because people make growth hormone in the middle of the night, that maybe the growth hormone had to do with the dawn phenomenon. And what they did was they measured the clearance of insulin in the bloodstream on awakening in the morning on patients given anti-growth hormone, somatostatin, that prevents the pituitary from making growth hormone. And they also had the same patients on other days not receive the somatostatin. And when they received the somatostatin, these were diabetics, when they received the somatostatin, their blood sugar went up in the morning. When they didn't receive it, their blood sugar, when they received the somatostatin, their blood sugars did not go up. And when they did not receive the somatostatin, their blood sugars went up. So they proved conclusively that growth hormone is the culprit in overnight blood sugar rise. And what they found was that even people who are not growing, mature adults, make a peak of growth hormone about 3 hours after they go to sleep. And that growth hormone causes the liver to have metabolic changes that take maybe 4 or 5 hours to occur, where the liver is clearing away insulin. Now, in a non-diabetic can make at least 3 times as much insulin as they'll ever need. Diabetics, however, have injected their long-acting insulin at bedtime, and it's being trickled into their bloodstream in small amounts overnight. And as this slow insulin infusion occurs in the early morning, the liver is able to clear most of it away so that blood sugars go up. Next has to do with insulin pens. If you are using an insulin pen, it would be wise to take a feel for your injection site after you give a shot. You give the shot and pull the needle out, wipe the site with your hand, and you'll feel that it's wet. Sometimes, if you look at the tip of the needle from the pen after the injection, you'll see a drop on the needle. The pens cause leakage from the injection site. It probably has to do with the fact that you're transmitting the pressure of your finger through a secondary system that reduces the velocity of the insulin outflow. If you were to take a syringe with insulin in it and push it hard with your finger, you might squirt the insulin several feet. Whereas if you do it with a pen, you might get it to squirt 2 or 3 inches. It's not coming out with enough velocity to remain under the skin, and it's too close to the surface and it leaks out. You can try the experiment I just mentioned and you'll see that it's valid. What I found is that smaller doses are more likely to leak than larger doses. But I should say will leak a greater percent than larger doses. Another fact that doctors don't know is the half-life of insulin in your bloodstream. You might ask your doctor, if he were to inject insulin into your vein, how long would it be detectable in your blood? And there'll be speculation because they have no idea. And the real truth, which has been studied and reported, but doctors don't read the research literature, is that insulin has a half-life in the blood of 6.5 minutes. So if you inject 10 units into a vein, in 6.5 minutes, there will be only 5 units detectable in the blood. And in 5 half-lives, there'll be none detectable in the blood. Now, what actually happens is perhaps 10% of the injected insulin finds receptors on cells throughout the body on which the insulin acts and binds to the receptors early on. And it takes a while, once insulin has hit a receptor, for the insulin to do its job, which is to bring glucose into the cell. So early on, the insulin gets bound, but it takes a long while to have its effect. And in the meanwhile, the concentration in the blood is being cleared away by the liver quite rapidly, half-life 6.5 minutes. The remaining subjects for this little talk are the musculoskeletal complications of diabetes, some of which I'll mention, but there are many, and most doctors are unaware of this. A couple of them I discovered and reported on many years ago, and they all involve glycation of collagen. Collagen is possibly the longest-lived protein in the body. In a 21-year-old non-diabetic healthy person, the collagen in their body probably lasts about 15 years, maybe longer. And if you glycate collagen, the collagen usually appears in connective tissue as fibers. And these fibers are interlocked with one another. They can slide so that a tendon can stretch and contract. But if you glycate the fibers, the glucose that's stuck to the collagen fibers acts as a glue. And when you try to move them, you're going to tear them apart because they've been glued together. And that torn collagen fibers, that tearing causes inflammation, pain, and restriction of range of motion. So the first of these musculoskeletal changes would be frozen shoulder. You'll find that many diabetics have 1 or 2 shoulders that have limited range of motion. They may have trouble putting on a t-shirt, trouble abducting their arm, raising the arm so it points over their head. Most commonly, difficulty on internal rotation. That is, if you stick your hand behind your back, try to touch your spine, and then move your hand as high up your back as possible, the diabetics will not be able to move it very far if they've had diabetes for many years. And it might even be painful when they try to move their hand. When I had this problem, which was before I learned how to control my blood sugars, I could not reach in the back seat of my car to grab something, or I could not, I needed help putting on a t-shirt. A treatment for the frozen shoulder is what's called trigger point massage, where you find these little knots or hard spots of glycated collagen along the upper arm, could go all the way to the neck, and strong massage, perhaps with a electric massaging tool, helps relieve the problem. Many orthopedists are injecting these trigger points with steroids, which will raise the blood sugar for a number of weeks, relieve the pain temporarily, but eventually the situation gets worse. So trigger point massage is the treatment. Next is Dupuytren's contracture, which is a flexion of the fingers of the hand. Usually it starts with the 4th finger. In some people, it's only the 4th finger. In extreme cases, the whole hand acts as a claw hand. There frequently is a lump on the flexor tendon. There are flexor tendons on your fingers, at the base of your fingers, going down the palm, and there could be lumps on the flexor tendon, lumps of glycated collagen. And one treatment that I've used for this is a mixture of collagenase, which is an enzyme that breaks down collagen, and DMSO, which is a solvent that carries the enzyme through the skin into the collagen in the fiber. There are some hand surgeons who actually give collagenase injections, and these may be covered by insurance. The injections are usually very painful, and they have to be given multiple times. So if the collagenase DMSO mixture works, you apply it maybe 4 times a day, and it's not painful, and it's a lot less expensive. But you have to find someone to prescribe the collagenase. Collagenase is a costly product. Next is carpal tunnel syndrome. The there's a band around the wrist that everyone has called the carpal band that protects the nerves and muscles going from the upper arm to the hand, and it protects them from injury. But this band is made of collagen, and it can get glycated, and when it's glycated, it can thicken and can press on the nerves and vessels that pass through this carpal tunnel, and that can give loss of sensation or even pain in the palm of the hand and weakness. So you'll find these people may have a weak grip. One test is to put a piece of paper between the thumb and the first finger or the second finger and have the patient press on the paper, and the doctor pulls it out. And if you have carpal tunnel syndrome, it'll be very easy to pull the paper out. Other people may find it that they're weak when they try to hold a cup of tea or coffee, that it's too heavy to hold. So there are a number of symptoms. There are certain professions that will exacerbate carpal tunnel syndrome, like in the old days was operating a cash register. Now it could be typing on your computer. So if you have high blood sugars and you're typing on the computer, you're subject to possible carpal tunnel syndrome. I never had carpal tunnel syndrome, but I'm certainly fearful of it because you could get it just from typing through your computer. So here's a wrist pad that I use with my computer to keep the pressure off the carpal band, off the carpal band. Next is iliotibial band tensor fascial lata syndrome. The iliotibial band is a strip of connective tissue like tendon that goes from the lateral hip up near the butt down to the knee. And there may be trigger points along the iliotibial band. There may be pain. You may have difficulty walking. Frequently people will have difficulty operating a car with the leg that has the ITB syndrome. Sometimes they'll use the affected leg for the gas pedal and the other leg to step on the brake, where most people use the same leg for both. The iliotibial band is connected to more collagen on the rear part of the hip, so called the tensor fascial lata, and we call it TFL-ITB syndrome because the two are connected, and frequently people have this whole big strip going back from the back of the butt down to the knee. Sometimes they call it sciatica, or the doctor calls it sciatica, but if it doesn't go down to the foot, it does not involve the sciatic nerve, so it's not sciatica. It's ITB TFL. And what I found as a treatment for ITB TFL is vacuum stretching, where we get a little vacuum pump and we have a plexiglass cup connected to the pump. We lubricate the ITB TFL so that you can comfortably move the suction cup along this whole strip, stretching it. And it's uncomfortable with a suction that's actually stretching and breaking glycated collagen, but it works. However, if you continue to have high blood sugars, it's going to come back. So the game plan is to normalize blood for all these things, is to normalize blood sugar and also do the treatment. Last on our list is Peyronie's disease. Peyronie's disease is an abnormality of the erect penis where it points off center. And you may have heard about this in the news if you're old enough, because we had a president of the United States who was involved with a female intern who reported to a reporter that his penis pointed to the side when erect. And when I heard that in the news, I said to myself and to my friends, this guy has diabetes. And sure enough, a few months, or maybe it was a year later, he was hospitalized at a young age for a heart attack, and I believe that he had a coronary artery bypass graft. Now, what would the treatment be? I've never had an opportunity to treat it. I only had one patient with this condition, although it's well described in the literature. It has to do with a collagen band that doesn't go all the way around the penis, that's sort of off center, and it pulls the penis in one direction because because this tight band is pulling. I imagine that the collagenase DMSO treatment might work. I've never tried it, but it certainly would be worth trying. There are many other gems like the ones I've just disclosed. on Dr. Bernstein's Diabetes University. Again, you can find it on the World Wide Web. Use your search engine, Dr. Bernstein's Diabetes University, and you can certainly read my book, Diabetes Solution, which tells how to normalize blood sugar. Thanks for watching.
Well, that was mind-boggling. Really, so much information in one talk. It's hard to know where to start. Although even we could talk for another 5 hours about his all those topics that he talked about. What about some of the practical things he talked about, like management of insulin?
Well, I think that's the key. I mean, a lot of people don't realize that different types of insulin that you can inject have different, speeds of onset and duration of activity. And that the type of blood sugar response that you get when you consume, say, a protein and a fat-rich meal is actually, quite a moderate curve. It's got quite a moderate duration. Whereas with the rapid-acting insulins, when you inject one of those, it's got a very rapid onset, very rapid offset, very short duration, and it's very difficult to actually match the type of blood glucose response you get from a healthy meal with a very, very rapid-acting insulin. And I guess one of the interesting things of that is, one, it's important to make sure you're choosing the right formulation of insulin, especially when you're eating a healthy, low-carbohydrate style diet. And also he talked about the insulin injection site, that if you were to inject it into a muscle, say, rather than the subcutaneous tissue, because the muscle's got a much better blood supply, that insulin is going to have a much more rapid speed of onset, and that's going to make it difficult to control things. So we know when things are moving rapidly, rapid onset, rapid offset, it's much harder to get them to match. So his advice to potentially avoid injecting the longer-acting insulins into muscle tissue seems to make sense.
Absolutely. Now, I was interested in his talk when he talked about gastroparesis. Tell us what you understand by that term.
Well, I mean, it's very interesting because basically this talks about gastric emptying, or the speed of it. So basically how quickly your stomach empties after a meal. So once you consume some food, it ends up in your stomach, and then the stomach will feed it into the intestines, and it doesn't actually get absorbed into the body from the stomach. It gets absorbed from the intestines. So while it's in the stomach, it's not going to be doing much in terms of absorbing glucose from the bloodstream. And we know that the rate of gastric emptying is determined by the function of what we call the parasympathetic nervous system, sympathetic nervous system, what we call the autonomic nervous system. And that if you have nerve damage, which is very, very common in diabetes, then the function of the gut emptying can be impaired. It can be delayed. And what that means is that if I were to eat an apple or something like that, then it would the sugar from that apple would enter our circulation quite rapidly. But in somebody who was a long-term diabetic, the sugar from that apple might actually sit within the stomach for a longer period of time, and then down the track, it finally enters the intestine where it can be absorbed. So you'd see that the impact of a meal on your blood glucose levels would be both delayed and less predictable. And I think this is something that certainly we only had a small amount of education on gastroparesis when I was in medical school. We just talked about, certain medications, what you could take to maybe help it. But we didn't talk about how common it was in diabetes, how you could actually diagnose it using essentially an ECG, as Dr. Bernstein has talked about, and nor what the consequences were for it on blood sugar management. So I think that was absolutely fascinating, and I certainly took a lot away from that.
Yeah, you've certainly got to take that into account when you're looking at your insulin dosages. One other point he made was that it's important to take into consideration not just carbohydrates when you're sorting out your insulin dosages.
Oh, absolutely. It's not just, we all know that carbohydrates are made up of glucose molecules, and that can enter into your circulation after a meal and increase your blood glucose level. But there's also an influence on your blood glucose levels of fat, and especially protein. And certainly if you're a type 1 diabetic, an insulin-dependent diabetic, you have to take into consideration the macronutrients other than carbohydrates when you're dosing your insulin. And I think that's easy to overlook and something that we should always bear in mind.
And finally, because I said we could talk about this for ages, but the dawn phenomenon.
Yes, well, this is interesting. I guess, he talked a lot about growth hormone and how that impacts on that. But one point I'd like to perhaps add is that we've got research that demonstrates that sleep deprivation exacerbates the dawn phenomenon. So basically, when people are sleep deprived, their morning blood sugars are higher. And that's been shown in experimental studies as well. And I think that speaks to the fact that sleep deprivation is associated with exacerbation of insulin resistance. So whatever insulin you have, and be that insulin that your body produces yourself or insulin that you inject into your body in the case of a type 1 diabetic, that insulin will not work as effectively if you're sleep deprived. So I'd probably just suggest that as an adjunctive measure to the management of dawn phenomenon. Make sure you're getting enough sleep. And I guess just one other point which Dr. Bernstein did mention, and I think we can never emphasize it enough, is that nutritional ketosis is different to ketoacidosis. They are quantitatively different. They're an order of magnitude apart. So while, yes, ketoacidosis is a problem, the acidosis bit just means that the pH balance of your body is being adversely affected. It's going outside the normal homeostatic range, and it could actually kill you. Whereas nutritional ketosis means that, yes, you have detectable ketones, but there is absolutely no change, no impact on your overall pH, and it's entirely safe. And we can't make that point enough, because we still hear doctors and dietitians and health professionals out there to this very day recommending against the ketogenic diet because of the unrealistic risk of ketoacidosis. And of course, we know that it can occur, especially if you're taking certain kinds of drugs like the SGLT2 inhibitors. But for most people not taking any drugs at all, it's not a realistic concern.
I agree. It's one of the things that just drives me crazy, the way doctors just don't understand that it's such a basic thing they don't understand. The trouble is, I guess the only time they've ever heard the word keto until recently was in conjunction with ketoacidosis. So they sort of associate the two, but massively different. All right, as I said, we could go on for ages with Richard Bernstein. Amazing man. And we've gone from an 83-year-old to the other end of the spectrum with our next speaker.
Yes, so our next speaker is Dave Dykman, who's 17 years old and who is a very impressive individual. He has type 1 diabetes. He knows Richard Bernstein very well. And in actual fact, he was central to the setting up of the Facebook group Type 1 Grit with Dr. Richard Bernstein, which has been responsible for helping literally tens of thousands of people around the world manage their type 1 diabetes. So he's got a life ahead of him, that's for sure.
Aloha, everybody. I really appreciate you giving me the opportunity to give this talk on how I manage my type 1 diabetes. My name is David Dykman. In this seminar, I'm going to give a detailed account of my type 1 diabetes management strategy, which is mainly based off of Dr. Bernstein's very low-carb protocol, which I've been following for about 7 years in rigorous detail, and I give insight into the nuts and bolts of the strategy, for which I've consistently attained low blood sugars and A1Cs below 5, with very low variation. I will also share new data from others who follow this strategy, including information regarding insulin usage, diet, and more. So a little bit about me. I'm 17 and a junior at Punahou School in Honolulu. I've worked as Dr. Bernstein's intern for Diabetes University since I was about 11 years old. My use of personal video accounts and social media was an inspiration for the Facebook group called Type 1 Grit. This led to the highly notable Harvard study published in Pediatrics, which demonstrated remarkable glycemic control in a large cohort of type 1 diabetics. I am a feature writer for the online magazine A Sweet Life, and have written articles on the physics of insulin dosing and best strategies to perform rigorous athletic activity as a type 1 diabetic such as myself. I am also a very passionate advocate for type 1 diabetes management. I've spoken at many children's hospitals, universities, and conferences. I'm working to address the health and inequality issues via the development of a diabetes curriculum currently. So the outline of my talk is I'm going to go through my diagnosis story, kind of the experience I had pre-diagnosis, post-diagnosis, the hospital experiences, what the doctors told me at the time, and then go through kind of post-diagnosis and my introduction to the Bernstein method. And I'll go through some of my personal motivations, so hopefully some of you guys can connect with that or draw something from that. And then I'll go into the nuts and bolts of insulin and how I personally use it to cover meals. And then I'll talk a little bit about school and social life, and then my strategy for athletics, because I do play sports. And then at the end we have some data from other Type 1 group members. So pre-diagnosis, I always noticed that about a couple months before I had a very sunken face. I couldn't really get out of the couch. I had a ton of loss of energy, and I was losing a lot of weight. And at school, for the most part, my head would just be on my desk, even to the point where the teacher had to call our parents and kind of bring it to their attention. So we took several visits to the pediatric doctor, and that resulted into a misdiagnosis, which was very bad. The advice that we were given was actually to drink a lot of milkshakes to regain weight, because at that point I had lost about 10 pounds. And that, as you could imagine, was probably the worst advice that we could have gotten. So following that, I became severely ill and stayed at home from school. And funny memory is that during that time, I was just watching March Madness with my dad on the couch, even though I couldn't get up. Didn't have any energy. I had a great time watching March Madness. But finally, I was able to walk around, and the test revealed that I had Type 1. So we got the call on Friday night, and we went straight to the emergency room. And crazy story that happened there was I really didn't know what was going on at all at the time. I was too young, didn't know anything about Type 1. But we kind of burst through the doors, and there's a huge lineup of people. So we were thinking at the time that we were going to be there for probably hours and hours, but we were able to cut in front of everybody and go straight through, and that's kind of the point where I thought that it was something serious, and I was a little bit worried. So my hospital experience. So upon knowing my diagnosis of Type 1, I got a visit by my endocrinologist, and he kind of gave me the basics where you eat, you go up, you bolus, you go down. You should stay from this range to this range. At the time he said 70 to 180, and he said normal blood sugars were 70 to 110. And he talked about how carbs would make your blood sugars rise. And at the time, knowing nothing, I told my doctor and my dad, I just want to eat carbs. And that was kind of a weird thing to say, but looking back on it, I was probably 100% right. But at the hospital, we were given meals of pancakes, milk, juice, french fries, and bananas, which are pretty much all things that are a disaster for me now. If I eat, I go up to, blood sugars that are exponentially higher than they should be. But my doctor was honest, and I know from a lot of your guys' personal experiences that you guys didn't have doctors like this at the time, and he said that if I retain high blood sugars for long periods of time, I'll suffer complications. And I didn't know what those complications were, but he explained it to my parents, I'm sure, and he was just a very honest person in that respect. Post-diagnosis, we didn't really know about Bernstein, we didn't know about low carbs, but we initially followed the ADA guideline, and as you can see from my blood sugar graph on the right, it was a disaster. I was going up to 400 at the highest and down to 60 or 50 at the lowest, and it was just a roller coaster nonstop. You can't see a flat line in there. And on the pictures on the left are pictures of pretty much the ADA guidelines, 30 to 45 grams each meal. Teens, it goes up to 60 to 75 grams each meal, which is a disaster. And bottom left is kind of a picture of what the recommended diet would be. Sliced peaches, mashed potatoes, skim milk, low fat, all that stuff. So about 1 month post-diagnosis, we had the realization and epiphany that retaining normal blood sugars, or what we thought was normal at the time, with high carb food and riding this roller coaster was impossible. So we were looking for anything, any guidance, and my mother actually found this Dr. Bernstein's Diabetes Solution book. So reading that, we all thought something clicked and it just made sense, what he was saying. So after that, we immediately switched and got off of the roller coaster to a low carb, high protein diet, and immediately saw improvements. And comparing this graph, which is about a month following the diabetes solution, to the graph we showed in the last slide, it's tremendous, the improvement we made. Still not great, but so much different, a completely other world than the other one. So about 6 months after my diagnosis, we've been following Dr. Bernstein's guide for about 5 months, and we had truly gotten to the point where we would consider it normal blood sugars. And then we were learning as we go, including new insulin techniques, which all led to better blood sugars. And we even got to meet Dr. Bernstein. It was very cool for me because I honestly think that he was one of the main reasons, or if not the main reason, why I'm able to be here and be so healthy right now. And then you can see this graph 6 months from where I was. It's pretty much normal blood sugars. Still not as good as we are now, but very good nonetheless. So here are some of my motivations, goals, and some more results that I've had. So my main motivation is I just want to be normal, and I know that's, sounds a lot of people, but not normal in the sense that I can eat a birthday cake with everybody else. Normal in the sense that I want to have the same blood sugars as everybody else and be able to do anything that anybody else can do. Here's a picture of me and my high school football team in Cali. It's one of the guys. And yeah, remove the awful feelings of hyper and hypoglycemia. Second motivation is to prevent complications. So like I mentioned earlier, my doctor was very honest about complications, and he mentioned that they can start as early as the blood sugars rise from normal. I know that Dr. Bernstein tests for about 100 different complications of elevated blood sugars. And my main motivation is just, again, to be normal, be a healthy kid, a healthy adult, and that includes avoiding complications. So here are some important complications and examples that I'll give. So number one is damage to the child brain, which occurs within the current guidelines. So there's a study done, and it showed that these results demonstrate that early onset type 1 diabetes has a widespread effect on the growth of gray and white matter into children whose blood glucose levels are well within a certain current treatment from guidelines and then for the management of diabetes. So like I said, if you're eating 60 for 75 grams of carbs a meal, your blood sugars are above a certain level, which they guaranteed will be if you do eat that, then you're at risk for this. Another one, this chart shows that for retinopathy, neuropathy, all these different complications, you can see the risk for these diseases or complications immediately start to rise once you hit above a certain A1C threshold. So where I'm at is probably a 4.5, no risk at all for any of these. And when you go up to about a 6.5% A1C, the percentage is way higher than it was. Another one that's very alarming to me shows that almost 2 decades of lost life for type 1 diabetic kids. This means that for kids with type 1 diabetes that have these high blood sugars, their lifespan shortens probably about 20 years. And I want to live a full life. I want to live a full, healthy life. So this is something that I'm very much trying to avoid, and that I am avoiding with Dr. Bernstein's method. So my goal, like I've stated multiple times, is that I want to achieve normal blood sugars. And normal to me means average blood sugar within the 80s, which I've been consistently able to do for the last couple of years. Very low standard deviation, which means I'm not on a roller coaster, and limit the hyper and hypoglycemia. So on this picture on the right is what you can see is a typical graph for me. Low standard deviation, average within the 80s, and that's probably how I want it to be all the time, if not better. So since I've switched to Dr. Bernstein's method in 2013, I've consistently gotten A1Cs below 5. I don't think I've gotten one above 5 since that time. My average blood sugars have always remained in the 90 to 80 range. Like I said, low standard deviations and no severe hypos. Another cool story is Dr. Bernstein keeps my 2 graphs that we showed earlier in the slideshow that he shows to new patients, which shows them that it can be done, it is very possible, and it is almost easy to some extent. So growth, I know a lot of questions I get is, oh, you're not eating, whole grain bread and different grain foods or carb foods. You must not be growing. Well, I'm 6'1". I play quarterback at Punahou. I'm very healthy. So I've seen no high blood sugar, stunting growth, which, I don't get high blood sugar, so it wouldn't be a problem, or any effects from not eating bread or grains or carbs. So a little quick note on ketones. I don't really worry about ketones that much. My ketones are around 0.2 mm or so. I eat plenty of protein, so I don't really expect them to be that elevated. But like I said, I don't really personally worry about ketones that much. So just a quick note there. So this is mainly the nuts and bolts section of how I personally manage it, with such as insulin, the meals I eat, and the lifestyle I live. So in my diet, I have a strong emphasis on protein foods. I eat a lot of also vegetables and nuts and other fibrous things. One thing that's very cool is throughout this whole experience and connecting with other people who are following the Bernstein method, we've actually discovered a lot of great low-carb treats that we can make, like waffles, pancakes, all stuff that won't raise my blood sugar in the slightest way. So I enjoy eating those. And there's also a growing number of products that you can find even at Safeway and stuff, such as like low-carb ice creams, different things that I enjoy. Mainly I stick to a meal plan because I want to remove the roller coaster possibility. And yeah, my hunger dictates my food quantities. I'm a growing child. For long day of sports, I want to eat a lot more, and that will dictate my insulin intake, depending on how many grams of protein I'll eat for that. And carbs pretty much consistently remain under 30 grams a day. My protein is around 2 grams per body weight, or per pound of body weight, so probably about around 300 carbs a day, or 300 grams of protein a day. And I don't really force meals of fat. If I eat fat, I eat fat. If I don't, I don't. But I'm not looking for that in my diet. So this is a quick slide just to show that there's a delicious low-carb alternative to any high-carb meal. This isn't even showing the majority of the pastries that you can make with things such as almond flour, which there's hundreds of them. But these are just some great meals, typical meals that I would probably eat for lunch, breakfast, or dinner. This is my bottom line. There's no deprivation. In my experience, there's been a delicious low-carb alternative to any high-carb meal. The only difference is that you won't go to 180 and then crash down to 50. And this is my basal bolus management with a very low-carb diet. So most of the insulin I'm given at meals is to cover grams of protein, which will raise your blood sugar, but not to the extent that carbs will. They're very different. So I use a intermediate acting insulin called regular, or R. It's very cheap. I found we mainly get it at Walgreens or Walmart. So I also have a very diverse set of low-carb, high-protein meals that I know how to bolus for properly through trial and error mainly. But once again, the risk is not there where if you bolus wrong or guess wrong, you're not going to go up to 150, you'll go up to 110 at the most. So R is, as Dr. Bernstein says, it's impossible to consistently match the sharp peaks of high-carb foods with sharp peaks of rapid insulin. So with the food that we're eating, it's going to be steady rises, not sharp peaks as you would if you ate high-carb meals. So R is the best insulin for that because it matches the peak of what people on Dr. Bernstein's guide would follow, high-protein, low-carb meals. So this is kind of the formula that I go off of to trial and error different meals or new meals that I'll be doing. So I mainly estimate the meal as 1 unit per 8 grams of carb and 1 unit for 12 grams of protein, although I rarely ever eat more than 8 grams of carb per meal. So if I go high and come back down after a meal, next time I'll pre-bolus a little bit. If I go high and stay high, I'll know that I need more insulin. If I go low and then I come up, less pre-bolus. If I go low and stay low, less insulin. So this is the trial and error method. Like I said in the slide before, the risk is not really there. If you mess up, you're not going to suffer like you would if you messed up in the insulin dosage if you're eating, pancakes or cupcakes or potatoes or whatever you would eat on a normal high-carb meal. So these are two differences, examples of different meals from a low-carb, high-protein diet and a high-carb, low-protein diet. Picture on the right again is from the ADA guideline that we showed earlier. This is about 67 grams of carbs, 25 grams of protein, 20 grams of fat. The meal on the left is almost double the protein, double the fat, with about 60 less carbs, with 0 rapid carbs. Same amount of calories, but the one on the left will not raise your blood sugar. requires half the insulin, and the other one will require rapid insulin. This one, like I said earlier, requires R, matching the peaks. Basal insulin. I use Levemir about 3 times a day and recently switched to Tresiba. I've split my dose of Tresiba 2 times a day, 1 dose at night, 1 dose when I wake up in the morning. My daily dose has varied from, where I started using Tresiba to where I am now, because I am in puberty, I am growing, I have a lot of hormones, stuff like that. So at age 16 and a half was where I am now. It probably dropped to around 24 units a day. At the most where it was at probably 36 units to a day during my main stages of puberty. But yes, like I said, it varies due to growth. I determine my morning and evening dose based on the last 6 hours after injecting. If I'm going low around 2 a.m., then I'll probably decrease it the next day, and so forth. Correcting highs and lows. So in the very rare occasion that I do go low or high, I'll probably just take a dextrose powder, mix it with water, and I'll go up pretty instantly to where I want to be. And this is just another example of something that I wanted to put in here, which is that CGMs are not always accurate, and you can't always 100% trust them. As you can see, this graph is very scattered, shows very inconsistent numbers. It's going off for most of the time, so don't always trust CGMs. Always finger stick when you can, or regularly. You don't have to finger stick every 10 minutes, but you get the point. High blood sugars, I frequently use an IM shot with rapid acting insulin, not R, rapid acting. So as you can see in the graph to the right, I'll go up to around, this is like 120, which is probably the highest I'll ever get, or that might even be 110. And then you'll see I have a decline, and it's steady. There's no roller coaster. I'm not tanking to below 60. I'm going to 110 to 70, and that's the worst it'll get. And then again, that's another CGM fail that we had in this graph, which is just to hammer home my point that CGMs are not always trustworthy. Low blood sugars, like I said earlier, I'll correct around 70 or below 70. So I always treat it with glucose, but I honestly prefer liquid glucose. It probably goes a lot faster, I've noticed. So I've almost never had a severe low because, like I said, with this you're removing the possibility of a roller coaster where you can't go down that fast with the stuff you're eating and the insulin dosages you're giving. So opposed from people that are on a high carb diet, I wouldn't be in the 50s or 40s, down from like the 180s. So this is just a picture of the liquid glucose that I use. Determine kind of a method as how much to give. So 1 scoop if I'm below that, and that'll raise me 15 points, and so on and so forth, depending on your weight. So school and social life, I found it to be very common that different kids will be on different diets, vegetarians, vegans, pescatarians. So I've noticed for the most part my friends don't really care what I eat. If I'm at a party and it's someone's grilling, I'll just have a hot dog with no bun, no one cares. Hamburger, no bun, no one cares. Pizza, take out the cheese, eat the topping only, no one cares. Drink a Diet Coke, no one cares. And I take pre-filled syringes and R with me just in case I ever do eat. And at that point, I'll have already known the correct dose for those foods. So this is my strategy for sports and athletics. I play football and basketball. Both are very hard to manage because of the amount of exercise that I'm exerting, and the adrenaline and whatnot affects your blood sugar. So what I've developed is I have pre-planned meals, pre-planned insulin doses to ensure normal blood sugars hours before the activity, so there's no variation, and I can focus on the sport and not my blood sugars. So I mainly try to avoid food and insulin before 2 hours before the sports because, like I said, that will create a roller coaster. Even if you're on a low-carb diet and you're taking huge amounts of insulin and eating huge amounts of foods before a game, you're gonna raise your blood sugars high because of the adrenaline you're exerting, and then crash them low because once you're after exercise, your body's just gonna absorb all that. And then I just plan and warm up like any other athlete. I focus on my sport, and I don't really have to worry about my diabetes if I'm doing this. Post-game is a little bit tricky sometimes. Basal insulin will probably be decreased because of the amount of exercise I do. My post-game recovery strategy is to make up the calories that I lost and keep my basal constant. And I try very hard to avoid post-game lows. So I probably eat 2 meals of protein and fats just to keep blood sugars from going low. I'll probably bolus less than I would normally post-game, and sometimes I make an energy shake, which is very high calorie, cream, protein powder, and it's kind of a smoothie kind of thing. So towards the end of this, I wanted to show some new data from Type 1 Grit, which is the group of a bunch of low carbers that are following the same method that I'm doing. So this is just to show the pediatrics paper that was published in 2018 by a lot of doctors, Dr. Blinn and Lenertz, Anna Barton, just to name a few. Richard K. Bernstein was a part of it. So it showed that for us, Type 1 diabetics, they studied about 300 diabetics. Carb intake was around 20 to 50 grams per day. Average A1C was 5.57. And they found out that carb intake was the only predictor of H1C. So yeah, most of the people, about 97, had better glycemic control than the ADA targets supplied. And a great quote from this is that their blood sugars seemed almost too good to be true, from Dr. Blinn and Lenertz, who was the lead author of the study and the instructor in the Division of Pediatric Endocrinology at Boston Children's Hospital and Harvard Medical School. It's nothing we typically see in the clinic for Type 1 diabetes, which is very true. And again, here's just some polls. There's a Tresiba poll, an injection poll, glucose poll, how many people use the 15-gram rule for corrections, how many use IM shots, how many split basal doses, has your child condition improved or declined since transitioning to low carb. Just some interesting little tidbits. So the first one is about honeymoon. Honeymoon phase is where you don't really need as much insulin when you're first diagnosed. And you can see that the majority of people will actually continue in this honeymoon phase for a little bit where they need less insulin. Very few people had to have no insulin for a few months. Very few people had to have no insulin for over a year. And then a little bit more people never had a honeymoon effect. Treating hypoglycemia, I would recommend using liquid glucose or glucose. Food is kind of too slow and you might get into the range where you have to end up bolusing for that food. So as you can see, almost 92% of the gritters actually use liquid glucose or glucose. And the majority of gritters use regular insulin, which is the one that I use to cover low carb meals. Small minority of them don't. A lot of the gritters also split basal. What I'm using is Tresiba. I'm actually in the minority here where I'm using 2 doses still. The majority of the Tresiba users actually use 1. Lantus, more people use 2. And Lovemir, it's kind of a 3-way split, but the majority of them use 2 doses. And this is just for pump users. I don't personally use a pump. I used to. I got off of it. I prefer not using a pump anymore. But you can see that multiple pumps is required for most meals for pump users. This is a pretty interesting one. Going back to my experience, I was not recommended a low-carb diet. And you can see that it's extremely rare, even with gritters. About 2% of them were recommended a low-carb diet once they were diagnosed by their doctors. 98%, an overwhelming majority, were shown the high carb method, and we're trying to get those numbers to be pretty much flipped almost. So this is a wrap up 2020 and beyond, or 2021 we're in now, I guess. So I'm just going to continue my advocacy for Type 1 diabetics. This is just a picture of me speaking at Low Carb USA in 2015. I've been doing this for a while. I enjoy doing it. I'm passionate about it, and I'm going to continue. So my main message that I'm going to leave you off on is that diabetics are entitled to normal, healthy blood sugars. Which is a message that I've been living by since I found Dr. Bernstein's book, and how I'm sure the thousands of people on Type 1 Grit are also living by. Thank you very much for this opportunity. And now I'm going to answer a couple questions. I know you guys haven't answered questions because it's online. Just in case you guys were unclear about some things, I just wanted to kind of simulate questions just in case. So question 1, what do you do when your friends are eating high carb foods? IG pizza. We already mentioned this earlier. You can always almost, at parties, you can find a way to eat something. If you're in that need for food, you know, there's always a burger no bun anywhere. There's always hot dog no bun. There's always a salad you can get anywhere. Take off the cheese out of the pizza. So it's very easy. you'll be able to manage this once you get more experience on it. But yeah, it's very easy. There's no really hardships or hacks you need to follow or anything. Question 2, do I ever measure my ketones? Again, mentioned this earlier in the slides. No, I don't really worry about my ketones too much. They've been around 0.2 the times that I have measured them, but I can't tell you the last time I measured them. It's not really a big interest of mine at this point in my life. Question 3, do you ever have a bad hypoglycemia? I honestly couldn't tell you the last time I had one. Again, the beauty of this low carb diet, almost the best part of it, is that you remove the possibility of a roller coaster ride, which is, I keep saying roller coaster ride, meaning, you know, blood sugars from 200 down to 50 when you overcorrect and stuff like that. So with the low carb diet, it obviously can happen. You know, you can get human error, you can add too much insulin by accident and whatnot. It just doesn't happen that often for me, very rarely at the most. And a bad hyperglycemia for me is probably in the 50s or 60s, which again, I'll take liquid glucose for and be normal in 10-15 minutes. So this is probably the most common one. Why not just eat like everybody else and shoot for an A1C of 7%? And like I said, two of my biggest motivations are, one, to live a normal, healthy life and have blood sugars as my non-diabetic friends or my non-diabetic family members, and two, to avoid complications. And with an A1C of 7%, like I showed you with an A1C of 6.5%, all the risks for complications are pretty much tremendously higher than if you were at an A1C, which I have right now at like 4.7%. Question 5, what is your message to newly diagnosed families? I guess my main one would be to order Dr. Bernstein's book, read through it. This is something that you guys all have to go through together as a family. It makes it a lot easier for the child, especially if you're dealing with a child with type 1. Support of the family is very important. And again, read Dr. Bernstein's book. Thank you very much, everybody.
What a remarkable young man, 17 years old. I shudder to think back to when I was 17, way back last century. Certainly quite remarkable. Lots of interesting things from that talk. Brain damage from an early age.
Yeah, and I mean, the interesting thing is that when he was first diagnosed with type 1 diabetes, he was whacked straight on a high carbohydrate diet, even when he was in hospital. Pancakes, fruit juice, French fries, bananas. I mean, this is ludicrous. And I suppose this hasn't really improved much. So the recent survey that he alluded to from the Type 1 Grit Facebook group showed that only 2% of the participants in that survey were recommended a low carbohydrate diet on diagnosis. We've still got a long, long way to go.
Now, what about protein? You had some interesting things to say about protein. I mean, there's this big sort of myth, I believe, that high protein adversely affects kidney function and so on. I mean, what are your thoughts on that for a start?
Well, I mean, there's really no clear evidence that high protein levels actually damage kidneys. And I think the proof is in the pudding. He's having the equivalent of 4 grams per kilogram of protein a day, in excess of basically 5 times the recommended daily allowance. And he's thriving. I mean, this whole notion that people with kidney disease shouldn't have too much protein, one of the theories for it, I think, arose because people would find protein in the urine of people with kidney disease, and they'd say, oh, the protein must be damaging the kidneys. In actual fact, the protein in the urine is a symptom of the damage to the kidneys, and one might logically ask, well, if you're losing extra protein from your body, is it really logical to then go and restrict the intake further? I mean, this whole fear-mongering over protein intake is just illogical, and I think it should be reassuring for most people that, you can actually consume protein to a higher level than the RDA suggests. The simple fact is, when they set their recommended daily allowance, the studies were mainly done on college-aged males, and it only considered the role of protein as a building block, as a substrate to make tissues. It completely ignored the important role of protein working both as an enzyme and as hormones. And I mean, they're both, proteins are essential for both of those functions. So they're missing out on all the potential health benefits of protein. And
So
yeah.
his amount of protein is pretty high. He talked about 2 grams per pound, which is 4 grams per kilogram per day. And as you said, the recommended dose is 0.8 grams of protein per kilogram. Some people suggest, particularly in older people, maybe 1.5, even up to 2. But I've never heard anyone talk about 4 grams per kilogram per day.
Well, I've got multiple patients on protein intakes of about that level without any evidence of deleterious effect.
Well, sounds good then. One thing I really liked his sort of takeaway line was that diabetics are entitled to normal, healthy blood sugars. Now that should be sort of written on the walls of every diabetic doctor and nurse and dietitian in the world, really, because that's not in reality what they recommend.
No, and we have the science. We know how we can achieve it. I mean, you only have to have a look at the tens of thousands of people on the Type 1 Grit Facebook group who have essentially achieved normal blood glucose levels. This is not some unattainable goal. This is realistic.
Yeah, absolutely. And the sooner that people understand that, the better. It's amazing that a 17-year-old can understand it, but many older and supposedly wiser can't. But anyway, we won't go there. Let's move on to our next talk. And it's a very special privilege for us to introduce Dr. James Mukey. Now, James is an ophthalmologist who from Adelaide in Australia, who has done a lot of work, obviously, with people with visual problems and blindness. But he's a very special person in this country. For those of you who are not Australians listening to this, every year on Australia Day, which is January the 26th, so one person in the country is anointed to be the Australian of the Year. So we have 25 million people, and one of those 25 million people gets to be Australian of the Year. And the Australian of the Year for 2020, the year that just passed, is Dr. James Mukey. And it's our great pleasure to listen to him now.
I suspect there aren't any kids out there who think smoking's healthy, right? And yet, back in the 50s, cigarettes were considered socially acceptable. Something like 80% of men smoked. Check out this ad for candy cigarettes for kids and the caption, "Just like Dad." The realisation of the health dangers of smoking in the 60s and the subsequent banning of advertising for cigarettes, the taxing of tobacco products and the rollout of hard-hitting and graphic awareness strategies such as these, that we all know very well, have made smoking socially unacceptable. And as a result, smoking and smoking-related diseases and deaths are on the decline in most countries. I suspect there are plenty of kids out there who don't realise that sugar can be unhealthy, and yet there are over 8,000 studies linking sugar to a range of serious yet completely avoidable chronic diseases, most of which begin in childhood. What are these diseases? Tooth decay. 40% of our 10 to 12-year-olds have decay in their adult teeth, and extraction of decayed teeth is the leading reason for days off school. Obesity. 1/4 of Aussie kids are overweight or obese, and there's a disturbing upward trend. The majority of today's children will have obesity at age 35 if we don't take action now. And obesity is the biggest risk factor for type 2 diabetes, a life-changing and life-threatening disease being diagnosed in 250 Aussies every single day, now appearing in our kids as young as 7, a disease that not so long ago was known as maturity-onset diabetes. Although obesity is the biggest risk factor for type 2, there are now more thin, metabolically unhealthy people than there are overweight or obese, metabolically unhealthy people. Clearly, there's more to this than just obesity. What's causing this explosion of tooth decay, obesity, and type 2 diabetes in our kids? Our poor diet. Our poor diet is responsible for more disease and death than tobacco, alcohol, or inactivity combined. A diet that's packed with sugar. Table sugar, sucrose, is what we usually think of when we talk about sugar. And sucrose is made up of equal parts glucose and fructose. It's important for us to know there's another very abundant form of sugar, the refined carbohydrates, sugar in disguise. Products such as white rice, white flour, white potatoes, and the foods prepared from these. Refined carbs are virtually all starch. And starch is just long chains of glucose which break down into single glucose molecules when they reach the gut. In fact, this is a process that begins as soon as these foods enter the mouth. When you consume refined carbs, you are quite simply consuming sugar. Sugar and refined carbs are nutrient poor and non-essential. There's not a single biochemical process in our bodies that demands we consume them. And yet, they are the major ingredients of ultra-processed foods, what I prefer to call ultra-processed food-like substances. Unhealthy substances that make up 62% of the American diet and 50% of the British diet. I suspect we're in the same ballpark here in Australia with our own diet. Disturbingly, our Australian Guide for Healthy Eating, which is based on our Australian dietary guidelines, is packed with foods made from refined carbs, foods that are relatively high in sugar and also ultra-processed substances. Can this document truly be considered a guide to healthy eating? How does sugar, refined carbs, and ultra-processed substances cause poor health? It can lead to a condition known as insulin resistance. This is a complex metabolic process. Let's look at glucose first. To help illustrate glucose metabolism, I like to use Dr. Jason Fung's analogy of a subway train in Tokyo, where the train cars are the cells, passengers are the glucose molecules, and the conductors of the insulin. As soon as glucose is absorbed into the bloodstream, it triggers the release of the hormone insulin from the pancreas, and the insulin helps move the glucose into every cell of our body, where it's either stored or used as an energy source. With prolonged and excessive consumption of sugar, the cells start to fill up with glucose. The insulin level rises to push more glucose into our cells. However, a point is reached when the insulin can't push any more in. We are now insulin resistant. The resulting overflow of glucose is taken up by the liver and may eventually be converted to fat, which is then stored within the liver. Fructose, the other half of table sugar, gives sugary products their sweet flavour. It's not recognised as a food by the body, and when absorbed into the bloodstream from the gut, doesn't trigger the release of insulin. The majority of the fructose is metabolised by the liver, where it wields its toxic impact and independently gives rise to insulin resistance. The seed oils found in cooking oils and ultra-processed substances such as margarine can also directly lead to insulin resistance within the liver and a subsequent laying down of abdominal or visceral fat. Progressive build-up of fat caused by sugar in the seed oils ultimately leads to a fatty liver. We all know what a healthy liver looks like, right? Deep, dark red colour. Here's an image of a human fatty liver. It's yellow because it's overloaded with fat. In humans who consume excessive fructose, a fatty liver can appear within 2 months. A fatty liver is key to the development of obesity and of type 2 diabetes, which in kids can arise in as little as 2 years. And what do kids and young adults who develop type 2 have to look forward to? Decades of unnecessary medical appointments, crippling expenses, lost work and life opportunities, and a battery of devastating complications. Above all, blindness. The most feared complication of type 2, the one that I deal with every day at work. Diabetes can cause bleeding inside the eyes that can take away the eyesight in an instant, and sometimes permanently. Fortunately, eye disease due to diabetes is rare in kids, although it has been reported, and the damage can begin in childhood. Diabetes is now the leading cause of blindness amongst working-age adults in this country. Meet Neil Hansel, an everyday Aussie bloke who constructs light machinery for a living. Neil was diagnosed with type 2 diabetes at the age of 26. Unfortunately, Neil neglected his disease. He neglected his health, and he paid the price. A few years ago, at the age of 50, Neil went to bed one evening with normal sight. He woke the next morning blind, in both eyes, and remains blind to this day. I asked Neil the last thing he remembers seeing before losing his sight. Here's his response.
I should have kept my medication up, and I should have followed the plans that were given to me by my doctors. I woke up one morning completely blind. Thought I was dreaming, went back to sleep for an hour, woke up and I was still completely blocked off. My wife's face when we went to bed. That was the last clear image I had.
The second most feared complication of type 2 diabetes is amputation of a leg due to gangrene. Here's Neil in a hospital bed in March 2020. I took this photo the day after his left leg was amputated. In fact, it was Neil's 9th amputation over a 14-month period. He's also had 2 heart attacks, so type 2 diabetes is a deadly disease. It's now the 6th biggest killer in our society. However, if we understand that it plays a major role in the top 3 killers, heart attack, dementia, stroke, then type 2 may well be the biggest killer in our midst. Type 2 diabetes is also an incredibly expensive disease, costing our health system at least $20 billion every year. Treatment of the disease and its complications, as well as the loss of productivity in the workforce. And if we realise that diabetes plays a major role in hypertension and cancer, then the cost is likely many times higher. How did this all come about? Why do we have an epidemic of chronic diet-related diseases in our children? It's a long story involving religious ideology, corrupted science, and the might of the corporate food industry. A disturbing 150-year history that culminated in the release of the Dietary Guidelines for Americans in 1980. A guideline document that discouraged the eating of saturated fat and cholesterol. On no strong scientific evidence. In fact, on flawed and manipulated scientific evidence. And to compensate for the resulting lack of flavour and the ability of fat to make you feel full after eating, the carbs had to increase. This low-fat, high-carb dietary recommendation persists to this day across the globe and in our own Australian dietary guidelines. And what's been the result? Cardiovascular disease has soared, and so has type 2 diabetes. There's been a 4-fold increase in type 2 globally over the past 40 years. And this rise has been even more profound in some countries and communities. In the First Nations people of Australia, there's been an 80-fold increase in type 2 since 1980. I have no doubt that a diet high in sugar, refined carbs and ultra-processed substances is driving this catastrophic epidemic, a diet that Aboriginal people have been encouraged to consume. A diet far removed from their ancestral way of eating. A diet that's highly likely to make them healthy and strong. Type 2 diabetes is also weighted toward lower socioeconomic areas. In Greater Western Sydney, for example, half of all adults over the age of 24 have either pre-diabetes or type 2 diabetes. For the first time in our history, we are overfed but undernourished. What can be done to curb this rising tide of a disease that's a serious threat to our health system, indeed to our society? If we're going to call type 2 diabetes a dietary disease, then surely there's a dietary cure, right? It should be as simple as reducing our consumption of refined carbs, of hyperpalatable substances, and of sugar. It should be that easy. However, there are a number of factors making this a difficult goal for most of us to achieve. I call them the 5 A's of sugar toxicity. Addiction, alleviation, accessibility, addition, and advertising. Let's look at them each in turn. Firstly, addiction. Sugar is highly addictive. It's been shown to be as addictive as nicotine. Sugar triggers the reward centre in our brains, leading to the release of neurotransmitters such as dopamine. They're what makes us feel good, what makes us want to do it again, and what gives us those cravings. Sugar is the only addictive substance, the substance that we willingly give to our babies. I came to understand the addictive power of sugar and ultra-processed substances only recently, and I'm a medical doctor. Once you're aware, it's impossible to put in place strategies to successfully reduce the amount of sugar in the diet, to detox from sugar, for you and your kids. The second A is alleviation. We often use sugar unwittingly to alleviate stress and make ourselves feel better when we're down. When we're anxious, the body is flooded with the stress hormone cortisol. The brain needs to balance the cortisol by releasing feel-good chemicals. Sugar does a very good job of triggering this reaction. Once you're aware that you're using sugar to alleviate stress, it's then possible to seek healthier options to activate your feel-good center for you and your kids. Send them outside to play. Get them out into nature. Music is also a powerful trigger. How good do we feel when we listen to our favourite playlist? The third A is accessibility. Sugar is cheap and sugar is everywhere in our lives, isn't it? We're being tested constantly. We can't walk into most service stations without being confronted by a wall of confectionery. We can't check out from most supermarkets without our kids being enticed by 2-for-1 chocolate deals, all strategically placed at their eye level. A recent study has revealed that 30% of junk food is on sale in any one week in our major supermarket chains, and these price promotions are more common in poor communities. At school supply stores, parents have to run the gauntlet of junk food and sugar-loaded beverages as they wind their way toward the checkout counter with their sugar-addicted kids in tow. We can't even escape junk food at pharmacies these days. Are they really protecting the community? Fourth A is addition. An astronomical amount of sugar is added to our food and drinks. In fact, 75% of our consumables have added sugar. And this is particularly problematic and concerning in remote communities where cheap, ultra-processed products are in abundance and fresh and healthy foods are often expensive, in scarce supply and at times even out of date. And how about those nutritional labels on the packets of our food? I can barely read them, let alone understand them. And they certainly don't tell parents the amount of added sugar contained within. Australia has a health star rating system. A system that's flawed. Flawed because it's voluntary. At this point in time, only 30% of manufacturers are using the device. It's also flawed because a large number of ultra-processed products receive a healthy rating. This is a system that's been designed by industry for industry. And there are at least 200 different names for sugar. Here are 56 of the common ones, only serving to confuse parents even more, particularly when a label states no added sugar. Sugar is sugar is sugar. Even honey is 70% sugar. The final A is advertising. Our kids are bombarded by ads and TV commercials for sweet and ultra-processed products on a daily basis. And this has been going on for decades. The slogan, "Breakfast is the most important meal of the day," was coined in 1906 by John Harvey Kellogg to market his newly invented breakfast cereal, cornflakes. Over a century later, there is still no evidence to support his claim. Indeed, many of us will do better by avoiding cereal for brekkie. On free-to-air TV, kids are exposed to 3 commercials for unhealthy food and drinks every hour. On social media, teens are exposed to 100 promotions for unhealthy products every week. There's absolutely no escape. On their way to school, on their way home from school. And there are countless other tricks that the junk and fast food industries use to reach our youngest and most vulnerable. What can be done about this? How can we stop this preying on our most precious? No doubt there needs to be courage, visionary leadership and decisive action. I've come up with another 3 A's. 3 overarching strategies of awareness, accountability and assistance. Let's look at these each in turn. Firstly, awareness. Our kids and their grandparents, parents and teachers need to be aware of the health dangers of these non-foods. And this awareness, this vital education, needs to begin early, in those formative first few years of school. Even earlier, during pregnancy. Glucose from the mother crosses into the blood circulation of the fetus. However, insulin does not. and so their child may be primed for a range of chronic behavioural diseases before they're even born. Breastfeeding is important in reducing the risk of chronic diseases in childhood. For those mothers who can breastfeed, the longer the better, to forge good metabolic health in our kids. And there's more good news here. Type 2 diabetes is largely preventable, but we must start with a comprehensive overhaul of our national dietary guidelines. A powerful but outdated and biased document that informs what's fed to our kids in hospitals, in childcare, and in schools and their boarding houses. It also informs health practitioners, health educators, and government health policy makers. South Australia's right bite policy for schools is based on our flawed dietary guidelines, so the policy itself must also be considered flawed. And most of us fear to stray outside guidelines or policies, even if they are flawed. We also need to take a close look at Australia's food pyramid. The old version to the right was diabolical, a dangerous device that promoted a diet high in cereals and refined grains. Even the new pyramid to the left encourages a carb-heavy diet and continues to discourage the eating of healthy fats. We need to celebrate the natural saturated fats in our food, fats that have been demonised for over 50 years, fats that are critical to health, to our survival. Fats such as those found in unprocessed red meat, eggs, and full-fat dairy. Healthy saturated fats that are not associated with an increased risk of cardiovascular disease. Perhaps my food diamond provides a better guide as to how we should eat. Enjoy foods containing healthy saturated fats from both animals and plants. Minimise highly refined cereals and grains, high sugar fruits, starchy vegetables and heavily processed deli meats. And avoid ultra-processed substances and unhealthy fats such as margarine and vegetable oils. There's nothing wrong with that old meat and 3-veg dinner. Type 2 diabetes was rare in our grandparents' era. We also need to be aware that type 2 diabetes is potentially reversible. If your child had life-threatening cancer, the first thing you'd want to know is whether the cancer could be put to remission, correct? In fact, it's your right to know. It's also your right to know that their type 2 diabetes can be put into remission. That the humiliation and destruction that accompanies this insidious disease can be avoided. The simple fact is there are proven dietary methods that have been shown to put type 2 into remission. And now over 100 controlled clinical trials to support the fact that a low-carb, healthy fat diet works to both prevent and reverse type 2 diabetes. Once again, we need to flip our eating pattern on its head, shifting from a high-carb to a low-carb pattern with a good dose of healthy fat. Our next overarching A is accountability. Accountability of businesses and industry to do the right thing by us. Businesses who prey on our kids' addiction to sugar, who know that kids are hardwired to love and seek out sweet things. Businesses and their industry allies who flood our environment with junk food and sugar-loaded drinks, who make it impossible to escape the lure of sugar, even if we want to, especially if we want to. And schools are by no means innocent. They need to review what's being sold in their tuck shops and canteens by private contractors, what's being served in the dining rooms of their boarding houses. And they need to find other ways to raise funds for sports equipment. There are many, many healthier options. And sporting clubs need to find healthy, real food sponsors rather than rely on the always eager fast food and junk food industries. After all, even our kids can't exercise their way out of a bad diet. Businesses and industry must also account for the amount of sugar they add to the products our kids are consuming. Make it abundantly clear how much sugar lurks within, and not to baffle parents with unidentifiable alternative names for sugar. Even many artificially sweetened beverages have been linked to chronic diseases, and they maintain our kids' addiction to all things sweet. Above all, our government needs to be held accountable. Our flawed health star rating system needs to be overhauled and the industry influence removed. It was a relief to see that orange juice has now been downgraded to 2 stars. How can a drink with as much sugar as a glass of cola possibly receive the healthiest 5-star rating? Encourage your kids to eat the whole fruit rather than the sugary juice. Nature has packaged the poison, fructose, together with its antidote, fibre. As well as filling you up, the fibre in whole foods slows down the absorption of the toxic fructose component. Sadly, there's still a long way to go. Perhaps this is a gloomy future for those soft drinks in our fridge. The same fate that ultimately awaited cigarettes. And our government also needs to rein in the rampant marketing juggernaut spearheaded by the ultra-processed food and sugary drinks industries. After all, 70% of Aussie parents want their government to step in and protect them from the predatory marketing of unhealthy products. And finally, we need assistance. Each and every one of us. Doctors need assistance. To have the education, resources and funding to manage kids with diseases such as obesity and type 2 diabetes. Teachers need assistance. To have the appropriate tools and training to guide our kids toward a healthier future. Parents need assistance. To know the very best foods for their kids to thrive. And there's plenty of resources out there for parents, teachers and schools. And Aussies from every walk of life should be able to afford fresh food, real food, healthy food, to reduce their risk of developing devastating diet-related chronic diseases. And we humans do care. A recent international poll has shown that the thing we care about most in life is our health. Type 2 diabetes is an all-encompassing disease that impacts the entire family. Here's Neil Hansel again with his wife and grandkids.
To Papa, you are the best partner in the world, and have a happy Christmas. Love from Anya.
We need to see more hard-hitting TV commercials such as Neil's story on free-to-air TV and social media. As an eye specialist, I never want to see another person go needlessly blind due to their diabetes. As parents and teachers, we can't afford to turn a blind eye any longer. Write to your school principal. Write to your local member of parliament. Join a movement. It's time to set our precious kids on the right path to an Australia that's free from type 2 diabetes. Thank you.
Thank you, James. Great talk. I love his passion, but gee, that's a scary story of that poorly controlled type 2 diabetic patient of his who literally woke up one morning blind.
And you know the rude thing about it? It's that it's completely and utterly preventable. I don't think most people realise that in the developed world, diabetes is the most common cause of blindness, and it's completely preventable.
James has probably only come to the low carb, low sugar world relatively recently, but he's incredibly passionate about it. And one area that we're all concerned about is dietary guidelines. And every country has their dietary guidelines. The US have just gone through a review of their dietary guidelines, and Australia is embarking on a long overdue review of the dietary guidelines at the moment. But I think we all agree that they are basically flawed. And one of the flaws in the dietary guidelines, obviously, is the fact that they are supposedly only for healthy people. And we know that very few people in our society can be defined as healthy.
Yeah, well, that's really interesting. So the data from the US, so they did a national survey examining the population on 5 metrics of metabolic health. And they found that for the US adults, only 12% were healthy on all 5 metrics. But then the scarier thing is that when you go to the over 60s, only 2% were optimally healthy. And I mean, assuming that the Australian population is not dissimilar to what we see with the US population, then it really speaks to the fact that most of our population is headed for development of chronic disease. And if you actually have a look at the dietary guidelines for Australians, it very clearly states that they don't necessarily apply to people with chronic diseases, to people with diabetes, to people with kidney problems and chronic heart disease. So does it really make a lot of sense to develop a guideline that applies to only a minority of the population?
And ever since we've had these guidelines, we've basically got fatter and sicker. So really, wouldn't you at some stage think, well, maybe there's something wrong? But no, everything's fine. People are just not adhering to them enough. That's the issue. Well, I think as we've discussed many times, the problem with these is they claim to be evidence-based, but they decide which of the evidence they want to look at.
Well, that's a really important point. So with the existing dietary guidelines for Australians, I went and had a look at their literature that they actually reviewed to come to their conclusions. And they openly admitted that they omitted a whole tranche of data on things like saturated fat and cholesterol because they didn't deem it to be relevant. Well, I don't know about you, but for my money, I would actually like to know whether or not saturated fat and serum cholesterol levels are important with regards to metabolic health. And I think first, that kind of topic where we've got literally hundreds of peer-reviewed scientific articles on the topic, I think to ignore the totality of that evidence as we have in our current dietary guidelines is a disgrace.
Scandalous. And I think one of our roles, certainly with this revision, is to make sure that doesn't happen again. All right, enough about that. Let's move on to our next speaker, Paul.
Well, our next speaker is somebody who everybody loves, Brian Lenskes. He's a family doctor in the States. He's on the co-host on the Low Carb MD podcast. Friendly guy, runs a busy practice, and he spends his days healing people of chronic illness.
Hello, my name is Brian Lenskes. I'm an internal medicine doc here in San Diego, California, and I'm highly honored to be here at the Low Carb All-Stars. Dr. Paul Mason, thank you so much for inviting me. I thought you might have made a mistake, so I figured I'd get this talk done as quickly as I could before you change your mind. So everyone, thank you for joining me. Hopefully this will be of some interest to you. I really want to talk about the clinical aspects of low carb and how we apply that in the clinic here. So my talk is called One Size Fits One, because ultimately that's what it comes down to, what works for you or that patient in front of you, if you're a physician or a healthcare practitioner. So disclosures, I have no financial interest in the pharmaceutical industry. That will become very apparent. I've been practicing almost 19 years now here in San Diego. I'm using a low carb keto intermittent fasting approach to my patients clinically for the last 3 years, going on 4 now. And this is my dietary bias. I'm co-host of the Low Carb MD podcast with Jason Fung and Tro Kalajian, and also founder of Low Carb MD San Diego, which is a direct primary care focusing on metabolic health. I'm also the host of Life's Best Medicine podcast, talking about all the other things that matter that we're going to talk about a bit today. Life's Best Medicine podcast is sponsored by Simply Snacking. They are helping the production costs. I am not taking a profit from that. Also, I'm unpaid board of directors for KetoKine nutritional drink. So patients often ask me, Doc, what's the best path to take for better health? And my answer is generally, it depends. It depends where you want to go and how long your journey is going to be. So this is the problem we run into. People say, well, my friend did it this way, and my other friend did it that way, and my aunt did it this way. So really trying to find the right path for you. It doesn't matter what everyone else does. It's really figuring out the best path forward for you. So some of us are the hare, and some of us are the tortoise, where we just plod along and do it. And I've seen people have success both ways. Sometimes the rabbit, as we know, will take off quickly and then burn out, but the tortoise just keeps plugging along. So, hopefully 4 steps forward and 1 step back as we go on this journey. So these are questions that come up daily in clinic. What is more important, diet or exercise? Should I weigh myself every day? How many cheat meals do I get a week? How much alcohol can I drink? Do I need to fast? Are artificial sweeteners okay? Should I eat more protein or more fat? How strict should I be on my carb intake? The answer is it depends. It depends where you're starting out. If you're really sick, if you're diabetic, or whether you're someone trying to maintain your health. So unfortunately, that's my answer a lot of the times, is it really does depend on the individual. And that's what we're coming back to more and more. So Dr. Ben Bickman is one of my favorite people on earth. And I happened to talk to him back at Low Carb Denver. And I said, Ben, look, as a physician, if I want to live a long, healthy life, what do I have to do? And he says, okay, Brian, 5 things, very easy. Number 1, watch your stress level. Don't work 14-hour days and run around like you're crazy all day. And at that time, I was in a standard practice, working 14-hour days, running around like crazy all the time. And he said, make sure you get enough sleep. Well, back then, I was working downtown, so I'd have to ride 45 minutes each way with no traffic. And so that wasn't working out. That, oh no, he only has 5 criteria and I'm 0 for 2. He said, next, don't smoke or drink to excess. Next, exercise regularly. Next, watch your diet. And he goes, that's it. What do you want to talk about now? So 5 things. And this is the other stuff I want to talk about. Not just the diet, but everything else that goes with it. Ben Bickman says, keep your visceral fat as low as possible for longevity, and all these things lower visceral fat and insulin levels. Dr. Ben Bikikio, who's the workout guy, says, okay, muscle mass is the most important thing. So I was thinking, who's right? Which of these guys is right? Well, it turns out they're both right, because the more muscle mass you have, the better off you do at keeping your insulin low and decreasing visceral fat. And we'll talk a little bit more about that as we go through the slides. Also, as a physician, I say, okay, is it about weight loss? So this is a slide that Ivor Cummins loaned me, and basically I talk about this in every talk I give, because these are people in the country of Colombia, and they were looking at heart attack risk. And they said, okay, let's look at people who had heart attacks and who didn't. And we're gonna review the labs and see what we could have done to predict this was coming. So total cholesterol, if it's a risk ratio of 1, means there was no difference between the 2 groups. High total cholesterol and high LDL made no difference between the 2 groups. Yet that's what we talk about all the time. High blood pressure doubled the risk of heart attack. And as Dr. Unwin and many others will say, high blood pressure is clinically correlated with high insulin levels about 90% of the time. High insulin level is almost a 700% increase. I have to move myself out of the way here. Hopefully you can see the top there, 6.7 times. So why don't we talk about this? Well, because this is what Ben Bickman's talking about, and this takes time. It's not these we could throw drugs at very easily, but this one, we really have to look at those 5 things that Dr. Bickman was talking about. So this is another one. I just wanted to throw this in there to give you an idea, because a lot of people say, well, low carb is not good because it raises cholesterol. But look at this back row. So if we're going from back to front here, this is HDL, low HDL versus high HDL. So we can see our risk of heart attack goes up and up and up as our HDL is lower. Guess what? Low carb and lifestyle changes raises HDL. So I'd rather be here in the front row with an LDL of 220 with an HDL of 85 than in the back row with a good LDL cholesterol. So this slide just brings a point that we really have to look at the whole picture and really monitor these laboratories closely. This is A1C adjusted for against cardiac risk. And as we can see, as the 3-month sugar average goes higher, the risk of cardiac complications goes up. So we're told that a 3-month sugar average of 7 in the US terms is good. Well, that's a 400% increased risk of cardiovascular disease. I think most people would rather be here on this end. So this is another slide by Ben Bickman. And this is one I use daily in my clinic, because this bottom line, the sugar and the 3-month sugar average, if we're just tracking this, we're going to miss the rising insulin. So insulin, the higher this gets, it's a sign of worsening metabolic disease. So if we're up here, we're in trouble. We're on the border of diabetes. The good news is this is a 10-year process. So if we catch this elevated insulin every year going up and watching it, and watching stress and watching dietary changes and exercise, we can really make an impact before the patient, any of us, are diagnosed with diabetes. And this is why this N of 1, the person in front of us, is very important, because it depends where they are on this curve of how strict we have to be at decreasing that insulin level. Because if someone's on the verge of diabetes, we have to be a lot more strict, or if they're diabetic, we have to be a lot more strict than someone who's just down here trying to maintain health. And this is type 2 diabetes here at the end. So insulin resistance, this is from Ben Bickman. I guess he doesn't have to give a talk. I'm giving all his lectures. So anyways, these are all the diseases we see. And as a primary care physician, this is what matters to me. I don't want to treat all of these with individual drugs. I want to attack the root cause of insulin resistance, lowering insulin, lifestyle. So can you spot the elephant in the room? I'll make it it's a little bit tough. Here he is down here, but here's the big elephant in the room: stress. This is what I see as the biggest factor for people not succeeding or having trouble changing lifestyle: stress. Lack of family support and stress, because we kind of revert back to our old ways. When we get stressed out, we want to eat more, and that's our way of dealing with stress and discomfort and just trying to make ourselves feel better. But in the end, we feel more like an elephant in the room. So this is what I use. This is called the Sika, and this is a scale that gives us body composition. So I can look at visceral fat, subcutaneous fat, muscle mass, bone density with this machine. But it's not necessary. We could do the same thing with the string, because the biggest indicator of metabolic disease is waist circumference. So we follow this closely. And as we'll talk about later, sometimes these inches will change way before the weight changes. And this is a huge topic. This is why I'm speaking about this today, because I think a lot of people give up, even though they're improving metabolically, they're improving clinically. The scale becomes such a focus that it really causes us problems. This, I think, is the most valuable tool we have. It's a continuous glucose monitor. We use it as a lie detector test, because if people say they're not eating carbs and we're seeing it spike like crazy, generally we can ask a few questions to ascertain what's happening. But more importantly, it's for the patient. When they see their sugar spike with eating corn or eating fruit, then it's not my opinion anymore. They can see it themselves. So a lot of people self-regulate quickly because they realize that creamer they have in their coffee is causing a problem, and they can make those changes quickly. And so this is a patient of mine, just as an example, came in with very poorly controlled diabetes despite being on multiple medications. And his sugar's in the 260, 240 range up here. So this is on October 1st. When we jump ahead, October 28th, and the same patient, his sugars are 70s, 80s, 90s, even in the 60s. When he finger stuck, his sugars, they were actually in the normal range. So, but he called me on this and said, oh my goodness, my sugars keep dropping. But he was actually running in the mid 60s at that point. But that's a lot better in the 260s. And here, this spike we see was from exercise. Because he's fat adapted, his body can release sugar to burn as fuel. So this is a great sign that we're looking for in people who are fat adapted. This one you can see flat, perfect. This is what we want to see. And then here, what happened around 4:00 p.m. on Sunday, happy hour, right? One margarita did it. So these kind of things, and they called me and said, oh my goodness, did you see what happened yesterday? So this is fun because we could see this happening. Here's another one, patient doing great. You can see before and after. This is the important thing, is after they were doing great the next day. 1/2 of a cupcake spiked her like this, over 190 or so. Because she had passed up these cupcakes 4 times that day, and then someone upset her at work, and she said, forget it, just went back to old habits, grabbed a cupcake, and there she went. But that was her last cupcake, by the way. So this one, you say, well, what happened here, doctor? Exercise. Went for a long bike ride. Here you go, exercise down here. So this is why the continuous glucose monitor is so important, because certain things are going to change the sugars. It's not always bad, because sometimes exercise will do it. What else can do it? Stress. This guy had to give a presentation in front of his board, and his CFO and CEO were both there, and it stressed him out. So sugar spike. He said, I didn't even eat anything with carbs, and look what happened. So these are important factors to look at. And these are those things Dr. Bickman was talking about also: exercise, watching the stress level. So when people say, is it a bad thing for sugars to spike? I'll say, it just depends. If it's spiking because you're exercising, then no, it's not a bad thing. Or stress, if you try to minimize the stress, it's good for you to see that. But lack of sleep will raise the sugars also. It's not just what you're eating. So it's all about the scale, right? I'm telling you, in clinic, we always focus on the scale. We don't, but in general, that's what people are looking at for their success marker. But metabolic health is our goal. We have to remember that. And I think that is a key. That's a key take home, I think, in this lecture. Visceral fat is linked to multiple comorbidities. That's the fat around the organs. There's subcutaneous fat, and we'll talk a little bit more about that, is the love handles and the stuff we want to get, the jiggly stuff we want to get rid of, but that's not actually killing us. It's the visceral fat. And we'll talk a little bit more about that as we move along here. But visceral fat associated with multiple cancers: colon, breast, endometrium, esophageal, and kidney cancer, stroke, coronary disease, dementia, early death, diabetes, and hypertension. So visceral fat is really our enemy. It's not necessarily the weight. Because if you're Sean Baker and you put on a ton of muscle mass, does that mean you're unhealthy because you weigh more? No, absolutely not. It's really looking at the visceral fat ratios and muscle mass. So this is my patient, Sue. I'm just putting her in here because she's one of my favorite people on earth, but also because she's made some serious life changes. This is at the end of our 16-week program. She went from 256 pounds, eating a low-fat diet, by the way, as a nurse, to a low-carb ketogenic type diet. 58 pounds down, 11 inches off her waist. As we talked about, that is a huge factor. Triglycerides dropped 249 points from 314 to 65. No drug that I know of is going to do that. HDL went up, just like that slide I was talking about, that the higher your HDL, the better. She went from a mid-range HDL to a very high HDL. I feel really good about that, especially in light of her LDL dropping from 193 to 134, 59-point drop. Visceral fat dropped in half, and this correlates with what we're seeing clinically. Her husband didn't want to be outdone. He basically had the same numbers as her, not quite as impressive as his wife, but after the 16-week mark, he started working out really hard, and he's put on a ton of muscle mass, and he's an absolutely different person, doing amazingly well. So this is another patient of mine, and this is where I say it's not about the weight. So this guy came to me. He had already lost 50 pounds doing a liquid diet. And so the interesting thing is, as his weight dropped, he came to me around this point, and his weight loss slowed dramatically. But his waist circumference dropped significantly, and he put on a ton of muscle mass. So when you look at him, he's wearing pants from when he was like 40 pounds lighter with just a minimal weight loss. So it's not just about the weight loss. It really is about metabolic health. This is another one of my patients came in, morbidly obese, severe diabetes, really in bad shape. Now, here she is making some changes. Now she's happy. They're happy-faced people now. So that's kind of nice to see. This is what we see in clinic. This is what makes us happy and cures burnout for physicians when you see people coming in like this, knowing that they're doing better, they're feeling better, they're coming off meds, and they have hope again. And that's a critical thing. So it's all about the scale, right? Well, who do you think can hibernate longer? The bear, who's designed to hibernate, or the lion? The reason I bring this up is this is me and my wife, right? Of course, this is me, and this is my wife. I'm insulin resistant. She's insulin sensitive. So what we would do, just like everyone else before I went low carb, during the holidays, we gain weight and say, okay, that's it. January 1st, we'll go out on a diet. Well, we would eat the same thing. She would make me breakfast and her breakfast. My lunch, her lunch. My snack, her snack. We had the same thing, same 6 meals a day like they told us to do. And I'm hardly losing any weight, and she's dropping weight like crazy. Everywhere we go, everyone notices, oh my gosh, you look great, you're losing weight. So I'm thinking, what in the world? I'm twice her size. I should be losing weight a lot quicker. So then I started thinking about bears. Why do bears hold on to their weight, right? What's the advantage? Well, if you think about it, the visceral fat is more like oak. It's harder to burn. So those of us who are far along, it takes longer to get rid of that visceral fat till we could start burning subcutaneous fat, which is more like kindling. So people with a lot of visceral fat, I'm finding, take longer to lose weight in the long term. Initially, they're going to lose water weight when they drop their insulin level down. That's a given. So when you hear about someone losing 30 pounds or something really quickly, it's generally going to be water weight, sodium at the beginning, because dropping that insulin again, insulin makes you hold on to sodium in your kidneys, raises blood pressure, right? Raises weight. So as you drop your insulin level down, your salt levels drop, and blood pressure generally gets better also. So subcutaneous fat is our unpopular friend. It's the first line of defense against excess energy. So free fatty acids, triglycerides will store there. So if you have a lot of empty visceral fat or subcutaneous fat, you're going to store triglycerides there, and your blood triglycerides are going to be lower. If you can think of it as storage units, and as those storage units are empty, you have plenty of place to put this garbage that you're filling up on. Approximately 80% of our body fat storage is in subcutaneous fat, and subcutaneous adipose tissue is negatively correlated with atherosclerosis, metabolic disease factors, and selective reduction by liposuction does not improve cardiovascular risk. So if we go and take off 20 pounds of subcutaneous fat, liposuction, guess what? It doesn't improve our survival It may make us look a little bit better until we get a little disfigured, but other than that, it doesn't have a huge effect on our health if that's our ultimate goal. So as we age, subcutaneous fat becomes dysfunctional, right? And the sex hormones like estrogen, progesterone, testosterone force the extra energy to the subcutaneous fat. When we lose that effect or the ability to store fat, now it's starting to go to our visceral fat, which is why as we age, we get more increased risk of cardiovascular disease, increased cardiac inflammatory markers, more insulin resistance, and more inflamed. So you can think about it this way. This is how I kind of conceptualize it. Okay, if I have a power plant, and my power plant's making extra energy, or I'm bringing extra energy into the system by eating too much, my body's going to store it in the best place it can. Well, if this is considered waste and toxic to the body, I'm going to store it over here in these iron drums. Oops, sorry about that. I went backwards here. Okay, so iron drums, because they're better storage form. If I fill up all my iron drums, I'm kind of forced to put it in here in the visceral fat. So once these fill up, I start putting it over here, which is a worse storage place. And that's where we can kind of get into trouble. So what happens as we age, these start rusting and they're not as good at storing energy. So in females, especially, what happens, the bigger hips, the breast tissue, the thighs, once we start being unable to store that appropriately, we shift it over here into visceral fat. So this is the problem. And this is the good news and the bad news. The good news is whenever we start losing weight, we lose the visceral fat first, and then we switch over to the subcutaneous fat. So as we get older, this is why muscle mass, exercise, activity become critical, even if the weight goes up, right? So compared to subcutaneous fat, visceral adipose tissue is mainly in the mesentery, around the organs, around the gut, and drains directly to the liver. That's why we see elevated liver function tests and liver abnormalities. Stress hormones, this is why stress is a huge one, right? More stress and androgen receptors in the visceral fat. So that will suck in the extra energy, and then we get fatter and we get the big belly picture rather than the big bottom picture. So more sensitive to lipolysis initially, but once it gets too big, once you fill up those fat cells really full, they get dysfunctional. So it's hard to break them down. It's hard to get that fat out of there. And that's what we find. That's why the longer we wait, the harder it gets. Markedly increased prediction of mortality. If you have more visceral adipose tissue, as we discussed, increases it with age in both sexes. Markedly elevated CRP, which is associated with cardiovascular disease. So visceral fats are really our hidden enemy. They're out to get us, but you don't see them. So you don't, the jiggly stuff is what we really want to get rid of. So as endocrine, paracrine function, there's a lot that visceral adipose does that's different than subcutaneous. After 17 or 18 years of practice, I never knew there was a difference. I thought fat was fat, but now we're starting to see all these different, and this research has been around, by the way, but most primary care docs don't know about it. Pro-inflammatory, this is what we're talking, Dr. David Diamond, other people are talking about increased risk of inflammation, increased risk of cardiovascular disease. Tumor necrosis alpha and interleukin-6 both can contribute. But we'll talk a little bit more about interleukin-6, which is an interesting hormone. Also takes up glucose faster with insulin stimulation. So visceral adipose tissue is sucking up that extra sugar you're eating. So people with less visceral adipose tissue aren't soaking as much sugar, and they're sending most of that to their muscles. So that's why they can stay thin and we can't. I know it's not fair, but visceral adipose tissue increases risk of all these things: diabetes, elevates triglycerides, lowers HDL, all these things that we're talking about with metabolic syndrome. Increased blood pressure and salt retention, as we discussed, correlates closely with atherosclerosis, heart disease, all these things. So this is all visceral fat. So only obese individuals with increased visceral adipose tissue show complications predictive of diabetes and cardiovascular disease. So obese people with normal visceral fat have a lower risk than people. You can have someone who's thin. This is what we call the TOFI. They look good, but then you look at their numbers and think, these are crazy numbers. And this is part of the reason. Again, both sexes, if we control for visceral adipose tissue, that is what explains our increased cardiovascular risk with age. And again, subcutaneous appears to be protective. All forms of weight loss, as we discussed, visceral adipose tissue is affected more than subcutaneous, and it appears that low carb does that even better. So this is one that was interesting in my research here, is TRPBR2 is elevated in visceral adipose tissue, but not subcutaneous adipose tissue. and it blocks and prevents normal lipolysis. This is probably one of the reasons why it's harder to break down big full fat cells than those that are empty. So this leads to dysfunctional fat storage. Absence of TRPBR2 blocks cytokine storm. And now cytokine storm is what kills people with COVID-19. So this is why this is important stuff: decreasing visceral adipose tissue, decreasing inflammation. That's an inflammatory process that's killing people. So in rats or mice where they block this, no cytokine storm. So that's a huge deal of what we're talking about with metabolic health. So this is the deal. Going back to my wife. My wife had this much visceral adipose tissue. This is me, right? So I have to burn through all this before I can get to her level. So that's why it's easier for her to lose weight. So you can think about muscle as this. It could be a little tiny match, or it could be a flamethrower, right? So there's bad combinations that we can have. You look at this guy, like he has this cool shirt, but this doesn't increase his risk. He might look better going out at night, but he's still at major risk. So I see this guy, it makes me very nervous. Why? Very skinny arms and legs, big belly. That's all visceral fat. So he's preferentially, he might be drinking beers. He might be doing stuff that preferentially causes visceral adipose tissue. So his combination, his muscle mass is like a flame. I mean, a little match. And his visceral adipose is that. That's brutal because that's going to be hard to melt. He's going to have to really do some work, put on some muscle mass, cut back on the alcohol, maybe, watch the caloric intake and carbohydrates. So this guy, some of you may know, Sean Baker, here's his combination. That's his visceral adipose tissue. That's his muscle mass. So you look and you go, okay, Sean's in pretty good shape. So you could debate meat all you want. And I think what is going to come down to is visceral adipose tissue versus muscle mass. So Sean's in pretty good shape. And because he's so big, I always say he's in good shape. So no matter what, I don't want to get beat up by Sean. So this is a study by Sean O'Meara. This is a MRI. You can imagine it's a cross section of the abdomen. Looking at, you're looking, like the lady cut in half with a saw, and you're looking up into the abdominal cavity. So this shows at week 0 to week 35, you can see the pink visceral adipose tissue, tons of it. And as this person progresses, very little. So this person is way metabolically healthier. But what's interesting is, as you lose the subcutaneous fat, slowly, you're losing visceral adipose tissue at a higher rate. So visceral adipose tissue was going before the subcutaneous, the love handles were going away. This is another one. This is a big person. You can see big muscle mass, very little visceral adipose tissue. There's a very thin person with no muscle mass, tons of visceral adipose tissue. So you can tell me who's at higher cardiovascular risk looking at this study, even though most people would look at this guy and say he's at worse shape. So people always ask me, which is a more important, diet or exercise? Getting back to the questions I posed initially. Well, if you ever fly, you say, well, which is more important? The front wings or the tail wings, right? Probably the tail wings. I used to say, which is more important, the right wing or the left wing when you're flying, because they both matter a lot when you're up in the air. But even without the tail wing, exercise maybe play a smaller role. Diet is a huge one. If you run on the treadmill and see how many calories you burn after running 2 or 3 miles, you'll see it's not that much. It's one Snickers bar basically. So diet is a key, but diet and exercise are both important. So the people who I find have success are the ones who exercise and watch their diets. Some people will do great with diet part, but they don't want to do exercise, and they slow down and they plateau. Some people will do great with the exercise, but they hate the diet part, and then they plateau. So it's one of those things where you try to figure out, okay, let's look at the big picture and say everything's important. So should I weigh myself every day, doctor? Well, that just depends again, because some people weigh themselves. I have one guy who weighs himself every single day. And I said, well, why do you do that? He said, I like data. He's an engineer. He likes data. He wants all the points. I said, does it stress you out when you gain a pound or two, after you work out, for instance? No, doc, I know it's a trend. I know I'm just looking at the overall trend, and never stresses me out. I said, okay, cool. That's fine. Weigh yourself every day. Other people, I can guarantee, weigh themselves 5 times a day, and they're stressed out and tense, and they're wondering why they're not losing weight faster. And it really causes this stress response. And I'm convinced that stress is the biggest hindrance. That is the elephant in the room. If you're worried about the weight so much, rather than looking at metabolic health or how you're feeling, that's a huge, huge factor. So it just depends. And I think this is knowing yourself. If it stresses you out, don't weigh yourself as frequently, right? Because for me, Tro and I have had this discussion. At least initially, I like to look at the continuous glucose monitor because that changes very quickly. Also, insulin levels, and there's other factors, ketones. There's other things we can look at to say, hey, you're getting metabolically healthier, even if you're not seeing it on the scale. Because an important point is Dr. O'Mara's data is showing, and if you think about a hibernating bear, when the bear wants to hibernate, what does it do? It gets fatter and fatter. What does it do? Inhibits muscle mass, right? So visceral fat is inhibiting muscle mass. Why? The more muscle mass you have, the shorter time you can hibernate because you're burning more energy. If you get rid of your muscle and you have a ton of fat, you can hibernate a long time. So what we're finding is when people initially lose weight, especially if they have a lot of visceral adipose tissue, their weight may not change much, but their inches are changing dramatically, like that example I gave you. So this is something I learned in the last 6 months is that, wow, some people will lose inches, their clothes are loose, but they don't see it on the scale. So if we're using the scale as our marker, it's going to cause way more stress than it's worth. And that makes people give up before they should. So what doesn't work? This is my toughest patient, right? If I have a menopausal, premenopausal, real estate agent, stressed out, trying to make sales, doesn't have time for herself, doesn't have time to prepare food, kids are screaming in the background, she's late for every appointment. While we're having our appointment, she's texting, go, hold on, doc, just give me, hold on, I'll be right with you. You can sense the stress, right? When you see that stress level and the intensity, gosh, sometimes it's just not the right season. It's just too much stress and trying to figure out, okay, how do I manage this? I'm trying to clean at home. Oh, can your husband help? Or can your friends help? What can we do to make this situation better? Because we have to knock a couple of these things off. Can't knock the kids off, I don't think, but you can help, just, getting them into school. And this is another thing right now, especially the COVID weight gain. A lot of that is associated with stress and just grabbing food for comfort. When you're stressed, tense, you don't have anything else that you can do. So I think this is really important. And looking at the scale 20 times a day, these kind of things just really make it a slow, hard, difficult process. So, this was from Airplane. It was like, okay, I picked the wrong week to quit smoking, drinking, all these things. But for us, we picked the wrong week sometimes to quit donuts because some people will see this and they get stressed out because if I could just have one donut, I feel better. But what we're finding in the low carb diet is a lot of times people feel like they don't need this anymore because their stress hormones drop. They're even, like you saw in those continuous glucose monitors. When we see that, I can see people coming back saying, yeah, everyone's eating donuts. I really didn't care. It didn't have that draw. Or you see it for what it is. And I think Rob Sivis, said, hey, Brian, what's your favorite donut? And I said, glazed. And he says, what happens if you have that donut, you've been waiting all day to have it, and you drop it and it falls in a pile of dog manure, right? Dog poop. Would you pick it up and eat it? Right? So of course not. So when you see it for what it is, you say, gosh, this is gonna make me feel bad. My energy is gonna drop. It's not worth it anymore. It's not the draw that it used to have. Saturday morning cartoons, all those kind of things, those emotional draws we have. Joe Niflin's great talking about this too. There's so many great people in this community really putting the pieces together, and that's helping us clinically. So what seems to work? Patience. Patience is the most important thing, I think, right? And then after that, the next important thing is patience. Next thing after that is patience again. So being patient, being the tourist, saying, okay, I'm just going to keep going. I'm not going to stop. I'm not going to give up when I gain a pound. I'm not going to give up because I had a bad weekend. And then next is perseverance, which I think is the same thing. Just keep moving, keep going forward, saying, okay, things aren't going the way they should, but I'm going to keep taking that next step. And I could tell you story after story. I have a guy who's lost over 200 pounds. He couldn't even weigh himself to start. He was on low carb for 6 months before he could get to the point where he can weigh himself on a 400-pound scale. So now he's in the 200s, and you think, wow, this is crazy. But it was one step at a time. He logged his steps, kept going, cut his carbs, kept moving, kept stepping, and had a little fall here, got back on the horse, kept going. So this is really, really critical. I think this is one thing that if I can hammer home is this: patience, perseverance. So what seems to work? Stress reduction. My greatest patient right now, she's lost weight every week since July. She cut her stress down, right? So I can look at who's had success and I can say, okay, let's try to extrapolate that to ourselves, right? Stress reduction, huge deal. Because if you're a stress eater, boom, you're going to stress eat. And this is the other thing. People say, well, should I have carbs sometime or not? Well, here's the problem. If you're the person who could have one cookie and then not have a cookie for a month, probably can get away with it. But some people have one cookie and then they go crazy for a month, or they take a week vacation. I've had people totally reverse. Like the husband was totally into this, working out every day, doing great. Wife is struggling a little bit, trying to get on board. They go on vacation. They come back and they switch places. She's working out every day, watching her cars, feeling great now because she said, I felt so terrible on vacation. I feel better now. And then the husband was saying, well, once I got back, I was too stressed at work. I had too many things going on. It's hard to get back into the routine. So I think really it's key to stay as focused as you can and then realize when you're feeling well and when you're not. That's where journaling comes in. It's very helpful. So having family support, because having couples where one says, let's go get donuts, and the other one says, no, not today. Then the other says, oh, okay, darn it. But or having, meals made at home, or prepping, or, all these other things that are so critical. Family support, stress. Two biggest reasons for failure: planning ahead, preparing meals, saying, hey, I'm busy, I'm crazy. Like the real estate lady I told you about. Prepare your meals on Sunday. Whenever you have a break, prepare, barbecue, get all your stuff ready for the week. And so you have it. So you don't have to go out to fast food. You don't have to go out to dinner. You can do it at home. Community. We're building community here. We have Zoom meetings, group walks where we all get together. And so we have some people who are just starting their journey and they may go slower, and we put them at the back end and I'll walk with them. And then we have some faster people at the beginning. My guy who's lost 200 pounds, he's at the very front all the time, right? Because he's in good shape now. He's been really working hard. So accountability, having someone who goes, oh yeah, well, the continuous glucose monitor, that's accountability. There's no better accountability in my opinion, because that really forces the issue, because there's no denying when you see a sugar spike. So this is helpful. Consistent exercise, no doubt about it. That is a huge factor, because as you put muscle mass on, you become more insulin sensitive. As you become more insulin sensitive, you get your insulin levels lower. All these things, keeping your sugars stable and flat, emotional eating, all these things get better once we stabilize. Get adequate sleep. Poor sleep will spike sugars. We see it on the continuous glucose monitor. Also increases stress, which again, going back to the top, is our biggest reason for failure. So adequate sleep is key. I'm working on that myself now. I've been years of sleep deprivation. Now I'm trying to get back on track. It's hard to do actually, because your body just naturally wakes up. I wake up without the alarm trying to sleep and I just can't, right? I'm working on it. Cutting alcohol. I'll tell you, I've done studies on this. Alcohol is a bummer because it does increase insulin levels. It decreases our metabolic rate, and it causes increased visceral fat. So you can overcome that. I'll talk a little bit more about that with exercise, but it is a tough one. Limiting dairy and nuts. My lady who's doing well, she cut out alcohol, she cut out dairy, nuts, and you just see her weight drop every week. So it's hard to do. So some of us, they say, well, should I quit dairy and nuts? Well, it just depends. It estimates say that 70% of us, 60 to 70% of us are sensitive to dairy. Yet we really, really like dairy. So it's one of those darn things. Nuts, I could tell you, macadamia nuts have been my downfall. So I don't have them in my house. I love them and I will eat them. Unsalted, I won't. Salted, will. So it's really figuring out yourself and what works. And also what your goals are. If you're only 5 pounds away, maybe you say, I'll cut the nuts so I get down, a little bit. Trust the process. Trust the process. Just say, okay, I'm going to take one step at a time. I'm not going to stress every detail. Visualize my outcomes. I'm going to be positive. I'm going to keep doing this, and realize it's not a sprint. It's a marathon, right? You're not going to try to run this marathon as fast as you can. So again, here we go. Alcohol. Don't hate the messenger here. I'm just showing what it says. And I did an experiment myself and gained weight drinking alcohol for a week during Christmas, and had to take it off. But the good news is I fasted for 2 days and my weight normalized back to 7.8 pounds of weight loss, because high insulin level, I'm insulin resistant. I know I'm the person who can't do it. So again, it depends, but very few people can get away with it if you're trying to get metabolically healthier. Not ever, but I'm saying in excess every day or every 4 days a week or something like that. So the more we can cut back, the better. And I think that's where it just depends comes along, because if you're drinking every day, if we can drink every other day, we're going to start that way. And then we'll go to every third day maybe. And then we kind of realize, and some people just quit. And that's one of the big things we've realized. Low carb MD, we've talked about that on the podcast. Several people have quit drugs, alcohol, pornography, things like that you wouldn't think are associated, but they are, because they're all stress reducing techniques that people have. Improvement in female sexual function on a low carb, a low calorie ketogenic diet, psychological well-being, quality of life, all these things get better. So exercise and fasting, calories in versus calorie out. So this is one that I thought was interesting, because my patients who seem to exercise do better. So I started researching the difference again between visceral fat and subcutaneous fat. So exercising muscle releases interleukin-6, interleukin-10. What does that do? It goes to the liver, says release some of the sugar. That's why we see that sugar spike. Also, we'll go to the fat store and say release some fat, because we don't want to store it in energy when the muscles are demanding it, especially with a Ben Bikikyo type workout, high intensity or interval training. So it will cause release of fat tissue. So people say, well, doctor, if that's true, why don't you just give us interleukin-6? Well, interleukin-6 chronically is an inflammatory. It causes inflammation. So if I give you a bunch of interleukin-6, you release fat, you don't burn it. What do? Put it back in your fat source. You're just cycling it back to where it was and causing an inflammation. So it's not a very good plan. But blocking interleukin-6, this is the calories in, calories out, right? So they took people and they put them on a 12-week exercise program with cycling, and half the people, they gave them an interleukin-6 blocker, right? So interleukin-6 blocker, the interesting thing is that it blocks you from getting to your fat store. So these people, their LDL cholesterol went crazy and they didn't lose visceral fat, even though they did the same amount of exercise. So they were burning the same amount of calories, but this tells you that it's not about calories in and calories out. There's hormonal activation also that really play a role. So again, exercise decreases the fatty liver, triglycerides store in the liver and all that kind of stuff, and ketones got better. This is a huge one. I think this is a huge take home also, self-compassion. So when we go off the rails, right? That's the thing, is when we go off the rails, that's a problem, trying to get back on the rails, because what happens, a lot of us who struggle with weight, once we eat something, we're a bad person, we can't do anything right, you're a loser, all these bad things. And there's so much negative, there's thousands of times a day we're giving negative self-talk. Look at you, the pants are too tight, you didn't do enough, you're not working out enough, you're doing terrible stuff at home, whatever, all those things. So we need the self-compassion, I think, of a caddy, for a golfer, because the caddy will say, okay, look, you're going to hit this club, you're going to hit it into the wind, you're going to move your foot a little bit, right? And the golfer gets up there and hits it right into the water. The caddy doesn't say, you idiot, you blew it, you're a moron. He says, hey, you know what? You almost had it. Next time we're going to change the club a little bit. We're going to change your stance. My problem on the grip, we got you. We're going to get this better. So I think that's a huge thing, is not just wallowing in your self-pity, but being able to say, okay, look, what did you learn from that experience? So if you go to grandma's house and she bakes cookies every time, well, what can I do different? Okay, I could tell her before I go, maybe you can make a different type of cookie. Make it do low carb. Let's do something different. Let's go for a walk instead. So thinking in advance, and this is the one thing my patients with success, they think in advance. They say, yeah, I'm going to this place. It's not going to be a good situation. So I have people who are taking snacks with them that are low carb. Or they're taking beef jerky that's low carb. They're planning ahead. They're bringing dessert that's fruit, berries and cream, things like that, rather than having 5 pieces of cake. So again, self-compassion is not giving yourself permission to do it all the time, but when you do, learn something from it and move forward, saying, okay, I won't make that mistake next year when this men's retreat comes up or whatever it is. Because we all go off the rails at some point. So the idea is not to go off the rails. So once you got to stop here, don't keep going for, till you get to Chicago or New York or something like that. So it's getting back on the rails that's a hard time, right? So give yourself a little bit of a break. Like, have this self-compassion. Here's the great thing. Keep a journal, because when you're doing well, we're on all cylinders and feeling great. All of us have been there, where you're working on it and you think, I'm always going to do this. And then 2 weeks later, you're sitting on the couch again, right? So think about your mood, productivity at work, relationships, all those kind of things, and write it down. And count your blessings too. That's another one that lowers stress hormones, right? If you're upset and bitter with the world, it's not a good combination. So keep a journal, see how you're feeling, and focus on these things. Because when you go off the rails, you'll be able to go back and say, yeah, 3 weeks ago, I felt great. And look at me, my attitude was positive. I wasn't depressed. I wasn't anxious all the time. And now I'm feeling those things. So the big thing is, a lot of people feel like when they blow it for the weekend, they say, okay, now I have to pay the price. Now I have to torture my body. I'm not going to eat. I'm going to work out 4 hours today, and I'm going to, blow out my knees and everything, because I deserve that. No, have fun, enjoy it if you're going to. Try not to as much as possible. But if you do, okay, I'm back on track Monday, and I'm going to do it because I deserve it, because I deserve to feel better. I deserve to get my energy better, and I deserve to have a positive outlook and have less stress, right? So get back on your sleep, get back on as quickly as you can. You're not a bad person just because you had a cookie or a donut or whatever, and be honest with people. Say, hey, look, when we're in group meetings, all the time I'll ask them, I know they're struggling, and I'll say, how come you didn't share that with last night at our group meeting? And they'll say, well, everyone else has their act together except me. And then the next person says, Everyone has their act together except me. And the next person says the same. So really, once one person says that, and I think being real is important, because you say, yeah, I'm struggling with this, me too. And then 10 people will jump out of the woodwork and you don't feel alone. Being isolated and alone is one of the worst, as we all know, is a horrible, horrible thing. So being able to have someone to give us compassion and to uplift us, because if your friend blew it, you would say, oh man, it's okay, we'll get him next time, don't worry, you lost the game. But for us, we're the biggest loser when we lose. So I think, if you think about it, the self-compassion is like going into a football game and you have one quarterback here who says, oh, they beat us every time, we can never win, they're the best team, and we don't have a chance. Or you take this quarterback who says, hey, you know what, they beat us last time, but I saw some tendencies, we can do some things, we'll make some changes, I know another guy on our team that can catch the ball better, let's make some changes and win the game. Who are you going to take to the game, right? So for ourselves, we have to bring that person who says, you can do this, you got it. Okay, you have a little loose skin, but next week it'll be better. Your weight's going to be down a little bit. You're going to be a little bit stronger. You're going to be a little bit faster. You won't be in last place forever. So let those things motivate you and not make you give up. Again, don't make yourself pay, because it's going to look like this for a lot of us. We look, and some people, it's like going to the stars, how far we have to go, but it's one step at a time. Just one step at a time, keep going. You may have to rest. It's okay. Enjoy the journey. Take a look, smell the roses, listen to the birds. It's okay, right? Because you can't run to the top of the hill and go, okay, I'm here. Now I can go back to do what I was doing, because that's going to put you back in the same disaster, the yo-yo plan that we've been on our entire lives. Because what you did before wasn't working, right? So for most of us, this is what our road looks like, right? It's not that straight road at the beginning. It's going to go back and forth and wander a little, but that's okay. Just stay on the road. You're going to get there. It's just going to take you a little bit longer, right? It's nice if it's a straight road, but sometimes you got to just go with it, right? This guy, I love this guy, Cliff Young. He's an Aussie, so Paul will like this guy. He shows up to run this crazy marathon, right? He grew up on his family farm. It was 2,000 acres. He had 2,000 sheep. They couldn't afford a horse because they were super cheap. I mean, they were poor. They were cheap too, probably because they were poor. So at 61 years of age, he said, I think I can run the Sydney to Melbourne marathon, ultra marathon. It's 544 miles. So yeah, big deal, right? So he shows up in overall and work boots without his dentures, because he said it would chatter too much when he was running. And the guy starts running. And he was, at the end of the first day, this guy had a weird shuffle, and it was just like, these guys that he was running against were trained by Nike, and they were having all the respiratory function tests and running and lifting and preparing. 23-year-old kids. He's 61 years old, right? He shows up in boots and Levi's. And the end of the first day, they're laughing, like, what are you doing here? He was dead last. But he didn't stop. Everyone else kept, taking sleep breaks for 6 hours. He kept running and kept running and kept running. And at the end, after 5 days of running, he won the race by 10 hours, right? And all the other guys couldn't believe it. So it's like the tortoise and the hare, right? He was the tortoise, but he just kept going. He didn't give up. He just kept moving forward. And so a lot of us in our low carb journey, at the beginning, they're laughing at us because they think you're Cliff Young. They think you're the person who doesn't know what they're doing. Everyone else is doing better. Everyone else is losing more weight than you to start with, but stay the course, right? Because he imagined that he was chasing the sheep before the storm. They said, why'd you go? Why'd you keep going? Why'd you not stop? And he said, because the sheep. I imagined I was saving my sheep. And so he had something that drove him forward. So for us, it may be our grandkids. It may be not being the last guy in the race. It may be whatever motivates us, but keeping that positivity. He wasn't aware there was a $10,000 prize too. So at the end, he goes, oh, there's a prize. Okay, give it to the next 5 guys who all broke the previous world record, by the way, but they were 10 hours behind him. But he gave them the money because it wasn't about the money. It wasn't about the final destination. He wanted to prove we could do it. So he just kept going. So this is something like, he's a huge story for us, really of this whole patience, perseverance. So sometimes we just need someone to point us the right way. There's a lot of great people out there, a lot of great docs, a lot of great nutritionists out there now who get in and say, okay, here's the road you're going to take. It's going to be a long road for some of us, and some of us it may be a shorter road, but having community, having someone on your side makes a huge difference. So like Rocky, you get up, don't stay down, you bum. And then when you get to the summit, you don't care about the pain, right? You just kind of get there. So I'm hoping that's where we all end up at some point, the best version of us we can be. We're not all going to have 6-pack abs. We're not all going to be Ted Naiman or Sean Baker, but we can be the best version of ourselves. So here's life's best medicine. Eat real food, stay away from processed foods, empty calories, that kind of stuff. Get enough sleep and rest, really critical. Exercise regularly. And a lot of us, unfortunately, we're sacrificing sleep to get exercise or exercise to get sleep. So it's figuring out how to get that balance, maybe changing up things, maybe watching less TV or exercising while you're watching TV. If you have to watch TV, turn off the news. That's good for a lot of different reasons. So don't smoke or drink alcohol to excess, control your stress level, and have good social support. Find out what you enjoy, count your blessings, think positive, be kind to others. It's going back to finding what you enjoy. I have a lady, she all of a sudden started losing weight like crazy when she was struggling before. And I said, what'd you do? She goes, that's when I took up knitting again. I said, knitting? How many calories are you burning knitting? She said, no, I sit there for an hour and I just tune out the world, right? For some of us, it may be prayer, it may be yoga, it may be putting puzzles together. Find your peace, find what you enjoy. That is key. That's a really important thing. Find your happy place. Like I said, church, yoga, collecting rocks, I don't care what it is. Keep your train as empty as possible. My other talks, I talk about filling up the train. The more full your storage units or your train is, the more insulin you have to hire to shove more stuff in there. So we try to empty that train out by watching our carbs, exercising, staying active, those kind of things. Never lose hope. Trust the process. Keep taking one step at a time. Don't get down on yourself. Say you should have lost 10 pounds this week instead of 2. Trust the process and trust yourself. Trust the people who are helping you. Reach out, listen to lectures like this. So thank you for listening. I appreciate it. And these are some of my references. And thank you. This is a great conference. I'm really honored to be a part of it. And I hope this helps you just clinically to think about, okay, where do I go from here? What happens when I do go off the rails? Not everyone's perfect. So give yourself some grace. I think this self-compassion thing is a huge deal. And just enjoy the process. Have a great day. Thank you for listening. I appreciate that.
Another great talk. So much to take in, really, from a talk like that. First of all, let's talk about insulin resistance. And I think he quoted that those with insulin resistance were 6.7 times more likely to have a heart attack.
Yes, I mean, it just shows how important serum insulin is as a measure. And as you always say, it's one that we don't measure often enough.
I wonder why. Why is that? It's strange, isn't it? I mean, if I go to a doctor and ask for serum insulin, they look at me as if I'm sort of from another planet, and yet it's so much more sensitive than blood glucose, because as we know, by the time the blood glucose is abnormal, you're way gone. It's much more sensitive as an early indicator that you're getting into trouble and you're developing insulin resistance. So I think serum insulin should be part of the sort of it should be a compulsory part of basic blood screening.
I think it comes down to ignorance, because we know it's a very good measure and it's very easy to test. There's no reason why we ought not be doing it, except for the fact that we don't know how important it is.
Now, we also mentioned waist circumference. I know that's one of your pet topics. And yes. Tell us how you measure waist circumference.
Well, as you know, that if you have what we call a pendulous abdomen, whereas rather than being, a gentle protuberant curve, you actually end up with an overhang, which is very common. Then the traditional methods which are described to measure waist circumference become a lot more difficult. Whether we wrap the tape measure around the belly button, the umbilicus, or do we do it at the point between the lower rib and the iliac crest, the hip bone. So what I've actually found is that if you lie on your back when you measure abdominal circumference, then this totally removes any of the effects of gravity. And the belly button is always at the right level. Then you just put the tape measure exactly around the belly button. It leads to very, very reproducible measurements. And I think this should be a standard of care in everybody from now on. I always measure my abdominal circumferences lying on the back, what we call supine. And I think that's a bit of a pro tip for any other doctors out there who manage patients for weight loss.
Great idea. A couple of other points you made is be kind to yourself and be compassionate when your patients go off the rails, as they inevitably do in these circumstances. Show compassion. Don't criticise.
Well, I think that's the whole thing, because the existing paradigm of obesity is one of blaming the patients. It's one of guilt and it's one of shame. It's one of you being greedy and you being lazy. And we know that is not true. And I mean, so first of all, for the patients need to be educated that they're not to blame. If they've followed bad advice, they're not the ones at fault. Give themselves a leave pass. And understand too that their eating habits have built up over decades, over their whole life. And it's not just a matter of flicking a switch and you're going to be perfect on a new diet. There will be ups and there will be downs. And I think for medical practitioners too, they need to appreciate this, that patients are not machines, patients are not robots, that we're all human, and that if we do have any deviations, that's okay. Dr. Unwin talks about this. Brian Lenski is very good talking about this. We need to appreciate the humanity in our patients and give them a leave pass once in a while. And if we can show that kind of compassion, the results are going to be better at the end of the day.
And finally, I can't believe that an American was talking about Cliff Young, who's one of our local heroes here. Who it's an amazing story, the Cliff Young story. They've actually made a movie out of it, I think. But I'm not sure that we would really recommend no sleep for 5 days, would we?
No, that probably goes against the grain. Also, I'm not sure that. Given Brian's emphasis on the importance of sleep there too, I think he was probably putting it to one side. But yeah, good on him. So Cliff Young, and as you know, one of the other guys, Paddy Farmer. Pat Farmer, another great marathoner of Australian history. But thanks, Brian, for throwing that in. Appreciate it.
Great stuff. All right, let's move on to our next speaker. And yesterday we had a really good sort of personal story. And I think we're going to hear another one today from Darren Graham, Big Daz, as we call him. Fascinating story of a guy who, I won't steal his thunder, but he was a bit of a mess, and he's turned his life around. And let's listen to his story.
Hi, my name's Darren. Welcome. This is a bit of a story about my journey of losing 100 kilos, approximately 230 pounds, from struggling to live to loving and enjoying what life has to offer. So hopefully you enjoy my story and get something out of it that for yourself, or that you can offer somebody else and help somebody else along their journey as well. So here are a few photos of my journey, everything from when I was 10 through to my late 45, 46 years of age. Yes, I had that mulleted perm when I was 18. I don't know what I was thinking back then. But all the things I went through, I was still trying to be sport orientated, eat right, do the right thing. But I could just never get my weight down. I would have my cereal for breakfast because my local sporting hero was telling me to eat 7 Weet-Bix in the morning. But then by mid-morning, I was hungry again. Then by lunchtime, an afternoon, come home from school, have something to eat in the afternoon because you're hungry. It was just a never-ending cycle. But even though I was big, I always tried to play sport. I used to play football or cycle all the way through. It just didn't seem to, it was ebb and flow. It was up one time, down the next, up the next time, down the next. So I have struggled my whole 45 years to 47 years, first 47 years of my life, with my weight in one way, shape or form. So go on a diet, they say. We've got the brand new thing for you. This is fantastic. So these are all the different things I tried over the periods. So first time was like Weight Watchers. I remember going when I was a kid at school, going on a Wednesday night back to my school where it was, and having to get up on a scale every Wednesday night in front of all these middle-aged people. You know, I was 16 or 17 and felt embarrassed, and it was just, it wasn't a right thing or a right way to do it. I've tried acupuncture. I've tried Slim Fast. I tried the low fat. And sometimes all I'll be eating was steamed vegetables. I just couldn't. That was what I was told was the way to go. Optifast, the shakes, 2 meals a day, 3 meals a day. Here's this, here's that. Herbalife. I was buying heaps of Herbalife. I think at one stage I was spending about $80 or $90 a week minimum on Herbalife, and having something in my tea and a spoonful of this and a tablet of that to try and stop the appetite. That's what it was. It was an appetite suppressant. Xenical, I remember coming out, it was like, the doctor called me in and said, I've got this new wonder drug for you called Xenical. You know, those things, I've tried everything. And even down the bottom there, that you'll see the reduced tablets. You've probably never heard of these before. I had never heard of these before. I even got that desperate. I was buying these tablets off my tailors in Thailand. So I go to my tailor in Thailand. He told me about these wonderful drugs. He was getting them in from India. And I go and get my shirts and pants made because I couldn't get them made anywhere else. I couldn't buy it off the rack. And so I was buying, you know, 2 lots of shirts and 2 lots of pants getting specially made, and a couple of hundred of these tablets as well to try and help me lose weight. I didn't know what was in them, what other medication they were mixing with, what other side effects it would be. I just was desperate. I needed to lose the weight. And this is the only way I saw out. I didn't see any other option. I just couldn't change what I was doing to myself time and time again. So here's a list of all the different medications I was on at one time or another, and some of them I was on 3 or 4 at the same time over the period of anything up to 10 to 15 years. I would have to have 10 visits to the GP every year minimum, 2 visits to my dermatologist, to the rheumatologist, and countless and many visits to the dietitian. Just nothing was working. Nothing that I could do would take away the pain and the way my body was just breaking down with all these medications and the obesity and the inflammation that was just slowly building up. My body was slowly dying and breaking down. The sad part, really, looking back, and I blame myself for not taking control back then, but some of the side effects of some of these drugs were unbelievable. I remember the sulfasalazine. I was told that I had to wait, if I wanted children, I had to wait 18 months to go off them before I could try to have children. That's unbelievable, that sort of a side effect that you're putting onto someone that's, 24, 25. And I was on some of these drugs for nearly 5 to 10 years. Mobic, I was on that for, I could see 10 years. I was on methotrexate for about 6 or 7 years. I remember having to set the alarm for the methotrexate every Sunday at the right time to take the 15 milligrams, because it was drummed into me that if I overdosed on it, it could be really bad for me. So some of the side effects of these things were absolutely terrible. I remember having to take 200 milligrams of tramadol a morning just to get going in the morning to be able to go to work. It's 200, and if I didn't time it right, I'd nearly fall asleep driving to work. So I had to work out what dose I was on, what my timing was like, just so I could function daily at a work and try and still earn a living or be just a functioning adult. And that was just the wrong way to be. So it all came to a head September 2015. I was on the right there. I was at my a friend's wedding in Bali, and I was just uncomfortable. I was a broken person. That was the worst I'd ever been. I had to get the shirt made while I was there in Bali because I couldn't find anywhere else to get a shirt that fitted me for the wedding. I was there happy and smiling, but really inside I was in so much pain. I was a broken person. You can't see it there, but I had 80% psoriasis coverage PASI score. I was bleeding. I was wearing shirts. I was changing shirts and stuff like that as well. I had severe arthritis, pain, depression, anxiety. I was on the 8 medications. Plus, you saw me beforehand. I was rattling every time I walked. My blood pressure was like 180 over 150. I had sleep apnea. I wasn't sleeping properly. So it was just crazy situation. I went from Bali to Thailand. And when I was in Thailand after this wedding, a friend of mine told me about low carb, high fat through Diet Doctor. Didn't take much of it, didn't take much notice, and just kept on going. But that was my first recognition or inkling that I needed help. And that was my first introduction to the low carb, healthy fat way of eating and lifestyle. So that was it. I'd done my research. I researched LCHF online. This is my last roll of dice. I was very much contemplating taking my own life. It got to that stage in around that December, January period. I found Diet Doctor online. So Diet Doctor, they sent me a 2-week meal eating plan, and that was it. I had no idea what I was doing, nothing at all. I took time off work due to bullying at work. I was being bullied at work and had issues at work, so I needed to complete break and just think of me for a change, and that's what had to happen. So from the January, things started to happen pretty quickly. From the January to the June, I'd lost 39 kilos. So 6 months, about 40 kilos. It was going off great. I didn't know what was happening. I couldn't work out how it was working. Why was this working other than other diets that I've been on before? So I started to research a little bit more and find out a little bit more about it. So back in the June then, I was 40 kilos lighter, so I started to go back to work 3 days a week. I used to ride to and from work every day, about 5.5 kilometres each way, and I was regularly fasting at work and during the days, anything between 3 and 5 days a week. Some days 24 hours, some days 72 hours. I was also going for walks at lunchtime and doing other stuff, so my energy and my enthusiasm for life had started to come back. And I was starting to see changes in my personality as well that other people had started to notice as well. And my eating patterns had changed. My mood had changed, my eating patterns changed, and my cravings had changed, all in that short period of time. In 6 months, I've been 47 years just lost in the wilderness. But in 6 months, it turned me around completely. To be honest with you, I found a difference within about the first 3 weeks, and that's all it took to start me on the track of a bit of a redemption, but a brand new life, that's for sure. So this timeline is pretty much a rough guide that I was tracking at the time for the weight loss. So you can see I started at about 185, and I know I was over that. I broke my scales, like I mentioned before, at my doctor's surgery, the dermatologist surgery, and they had to buy a new set of scales at about 185. But you can see the rapid weight loss because I was broken and I needed a change. So you can see the rapid weight loss peaked out a little bit, rose a little bit, but nothing's ever straight down. And it held for those 2 years. It was great. The one thing that I do find, and it was fantastic, sometimes there on the plateaus, you can see there from maybe a June for 6 months, I never lost any weight, but I went down 2 sizes in pants and 3 sizes in shirts. So it's not all about the weight loss. It's not all about the scale movement. It's the non-scale victories and your body changing, your body adapting. That is going to be the big thing that you'll find, and your healthier and healthier lifestyle. Your internal body will dictate how healthy you are. The good thing about the low carb is if someone's majorly obese, that initial response and initial weight loss gets them going, gets them motivated, and keeps them going, keeps them on the track. So now I'm up to 5 years going strong, holding the same sort of weight in maintenance mode now, and enjoying life completely. As you can see, over those first 2 years, the results in the blood work have been fantastic. But the main thing is my overall health has changed. My blood pressure was like 180 over 150 at one stage. Now average is about 117 over 74. My resting average heart rate was 60 plus. It was terrible. Now my resting average heart rate's between about 47 to 48 most days. I used to get 4 to 5 hours sleep. If I was lucky, I couldn't get to sleep. I'd wake up snoring, sleep apnea all the time, wake up tired. Now, as you can see, I can get 8 to 9 hours sleep minimum every night. I don't wake up. I've got pretty good heavy, deep sleep through most of the night. I wake up not hungry. It's been fantastic. It gives me energy and revitalizes me every day. I don't want my afternoon naps anymore. I used to need a nap just not long after I got up in the morning on some days, and then I have a nap in the afternoon. It's just great. Now I have so much energy that it's a new lease on life completely. Okay, so what are some of the achievements I'm pretty proud of over the last, what's it now, 4 or 5 years? Starting off early on, I thought the best thing I could do was a 5-kilometre city to surf in Melbourne. I was still 130 odd kilos, so it took me a while to do it. All the way through to setting different achievements and different goals, your mind is clear. Your brain fog from the sugar and the carbohydrates clears up. So it was sometimes a good thing, sometimes a bad thing, because I just kept setting myself bigger and bigger goals. I got back on the bike. When I was a junior, as I mentioned earlier, I was always into some sort of sport. I was a junior Northern Territory road, track and road champion of cycling. So I always had that great love of getting back on the bike again. So I did 145 Great Ocean Road Ride, which is up and down hills, 5 hours on the bike. Mind you, 30 hours fasted by this time. So I hadn't eaten anything for 30 hours, and I did the 5.5 hour bike ride. Same with my Melbourne Half Marathon. Same with my second Melbourne Half Marathon. 30 hours fasted. So what do you do when you've done 2 half marathons? Well, you step it up a gear, don't you? So I decided in 2019 to do the Melbourne Marathon. So I did my first ever Melbourne Marathon in 2 hours, 30 hours fasted, and I did it in about 5.5 hours. Not a great time, but it was a great time. I enjoyed it. It was fantastic. Did nothing but water the whole time, no gels, no fruit, no nothing at all, no supplements, nothing, just the water to get me through. I kept seeing people along the wayside that were falling over, doing a lot of other stuff. But me, I enjoyed it so much that even like 2 days later, I was back training again. So the body has changed. The body has taken on the new fats and the protein as a fuel, and I'm not a carb burner or a sugar burner in any way, shape or form anymore. It's fantastic. So here are some of the changes on some of the befores and afters. You can see remarkable changes, especially in my psoriasis, going from 80% PASI score to 0. It's just amazing the life that changing, that the amount of inflammation has gone away, and the irritable bowel syndrome, the pre-diabetic, the sleep apnea, the heavy breathing, the snoring, arthritis, the pain from the arthritis. I've still had the arthritis, but I don't have any of the pains anymore or the joint inflammation. So going from such an obese 200 plus kilos down to around the 100 kilos, 95 to 100 kilos, has been a remarkable difference. But this goes to show you that no one is ever too far gone. If someone's trying to tell you they're too far gone at 30 kilos overweight, they're not. 50, 60 kilos, there's always hope. There's always a way back. And it doesn't mean it's going to take long. It doesn't mean it's a never-ending battle. It's there and it's right within their grasp. I get asked all the time now, what can I eat now? So I've gone full carnivore now in the last 3 years. I've had no plant material in 3 years, other than my coffee. But I still drink my coffee. But now it's nothing for me to have a steak or a lobster or prawns or some fish, some chicken. I'll have bacon and eggs if I want for breakfast with a coffee. I'll have hamburgers for lunch. I'll eat out. I'll just adjust the menus where I am. If I want to go out and have a hamburger, I'll have a hamburger. I won't have the bun with it. I won't have the sauces with it. I know what I can and I can't have now. So it doesn't inhibit me in any way, shape or form. It's great. It's empowering. If you start to look at what you cannot eat, then you are not ready. You haven't got the want. You've still got the need. If you get the want, you can find any food, anywhere, anytime to eat and not have it be restricted in any way, shape or form. By the way, That one on the bottom right, that's me doing a 1.2 kilo tomahawk steak for my 50th birthday. And you can see I haven't touched the chips at all. And the salad, well, that was just the garnish they brought on the plate. So are you ready to do what I did? Are you ready to take control back of your own life? You be your own superhero. You be your own person that guides you. You need to change. You need to have the want to get healthier. The low carb, high fat, keto, carnivore is the only way that I have ever felt healthier. I am lighter than I was in year 9 when I was in school. I'm healthier than I've ever been in my whole life. The depression goes, the brain fog goes, the carbohydrate requirements go, the need for the afternoon naps have gone. My pain from my arthritis has gone. I've gone off 8+ to 9+ medications, saving myself thousands and thousands of dollars a year, and also the government for subsidies. So it's up to you. You're the one that needs to take control. Nobody else can do it for you. We're all here to help you. That's fine. We can help you along the way, but you need to take control of your own life. You need to be the driver of your own bus. Don't let anyone else be the driver of your bus.
Well, another great story. What incredible what Darren went through as a kid, and then as an adult. Weight Watchers as a kid, that's a tough gig. But I thought the most interesting thing was, if there's no other reason to follow this program, it can come back to money. And Darren's chronic illnesses were costing the Australian taxpayer $20,000 in medication per year. And by changing his diet, he has saved the taxpayer $20,000 a year. Now, how many more people out there could do the same thing?
And that's not to mention the myriad toxic side effects of the drugs he was on. I mean, he was taking 200 milligrams of tramadol just to get going in the morning. Yeah. And, every medication he was taking, have no doubt, they came with their attendant side effects as well. These drugs he was taking were far from benign. It was a cornucopia of toxic pharmaceuticals.
Yeah, and also I think the mental health and self-esteem and self-image issues that he highlighted is just so important.
I don't think people, and when I say people, I don't think medical professionals appreciate the degree of hidden suffering that is associated with obesity. The sense of shame, the low self-esteem, the physical suffering, the physical pain, the sleep deprivation, and the psychological issues that manifest even directly from that. There's a hidden iceberg of suffering that's related with metabolic disease and obesity that people don't realize. And I think if the people responsible for the dietary guidelines actually knew how much suffering their guidelines were causing, or at least could prevent and weren't preventing, I think they'd recant in a second.
Mm. And, did a remarkable job, really with very little help. I mean, he basically did this himself.
Well, basically, as you saw, he just went and got a 2-week subscription to meal plans online. So this was 5 years ago, back in 2016. So, things are a little better nowadays. We've got, people developing apps like your app, the Defeat Diabetes app, which can give you a little bit more support. But basically, he had a huge strength of character to know what he wanted. He was motivated to get it, and he needed to get it. We could say, he was desperate, but he was really motivated. And I guess it was sort of some of the points he talked about were almost humorous when he went and got these weight loss pills with, unknown chemicals in them from a tailor in Thailand who was importing them from India. God only knows what they were going to do to you. But look, sure, we can say that's desperation, but if nothing else, it shows you he really, really wanted it. And when he figured out how to do it, he went and did it.
I think people always say to me, how do you keep motivated? How do you keep on this diet and so on? But, when you see the changes that, obviously very dramatic in his case, but you see, everyone sees the changes to their body, to the way they feel, to their weight, to their blood glucose, etc., etc. Surely that is the most motivating thing of all. Once you and you feel so much better. So I don't think that people say, oh, it's too hard, it's too difficult to stick to these diets. But when you see the results and when you're feeling so good, it's not hard.
Well, and when you see, he's obviously moved to the animal-based diet as he showed us towards the end of his lecture there. But, when you look at 1 kilogram of tomahawk steak and you compare that to what he said he used to eat, steamed vegetables, I know what I'd rather.
Well, yes, we won't go there for the moment. Great talk. Really very interesting. I just love these personal stories. Anyway, it's time for our Q&A. Well, another great story.
Good morning.
Hello. How are you, Paul? Good evening.
I'm very well, thank you. So we have, just to introduce everybody, so I'm Paul Mason. We have Dr. David Diamond, or rather Professor. For people who don't yet know him, David is very accomplished in the field of neuroscience, but he's also got a passion for lipidology, and he's very, very well published in this field. And Dr. Nadir Ali, you see in the bottom left of screen here. Good morning, Ali. Nadir. You're a cardiologist, also passionate about lipidology. And as we're also fortunate to have Dr. Gary Fetke from Tasmania up in top left of screen, orthopaedic surgeon, really needs no introduction in the low-carb world, has really made a path for others to follow, like myself. He's taken on vested interests and is still doing so, and is a force to be reckoned with. So welcome all.
Thank you.
So I might just ask for some opening comments if you'd like to comment on something you've seen in any of the presentations thus far, or just a comment that you'd like to make that you think is worthwhile for discussing further today. So I'll start with Gary. Okay, it looks like we don't have Gary. Let's go on to David.
Well, let me just say I have great admiration for the fellow who just spoke, who took charge of his health by adopting the low-carb, high-fat diet, and using Diet Doctor, getting good medical advice. He didn't raise the issue of cholesterol, but we all know that this great concern is that every biomarker moves in the right direction. You lose weight, your blood pressure's down, your blood sugar's down, you're feeling phenomenal. But if that cholesterol happens to tick up, well then so many physicians, especially cardiologists, want to put you on a statin because they'll fear you have a heart attack. And you're at great risk for a heart attack. And I can say 20 years ago, I was a bit heavier and I had extremely high triglycerides and extremely low HDL. And I didn't know much about either one. And in a sense, I wasn't obese. I was about 15 kilograms heavier, about 30 pounds heavier than I am now. But my doctor told me that I increased my risk for heart disease if I went low carb. So, I decided to do the research on my own. And here I am 20 years later. I've improved all biomarkers, although frankly, my LDL is still 200. My total cholesterol is 300. And I happen to be a genetic anomaly. I don't have ideal lipids, but everything else is great. And I think this is something we really need to understand better. And this is why I'm passionate about moving not only I study neuroscience, but I also need to study heart disease for my own personal benefit and from I learned from the three of you. Frankly, I always want to add, I'm in awe of the three of you. Outstanding clinician scientists. I mean, you guys have helped me to learn more about my health, and I'm just really so pleased to be able to share it with everybody else.
Well, thank you, David. So might just have an opening remark from you, Nadir. Okay, you're on mute.
I want to echo what David just said, and I'm just totally honored to be on the same platform as Gary Fetke. I've been a long time admirer of his. He's taught me a lot. I have shamelessly used a lot of his slides, as well as David and you, Paul. And I think that I just want to end by saying that one comment that David Diamond made about people going on a low carb lifestyle, predominantly animal sourced food, with fasting, and they see a skyrocketing of their LDL, and it creates such a conflict between them and their physicians, and it creates a level of anxiety in both of them that this is going to ultimately kill them. And I think that this session is very important to dispel that myth, but also perhaps there are some nuances that we need to get into, in the sense that one size does not fit all. And when we get a chance, we will discuss into the nuances as to which particular person is one in whom we need to be careful and say, hey, just going on a low carb, high fat, animal source diet for you may not be enough. You may need to make a certain few modifications. So we should not make the same mistake that we stereotype everybody like mainstream medicine does into one category. So I hear from Gary next, and from you, Paul.
Lovely, thank you, Gary. Good morning.
Good morning. I don't know what, it's probably still night for a couple of you. Look, Paul, thank you for putting this together. I've watched all of the talks so far, and I've been a seasoned campaigner here for a long time. I've learnt something from every one of you. Okay, and I haven't heard David and Nadir speak yet, but I've seen your past work, your past talks. I've previously introduced Paul at a meeting. I might have been one of the early vocal proponents. I'm not banting. I wasn't around the previous, couple of 100 years ago. But that complex of, refined carbs, sugar and polyunsaturated oils, that's my topic of nutritional inflammation. And what, that's just a big jigsaw. I saw that, and I'm very fortunate to have seen it, and got me into all sorts of trouble. Welcome to Tim Noakes in my life. But what Paul's doing, what Nadir's doing, what David's doing is they're filling in all those gaps in the jigsaw puzzle so that others can see it. And so we're all part of a big team putting together a big jigsaw puzzle to actually clarify what it is for the wider community. And I think, Nadir, what you got right to the point there, that there's so much misinformation out there which needs to be debunked, dissolved, and then re-educated. And the medical community are the first ones that need to be, that to be done by. And that's where Belinda's work comes in, about trying to work out all those vested interests that have actually been responsible for the disinformation, the deliberate misinformation. So look, I've learnt stuff from the three of you, and I'm looking forward to learning a bit more.
Excellent. Well, I think there's probably a couple of topics of discussion that will probably utilise the talents of you three gentlemen. And I think the first, I'll put them out there. So the wider concept is use of LDL as a surrogate marker for overall health, and how that has led to the distortion of nutritional science, where we blame ancient foods rich in saturated fat for diseases of modernity. So I think that's the bigger conversation, of both about saturated fat-rich foods and LDL, and how on God's green earth did we come to assume that people with high LDL levels were perched on the edge of their perch and they're about to drop into the bucket. It just makes no sense. And then I'd probably like to touch on a couple of things just heavier with LDL and some of the root science, while we've got some of the true scientists in this area on the field. And I do actually count both Nadir and David as deep thinkers in this regard. Very few people know as much about the pathophysiology of atherosclerosis and lipidology as you two. And I probably want to delve into some of your comments, Nadir, about the nuances and differences between individuals. And I've probably got a few thoughts on that myself. So I think we might just start with the general concept of use of LDL as a surrogate marker for disease and how that's led us up the garden path. So I might start with you, Gary.
Oh, I thought I'd defer to the other two. Look, I think it started in 1920s, 1930s. I blame the microscope for a couple of things. I blame it for the cholesterol myth, and I also blame it probably for the genetic model of cancer, because that's what you looked down the microscope and they saw. So in those early cases of cardiovascular disease, they looked down the microscope and they saw cholesterol plaques. They were able to start measuring cholesterol. I think it was 1923, David, I think that was about right. So they had something to measure. And so as a result of that, you know, the medical profession love finding things to measure, which you can, and then quantify, and then actually try and come up with a way of treating it. Unfortunately, and you know, I'm not the only person to have used this comment, cholesterol was seen at the scene of the fire. You know, the silly thing is that's part of the cleanup mechanism. Why on earth did we start then blaming the firemen for the fire? And then, you know, and now the concept of cutting funding for the fire brigade to actually treat the disease. So that's, you know, brief history. That's my take on cholesterol from where it started. But as time went on, we started looking to find other particles, and I actually don't like utilising just LDL numbers. If we're going to ever apply anything, it should be a whole lipid subfraction analysis, and then start, you know, delving into that and how that all works. The LDL cholesterol is when they started looking down and saying, okay, which particles within this overall profile could be responsible. And very much like we've now debunked cholesterol as a true marker, we're in that phase now of actually debunking LDL cholesterol. And the thing which comes across most healthcare professionals' desks is that LDL, which is actually not a number. It's actually part of a subtraction equation. And yet we've, you know, the whole industry, you know, that whole, what I call, you know, big public health, you know, pharma, have got an enormous vested interest in finding a criminal, then finding some way of actually demonizing it, and then actually finding a drug to treat it. And as it's turning out, it's not the LDL-C, it's not HDL, it's part of a very complex picture. And I'm going to, you know, that's the brief history of it. We've started, now the entire pharmaceutical industry and medical industry can't actually admit they got this one wrong, to say statins are actually harmful. Imagine the amount of blowback. You know,
let's just pick up that thread for a moment there, Gary. So you've just introduced the pharmaceutical companies and the concept of statins. So some people may argue that it's actually this, I guess, the link, the purported putative link between saturated fat ingestion and LDL that has only been perpetuated because we have a drug to reduce LDL. And in the absence of a pharmaceutical which could be profitable, perhaps there would be less resources thrown at encouraging the persistence of this notion. David, I don't know if you think that would be a fair assumption, fair assessment?
Well, let's remember a bit of history, that long before there were statins, we had corn oil. And corn oil very effectively lowers total cholesterol. Corn oil sells itself. It began in the 1950s with Ansel Keys. And you had this study by Rose in BMJ in 1965, in which corn oil was explicitly used to lower cholesterol, presumably lowering risk of heart disease in men as a secondary prevention. And so corn oil by decades preceded the statins. And you look in the ads right now, corn oil is sold, and they say it's superior to olive oil because it lowers cholesterol more than olive oil. And everyone seems to have neglected that critical study published in 1965, which showed people died at a higher rate taking corn oil, a couple tablespoons of corn oil every day, compared to the placebo.
And this was shown in three. So the Rose study, the Sydney Diet Heart study, and the Minnesota Coronary Experiment all showed that.
Exactly. Right. So, well, there you're exchanging saturated fat for polyunsaturated fat. You're lowering cholesterol, and people are dying. And I believe it was Abramson at Harvard who said, you know, dying with a lower level of cholesterol is not a successful outcome. So I think the industry was there. The food industry was present decades before the pharmaceutical industry. And I have to tell you, in 1984, cholestyramine was given over about 7 years to men who had extremely high cholesterol, probably a good percentage with familial hypercholesterolemia. And in fact, there was no effect because cholestyramine is relatively specific to LDL. No effect whatsoever, no statistically significant effect, but they artificially changed the statistics. They took an 8-band difference out of over basically hundreds of thousands of men in the study, and they created an effect, which then ultimately led to statins and now the PCSK9 inhibitors. So I just want to get some broad perspective that we have industry, including the food industry, selling reduction of cholesterol. I mean, think about it. We have herbs, we have garlic, you name it, Cheerios. I mean, if you look at the box of Cheerios, it's got a great big heart on it, and the ads say you're eating Cheerios because you're lowering your risk of heart disease. And there was some trivial difference in cholesterol in some study, probably run by the Kellogg's, show lower cholesterol. So it's not just medication. It's any food that lowers cholesterol is seen as a cardiovascular benefit. And of course, there are no actual events that have been shown to benefit, but just having this surrogate marker is a great way to market your product.
Yeah, and I guess you made two comments there that was interesting. So one of them referred to, dying with low cholesterol not necessarily being a good outcome. So LDL is a terrible surrogate marker. If we're concerned about living longer, we should actually measure living longer. And the other comment you made was about the replacement of saturated fat with seed oils, polyunsaturated oils. And the interesting thing there is that forever and a day we've been told that ingesting saturated fat increases LDL level. And that's not the correct way to think about it. You stated it just then. Zoe Harcum very eloquently discussed it in her lecture as well. It's not that saturated fat increases LDL. Mechanistically, that's not plausible. It just doesn't happen. It's that plant sterols contained within seed oils lower LDL cholesterol. And for all intents and purposes, as in Zoe's publication when she did a review of the data, yes, plant sterols effectively do lower your cholesterol, but no, they don't help you live one extra second. So I think we actually need to educate people that it's not that saturated fat increases LDL, and I might get your comment on this too, Nadia, but rather that plant sterols found in basically things that don't contain animal saturated fats, that reduces cholesterol rather. So let's actually talk about directionality and causality correctly. Thoughts, Nadia?
Sure. Yes, I would agree with Zoe about her work. And there is a very tight correlation between phytosterols, which is plant cholesterol, and your cholesterol in your blood, because the human body is actively designed to reject a phytosterol. When you ingest a phytosterol, when it gets through the brush border of intestinal lumen, there are mechanisms to spit it back. And you become less selective under two circumstances. One is when you're taking a statin. When you're taking a statin, you're actually reducing cholesterol production and hence LDL export through the liver. And so the body says, hey, I cannot make any cholesterol. Let me start absorbing more cholesterol from the food that this person is eating. And instead of just being able to absorb the real cholesterol, it becomes not less selective and starts absorbing phytosterols. So there is enough clinical in that when you're on a statin, the levels of phytosterol like cytosterol goes up. And the more plant-based food that you eat at that time, the likelihood of phytosterols going up is higher. And phytosterol is not the kind of cholesterol that our cells need, because when it's in our cell membrane, the cell membranes are rigid, they don't function properly.
So sorry, just to clarify, Nadia, so what you're saying is the plant sterols, the phytosterols, they're physiologically incompatible with our human physiology. They don't work in the same way. They disrupt
our normal functioning. Is that understanding that correctly?
Absolutely. There is genetic disorders in which people absorb too much phytosterols. It leads to fragility of the cell membranes. It leads to different kinds of red blood cell disorders. And that's just the tip of the iceberg. The subclinical manifestations of high levels of phytosterols is perhaps atherosclerosis, perhaps degenerative vascular diseases. There is no real interest of looking into it. And so I'm glad that Zoe is bringing that up from a different perspective. I think that the dangers of phytosterols or plant cholesterols should be properly put out for the general public, and we as a community can do that. I'd also like to add a little comment about the LDL and statins and PCSK9 inhibitors, because as Gary pointed out, there is a huge conflict of interest from professionals, from the FDA, from the pharmaceutical industry, from the food industry to promote it. But also, just imagine the collective victory, like David Unwin says, between the patient and the physician. The patient comes back after taking a statin and their LDL levels are 50% low, 60% lower. They both rejoice in that collective victory, which is misplaced. And it feels like you have achieved something. And in that patient-physician interaction, everything is missed. Hey, do you have myopathy? Do you have cognitive issues? Are you heavier now and less active than before? Are you more insulin resistant? Do you have visceral obesity? These are all the side effects of statins that are completely ignored in that encounter between the patient and the physician, between the individual and the healthcare provider.
There's an enormous burden here on the physician to actually say, I'm sorry, I got that wrong. I have caused you harm. And that is a major ongoing problem I see for doctors around the world. Say, oops, I got that wrong. My credentials here, I used to be the cake judge at the hospital, and I got that wrong. I wouldn't take plasters off unless you actually brought me a chocolate cake. I'm sorry, I got that wrong. But the moment you can actually say, I got it wrong, you can move forward. You can, we tell our children, don't tell lies. Yet we see health professionals every single day telling lies. And I suspect more and more of them knowing that they're telling lies, but don't actually come along and say, oops, I'm sorry, I got that wrong. It's a major turnaround time. But as Tim Noakes has said, should not be a single doctor in South Africa who hasn't heard about low carb and the management of diabetes. And I'd like to think the same thing's happening here in Australia, particularly with James Mookie's work over the last year. And it's the same thing's going to will happen with statins. That we, as a health professional, are going to have to say, sorry, we got that wrong. I can't wait.
Well,
if I could
expand,
maybe I could expand on the comments by Nadir as well as Gary. First, just a bit more about the statins. There was a very important paper that was published about a decade ago, and it's been completely ignored. And it was published in American Journal, I believe, Geriatric Pharmacology. And you have 75-year-old people, men and women, all reporting cognitive deficits, all being diagnosed with early dementia. And they all were taken off their statin. And within about 6 weeks, the dementia had dissipated. Dementia was gone. Their cognition improved. And the critical finding is that there was a re-challenge. All were put back on their statin, and all now once again are diagnosed with dementia. All had impaired cognition. And we published a paper that showed, based on FDA adverse reports, that the statins that are associated with adverse cognitive events are the ones that can access the brain, those that are lipophilic, such as Lipitor. So Lipitor, you see far more adverse cognitive events compared to Crestor, which has more difficulty to get into the brain. And we need to understand the brain makes its own cholesterol. It controls the amount of cholesterol it has because the brain needs cholesterol to make new neurons, to make synapses, and to make memories. So when you take a statin that can access the brain and interferes with the brain's machinery to make cholesterol, you're interfering with essential brain function. And I think it's a travesty, actually, that there's been no follow-up study. And that's not cited by the American Heart Association when it reviews statin adverse effects. As well, diabetes is brought up with statins, and this is also minimized by American Heart Association. But I think the best study was conducted by Cederberg, in which they did an RCT and actually had people, none of which had type 2 diabetes in the beginning of the study. 6 years later, the placebo group spontaneously developed diabetes in about 5% of them, and the statin group developed diabetes in about 11%, where it's about 6% to 11%. So there's an additional 5% of people who are developing diabetes, which is associated then with taking the statins. And now, of course, that's increasing their susceptibility to every Western disease. As a result, clearly taking statins. And we know statins interfere with pancreatic function. That contributes then to the increased incidence of diabetes. And if I could also just elaborate, I think Gary made the important point. People started measuring cholesterol in the 1920s. And it is a fact that when you see someone die of a heart attack in their teens or 20s or even 30s, very often they have extremely high cholesterol, and that's became familial hypercholesterolemia. We know they have a genetic disorder in which you have impaired LDL binding, and these people have extremely high cholesterol. So when someone is 25 and dies of a heart attack, they typically have high cholesterol. But we have looked at the literature. We have published papers that show that there is something else that's crucial. The subset of people with FH that are dying young are the ones that have high clotting factors. So there are really two components to FH. There's the high cholesterol, which turns out to be a red herring. What these people, a subset of these people also have, is that they have extremely, for example, high fibrinogen, which you find in non-FH, normal people, as well as FH. And that goes for homozygous FH as well. These people can die when they're 15. But these people have extremely high fibrinogen, which has been ignored entirely. And we compare side by side. This is 40-year-old literature. The subset of people with FH that die prematurely of heart disease are the ones that have more clotting factors. And now those clotting factors I'll add as well.
Sorry, David, I just make the point, just for people who are listening too, that a lot of the data that's putatively used to support the prescription of statins is based on populations that have a disproportionate number of people with familial hypercholesterolemia. This is the prototypical patient who's meant to benefit from statins.
And this is where the great fear of cholesterol comes as well, because these people come into the physician's office and they'll have cholesterol that's 400 or 500. And so they're told you must immediately go on some form of cholesterol lowering medication. But what they should really be looking at are the clotting factors, because ultimately I see the real trigger of heart disease has to do with hypercoagulation. And now what else adds to it? And again, the subset of people with FH have extremely reactive platelets. It's remarkable. You put adrenaline on platelets and what will happen is they will clump, they will aggregate. Well, the person with FH that's developing heart disease is 100 times more sensitive to adrenaline than a normal person, a non-FH person. And so this is where stress connects to heart disease. It is the increase in adrenaline which activates the platelets, which then contributes to development of stroke and heart disease. Cholesterol,
so I have a question
again,
for you, David.
is a bystander.
If LDL doesn't have direct correlation to this thrombotic tendency, this tendency to form clots, then is there anything in the lipid panel, and I'm referring to here what's known as atherogenic, the profile of low HDL and high triglycerides, is that associated with hypercoagulability? And if so, do we understand the mechanisms?
Well, as you've lectured extensively on the small versus the large buoyant LDL, what you find is an association of the small dense LDL with heart disease. And it exists in a metabolism that has the high triglycerides and low HDL. I would say now I'm trying, I think it's a great question. Is a high level of small dense LDL, high triglycerides, and low HDL, is that found in conjunction with elements of hypercoagulability? And I have to say at the moment, I don't think people have looked at that question. There is an insufficient amount of work associating coagulation factors with lipids. And it's really fallen out of favor. The work that was done on platelets in FH individuals, you really have to go back 20 to 40 years. Frankly, there just isn't much money to giving someone with FH aspirin. I mean, the whole industry has gone to giving them statins and the PCSK9 inhibitors. You see almost no measurement of clotting factors. So off the top of my head, I don't know, frankly, I may have published it, but I'm forgetting it. But I don't know of an association of small dense LDL with greater clotting factors or clotting potential, but I would predict there would be.
David,
I would chime in here.
Right.
Go ahead, Nadir.
Ahead, Gary.
No, I was just going to say, which clotting factors would you be doing? Sorry, I'll back up.
Let me just quickly say, the one that's been studied the most, that I'm most familiar with, is fibrinogen. And you see whether it's homozygous, heterozygous FH, or the general population, there is an extraordinary correlation between resting fibrinogen levels and coronary heart disease and stroke, basically from people from 40 years of age on. It is one of the best measures to predict both stroke and coronary heart disease.
Do you think that Lp(a), being a breakdown product of this whole cascade, that could just represent a surrogate marker by association of an increased thrombotic tendency?
Oh, no, really good question. So Lp(a) is actually involved in as a coagulation factor. Lp(a) is very similar to one of the clotting factors itself, and the higher Lpa appears to mimic actually the hypercoagulation effect. And actually, it's not a coagulation factor per se. What high Lp(a) seems to do is reduce fibrinolysis, the spontaneous breakdown of the clots. So it's clearly involved in the hypercoagulation process.
And if I could just ask for an opinion, I've got some perspectives on Lp(a) that are not widely shared. And I'll just, as experts, tell me if I'm barking up the wrong tree here. So a lot of people like to associate Lp(a) with an increased risk of death. And basically what it is, we've got an LDL particle that's got this lipoprotein A attached to it, attached to the ApoB100 moiety that sits in the coat. And we've got a lot of data that suggests that the little a will only attach to B100 if the B100 is oxidized. So in effect, it seems to be that the Lp(a) is representing degree of oxidation. But when we actually measure it, what we really care about is the number of LDL particles that are actually oxidized, and that will be given by the particle count of Lp(a). But when we do the blood test, we don't do a particle count because that's too hard. Well, it's possible. It's just cheaper to do another way. What we actually do, we get all the Lp(a) and we chop it up. And then we assume that your Lp(a) is a certain size, and we divide it by this arbitrary number, and we come up with a result. And we know that the length of this molecule is actually genetically determined. So if you have a genetically longer one, then you'll have a high reading. If you've got a genetically short one, you'll get a lower reading. In effect, it'll be false negative results. So people are correct when they say it's genetically determined in terms of volume. That is absolutely true. But in truth, the factor of this measure that confers the risk is the number of attachments, the number of LDL particles which have the Lp(a) associated with it. So, and until we start doing quantitative measures where we actually count rather than guessing at what people's genetic Lp(a) size is, the test is always going to be unreliable.
Go ahead, Gary.
I can remember that conversation on a phone call with you some months ago, Paul. I still didn't quite understand it fully. But again, we're caught up with doing tests and trying to find surrogate markers to support an industry where I think we've just gone down the wrong path. And, because what we're talking about here is, a first world problem of being able to test this material. And it becomes interesting when the big picture stuff is if we could get 50%, 90% of the population to reduce their ultra-processed food intake, then all these things will align. And I'm fascinated by the topic, but I'm also caught up with which tests are we going to do, which ones can we apply when we've got a finite resource. And I'm still caught up on the whole inflammatory model of cardiovascular disease. And I think you're right, it's about the oxidized amount. But how do we measure it and then extrapolate it backwards to preventative health measures?
I'll yield to Nadir if you would like to comment, but I also want to comment on this.
Go ahead,
I'd
David.
like to make 3 comments here. I guess I am not. Are you able to hear me?
Yes.
I'd like to make 3 separate comments out here. So number 1 about the hypercoagulable aspect that you talked about with high triglycerides and low HDL. And I'm not sure that we really need to invoke that at all, because a high triglyceride, low HDL, a high LDL small p is a very hyperinsulinemic situation, which is causing hypertension because high insulin causes blood pressure, it causes microvascular damage. So you're getting vessel wall damage that is then going to lead to atherosclerosis. So it's not necessary to invoke a hypercoagulable state in a disordered lipid metabolism that Gary has completely pointed out. We were not genetically designed to eat this much of processed food that has led to that. The second point that I would like to make is that either LP or LDL as a culprit in anything. I want to have a paradigm shift in the thinking of all physicians, all healthcare workers, that LDL is a molecule that comes in to dampen inflammation, to protect us from injury. So it is a firefighter, it's not an arsonist. And even oxidized LDL, because if you look at LDL, it has a high amount of many antioxidants, CoQ10, vitamin E, the phospholipid membrane. These are all trying to dampen inflammation at a site of vascular injury, and to consider that as a culprit, or even consider LDL as the culprit, is wrong. And the way the body clears the oxidized LDL is very different than how we clear a regular LDL through the LDL receptor. The oxidized LDL is no longer recognized by the LDL receptor. It goes completely different channels, like through the macrophages, so that you are clearing away a molecule that has done its job in protecting the host. Finally, with regards to Lp(a), it has several of these kringles which dampen fibrinolysis. And the information about Lp(a) is perhaps as contextual with inflammation as it is with LDL. In the setting of inflammation, this is perhaps a molecule that is increasing coagulation and perhaps contributing to some aspect of vascular disease.
Sorry, just to interrupt there, Nadir. Just to clarify, so when we're talking about fibrinolysis, we're talking about the breakdown of clots that are already formed. So this relates back to what David's already said, that saying it's actually the prothrombotic or the tendency to form blood clots that appears to confer risk to those with familial hypercholesterolemia. And what you've just told us, Nadir, is that this LP little a appears to actually impair the body's ability to break down clots once they're formed. So, you know, whether this is a problem of excessive clot formation or deficient clot breakdown, either way, the problem is the same. We end up with too much clot. Carry on.
I agree. But if you follow some of the work that Siobhan Huggins has done, that is perhaps more potent antioxidants that we have. And it's present at the site of injury not to cause trouble, but to dampen inflammation and repair the tissues. And it's a paradigm shift that the whole medical field needs. And owning up, like Gary says, that I am so sorry that for 50 years I have led you down the wrong path. We need to have a completely new thinking about what the lipoprotein does for the human body.
If I might add as well, the cardiologist, certainly not Nadir, but your typical cardiologist views LDL, and I've even heard this, as a toxic molecule, that it is an atherogenic molecule. The immunologist views LDL as a crucial part of the immune system. LDL basically is used to eliminate pathogens, viruses, and bacteria. It's the savior for the immune system. And it's represented best when you look at elderly people who are 70 years of age, who have astronomically high cholesterol, have a 40% reduction in death. Overall, all-cause mortality in the next 10 years, from 70 to 79, they're significantly less likely to die. And overall, people with extremely high LDL have a lower rate of death after their age of 60 years. And we publish part of this, and this has actually been published, genetically confirmed FH. People have a lower rate of all-cause mortality, primarily because they have a dramatically lower rate of cancer and death from infection, and they have an average rate of death from heart disease. And here you're looking over decades. So LDL, there's nothing evil or inherently atherogenic or harmful about LDL. Now, when Gary mentioned markers, I do think markers are very important. Markers helped me to realize that my diet was off because my triglycerides were too high, my HDL was too low. And so therefore I learned how to change that with diet. I've learned from Paul so much about, you've lectured on the small dense versus large point LDL. I think it's important to know your small dense versus your large point LDL. Are you type A or type B? Because I think that you don't want to take medication to change your small dense or large point. You need to change your lifestyle. So those markers can tell you if your metabolism is off. If your blood pressure is high and your blood sugar is high and your small dense LDL is high, well, that's telling you to change your lifestyle. And I emphasize to people, good health is not in a pill. What you got to do is change your lifestyle. So I do think there's value to the markers. And I think the LP little a, by the way, there's just not enough measurement of LP little a with low carb diet work. I know of only one study by Jeff Volek in which they measured LP little a with people before and after they're on low carb, and it dropped. It dropped significantly. But that was not ideal because it wasn't terribly high to begin with. But I do think that's an important marker if we ultimately get back to, again, coagulation, potentially along with inflammation as a trigger for atherosclerosis.
Look, I think some important points there. So first of all, you're saying it's the bigger picture of risk assessment, which is exactly what Gary started off by saying. Agree with that. the LP little a reducing on low-carb diets, I see that in clinic all the time. I guess the key is that you need to see the trend, because if you just have a single value, you don't know how much of that value is genetically determined and how much of that is oxidatively determined. If you have a trend, then at least you'll know if you're getting better or you're getting worse. So that's what how I cancel my patients. I cancel them that if you want an LP little a, it's a private test and you're happy to pay for it, sure, I'll order it. But if I have one, I'm not going to tell you what it means. You need at least two. It's a trend.
Right.
Now, I just want to talk about oxidation. So Gary also mentioned oxidation earlier, and we talk about small dense LDL and glyco-oxidation stress. And it's my personal belief that oxidation is actually the root cause, as closer to a single root cause of atherosclerosis as we can be. And it may even be that it leads to an increased thrombotic tendency, as you've already discussed, David. So if we have a condition like Gilbert syndrome for an Aussie, or if we're a little more educated, we call it Gilbert syndrome. This is a condition where we have elevated levels of bilirubin, and we call it a syndrome, like it's a disease. And bilirubin is a potent antioxidant. And it just so happens, as I'm sure you're all aware, that people with Gilbert syndrome have approximately a 50% reduced risk of heart disease. And I think, if nothing else, this really should lead to food for thought. Why exactly does an elevation of a potent antioxidant reduce our risk of dying of heart attacks? And I guess on the flip side of that, I've also made the observation that when I have people come in with terrible LDL profiles, they've got horrible amounts of small dense LDL, and they've often got very high triglycerides. I noticed that they had very high levels of ferritin. And I thought, well, what goes on here? And then I look in the literature, and as you're probably very well aware, hypertriglyceridemia completely associates with a condition called hemochromatosis. So I looked into hemochromatosis a little bit more, and I actually was educated by my good friend Pran Yoganathan, and he told me about the genetics of hemochromatosis. This is a gene that increases iron absorption into the body. And it appeared to be selected for evolutionarily when societies went to grain-based agriculture. They went away from these iron-rich animal-based diets, evolutionarily appropriate diets, and they started consuming iron-deficient grain-based diets. And it appears that about that time in populations all over the world, when that transition was made, there became a positive selection pressure for these genes, the HFE1 gene, hemochromatosis genes. And there's literally hundreds of these genes that have been described, although we generally think about them
around the Mediterranean.
Particularly
around the Mediterranean.
So this gene is, you're not getting something for nothing. That's the whole principle of these genetic changes. So if we're absorbing extra iron, we've always assumed that iron, we know, has oxidative capacity. But if you're absorbing extra iron, at what expense? At the expense of what else? And two things that share the same transporters as iron are zinc and copper. And as you know, David, and I guess Nadia as well, you've probably read the literature, you've read it as well as I have, that copper is a stabilizing influence on iron. In the presence of copper, iron is much less oxidative. And it's actually been shown that when LDL that's exposed to both iron and copper doesn't really oxidize, but if you expose LDL to iron alone, in the absence of copper, then it does oxidize. So this association that I frequently see, and the reason I'm saying this, Nadia, is you talked about the nuances of some people who need different management strategies. They're not responding in the same way as everybody else on a standard diet. If you're hemochromatosis, the problem is not an excess of iron, it's the fact that your iron is not being stabilized by copper. It's a relative copper deficiency. And we know this to be true because when we venesect people, we take blood out of them and bring their iron levels in their stores, what we call ferritin stores, down to below normal levels. They still exhibit increased oxidative stress. So I might throw it open to discussion. So my personal belief is that oxidation stress is the root cause of atherosclerosis. And if we were trying to target something as a root cause, that's where we go.
I couldn't agree more with what you said. Go ahead, David.
Go ahead. Well, I'll just add, I think there are numerous root causes of heart disease. We should also consider glycation as, in a sense, a damaging of proteins all over the body. It's most obvious when we look at glycation of hemoglobin, but glycation, as far as I understand, is about one of the only non-enzymatic reactions in the body, that the glucose molecule literally can attach to almost any protein in the body. And that's what we're measuring with A1C, is the glucose attaching to hemoglobin, which is also why you see proteins degrade all over the body. And of course, you're experts. This is why people with diabetes have so many diseases, because their proteins are damaged by glucose. And so you have glycation of LDL as well. You have glycation essentially of so many different proteins. And as I understand it, the worst possible combination is called glycosylation. You have not only oxidation of molecules, you will have glycation of molecules. And so this is really the worst possible metabolic scenario, in which you have essentially a defective home with gasoline poured all over it, and it isn't much to light a match and have that home burn up even more quickly. So I would agree with you, although I don't fully understand how we increase oxidative potential. Let's connect that to lifestyle. But what's very clear is we know how we increase glycation, and that's with chronically elevated glucose.
And what I'd like to add about the nuances.
Go ahead, Nadir, you're on mute.
Yeah, what I wanted to add about the nuances was a slightly different scenario. And that scenario is one of a person who comes in who is severely insulin resistant, hypertriglyceridemic, with significant amount of visceral obesity. And these are the people that I get a little concerned about when I tell them that, hey, I want you to go to a low carb, high fat diet. And the reason for that is that their fat cells are already overstuffed and filled. They have visceral obesity. They are not programmed in that metabolic situation to handle the amount of fat that we give them a license to eat immediately. So these are the people I would say that, hey, look, at this time, you're perhaps better with a low carb, sort of a low fat diet if possible, mostly lean meat and lean protein, with a huge emphasis on fasting. Because if you're not emptying your fat cells, if you're not removing fat that has accumulated in your pancreas, then adding more fat would add a little bit of fuel to the fire, that you're not going to get metabolically healthy, because that is where you would get into lipotoxicity. And that is the kind of modification that we need to make. And many of these patients come in, and I think that as humans, we are genetically programmed to overeat even the good stuff, even meat and fat and animal sourced food. And I have had a number of patients over the last 8 years who are not able to lose weight, able to get metabolically healthy. And these are the people who need hand-holding.
Sorry, I'll just interrupt there, Nadir. So can you just elaborate, when you say we're genetically programmed to overeat, could you just elaborate on that in the context of we don't really see obese animals in the wild?
Well, obesity happens whenever there is significant availability of food in a situation of a modern society. And humans are, if you look at our genetics, and I've just recently done work on this, as soon as we start eating, our ghrelin levels go up significantly. They peak within a few minutes. Even the thought of food starts the rise in ghrelin. And ghrelin levels do not come down, and this is the hunger hormone. it does not come down for over 1 hour. And I have observed this not only in myself, but in several of my patients. They come in and say, hey, I have eaten and I know that I'm full, but my brain tells me that I still want to, I have a desire to eat more. And that desire will not be present in an ancient world in which you don't have a supermarket and a fridge, because there was not a guarantee that food would be available to us all the time. And because of that, most animals were designed to overeat when food was available so that they could survive through periods of scarcity. Humans are also programmed like that. And we live in a very different conditions than our ancient ancestors lived. And perhaps some of us are genetically more susceptible to overeating than others. And that's the kind of group that we need to advise better. And we shouldn't tell them that, hey, look, we told you to do something, you're just not doing it right. Because as clinician, I come across many patients who say, I have done everything that you told me, but I'm still not successful. And I think those are the people in whom we need to program them to say that, hey, you are genetically designed to overeat. You need to somehow figure out how you can program your brain to eat the right amount of food.
I would like to comment. Or go ahead, Gary.
Paul, just coming back to your previous sort of comment, question, statement. I've come from the back. My whole background in nutrition now, I suppose, has been based on this inflammatory model of modern disease. That inflammation sits behind it as the root cause, and that's why I took a different tack with my talk yesterday, which was really to actually say, let's take an academic argument to say what is the toxic dose of carbohydrate, because glucose and fructose, the body does everything, rather than seeing them as actually positive things, think about them, why the body does everything in its ability to get it out of the bloodstream right from the word go. So before there's oxidation, David's quite right. The moment blood glucose goes up, you have to start getting glycation of proteins, and those proteins are throughout the body. And they're the damages that's occurring to the glycocalyx within seconds and minutes. It's got nothing to do with oxidation and inflammation. The oxidation is a secondary process, but that's what I found fascinating, is that we know that the direct causes of fructose, and it's been widely described, and Robert Lustig's seminal work there based on who's the guy in Switzerland? Got a blank on his name. It'll come back to me. But essentially, there are direct toxic effects of glucose and fructose, which are there on our tissues and particularly on our blood vessel walls, on the glycocalyx, within seconds of it hitting it. And the oxidation, which is the secondary effect, I think is, so it's bloody complex in Australian terms, but literally it's not just oxidation, it's not just glycation. It's, it's clearly tied up with the excess of processed food since the onset of the agricultural revolution, compounded by the industrial revolution, and now what I call the processed revolution. And it's almost my closing statement for you.
David?
So I do want to comment on Nadir's perspective. And I am obviously, I'm not a clinician. I don't see people having difficulty with low carb. This is based solely on my reading of the science. And we go back to one of the first low carb trials, which was run by John Yudkin around 1960. I believe it was Yudkin. And he said it should not be called a high fat diet, because when they monitored what people ate, they found that what really happened was they lowered their carbohydrate consumption, and they actually ended up eating about the same amount of fat that they had consumed before. And when you look at the methods of virtually every low-carb trial, people are not told to restrict calories. They're not told to restrict fat. They're told to restrict carbohydrates. And what you find is a spontaneous reduction of total calories. You find relatively stable fat consumption, and the real reduction, not only in a meal from carbohydrates, when you monitor calories over a 24-hour period, you find that despite the fact that people are told you can eat as much protein and fat as you want, people actually overall consume fewer calories. So your concern that people would eat too much fat, at least from the literature perspective, is that generally doesn't happen when people go low carb, unless they're attempting to go out of their way and gorge themselves with fat, which really is inappropriate. The other thing is there are mechanisms that come into play, and clearly there are genetics involved here that produce this powerful satiety. The reason why people eat less on low carb is because, and it does take a half hour to an hour, I feel it myself, after a meal of protein and fat, it almost feels aversive to want to eat more, and that lasts for many hours. So there's a powerful satiety trigger that's involved with consuming fat and protein. So I don't think, in general, that your concern about too much fat consumption is warranted. I think when people naturally cut back on their carbs, especially if they're going ketogenic, then they will naturally also restrict fat from being overly consumed.
Well, if I can...
let me just add one more thing. Yes, people will plateau. And I think at that time, intermittent fasting may actually help to boost to get to a newer, lower level.
Thank you, David. So I have to say, I agree with both Nadir and David on this one. So how on God's green earth can I do that? Because I have two types of patients. I have patients that follow the science perfectly, that show that when you eat to ad libitum, basically eat as much as you want, but eat healthy food, your appetite is incredibly well controlled, and bang, you lose a huge amount of weight. And on average, we know that these patients lose so much weight that on average, in any study you do, which we've seen time and time again, the high-fat diets are superior to low-fat diets in terms of weight loss. And that's been proven, in, as far as I know, in every single randomized controlled trial that compared two diets head-to-head. Now, but what Nadir is talking about is these patients who still overeat, and there still are those. And I believe that we need to distinguish between what's hunger and cravings. So we also have addictive type of eating behaviors, and I'll just discuss it briefly now, is that often one thing that carbohydrates and food does for us, and I'm sure you've read the book, Salt, Sugar, Fat, these great book about the bliss point of food and how the modern food industry manufactures food to be incredibly rewarding. What does that mean in a chemical sense? That means dopamine in the brain. Now, humans are hardwired to want dopamine. Human survival is predicated on behaviors that release dopamine into the brain. This includes procreation. This includes eating. We are literally hardwired for this. So if we have any issue within our physiology that precludes us from producing dopamine or other neurotransmitters at an appropriate level, we're going to have a deficiency and understand we're hardwired to chase these chemicals. So what could cause deficiencies of these chemicals? Well, if we call them catecholinergic neurotransmitters, there's dopamine, there's serotonin, and there's noradrenaline. And they all require nutrients like vitamin B12. And so if you're deficient in that for whatever reason, be it an autoimmune condition or just say a vegan diet, then you'll have lower neurotransmitter levels, you'll have lower dopamine levels, you'll have this drive, you'll to eat foods when you're not hungry, because you're not chasing hunger, you're chasing dopamine release, you're chasing that warm embrace that sweet foods and carbohydrates give you. Chronic inflammation, because it sequesters iron in ferritin stores and makes it unavailable within the serum for use. So yes, the amount stored in your body goes up, but it's not available to be utilized. We know that when we inject people with inflammatory chemicals, we can halve the circulating iron by 50% in 2 hours' time. So people with chronic autoimmune inflammatory conditions find that they have this functional iron deficiency, and iron is a necessary cofactor for the synthesis of these chemicals. And in that situation, if you're deficient in neurotransmitters, then yes, of course, then you will eat something sweet. You're hardwired to chase these chemicals. And then just as an aside, people are wondering, well, why don't we just take antidepressants? Because antidepressants, the way they work, they don't increase the production of these chemicals. They just preserve what's there for a little bit longer. But if your production is really clapped out, then, you know, just because you preserve a little bit longer doesn't count at all. So that's why the science is absolutely correct. We do know that deficient neurotransmitters is the underlying pathophysiology of depression and anxiety. It's just unfortunate that the drugs we give don't treat the root cause of it, which is usually, it can be nutrient deficiency, it can be chronic inflammation, so on and so forth. And that's why, you know, these drugs are only effective for a small minority of people when we actually look at it. But when we treat people's chronic autoimmune inflammation, their mood often significantly improves. So I'd suggest, Nadir, next time you're having these patients who are overeating, don't just look at it in terms of an energy in, energy out perspective. Maybe consider it from a neurotransmitter perspective. So I can actually do serum serotonin levels on my patients, and I actually see that when we treat them over time, that their serotonin levels actually increase. And they've done studies in patients with celiac disease where they've actually taken the fluid from around their brain. It's called a lumbar puncture, and they take the cerebrospinal fluid, and they've actually found differences in the serotonin level when they're on a gluten-free diet or when they're not on a gluten-free diet. So this is absolutely a very real construct.
Let me elaborate on what you just said, Paul, and lead to a question for Nadir. So you're absolutely right that sweet foods, and actually the combination of sweet and fat, is powerfully rewarding and has been shown to increase dopamine. The dopamine actually increases in anticipation of eating the food. That's part of the craving. But what I would predict, and I ask this of Nadir, is if you eliminate the sweet foods, which is the essence of low carb or even ketogenic diet, what I would wonder is in your patients that are failing to lose weight, that are overeating, are they actually producing ketones? Are they ketogenic or are they cheating? And so if they're eating a combination of carbs and fat, that's going to interfere with their weight reduction. My prediction is I would be surprised if they're producing ketones and they're saying they're overeating.
So absolutely, I listened to all of your comments, but I was talking about a specific subset of patients, and to these patients, we advise them bulletproof coffee with high amount of heavy whipping cream, fat bombs. And these people are already hypertriglyceridemic. They already have stuffed fat cells. They have visceral obesity. Their pancreas is not talking properly because the insulin producing cells do not actually communicate with the glucagon producing cells. So in these people, even though you are making ketones, you still have high triglycerides, you still have high sugars, because even though they eat a protein-rich meal, their insulin goes up, but their glucagon skyrockets. And when glucagon skyrockets, it's converting all the protein that you have taken into glucose. So there is a subset of patients who are insulin resistant. And one of the things that we need to recognize is that years and years of insulin resistance and visceral obesity causes a fatty pancreas, and that fatty pancreas is unable to correct metabolism properly without some degree of a fast that removes fat from their diet. So that's the group of patients that I deal with, and I think that we need to advise them differently.
Can I put that in lay terms to summarise? This is my take on what you've all said, and obviously it's my opinion, so apologies. When you take modern food, particularly sugar, fructose, glucose, and refined carbs and polyunsaturated oils, that has significant behavioural change. It drives behaviour. When you reduce that, particularly the sugar component, you allow people to eat to their nutrient requirements rather than their caloric requirements. And so once you actually, I'll use the pizza example, you can have an enormous amount of pizza, it's got all sorts of colours. It's got an enormous energy requirement, but it hasn't fulfilled any nutritional requirements. or not to a requirement. So what do? You want to eat another one. So the take-home message for me is when you reduce processed food, particularly the sugar, particularly that fructose, you then start eating to your nutrient requirements. Your body will tell you you're hungry. You've stopped that overeating. And on the majority of people, and I agree with you, Nadia, there's a whole subset of people that doesn't work with, they end up reducing their caloric intake. So you've got a lower caloric intake. So it gets said, oh, low carbs, low calorie. It's low calorie because you end up there.
Okay, so I think that's
Paul. Oh, sorry,
David,
go ahead.
carry on.
Well, I did have a question for you. Oxidation. I haven't seen a lot of work on how we either increase or decrease oxidation of our molecules, particularly LDL or any other molecule. So how does lifestyle, or how does low carb diet, how does sugar specifically affect oxidation? And are there studies showing that low carb will actually change oxidation in general? And how does one measure it as well?
Okay, so I'll be brief because we're getting a bit long in the tooth here. So first of all, it's very difficult to tease apart sugar and oxidation. So we use the term glycooxidation to reflect what happens to LDL particles, where we use them almost interchangeably because fluctuating blood glucose level generates oxidative stress. This has actually been shown. So when we measure people's blood glucose trace, people with an average blood sugar level, even if it's higher, if it's stable, they'll have lower oxidative levels circulating than people who have an up and down one. So and I have come across the mechanistic data having a look at mitochondrial metabolism that shows that the fluctuation in fuel supply, high glucose, low glucose, actually leads to the mitochondria actually generating extra reactive oxygen species. We also ingest a huge amount of oxidation, so we can actually, when we absorb lipids, when we absorb fats from the diet, so when we're consuming seed oils, by definition of them having double bonds between carbon atoms that are prone to reactivity, we're ingesting oxidation products. And these get directly incorporated into our chylomicrons. So if we did a non-fasting blood test, and there's been studies that have actually done this, and we actually measure the level of oxidation being incorporated into the chylomicrons, we actually see people who are ingesting seed oils are actually ingesting oxidation products. These oxidation products eventually find their way to the liver. We've got mouse studies that show that when you deliver oxidation products to the liver, it actually causes fatty liver disease, which is then sequentially leading on to insulin resistance. And as you talked about before, Nadia, all these other things on insulin resistance and all of that, well, these are all very interconnected. So we've got I think quite a convincing amount of data that oxidation is both sugar related and seed oil related. And then to add insult to injury, they did a beautiful study where they actually gave people oxidized oils. And when I say oxidized oils, that could be any seed oil because they're all oxidized, I promise you. There's no way you can stop them from oxidizing. It's a chemical reality. And they actually had people in three groups. So non-diabetics, well-controlled diabetics, and poorly controlled diabetics. And then they measured the level of circulating oxidation products within their circulation. And they found that for the well-controlled diabetics and the non-diabetics, they had quite low levels of oxidation products that were pretty much cleared from their circulation within about 8 hours. For the poorly controlled diabetics who had these higher up and down levels of blood sugar, their oxidation products persisted for 3 days. So it is absolutely the interaction between the two. And I was perhaps being a little bit mischievous before when I just mentioned oxidation in isolation. Of course, sugar control is absolutely important. And the reality is we can't tease them apart. In effect, one can cause the other.
Right. I knew you were being naughty, okay?
So, look, I'd just like to, a couple of comments. So Amber Ahern, who is absolutely fabulous, one of the most creative thinkers I know, has made the comment that plants are largely treated as toxins by the human body, and that relates back to the original comments about plant sterols. They're really not a part of mammalian physiology. I think it's important that we don't forget that. We're probably running over, so just to answer one question here from another favourite person of mine, Dave Feldman. Have we seen much CT angiogram data on our lean mass hyperresponder patients thus far? So I don't know, Nadia, talking about, I guess, the lumen, the size of the opening in the blood vessels, and whether we have any coronary artery calcium score data, have you seen what progress have you seen in your patients in those metrics?
So I can only give anecdotal information. I have not seen large studies in this anywhere. And I think that we are being overtly simplistic by saying that when you go on a low carb diet, your triglycerides fall, your HDL increases, your LDL increases. And by the way, the inflammation markers like CRP and GGT and serum ferritin go down. And this has been shown not only in many clinical trials, but also in my practice convincingly. And we would expect that this group of people, the lean mass, the so-called lean mass hyperresponders, would have a stability in their calcium score. Either they will remain zero, or if they were at some level, that they would not progress. And the important aspect here is to recognize that after having done CT calcium scores for about 5 years, in my clinical practice, I still see a subset of people progressing. Their calcium score increases. And that is where I want to make a very important comment, that human biology is inherently very complex. And when you are dealing with complex systems, an outcome such as coronary calcification is inherently unpredictable, because it's not just LDL and our metabolism that's going to lead to coronary calcification. It's going to depend on how well we sleep. What is our stress level? Are we exercising to a level in which we are not causing a heightened adrenergic state? Is it an optimal level of exercise? So there are several different variables that would cause vascular disease. And for us to be just simplistic and say that we have the ultimate cure is wrong. I think it's part of the puzzle. I would much rather be having high LDL and low triglycerides and high HDL and say, yes, I'm going to protect my coronary arteries. But to say that that is the sole answer would be wrong. And if we see a group of patients who are low carb and lean mass hyperresponders, and that they have a slight increase in their coronary calcium, we should not think that that is a failure. We just are dealing with a very complex biological system with an unpredictable outcome.
Thanks, Nadia. And just my own experience, like Nadia said, some people don't do well, some people actually progress, and they're the fun patients, because then we get to work out, are these the hemochromatosis patients? Do they have thrombotic tendencies? We need to work out why. Having said that, I've also seen people reverse, and I recently had a letter from a cardiologist advising me that there was a mistake with the patient's coronary artery calcium score because of the degree of reduction in a short period of 2 years. So he was actually trying to have it repeated. I have followed up on that recently, and as it turned out, it wasn't a mistake, and it was certainly eye-opening for this cardiologist. So I might just take some closing remarks, beginning with Gary.
I'm humbled to be part of All Stars International. Look, Paul, you put together a great show. I've listened to all the talks yesterday, so far today. I'm still learning, okay? And that's the important thing for all of us. We are all still learning. We don't have all of the answers. I think we're in the right direction. Thank you.
David?
Just one fact, just to add on the coronary calcium, is menaquinone, vitamin K2, is very well associated with coronary calcium. So it appears to interact with vitamin D, and making sure that the calcium is directed to the bones and not to the arteries. I also want to thank you, Paul, for putting this together, and I expect to watch all the talks. Ultimately, I assume that they'll be recorded and available. I'm honored to be with the three of you. Absolutely astounding. I have learned so much from you and from so many other people. And perhaps as a scientist, I've been a scientist for 40 years, and I never had any controversy being a neuroscientist. But one thing I think does come across in my talks, my entree to cardiovascular disease research, I sometimes that antipathy I feel anger, and it comes across because I see how the field has been tarnished. People have been misled in this field in a way that I never knew. Even I had pharma funding in my neuroscience research, but to me there was nothing like the way the American Heart Association has been in bed with pharma, and they have such a great control, such a great influence over how people are treated. And this really comes across in my writing and in my talks. And I guess it's fortunate I'm not a clinician. I just get to say what I want, and I give no advice, just information.
Thank you, David. Nadia?
Well, I'm simply honored to be on the same stage as the three of you. And it's a dream. I have to pinch myself that I'm actually on the same stage as all of you. My final comment that I'd like to make is that the change that Paul is so strongly trying to create through this conference and others, and I'm going to enjoy all the talks that have been put out, is actually should be directed as a grassroots effort. And the grassroots effort is what's going to change medicine. This is not going to come from top down. There is way too much money in and conflict of interest for physicians and major organizations to admit that they got the whole paradigm wrong. They're going to be forced to think in that direction from the work of Paul, from the work of Gary, in which general public is being educated and the gap between the so-called academicians and the general public is narrowing. So I applaud you for doing what you're doing, and we should continue our efforts.
Well, it seems that we've got a mutual admiration society all around here. Look, I'm truly privileged to be able to count you as friends. I genuinely appreciate your time for both your lectures and for participating in this panel. And I actually thoroughly enjoyed this discussion. And I absolutely know that we're going to be having a lot more discussions. And I'm hoping that we'll be able to collaborate on some future writings together as well. So I'll definitely be in contact. But thank you. Look, you have my sincere gratitude. Thank you so much. And back to the program.
Thank you.
Thank you.
Thank you.
Well, welcome back to Low Carb All Stars 2021. And for some reason, there's only one person on this program who gets to speak twice. Now, maybe they had some influence over the program. Anyway, Dr. Paul Mason.
G'day, I'm Dr. Paul Mason. I hear many people who believe that their doctors deliberately provide them with misinformation about nutrition and drugs. Do many provide poor advice? Yes, but not deliberately. It might surprise you, but even doctors have trouble navigating the maze of misinformation when it comes to separating fact from fiction. Last year, I received this email from a colleague. The medical group she belonged to was actively reviewing her prescribing habits to make sure that each and every one of her diabetic patients was on a statin. In effect, she was being pressured to prescribe statins to all of her diabetic patients, despite her belief that many of her patients would not benefit from this. So she went looking for the evidence, actual scientific papers that would answer this question. And she came across this, an expert review paper which strongly promoted statin prescription for diabetics. And there was no two ways about it. Statins were unambiguously recommended. Basically, it was claimed that taking statins would help diabetic patients live longer. And so she asked me if I could explain the conclusions of this review. And there were 6 references cited in support of the claim. So I went and had a look at each of them. And the first thing to understand is that for a study to make a claim about something like mortality, it has to actually study mortality. Pretty obvious, really. And 3 of the 6 studies cited fell down at this first hurdle. This expert review paper cited them to support something they didn't even look at. And the other 3 studies did measure mortality, but they didn't get statistically significant results. In other words, the findings could be explained by random chance alone. Not the kind of findings you should be using to determine whether or not a medication is prescribed. Especially a medication that can increase your chance of developing diabetes, as was found by the Women's Health Initiative study. They actually found that the risk of developing diabetes increased by 71% in those taking statins. The recommendation to use a drug known to increase the risk of diabetes and worsen sugar control in those already with diabetes is nothing short of extraordinary. The evidence cited to support this recommendation was anything but. Despite this, this paper has been somewhat influential, having been cited 69 times in the peer-reviewed literature, and this illustrates a major problem in medicine today: eminence-based medicine, where expert opinion is relied upon, despite often being no more than perpetuation of long-standing myths and falsehoods. Basically, those in positions of authority at venerable institutions exert an undue degree of influence over general opinion. Eminence-based medicine, it should be said, is the direct enemy of evidence-based medicine, which is based on critical appraisal of the best available science. Now, coming back to the email, this doctor was clearly trying to do the right thing, and she knew enough not to necessarily trust expert opinion. Many doctors, however, aren't aware that they've been misled and fed falsehoods during their training. The fact is, even in 2021, most doctors still believe hook, line and sinker the nutritional falsehoods that they've been taught. I saw this myself when I gave a group of junior doctors a short test on nutrition, and they were outscored by my receptionist. And if this reflects the nutritional knowledge level of the average doctor, what hope is there for the general public? They might, for instance, be guided by the food star system, not understanding that it is an absolute joke which is being gamed by industry. Take this cereal, which contains 17% sugar, and scored 5 stars, while this salt-cured salmon scored just 1.5 stars. Is it any wonder people make bad food choices? And just as the public can be misled by the food star system, doctors can be deceived by a lack of openness and transparency in the reporting of data. You may be familiar with the Women's Health Initiative study published in 2006. This massive study of over 48,000 females cost $700 million US. It was designed to definitively determine whether or not low-fat diets benefited health. Well, that's not exactly true. You see, the investigators already held the view that low-fat diets would be beneficial, and all they really wanted to do was to prove their hunch. To do this, participants were randomized to either a low-fat or a regular diet and then followed up for about 8 years. Given the size and prominence of this study, its results were published with great fanfare, the lead investigator going on record as saying the findings demonstrate the need, indeed the benefits of dietary reductions in fat even greater than the 8 to 10% studied. Except the results showed nothing of the sort. Not that you could figure it out if you read the results table or the conclusion. No, to get to the truth you had to go to page 661 of the journal in which it was published, and there, in obscure text, was the only statistically significant finding of the whole study, the only finding not likely due to chance alone. The finding was that those randomized to the low-fat diet did worse. Those with a history of heart disease who were randomized to the low-fat group had a 26% higher chance of complications, like heart attacks. How was this finding from a publicly funded $700 million study kept hidden from public view? How were the researchers able to conclude that this study didn't just support low-fat diets, but supported low-fat diets even more extreme than what they studied? The way the results were presented was flat-out deceptive, leading doctors and scientists and ultimately the public the world over to believe this study provided evidence for low-fat diets. You may have also heard of the Sydney Diet Heart Study. a good quality randomized controlled trial examining in men who'd had heart attacks the effect of replacing saturated fat with polyunsaturated fat, and the result on whether or not this diet actually reduced the risk of death was actually destined to never be published. That's right, it was only a stroke of luck that a researcher uncovered the original study data in a basement and was able to decode it and publish it some 40 years after the study was concluded. And so, in 2013, the results of the Sydney Diet Heart Study were finally published in the British Medical Journal. The conclusion, reducing saturated fat in the diet and increasing polyunsaturated fats increased the risk of death by 62%. This is probably one of the most important bits of research you've never heard about, and truth be told, one that you almost didn't find out about. Now, of course, evidence like this, which undermines the orthodox view on dietary fat, is not going to be unchallenged, and indeed it did face a barrage of criticism, most of it deceptive and irrelevant. The one argument that most often gets repeated is that the 62% increased risk of death was due to an increase in trans fat consumption. Specifically, it is claimed that the margarine consumed in the intervention group was high in trans fat. And for all intents and purposes, this argument is the only justification these saturated fat fearing zealots have for ignoring the harms of polyunsaturated seed oils. This argument, however, is flawed. It comes down to the difference between hard and soft margarines. Hard margarine did, back then, contain trans fats. However, the margarine used in the study was Miracle Brand, a soft margarine, and clearly advertised as such. And soft margarines contained very little, if any, trans fats. And the consumption of biscuits, cakes, pastries and puddings, all of which were often made with trans fat containing hard margarine, was expressly discouraged in the intervention group. Furthermore, safflower oil, which also contains little if any trans fat, was used in the intervention group, further displacing other sources of trans fats. The upshot of all this is that the trans fat intake of the intervention group almost certainly reduced, which leaves us with the uncomfortable truth that the increase in polyunsaturated oils in the diet, as recommended by our current dietary guidelines, increased the chance of dying by 62%, all shown by a good quality, long-term, randomised controlled trial. And the Sydney Diet Heart Study is not the only randomised controlled trial showing the harms of replacing saturated fats with polyunsaturated oils. The Minnesota Coronary Survey, also completed in 1973, was a gold standard, double-blinded randomised controlled trial on more than 9,000 men and women, in which a high saturated fat diet was compared with a high polyunsaturated fat diet. And again, like the Sydney Diet Heart Study, the results were almost lost to history. That is, until, in a striking case of déjà vu, the original study data was recovered and finally published in 2016. And again, the results mirrored those of the Sydney Diet Heart Study, reducing saturated fats and increasing dietary polyunsaturated fats increased the risk of dying. And there's a footnote here. Before his death, the lead author was asked about the delay in publishing the study findings, to which he replied it was because the study findings were disappointing. Clearly, this is not how science should work, and yet it does. We've just seen two egregious examples of where the truth regarding polyunsaturated oils was almost lost to history, simply because the study investigators didn't like the results. Of course, we still face the problem that even when research is clearly and accurately portrayed, that's either ignored or dismissed without foundation. This paper suffers from both. Despite being published in one of the world's most prestigious medical journals, few doctors I speak to outside of the low-carb sphere have even heard of it. And one reason I suspect it hasn't been widely shared and discussed is that its findings effectively demolish the argument that we should avoid saturated fat because it might increase our LDL levels. It found, in fact, that those with the highest LDL levels lived the longest. Much easier to pretend this study just doesn't exist. The thing is, this is actually a systematic review, which included every prospective cohort study available to answer the question of what happens to those with high levels of LDL cholesterol. It didn't involve any cherry picking of the data. All suitable studies were included. In fact, it ended up being 19 prospective cohort studies with over 68,000 participants. And collectively, the overwhelming finding was that individuals with the highest LDL levels live longer. In fact, 16 of the 19 studies found this relationship. The higher your LDL level, the lower your chance of dying. Let's now take a closer look at the data from the individual studies. Different studies are represented by rows, with the 4 columns representing LDL levels. Basically, each column represents a grouping of 25% of the study population based on LDL levels. The left-hand column shows those with the lowest LDL levels, and the right-hand column those with the highest. And the numbers represent relative risk of dying. Numbers less than 1 indicate a reduced chance of death. And if you compare the chance of death between those with the lowest LDLs and those with the highest LDLs, you'll note that higher LDL levels are clearly associated with a reduced chance of dying. This study, for instance, found that those with the highest LDL levels were 34% less likely to die than those with the lowest levels. This study finding a 47% reduced chance of death in those with the highest LDL levels. And as you look through all the studies, you'll note this is a consistent finding. But still some people reject this finding, claiming that reverse causality might be at play. The concept of reverse causality is basically that illness lowers LDL levels, and so that those with the lowest LDL levels simply mean those who are already ill. Indeed, a drop in LDL level in the last 2 years of life is well known in the literature. But this argument fails on 3 levels. First of all, the average period of observation in each of these studies was significantly longer than 2 years, and still those with the highest LDL levels lived the longest. Secondly, even when study subjects with terminal disease, heart disease or diabetes were excluded, there was no change in results, not even a weakening of the findings. This study found about a 50% reduction in the chance of death in the highest LDL group despite these exclusions. And finally, even if we exclude the 25% with the lowest LDL levels, supposedly those with the chronic illnesses, and compare those in the second quartile of LDL levels against those with the highest LDL levels, we still see superior outcomes in those with the highest LDL levels. The fact is, the findings of this systematic review are robust, and dismissing or ignoring the findings is scientifically dishonest. Another common example of what I consider to be an egregious dismissal of scientific evidence is with respect to high-fat diets and weight loss. Between 2003 and 2018, there were 62 published randomized controlled trials comparing weight loss on high-fat and low-fat diets. And of these 62 studies, 31 had statistically significant results, while the other 31 had results which may have been due to chance. And so here, I have graphed the results of the 31 studies with statistically significant results, leaving out the studies whose findings could have been due to chance. The green bars represent the amount of weight loss on a high-fat diet, and the adjacent red bar, the amount of weight lost in a low-fat diet. And if you look at each pair of results, you'll see that those on higher-fat diets lost more weight in all of them. All of them. Not a single study found in favour of low-fat diets. And despite this overwhelming evidence, many doctors still promote low-fat diets for weight loss. This is a copy of the handout one of my patients received from another doctor, specifically recommending a low-fat diet. When doctors ignore science like this, it's no wonder we have an obesity epidemic. And some doctors can't even bring themselves to question their beliefs when they see patients heal themselves in front of them. Take this 71-year-old male patient of mine who, amongst other things, reversed diabetes, fixed his blood pressure, stopped 5 medications and put his inflammatory bowel disease into remission, all with dietary change. You'd think his original diabetes doctor, who was an endocrinologist, would be happy. Well, in this letter to me, his doctor acknowledged that the resolution of his diabetes was likely due to this new low-carb diet, but then proceeded to recommend he resume the exact type of diet he was on when he developed these multiple medical issues in the first place, despite the patient clearly telling his doctor that he had already tried this recommended diet. And for good measure, the doctor also recommended this diabetic patient take a statin, despite having had side effects to one previously. But there is now some light at the end of the tunnel. For example, the American College of Cardiology, once a bastion of anti-saturated fat recommendations and dogma, has now shifted its opinion. In this recent review paper, it is acknowledged that the weight of evidence does not support restricting saturated fat. Indeed, it is explicitly recommended that dairy, meat and eggs be freely consumed. And to understand the significance of this shift, you need to realise that 3 of the authors of this article were on the committee that produced the 2005 Dietary Guidelines for Americans, and that includes the chair of the committee. All we need now is for our guidelines and medical education to catch up, or at the very least for doctors to begin to independently appraise the literature for themselves. Now, for health professionals who do understand the science but are afraid of recommending against the dietary guidelines, you should know something. On page 2 of the Australian guidelines, it is explicitly stated that the guidelines only apply to those who are healthy, not to those with medical conditions which require specialised dietary advice. And I'm yet to meet a medical condition that could not be impacted by dietary advice. In effect, if you're providing nutritional advice to manage diabetes or obesity, the dietary guidelines need not apply. So, if you're confused by your doctor's advice, understand that doctors don't have a monopoly on knowledge. Indeed, my observation is that doctors are at least as likely as everybody else to demonstrate cognitive dissonance when faced with evidence that challenges their beliefs. Don't blindly trust so-called experts. We should no longer confuse eminence for evidence. Only evidence should guide the practice of medicine. Thank you.
Thanks, Paul. It's been a bit of a recurring theme, hasn't it, this weekend, both with Tim Noakes and Zoe Harcombe yesterday, and your talk then about the interpretation of research and of data in particular. And if you wanted to sort of give some suggestions to our viewers about how do you go about assessing a research paper that you might read on nutrition. What are the tricks to determine really what's important and what's not?
I think the first thing I do is I go to the data section. I go to the results section and I actually look at the raw data. The simple fact is if you're relying on the abstract or the conclusion or the discussion, you're potentially going to be misled by the cognitive biases of the author. And the interesting thing is I sometimes find I have to go to the supplementary material. There's often data hidden in supplements to journal articles that for whatever reason, through limitations of space or perhaps just questions of palatability to the authors, they don't make it into the main article. And there's been several instances where I've actually managed to come across some very revealing data in the supplements. But at the end of the day, don't trust the interpretation of the authors in the conclusion and look at the data for yourself.
It's so true. There's such a temptation. We're all time poor. Let's have a quick look at the abstract, go straight to the conclusion, 2-3 lines, sums up the whole thing. And as we've found out from your talk and Tim's and Zoe's, sometimes there's very little relationship, in fact, between the data and the conclusion. So, well done again, even if it was your second talk. Let's go on to our next speaker. It's got an interesting parallel careers, really, in neuroscience and nutrition.
Yeah, so I mean, Professor David Diamond, he's very well credentialed in the field of neuroscience, but he's got a clear passion for lipidology and cholesterol science, and indeed, he's very well published in both fields. And he's very analytical, very insightful. One of the most, he's got an incredible ability to critically appraise articles, up there with anybody else I know. I'm sure this is going to be a cracker of a talk.
I'd like to thank Paul Mason for organizing this spectacular conference and for inviting me to talk about cholesterol, diet, lowering cholesterol with statins. But first, let's cover my disclosure. What is it that motivates me to want to study this area of science? Well, in general, my disclosure would be for my primary area of research. I'm a neuroscientist with a PhD in biology with a specialty in neuroscience. I've been funded by all major federal organizations as well as some drug companies. But I'm not going to be presenting neuroscience work today. What I'm going to be presenting is something actually that is very personal and is unfunded. And it's based on my own risk for developing heart disease. A bit over 20 years ago, I was diagnosed with a genetic disorder. It's called familial hypertriglyceridemia. I had astronomically high triglycerides, about 10 times higher than would be typical, and I had extremely low HDL, and I also was overweight. Plug in my numbers, and you can see on this graph, I had about a 15 times greater risk of developing heart disease compared to someone with optimal lipid measures. And I took this very seriously, and I was very concerned. I went to see my doctor every year about this, and at some point, after numerous years, really about 5-8 years, in which I persisted in having extremely high triglycerides, despite diet and exercise, my doctor urged me to go on medication, including statins. Now, I knew a whole lot about the brain, but very little about heart disease and not much about statins at all. So what I decided was to put my PhD in biology to good use. I started reading about triglycerides and heart disease. And over the years, I would say what happened was I had a combination. At best, I was disenchanted. Really, at worst, I was outraged at what I learned about heart disease and conflict of interest. And that's what I'm going to share with you today. Essentially, the way I look at it is it's very nice to see how this relates to a story of the man who lost his keys. And what did he do? Well, he's looking for it under the streetlight. He doesn't know where his keys are. And someone walks by and says, well, you don't know where your keys are. Why are you looking under the streetlight? And he says, well, that's where the light is brightest. And to me, that tells you a bit, as it epitomizes the search for the cause for heart disease, and cholesterol has been under the streetlight. And why is it that cholesterol has been under the streetlight? Well, frankly, what I'm going to talk about is this conflict of interest. The conflict of interest really originates with the vast fortune, okay, the incredible profits that have been derived from demonizing cholesterol. So you want to sell a product, whether it's oatmeal or corn oil, Cheerios, and of course medications such as statins. The primary way to do this is to say that it lowers cholesterol. And so part of the real problem is that there's a financial conflict of interest motivating companies to be able to say that they can lower LDL cholesterol specifically. So what I'm going to talk about is that there are far more important factors than LDL that are associated and even mechanistically connected to heart disease. So I'll be talking about low-carb diet, emphasizing triglycerides and HDL, in particular one component of the LDL called the small dense LDL. I'm going to talk about a disease, familial hypercholesterolemia. These people have extremely high cholesterol, and I'm going to say that this is misunderstood, that a subset of these people do have more heart disease, but it's not because of their high cholesterol. I'm going to talk about whether or not someone on a high fat diet, a low-carb diet, should be taking a statin if they have high cholesterol and specifically high LDL. And finally, I'll talk a bit about coronary artery calcium. This is one of the most important biomarkers to tell you about your risk for developing heart disease. And this really has been ignored to a great extent. Clearly, it has not been emphasized sufficiently. So let's go back into the 1980s, when Brown and Goldstein won the Nobel Prize for their study on the LDL receptor in people with familial hypercholesterolemia. Brown and Goldstein basically declared LDL guilty of causing heart disease. And here is just one of their papers in which they reviewed this, stating as a fact it's a causal relation of LDL to heart disease. The problem, of course, at the time was there was very little strong evidence that LDL actually caused heart disease. And so there was a study that came along that was very important that helped to convict LDL of causing heart disease. And that study here is the Mr. Fit study, in which a large number of men, hundreds of thousands of men, were followed, middle age, for quite a few years. And they looked at their rate of death from heart disease in terms of their cholesterol levels. So you have here a rather frightening graph, which came out of their work. and you look at relative to the people with the lowest, and this is total cholesterol, and 1.0 is their rate in which they died of coronary heart disease. And so when you go from 1 to 2, that's twice the rate of death of heart disease. 3 is 3 times, and 4 is 4 times the rate of death from heart disease. And so as you see, with every small increment of cholesterol, you're increasing your risk of dying of coronary heart disease. So at the highest level, you see that you're over 4 times likely to die of coronary heart disease with high cholesterol compared to low cholesterol. So this helped to demonize cholesterol in general as far as causing heart disease. So I read this paper, and what I want to show you is the actual data from the study. This is a derived aspect of the data. I want to show you closer to what was actually found in the study. And that I'll show you in blue bars. So the same data in the blue bars derive the data in the red bars. So I'm going to show you the percent of people that did not die of coronary heart disease based on their cholesterol levels. And that is in this graph. So you're seeing in the blue bars the percent of people that did not die in relation to their cholesterol levels. And you can see it's virtually 100% all across the board. These people were horribly uncooperative. Almost none of them died of coronary heart disease. So I'm going to add a line in at 99%. So you can see that at the lowest level of cholesterol, just slightly more than 99% did not die of coronary heart disease. And at the highest level of cholesterol, which is considered really dangerous, slightly less than 99% did not die of coronary heart disease. So how do you get from the blue data to the red data? The blue data basically says across the entire range of cholesterol, there's only about a 1% difference in the rate of death. But the red data are very alarming, showing very high incidence of coronary heart disease with higher levels of cholesterol. So this is what they did. When you look at the lowest level, that's your reference level, 0.3% of those people with the lowest cholesterol died of coronary heart disease, CHD. And let's go to the highest level of cholesterol. And at this point, what you got is about 98%, 98.7% of the people did not die of coronary heart disease. So 1.3% did die. The difference across the entire physiological range is about 1%, which is rather trivial, almost no difference overall in death. So again, let's go from the blue to the red. The way they did this was, and you look at how do you get over 4.0, 4 times the rate of death from coronary heart disease, you take the 1.3 and you divide it by 0.3 and you end up with 4.3%. Okay, 4.3. And this is how he appears as if there's a 400% increase in death from heart disease. You take a 1% difference and amplify it to 400%. And why did they do this? Well, frankly, there wasn't really good evidence that cholesterol caused heart disease. So it's a bit like at the time, you know, the banks were too big to fail. People say that. Well, cholesterol was too big to fail. So they couldn't just say there's almost no difference, lowest to highest cholesterol. What they had to do is amplify the effect to make it appear as if cholesterol was essentially toxic, atherogenic. So let's look at the people with the highest cholesterol. These are people who would be urged to go on a statin now, in which their cholesterol is extremely high. And yet, here are middle-aged men. For many years now, you're looking at their cholesterol extremely high. And about 99% of them did not die of coronary heart disease. Let's look further into this. Familial hypercholesterolemia as a result of genetic modification. These people, because the LDL doesn't bind very well to the receptor, have extremely high cholesterol levels. And in the first half of the 20th century, what was found was a subset of people who died young had extremely high cholesterol diagnosed with hypercholesterolemia. And you see that the cholesterol is in their artery walls. Very simple idea. High cholesterol in the blood seeps into the artery walls. It therefore clogs their arteries and is going to cause them to die at a very young age. And this is now the contemporary view. Here is a contemporary study in which emphasizing without proper treatment for people with familial hypercholesterolemia, you can see that they're going to die at a relatively young age. So they're unlikely to make it past 50. You can see that they're likely to have cardiovascular disease or an early death by the time they're in their 50s. And so this is the current contemporary view of familial hypercholesterolemia. The high cholesterol interferes then with cardiovascular function. So as a scientist, I've got a very simple hypothesis. High cholesterol clogs arteries, causes people to die young. So the first thing we should see from the literature is that people with FH, which is familial hypercholesterolemia, should die young. The second thing is, what's pretty obvious, pharmacological reduction of LDL should be able to reduce the rate of mortality. So let's look at those studies. Well, the first is there are quite a few studies looking at lifespan of people with FH, consistently showing that these people have a normal lifespan. And here is a contemporary study, which I think is very important, in which you're looking at genetically confirmed FH, people with high LDL cholesterol, and you're looking at their rate of death over different decades, from birth on up into their 80s. And so the line at 1.0 is showing you the average rate of death, in this case in the Norwegian population, at each age range. And so the first thing is when you look at the first few decades of life, there's an extremely low rate of death. So everything is relative. So very few people, only 1 or 2% of people die in the first couple decades of life. And so that slight increase in the bars in the first few decades is not statistically significant, showing it's almost no death in the people diagnosed with FH, and it is not statistically significant. What's really important is as you look, as people get older, there's actually a decline in the rate of death. And after 60 years of age, it is lower than the average for the Norwegian population. And in fact, it's statistically significant. People with FH, extremely high cholesterol, in their 70s have about a 40% reduction in death compared to the general population. This is some disease. This is a disease that actually enables you to be healthier. And the reason for that is that cholesterol is a part of our immune system. The people in their 70s have a normal rate of cardiovascular disease compared to the population, and a lower rate of cancer and diseases having to do with inflammation. So it is in fact healthier to have extremely high cholesterol for people over 60 years of age. And it's not just for people with FH. It goes for the general population. I had the pleasure to work with an outstanding group of clinician scientists, and we published a review of all the literature looking at mortality for people over the age of 60 as a general population. And what you find in general is that the people over 60 with the highest LDL live longer than the people with low LDL. And there's no study showing shorter lifespan of people over 60 with the highest LDL compared to the lowest. So we concluded that elderly people with the high LDL live as long or longer than those with low LDL. And you certainly want to question then whether LDL is actually clogging arteries. These are people living a long life, long healthy life with high LDL. And you certainly want to wonder, why would an elderly person want to lower their LDL when they can actually be living longer than someone with low LDL? Now, let's look a little further into people with FH, because they're sort of a template to guide us as to whether or not high LDL is to be disconcerting to us. So here's a study in which you have people who all had a heart attack, people with FH, all put on a statin. And so now you can see their LDL levels here on the left. And so you've got a subset of these people, all on a statin, have coronary heart disease. They have a second heart attack after the first. And a subset don't have a second heart attack. And you look at their LDL levels, and there's no difference. So LDL doesn't tell you about the population that's now having the second heart attack. What's the difference between the population? Well, the people who have the heart attacks, more than 3 times as many, are smokers. And of course, this is a risk factor for everybody, but it may very well be that this is even more important for people with FH. And this has nothing to do with their cholesterol. And so this is a very important risk factor for heart disease for anyone. It may very well be even more important for people with FH. But what's very clear is it's unrelated to their LDL levels. And they look over 25 years. These individuals, they studied people. And you look over a 25-year span. The people who were smokers, only about 40% of them were able to go this period of time without having a coronary event. But the non-smokers, over 80% of them didn't have a coronary event. So what's really important here is to understand the people with FH have the same risk factors for heart disease as everyone else, and it's independent of their high LDL. Now let's look again at an FH study. This is so incredibly important because again, we've got 2 groups of people with high cholesterol, and they're all on lipid-lowering medications such as statins. And you've got one group with no heart disease and another group with heart disease. And again, no difference in their LDL levels. So LDL does not tell you which group has heart disease. What is the difference? Here it is such an important measure. The group here in blue, okay, is the group that develops the heart disease. And they have extremely high coronary artery calcium. That calcium belongs in your bones, not in your arteries. It is a great indicator of the future risk of developing heart disease. So with equivalent level of LDL, what you find is the people who have high coronary artery calcium are the ones that have the heart disease. And this goes for the general population as well. Those who don't have the heart disease have zero coronary artery calcium. And again, this is independent of their LDL levels. So what is another difference between the two groups? This is so important. When you look at the people that have the coronary events, that have high coronary artery calcium, what you find is significantly higher fasting blood sugar, fasting glucose, in the group that had the events. So they are in the pre-diabetic, borderline diabetic range with high fasting glucose, whereas those that didn't have events have nice low blood sugar below 100. So this is what's really important. We need to know what factors are actually associated with heart disease. And it's not LDL. In this case, it's high coronary artery calcium. It's high blood sugar. One more study that I think is so incredibly important in comparing people with FH with heart disease versus those that don't have heart disease. So when you look at this graph of this study, contemporary study, looking at people with extremely high cholesterol, total cholesterol, and LDL, and you can see the recommended LDL levels below 100, total cholesterol below 200. These are two groups of people, one diagnosed with coronary heart disease and one without. And you see minor differences in their HDL and triglycerides, but huge LDL levels, which are statistically equivalent. So what is different about these two groups? There is a genetic difference. The group that has more heart disease has a polymorphism, a different form of a gene for a protein called prothrombin. Prothrombin is a clotting factor for both FH people as well as the general population. The general population that has this genetic anomaly has significantly more heart disease, and it is independent of LDL. So this is what's so important. The people with high FH, as well as anyone with a high cholesterol, what you're going to find is the clotting factor, prothrombin, is critical factor in determining whether or not someone develops heart disease or not. And that is independent of the LDL levels. So there's a vast literature on this topic, and we've actually covered this. We published a review in which we covered coagulation factors versus cholesterol in people with familial hypercholesterolemia. And the conclusion we came to was that, in fact, it's hypercoagulopathy. It's high levels of prothrombin or fibrinogen, other clotting factors, and the inability to break up clots, called fibrinolysis, that you find is the critical factor related to heart disease rather than cholesterol. And so if you look at fibrinogen, which is really a powerful clotting factor, what you find is fibrinogen is independent of age and is associated not only with coronary heart disease, it is also associated with stroke. And cholesterol absolutely does not relate to heart disease as well as stroke as good as fibrinogen. So this is a critical factor that contributes then to heart disease independent of LDL cholesterol. So here I just summarized a vast literature. When you look at the risk factors, primary risk factors for coronary heart disease, they all mechanistically link up to what's in the center. That's a picture of red blood cells in the formation of a clot. So clot formation as well as degradation, all these risk factors contribute to the increased risk for developing heart disease. And it's independent of cholesterol. And I've highlighted toward the bottom that the subset of people with familial hypercholesterolemia, this is the subset of people that have increased clotting factors. So therefore, it's all people with FH have high cholesterol. But the subset of people with FH that have high fibrinogen or high prothrombin, they're the people much more likely then to develop heart disease. So is LDL completely innocent of causing heart disease? Well, yes and no. there is an aspect of LDL, which is covered so very nicely by Paul Mason in his lectures. But there is a component of LDL which can be considered damaged LDL, called small dense LDL, that is associated with heart disease. So if we look at a person that is healthy with low blood sugar and low triglycerides and high HDL, what you're seeing is coming out of the liver and in the blood you'll find native LDL. This is called large buoyant LDL. And this is an LDL that's essential for providing nutrients through the blood. And it's a form of LDL that is not associated at all with heart disease. But if a person has a high blood sugar and high triglycerides, what you find is as the LDL proceeds through the bloodstream, it then sort of deteriorates. It becomes a small dense LDL. Small dense LDL is found, a high proportion of small dense LDL is found in people typically who have higher blood sugar, who have higher triglycerides, who have metabolic syndrome, higher blood pressure, high blood sugar, high triglycerides. So it is associated with heart disease because it exists, in a sense, in a damaged metabolism. So here's a study that actually looked at that to confirm what I'm telling you about. And so you look at the people that have the highest small dense LDL. And what other measures are there associated with it? Well, the people that have the highest small dense LDL have extremely high triglycerides. So that's on the left side of this graph. So they have extremely high triglycerides. The people who have a low level of small dense LDL have an extremely low, healthy level of triglycerides. You look on the right, the people diagnosed with metabolic syndrome, okay, have an extremely high percentage of small dense LDL. The people who are not diagnosed with metabolic syndrome are the ones who have a low level of small dense LDL. So it's really important to see that when you see an association of small dense LDL with heart disease, all it means is that that small dense LDL is found in a damaged metabolism, in an unhealthy person who has multiple risk factors. The small dense LDL does not exist in a vacuum on its own, does not cause heart disease. So here's another very nice observational study. When you look at the people who have the highest small dense LDL, here followed over quite a few years, what you find is those with the highest small dense LDL, and again, which is found in conjunction with high triglycerides and high blood sugar, you find those are the people that have the highest rate of heart attacks, coronary events. The people with lower level of small dense LDL, okay, have much fewer heart attacks. And so again, small dense LDL is found in a damaged metabolism, in an unhealthy metabolism. Let's look at the large buoyant LDL. Okay? This is basically the kind of LDL that's produced by someone on a low-carb diet with low blood sugar, low triglycerides, someone who is exercising. You're more likely then to have potentially a higher level of LDL, but it'll be primarily a large buoyant LDL. And you see here on the right, there is no association of large buoyant LDL with coronary events. So this is a far more sophisticated approach than just talking about LDL-C. But this is really important to see that the type of LDL is associated with the health of your metabolism. Healthier metabolism produces a dominance of the large buoyant LDL, which is not associated with heart disease. We summarized much of this research in a review we published last year. I have worked with cardiologists and diet experts. So I was really very fortunate. And so I want to emphasize in that, here's a figure from our paper showing that on the low-carb diet, you see where the arrow is pointing on the left, dramatic increase, greater levels of large buoyant LDL in the people on the low-carb diet, which of course is at worst benign, potentially very helpful, and a small increase in LDL-C. But let's look on the right side, whereas down is a good move for all these biomarkers, and you see the small dense LDL declines compared to a low-fat diet. So the low-carb diet is moving all the biomarkers in the right direction, including the small dense and the large buoyant LDL. So we're taking care of the first one. It's very clear that having high LDL not only doesn't cause you to have an early death, having a high LDL enables you to live longer. But now let's look at what happens with pharmacological reduction of LDL. Does it actually reduce the rate of cardiovascular mortality? Well, there are a couple of primary approaches pharmacologically that I have time to cover. The first is called the CETP inhibitor. This is a completely different mechanism from statin. So these drugs interfere with an enzyme that helps to convert HDL into LDL. So the result is you have an increase in HDL and a reduction in LDL. It's the ideal change because high HDL is associated with less heart disease. So this was to be a blockbuster drug. And the contrast is with statins, which interfere with HMG-CoA reductase, ultimately resulting in lower LDL. Two completely different mechanisms. So let's cover first the CETP inhibitors, which increase HDL and lowered LDL. And to save time, what we can do is look at basically a summary coming from a news report. But what we had is multiple trials. Tens of thousands of people were studied. Drug companies spent over $1 billion developing this category of drug over the course of about 20 years. And it really comes down to this, dashing hopes. The cholesterol drug had no effect. And so this is over 10,000 people were studied. No benefit whatsoever, heart disease or stroke. It says here the investigators were stunned. There was no benefit with a dramatic reduction in LDL levels. And so this part of it was Stephen Nichols, who's an expert in heart disease, statin advocate, said this drug seemed to do all the right things. It lowered LDL, raised HDL, and he said it's a mind-boggling question as to why it was so ineffective. Well, if LDL is not causing heart disease, then it's not a mind-boggling question. Lowering LDL provides no benefit because LDL alone does not cause heart disease. And it's really important to understand this is a kind of a drug that is relatively specific to raising HDL and not lowering LDL. We're going to contrast that now with statins. So statins now, the wonder drugs, the go-to drug, the drug that's now being prescribed to tens of millions of people because it is seen as almost a cure for heart disease. So here's a study published almost 2 decades ago in Lancet. Lipitor reduced heart disease by 36%, a powerful effect, and this is why statins are seen as the wonder drugs. Over a third of the people, therefore, would not have a heart attack as a result of being on Lipitor. And this is really what propelled Lipitor to generate hundreds of billions of dollars in revenue, because it has such a powerful reduction in the incidence of heart attacks. So let's look at this study. So to show you that 36% is accurate, here it is in the study published in Lancet about 2 decades ago. Reduction in fatal and non-fatal coronary heart disease. Well, what I did was I took the data from that study and I'm graphing it here in terms of the percent of people that did not have an adverse event. An adverse event, for example, would be dying. So we're looking at the percent of people that did not die, and that's in survival. And you can see here, like so many heart disease studies, these people were terribly uncooperative. Almost nobody died. Almost nobody had a heart attack. And so you can see survival. You can see no cardiovascular death, no stroke. And so somewhere in this graph is a 36% reduction in heart attacks. I kind of call it a Where's Waldo because it's really kind of hard to see. And it's right there. You see that? That sliver of a difference on the far left slide between the red and the blue. That's the people treated with Lipitor versus placebo. And you're looking at fatal and non-fatal coronary heart disease. That difference is a 36% reduction in the incidence of heart attacks. Now, when I show this to people, you know, I don't have an audience in front of me, but when I show people this, I get this look from this little guy. It's the same look I get from the public, I get from cardiologists. It's like, come on now, seriously? I wasn't born yesterday. That's not a 36% difference. Yes, it is. That difference is a 36% reduction in the risk of a heart attack. So let's see how that can be a 36% reduction. Well, the actual difference is 1.1%. So 98.1% of the people on Lipitor did not have a heart attack or die of a heart attack. 97% on placebo. So doing nothing on the placebo, 97% of the people did not have a heart attack. The difference is 1.1%. So the ad, though, says it's 36%. So are they lying? How can it be 1.1% and how can it also be 36%? Is this fraud? Actually, no. This is not a lie. But let's look a little more closely at that advertisement. Amplifying. Did you notice the blue font on the blue background? In a clinical trial, 3% of the patients on the sugar pill, the placebo, had a heart attack compared to 2% taking the Lipitor. So they're telling you the real difference is 1%, But the ad is also saying it's 36%. How can they do that? Well, let's look at how you can do this. And I kind of call this statistical alchemy. Be able to turn lead and data into gold. Okay. You take the 1.1%, which is the real difference, called absolute risk, divided by 3%, which is the rate of heart attacks in the placebo group. 1.1 divided by 3 is 36. Yes, seriously, I'm saying 1.1 divided by 3, that's 36. That is called the relative risk reduction, and that allows you to legally say you have reduced the risk of heart disease by 36%. Now, why don't the statin makers, drug companies, give the real data, which is the absolute risk compared to placebo? Lipitor reduces the risk of heart attack by 1%. Well, when people look at that ad, obviously they're a whole lot less likely to want to buy the drug and how to use it. So 36% is a lot more impressive. But realize the real difference with this drug treatment is so incredibly trivial. Frankly, I find it outrageous. And in fact, I was so motivated and so outraged by this that I had the pleasure to work with Ufi Ravenskov. And about 6 years ago, we published a paper describing all the different trials in which this kind of statistical deception has been used to amplify the appearance of statins to be wonder drugs, when in fact, when you look at absolute risk, the differences are minuscule. And we talked about the war on cholesterol and how the effects of statins have been amplified and the adverse effects have been minimized. So let's look at a study people like to refer to, one in which provided the best effect of statins, and this also involves secondary prevention. So this is the 4S study, published almost 3 decades ago, and it's the best finding of all. And we're going to disregard that this was a study designed, implemented, and the data were analyzed by the drug company, something that couldn't be done now. But let's accept that, because this is a kind of important study. And even though they imply it's a 4% difference, it actually was a 3.3% reduction in total mortality. The advantage of this study is that it was reanalyzed in 2001. A subset of the data were reanalyzed. What's really important here is you have 2 groups of people. Both have high LDL, but they looked at outcomes in this study for people who had high triglycerides and low HDL, which is unhealthy, compared to the people that had low triglycerides and high HDL, which is healthy. What's really important is both groups had high LDL. So what was the outcome in terms of coronary events and the effects of statins in these 2 groups of people? The first important thing is it confirms that having high triglycerides and low HDL is unhealthy. You see a lower percentage of people over time with the open symbols, a lower percentage go without having a heart attack. Okay, and that's the open circles going down. So it is unhealthy having high triglycerides, low HDL. The statin-treated group that was unhealthy had a lower rate of heart attacks. This does show that there is a benefit of the statins in this group. My guess, my hypothesis, is because statins also reduce coagulation and reduce inflammation, and it has nothing to do with LDL. But let's look at the people who had the low triglycerides and high HDL. When you look over time, you see that, first of all, these people had a lower rate of coronary events compared to the people with high triglycerides. But the most important thing is there is no difference in the curves for the people that had the filled data points. They overlap. There is no benefit of the statins for this group. This is the closest we can come to looking at people who have the kind of biomarkers for someone on a low-carb diet and asking the question, would taking a statin benefit someone who has the low triglycerides, high HDL, and high LDL? And the answer is there's no obvious benefit whatsoever. And in their summary graph, you can see what they call the lipid triad. High LDL, high triglycerides, low HDL. These are unhealthy people. There was a statistically significant benefit. But for the people at isolated high LDL, meaning high LDL, but the other markers are good, there's no benefit of the statins. And again, this is the closest we can get to see that a statin would not benefit someone who's following a low-carb diet. So to summarize the statin benefits, there is a small subset of studies providing evidence of a small benefit in coronary events and outcome, and it ranges from about 0 to 3%. Okay, that's really the range of all the studies on statins, and most of them really were done over a decade ago. There has never been a study showing benefits for people who are relatively healthy. That is, for non-smokers, for people with low triglycerides and high HDL. So it's probably helping a subset of people who are unhealthy because they have excess coagulation, inflammation. It has nothing to do with the LDL reduction. So what about the adverse effects? Are that small benefit? I mean, silly, if 2 or 3% of the people have less heart attacks, that's fantastic. But are there adverse effects? Well, yes, there certainly are. So in a brief period of time, I want to cover some of the adverse effects that have been documented. So we know it is established that people on statins develop more diabetes. And this is probably one of the best studies that was done. Here you have a prospective study. Nobody's got type 2 diabetes in the beginning. You got a placebo group and a group that gets statins. These individuals in this government-funded study monitored their fasting insulin, their fasting blood sugar. And so you have multiple measures of type 2 diabetes, and you find after about 6 years, in the placebo group, you've got spontaneous development in about 6% of the people develop type 2 diabetes. But those on the statins, almost twice as much, over 11% of the people develop type 2 diabetes. So this is quite dramatic. Think about it. 5% of the people are now developing diabetes compared to the placebo. And that increase in diabetes now increases someone's risk for multiple diseases, not only heart disease, but also cancer and brain diseases such as Alzheimer's disease. Now, it appears, and that study was done exclusively in men, women appear to be more sensitive to the diabetes-producing effect of the statins. So here's a paper published by a group that analyzed the incidence of diabetes in studies in relation to the percentage of women in the studies. With an increased percentage of women in the studies, you see overall an increase in diabetes developing in the studies. And at the extreme right, the Women's Health Initiative, which was all women, you see the highest percentage of people develop type 2 diabetes. And so the group concluded that there is a profound association of statin use to the development of type 2 diabetes, perhaps even far more susceptible, women are more susceptible than the men. Now, the cognitive effects of statins have been downplayed. This is an incredibly important study that has been ignored, published almost a decade ago. And what you have here is people who are about 75 years of age had gone to the doctors reporting cognitive impairments. They're diagnosed with mild to intermediate dementia. And so what they did in this study was they took them off of their statins. And we know that they were off of the statins because their cholesterol levels rose. And after about a month or two of being off of the statin, their cognition improved to the point where they no longer are diagnosed with dementia. And what's critical is now you put them back on the statins under controlled conditions. When they were put back on the statins, their cognition worsened. And so the dementia diagnosis returned in these people when they were put back on statins. And we had published a paper as well on this topic showing that the initiation, the presence of the adverse effects, the cognitive adverse effects, is associated with the capacity of the statin to be able to access the brain. And so they can get through the blood-brain barrier and then interfere with the ability of the brain to produce its own cholesterol. The brain needs cholesterol to produce new brain cells or neurons, to produce new synapses, to make memories. And so the kind of statins that can get into the brain, such as Lipitor, are the ones that have the highest rate of adverse effects reported to the FDA. And so clearly now what we have to be concerned about is with this epidemic of Alzheimer's that we have. The question is, how many 75 and 80-year-olds taking statins are reporting now to have dementia, but it's a false dementia because it's caused by the statin, not by any genetic or other cause for someone to have Alzheimer's disease. We don't know because the studies have not been conducted. Now, I don't have time to go through all the different kinds of adverse effects, but they're published in peer-reviewed medical journals. And here's just a subset of the adverse effects of the statins. What you have is erectile dysfunction, low testosterone, kidney disease, muscle atrophy, and osteoporosis. All of this to get about a 1 to 2% improvement over doing nothing, taking a placebo. So, in summary, what I've talked about is that cholesterol has been the focus of research for decades. The linkage of LDL to coronary heart disease is incredibly weak. So why is cholesterol under the streetlight? Well, what I really focused on is to explain that something with such incredibly poor evidence to link one factor to another, to link LDL itself to heart disease, the primary motivating factor is profit. And so now you can see so many products, oatmeal, corn oil, Lipitor, as well as the newer drugs, the PCSK9 drugs. What's ideal, you want to sell Cheerios, you say it's heart healthy. What's ideal is to continue to demonize cholesterol and specifically LDL because it enables you to sell your product. But frankly, there is no strong scientific basis for the continued demonization of LDL cholesterol. So statins specifically have had meager benefits. We're really talking about single digits benefit compared to doing nothing. About 1 or 2% better than placebo in all of these trials. So the benefits have been inflated. You hear about 30, 40, even 50% reduction in events. This is called relative risk reduction, which is a way to inflate minuscule benefits. And the adverse effects have clearly been ignored. They have been dismissed. So what I've talked about are factors that really are far more important for improving cardiovascular and overall health. We want to get our triglycerides lower, raise HDL, and minimize the small, dense LDL. And the optimal way to approach this is with a low-carb diet, keeping blood sugar low, minimizing consumption of food that will raise blood sugar. FH has been seen as a disease of cholesterol. And what's clear is it is not, first of all, it's not a disease because the people with the highest cholesterol are actually incredibly healthy. And as they get older, actually have a lower rate of death. Are statins of benefit for someone on a low-carb diet with high LDL? There is no evidence that you will benefit by taking a statin by lowering your LDL cholesterol if you're on a low-carb diet. And finally, what we really want to investigate and study even further is the coronary calcium. It appears as if this is associated with the high triglycerides, metabolic syndrome, high blood sugar. And in fact, taking a statin, there's strong evidence increases coronary calcium. And there's evidence then that having low blood sugar is associated with lower coronary calcium. This is something that's so incredibly important, but has largely been ignored in the literature, primarily because there is no drug that will lower coronary calcium. And I want to leave you with a review we published about a year ago. I had the great pleasure to work with numerous cardiologists, other clinician scientists, and experts in nutrition and diet, published basically about the benefits of the low-carb diet, and that there was no reason for someone with extremely high LDL levels to go on with the recommended diet, which is the low-fat, the low-saturated fat diet. There is no reason to restrict saturated fat for basically anyone, or specifically, especially someone with high cholesterol. And this is one of the figures from our paper. And it's so important because it shows relative to the general population, the people with FH, again, extremely high LDL, you can see if you have low fasting insulin and you're not overweight, the rate of heart attacks is no different from the general population. And it's only until you see those individuals that have either high fasting insulin or you have high fasting insulin and being overweight, you're about 7 times more likely to have a heart attack compared to the general population. And again, this is independent of the cholesterol, independent of the LDL. So ultimately, what really matters then is keeping that blood pressure, the blood sugar, triglycerides low, which automatically then results in higher HDL. The LDL turns out to be irrelevant. So I want to acknowledge that I've learned from so many people. Just as Isaac Newton centuries ago said he stood on the shoulders of giants to see further, I have seen further because of the scholarly work of so many people I've depended on. Here are a couple of books that I would recommend. I have a chapter in each of these books, and there are many other chapters written by scholars. So I highly recommend follow up this talk by looking at these 2 books, and I thank all those individuals who I've benefited from. So I'm on Twitter on almost a daily basis. My username is LDL Skeptic, and I look forward to interacting with people, and I certainly look forward to the Q&A session that will follow this. I thank you very much.
Thanks, David. Another talk full of information. It's hard to get your head around all the different things. But it just shows again how LDL has been demonized as the cause of everything. And it's amazing how that can happen when there's really so little evidence.
And especially, I mean, the evidence that LDL is a problem relates to this subset of LDL, the small, dense LDL that we find in this atherogenic dyslipidemia. And on the balance, people with higher LDL levels live longer. I mean, it's like with a lot of things in nutrition, the opposite is true.
It's scary stuff, really, isn't it? And obviously, there's a lot of money to be made out of people with high cholesterol because there happens to be a drug that can lower cholesterol occasionally. And we've heard in your talk and in this and other talks about statins. But obviously, a lot of the patients that we see who come to us for dietary advice with chronic disease, they might have diabetes, they might have metabolic syndrome, etc. Many of them are taking statins. And what do you say to those people? What advice do you give them about their statin use?
Well, first of all, I guess the way I see my role as a doctor is as somebody who educates the patients. I mean, to doctor means to educate. And it's not to impose upon a patient my will about what I think they should or should not do. So I present patients with the evidence. So if, for instance, there was a diabetic patient and they were taking a statin, and we saw that when they'd started taking the statin that their glycemic control had gotten worse, I would educate the patient about this. If, for instance, a patient had elevated liver enzymes, evidence of liver damage that got better when they stopped the statin, that's another education point. If we saw evidence of muscle damage, because we can measure for enzymes of the muscle cells dying, again, it's about educating the patient these are the potential side effects. And then it's also, I guess, balancing this against the potential benefits, which, as David has very clearly pointed out, there's a big difference between results if we present it as absolute risk reduction or relative risk reduction. And I present the data in terms of absolute risk. And at the end of the day, I then let the patients know it's not up to me to make the decision about what's right for them. It's my job to make sure they have access to the best scientific information, and then they can make the decision that's right for them. And of course, this is all very, very individualized. So we're not just going to look at an isolated LDL level on a blood test and make a determination. We want to know, is that LDL, atherogenic? Is it small dense? Do we need to run a blood test called a lipid electrophoresis? Do they have calcific plaque in the arteries around their heart that we can detect on a coronary artery calcium score that is a very good predictor for risk of heart disease? Do they have diabetes? Do they have poor blood sugar levels? All of these things feed into the bigger picture of evaluating somebody's risk. So I guess to make a long answer short, we manage everybody as a unique individual. There's no such thing as blanket recommendations. And number two, at the end of the day, the patients are the ones who make the decision, and it's my job to make sure that they've got access to the best possible information that they can possibly have.
Yeah, I agree completely. It's a big challenge, but it just frustrates me that there are so many people out there who are on statins and their GP, cardiologist, whoever is absolutely convinced that it's of huge benefit. I remember talking to my mother who recently passed away at the age of 99, but I think she was 90 at the time, and she was having a lot of muscle pain, which I was quite sure was coming from her statin. And I suggested that maybe she should discuss with her cardiologist going off statins, and her cardiologist got very angry. And said that there are thousands of people who'd be dead if it wasn't for statins, and you are certainly staying on your statins. So she continued for the next 9 years of her life to be miserable because she had muscle pain from her statins. But what can you do?
And the ridiculous thing is that in the insert in the box of the statins that she would have got, there would have been a warning that says they should only be prescribed with caution in people over the age of 65. And this is true of all statins. The side effects get worse, they're riskier the older you are.
Yeah, and the efficacy is dubious anyway. All right, enough on statins. Well, maybe no. Let's see who our next speaker is.
Well, it's Dr. Nadir Ali, who's a cardiologist from America. I've met him a couple of times. He is an absolutely magnificent chap, very humble, very friendly, and very, very smart. So let's see what he's got to say.
Today, I wanted to talk about a unique topic that has not actually ever been addressed in any of the conferences or any of the discussions on the low carb forums or the low carb sites. And it relates in many ways to fasting and low carb diets, movement or exercise, and sleep. And that is called calorie restriction. So what does calorie restriction actually mean? And what my objectives for today's presentation are. So my objectives are to define what calorie restriction is, go through how we know it is helpful for us based on animal studies, based on human data. We're going to define the biology of hunger. I mean, how do you control hunger? What are the factors that make us hungry? And then finally, any presentation I give, I want to make it practical for you. I want to make it so that you are able to practice calorie restriction by methods and techniques that I'm going to explain to you about. Now, at the outset, I want to say that intermittent fasting does not contradict with calorie restriction, because when you do intermittent fasting, in some ways you're practicing calorie restriction, because intermittent fasting reduces the size of the stomach. It gives you better control of a hunger hormone called ghrelin. We'll explore that further. The reduction in insulin levels makes you eat less. And there is better functioning of a satiety hormone called leptin. Now, up until recently, I've been fairly successful in getting people to reduce their weight, reduce their insulin resistance, and they have improved their health. However, there is a substantial proportion of patients, like for example, I was talking to the daughter of one of my colleagues, and she's been doing intermittent fasting, she's been doing a low carb diet, and yet not losing weight. Perhaps the tool that she's lacking is calorie restriction. And the way I define that is that humans are designed to overeat. The Paleolithic humans before us, before modern humans, had to hunt for food. Food was not consistently available, so they went through periods of involuntary fasting on a regular basis. And in order to protect us from famine, our biology is designed to overeat when food is available. What was helpful to us in the Paleolithic times is hurting us because modern humans have mastered agriculture. There is availability of food. There is a refrigerator in your home. So your Paleolithic instincts, your human instincts, have not evolved to deal with this food availability. And that's the reason why overeating and obesity is so common. In addition, food manufacturers have engineered our food. They have made the food such that we would overeat. If you take a bag of chips, the hotness index, the spicy index of that chip varies from chip to chip with a specific purpose that is designed to make you overeat because they profit from that. So what is the animal data on calorie restriction? Now, this is a study in mice. So this study in mice, a group of mice were taken And if you look at the top line, and here is my arrow, this group of mice were fed ad libitum. That means that they were given as much food as they wanted. The next group below them, they were given about 20% less calories. So their calorie restriction was by 20%. The third group, which we will just take as the 40 kilocalories per week, they reduced their calories by about 65%. The ad lib mouse, they are heavier. They almost reach about 50 grams. With 20% less calories, they are around 35 grams. With 65% less calories, they're about 18 to 20 grams. So that is their weight. But how long did each of this group live when calories were restricted? So what has shown that when you restrict calories in mice, not only do you increase their average lifespan, but you increase their maximum lifespan. Let's show that a little bit more clearly. So these are the group of mice that were fed ad libitum, however much they wanted. They all died at 35 months. The group that was restricted by 20% lived about 7 months longer. But look what's happening to the group that were restricted by 65%. They lived up to 55 months, 20 months longer. So what I wanted to tell you is that it prolonged the life of these mice by almost 65%. So people will say, mice are not human-like, the information in mice is not useful. So this is information from the Wisconsin Primate Research Center. They have rhesus macaque monkeys from India. And they did calorie restriction experiments in monkeys. They took about 76 monkeys, 38, they studied their feeding behavior. In fact, they studied the feeding behavior of all 76 animals before and saw how much they were eating. In the 38 that they utilized for ad libitum group, which meant that they ate as much as they were eating before, the other 38, their calories were restricted by about 30%. Now, monkeys in captivity live for between 28 to 40 years. So this study was not a short duration study. This study was carried out for 20 years of follow-up. A typical pharmaceutical trial is only lasting about 1 to 5 years. So this duration of follow-up is humongous. These monkeys are not fed the diet like we advocate from the fasting method or any low-carb community. These animals were given the same junk food that Americans eat, which is written as the standard American diet. They were given some protein in the form of lactalbumin, but there was a lot of sugar and corn oil, vegetable oil, which is not bad, which is very bad for us. The control diet had more calories. The restricted diet had fewer calories. They were reduced by the same percentage, but an important aspect of both rat as well as the rhesus monkey studies is that malnutrition was avoided by giving them important vitamins and minerals. The animals were recruited in 3 different phases. The first phase, this was because of funding. There was a period 1 in which they enrolled about 30 animals. Then another time they enrolled 30 animals that were mostly females, and then they enrolled another 8. So they ended up with at least 15 females in the ad libitum group and 15 females in the group that were calorie restricted. Now, as I said, this study was carried out for 20 years. There was an interim analysis at about 8 years in 2000. And this paper was published, and in the interim analysis, they looked at the difference in weight between the group that was given as much food as they wanted versus calorie restricted. So this group, which was given as much food as they wanted, was heavier. The calorie restricted group was lighter. This was the second enrollment period. Within 24 months, these curves started separating. The ad libitum group were heavier, the calorie restricted groups were lighter, quite significantly in all three groups. What happened to their fat mass? So this is total and regional fat mass. In the control group, the fat mass was much higher compared to the group that had undergone dietary restriction or calorie restriction. It was lower not only in the abdomen, but in all places. So these animals were lighter. Now, one of the surrogate markers of better health is blood sugar levels and insulin levels. If you looked at blood sugar levels, the blood sugar levels were lower in the animals that were calorie restricted. Insulin level was significantly lower. This is the first group. These were the second two groups that were enrolled, blood sugar levels being low in the calorie restricted group compared to the control groups, insulin levels being low. Leptin is an important hormone that is elaborated by the fat cells. If your fat cells increase in size and number, less leptin is made. So the control group that had a lot more fat, I guess I'm saying that the opposite way. When you have a lot of fat, a lot more leptin is made, and the leptin was higher. When your fat mass is lower, less leptin is made. However, as you become heavy and if you have higher insulin, the brain does not see leptin and you're leptin resistant and you don't get the same satiety signals. Now, as I mentioned at the outset, in this rhesus monkey study, there was a 20-year follow-up. Their diet was controlled for 2 decades. So in other words, in this experimental program, they could exactly determine how much food we gave to these monkeys. It's not like a human trial in which we cannot control these factors. The Wisconsin Primate Research Center is a high-quality facility. These animals were monitored every day. Their death rate was precisely assessed. And chronic diseases, unfortunately, rhesus monkeys have the same chronic problems, chronic diseases like diabetes, heart disease, cancers, and brain atrophy like humans do. Now, at the end of 20 years, this is a representative sample of a monkey that was fed ad libitum versus calorie restriction. You can clearly see that this monkey looks a lot older. You can see that this posture is that of an older person with significant degree of hair loss. This is a calorie restricted monkey. He looks younger in his face. His posture is better. The hair quality is better. But I guess you guys don't care about all of this. What you want to know is that did they live longer? And if you looked at age-related mortality, not mortality that was as a result of injury or surgeries, this is in blue, the monkeys that were fed as much food as they wanted. 50% of them were dead by about 20 years of follow-up. On the other hand, in red are the calorie-restricted monkeys. At 20 years of follow-up, 80% of them were alive. So at any given time, the calorie-restricted monkeys had a 3-fold higher chance of living compared to the monkeys that were fed as much food as they wanted. Like we discussed, monkeys also die of cancers, heart disease, and diabetes. If again you looked at this graph, and you looked at the calorie restricted monkeys, they had a much lower chance of getting these chronic diseases, of acquiring these chronic diseases, compared to the monkeys that were in the control group. In fact, almost all the monkeys in the control group got some kind of a chronic disease or another, whereas nearly 70% of monkeys in the calorie restricted group were free of chronic diseases. Now, I want to give you a little balance from the rhesus monkey studies, because there was another group at the National Institute of Aging that did a similar study. Now, I don't want to go into details because I want to spend time with what I think is important. But in the NIA study, there was a significant reduction in chronic diseases, and there was the same direction in terms of reducing mortality, but it didn't reach statistical significance. And there are differences in which the NIA designed their studies versus the University of Wisconsin designed their studies. And I think those are really the reasons why it is responsible for differences in outcome. And for people who are more interested, I'm writing a paper, and I will show you the paper here. This is the paper, and it is an exhaustive document with references. And Melissa is going to post it. It's going to be posted on the website of IDM and the fasting method. So you will have access to it. So that's why I wanted to show you that a paper has already been written that'll get posted. So you would say monkeys are still not humans. What is the human data? So I want to take you through what we know. During World War II, there were several European countries that restricted food intake of their population. One of the countries was Norway. In Oslo, Norway, they said, we're going to do 20% calorie reduction for you because it's wartime, Second World War, we can't feed you. But they said that we're going to try to provide you with balanced food. They gave them fresh vegetables, potatoes, fish, whole cereal. Still not the best diet that I would recommend, but there was enough variety. And that was to prevent malnutrition. It was undernutrition, but not malnutrition. When compared to pre-war levels in both men and women, there was a 30% reduction in mortality. Many of us have heard about the Okinawa effect. Okinawa is an island in Japan where it was found on a research survey that these Okinawans ate about 17% less food than mainland Japanese, and roughly about 40% less compared to the Americans. And when you looked at the lifespan, the average lifespan and the maximum lifespan, the Okinawans had about a 4 to 5-fold better chance than, let's say, the United States or the United Kingdom of reaching 100 years of age. Their average lifespan was increased by about 2 years, and their maximum lifespan was extended by 4 years. So there is some evidence based on demographic studies that calorie restriction is beneficial. But you will say, hey, is there any randomized trial in humans? Have you taken a group of humans and you mashed them before, and to half of them you gave them less calories and the other half you said feed ad libitum, however much you wanted? So my response to that is that that is difficult. The reason it is difficult is because to get an outcomes data like death rate or mortality, you would need about 30 years of observation. It would also be impossible to be certain that these humans are doing calorie restriction and impose it on them for that many years. On the other hand, you can do short-term studies in which you get surrogate markers of health, like weight, like metabolic rate, like energy expenditure. I will define that further, like insulin levels, triglycerides, and blood pressure. So a study like this was done. They enrolled about 218 patients. About 117 completed the study in the group that were calorie restricted. They were divided a little differently. In other words, 145 were in the group initially, 75 were there in the other group. Of the 145, 117 agreed to do the intervention. Of the 75, 71 were able to complete. So let's see what happened to these individuals. So now here we are looking on this graph, the amount of calorie restriction. How good were they at restricting calories over time? In the first 6 months, they were able to do 20% calorie restriction that was advised. But the amount of calorie restriction between 6 to 12, 12 to 18, and 18 to 24 months declined. So on an average, they restricted 10% of their calories over 2 years. What happened to their weight? This is weight loss over time. This is the unrestricted group. This is the restricted group. They lost an average of 8 kilograms. That's roughly about 20 pounds. It's impressive. Now, let me tell you what metabolic rate is. Metabolic rate is when we take fuel and burn it for energy. So that is the oxidative phosphorylation, big term. But basically, when you are burning fuel for energy, you create a little bit of burn injury. That's called oxidative injury. So higher your metabolic rate, perhaps faster you're aging because you're creating more free radicals that will cause you to age. So a reduction in your metabolic rate, a reduction in your total daily energy expenditure could be a marker that you are aging at a lower rate. And with calorie restriction, you found that the resting metabolic rate as well as total daily energy expenditure got reduced. Now, we already know that insulin is a surrogate marker of health. Less insulin, more effective insulin works, the better the health is. And HOMA-IR is a marker of how well your insulin is working. Lower is better. So the HOMA-IR fell in these humans that were calorie restricted compared to not calorie restricted at both 12 and 24 months. Their blood pressure declined. Their blood pressure declined significantly, which is another marker of health. Now, the slide got a little bit out of place, but here is the slide. Now, another good marker of health are triglycerides. Triglycerides is fat and blood. Having less amount of fat and blood is useful for us. And with calorie restriction, the triglycerides dropped significantly. Now, there was not a significant change in their cholesterol levels. In fact, the cholesterol levels dropped significantly. But I'm not sure that this is such a beneficial aspect. And I think this happened mostly because of the type of diet that these people were eating. So I want to move on from calorie restriction now. So I have shown you what calorie restriction is. But now I want to help you figure out why we feel hungry, because if you understand hunger, you will be able to restrict your calories. So let's take a look at what causes us to be hungry. Now, there are many factors, but one of the most important factors that makes us hungry is a hormone that gets released at the sight, smell, and thought of food, and that is ghrelin. So ghrelin is released by the stomach. It goes and acts in the brain and makes you eat. It starts your eating behavior. The ghrelin also is modulated to some degree by another nerve that is going from the stomach called the vagus nerve. We will not get into that. So let's see how ghrelin is released. So this is a person who is eating breakfast here, lunch here, and dinner here. At this time is midnight. So the thought of breakfast, the ghrelin starts going up pretty rapidly. It reaches its peak. But the most important thing I'm trying to make you aware of is that it takes about 60 minutes to an hour for this ghrelin to come down. And many people postulate that as the ghrelin goes up, so does insulin, and that rise of insulin is actually the stimulus that makes the ghrelin go away. I'd like to argue that there are other factors that can do that too. So the group took to try to figure out how powerful is ghrelin in making us eat. So they took 9 healthy individuals, they gave them ghrelin intravenously, and also at another time they gave them saline to see how much food they would eat when ghrelin was given and how much they would eat when saline was given. And these individuals were taken to a buffet lunch, and they found that they ate substantially more calories when they were given ghrelin. So here is the graph. The saline group ate this many kilocalories. The ghrelin group ate a lot more. Over a period of one day, they ate almost 550 more calories. Every single person who was given ghrelin compared to saline ate more. So it was not like ghrelin was making one person eat more and not another person eat more. They also looked at the visual interpretation of hunger by these people. Looking at food, who was more hungry? Looking at food before infusion, the hunger was the same. But after infusion, the hunger was a lot more. The perception, the thought of food and the hunger through visual cues was a lot more in people who were on ghrelin. Now here is an important aspect. When you fast, when you're doing fasting, our body is on a circadian rhythm cycle. It knows night and day. And what happens is that during fasting, even when you're not eating, at lunchtime, at dinner time, at breakfast time, the ghrelin levels are going up. This is the median, this is the top group, this is the bottom group in terms of ghrelin production. So if you look at an average, there are peaks at the time of lunch, dinner, and breakfast. There is a midnight peak also that is responsible for releasing growth hormone. So there are two important aspects about ghrelin and fasting. One is that ghrelin is still released when you're fasting. The second aspect is that the ghrelin is coming down on its own without an increase in insulin. So what does that tell you? What that tells you is that if you ignore ghrelin, if you cognitively say, hey, I'm fasting and I cannot have any food, if you ignore the stimulus to eat through cognitive control, the ghrelin will go down. The third important thing that this is showing you is that over a 24-hour period, the direction of ghrelin is coming lower. So in other words, with fasting, the hunger stimulus is declining, not continuously increasing. So before you go off and say, hey, I know how to master ghrelin, I want to share with you one other information, and that is, what do ghrelin levels do when you lose weight? Do they come up? Do they go down? So this group took a group of people who were overweight and heavy, and they did diet-induced weight loss, not the kind of diet we recommend, just calorie restriction. And then another group of people, to 5 of them, they did gastric bypass surgery and measured ghrelin levels. So let's see what happened. So this is the group with diet-induced weight loss. They lost their body weight substantially. This is in kilograms, which is a humongous amount, about 17 kilograms. They preserved their muscle mass because compared to their body weight, their non-fat mass increased. Their abdominal fat dropped by almost 50%. Their insulin worked better. Their blood pressures went down. But the reason I'm showing this to you is that when you lose weight, the ghrelin levels go up. This is the ghrelin levels with them being heavy. These are ghrelin levels after they lost weight. The other important thing that I'm showing this graph to you is that the ghrelin levels are taking approximately 90 minutes for them to come to their trough levels, to come to their nadir, to their lowest point. So after they peak, they don't come down within like 20, 30 minutes. It can take up to 60 to 90 minutes for them to come down. So your hunger stimulus, the reason why we overeat is because our biology is designed to make us overeat. Now, when you do gastric bypass surgery, you remove a portion of the stomach that's making ghrelin. So these are people who went through gastric bypass surgery. The ghrelin levels were very low, which is what you would expect. But before you say, hey, I want to conquer my hunger by going and getting gastric bypass surgery, I want you to think twice, because stomach is very important for our health for many different reasons. And one of the reasons here is that the ghrelin is making, so this is ghrelin levels here in the solid line, and these are growth hormone levels. The rise in ghrelin stimulates growth hormone release, which is very important for our health. So I have spent about 30 minutes talking to you about why calorie restriction is important. I've spent a few minutes of those talking about the biology of hunger, what makes us hunger, how long would we be hungry for. And now I'm getting on to a little bit of uncharted territory because this is not my expertise. But I have counseled patients a lot, and I've been practicing the skill for about 7 years in counseling and on myself. So I think that I understand partially the habits and the behavior and how to modulate it. So not only do I want to tell you that calorie restriction is important and how it helps, not only do I want to tell you what the biology of hunger is, but I want to give you techniques and tricks on how to eat less. So in order to do that, I want to use the work of James Clear. Now, I've read many books on habit formation. Charles Duhigg wrote a book called The Power of Habit, which I read from cover to cover. And I have heard James Clear, and I have read this book of his from cover to cover as well. And what Mr. Clear says is that a habit has 4 different components. There's a cue that leads to a craving, that creates a certain behavior, which is response, that leads to gratification or reward. So let's take these 4 aspects that are driving our food intake and apply them to food. So the cue is the sight, smell, and thought of food. The craving comes when you see that cue. The cue is what is leading to this craving inside your brain saying that, hey, I want to eat. And that craving is happening because your ghrelin levels are going out of control. The response is the act of eating, and the reward is the gratification that you get from eating that food. So this is a loop. It feeds on itself. The cue leads to craving, leads to a response, leads to a reward. And this behavior is repeated because it's creating gratification. So here is what James Clear says, that if you want to create a good habit, you should make the cue obvious. Make it present in your environment. If you want to make the craving of a good habit present, make it attractive. If you want to do that behavior, make it easy and make it satisfying. Now you have to inverse that. So for our purposes, we want to eat less. We don't want to have wrong cravings. We want to make it difficult. We need to have a commitment device that we're going to do intermittent fasting, and I'll explain that in a bit. And we need to make it not satisfying. However, I want to modulate all of this for you to see whether it can help you create some better eating habits. So dealing with cue. One of the first things that I tell is that remove the cue from your environment. If I'm working in my office, I don't want to have food available here. I want it not present. At home, clear your pantry of all the junk food. And even the good food that you're eating, you're going to overeat. So you need to have techniques to avoid that. So keep just the amount of food that you need to eat and don't have more. In other words, make it less available. Spend a substantial amount of time in a place where there is no food available for you so that the practice and act of fasting becomes easier. It's very difficult in our environment. What about craving? How do you deal with craving, which is the second aspect of habit formation? We already said eliminate the cues. Knowing that the cue is causing the craving is important. Understanding the biology that ghrelin is leading to that craving for food will help you. Understanding the biology that if you ignore ghrelin for about 20 to 60 minutes, your hunger will go away. So in other words, it's not like hunger will last forever. If you ignore the craving, the ghrelin will say, I want to take a hike. This person is not listening to me. I'm going to go away. I want to take the example of a Muslim fast. These people fast from sunrise to sunset. At this time, that's nearly 16 hours. They have no food, no water. These people are not fat adapted. They are not on a low carb diet. The reason they are able to do that is because through cognitive control, they are able to control their craving. And another reason they are able to do that is because this is a group of people who are fasting together for a religious reason. So in other words, I'm trying to plug in my group here. If you join a group that practices fasting, if you join a group that promotes a certain behavior, that behavior can be fostered and it'll be easier for you to stick to that behavior. I'm almost coming to the end. Now, the third law, which is the act of eating, how do you get rid of that? And for that, I want to take the story of Odysseus and the Sirens that I got from Goldstein from a TED Talk. And many of us have read about the Odysseus story in high school or junior high. And Odysseus was this big hero who won the war, and he was going back home. And they knew that they were going to pass through this island where there were the sirens. These sirens are these beautiful women that sing an enchanting song. And any sailor that listens to the song will jump out of the ship, go to the shores, and get hit by the rocks and will perish. And Odysseus is telling to his mates that, hey, listen, we're going to tomorrow pass through that island, and I want to listen to that song. and I want to listen but still live. So what I'm going to do is to put ear wax in all your ears so that you can't listen to the song. And he tells the first mate that you're going to tie me to the mast, as shown out here. And as we pass, I'm going to listen to the song. And your job is that no matter what I do, what kind of actions I do, you're not going to untie me so that I will not jump out of the ship and go to the shores and perish. So you would think that for such an important act, like Goldstein is describing, that there would be a rehearsal. So Odysseus gets tied up to the mast and he tells the first mate, you know, I want to go to the sirens, release me, cut me loose. And the first mate wisely does not cut his hands, cut his rope that is tying his hands. And after some time, Odysseus says, I see that you get it. Now let's stop this rehearsal, cut the rope and let's get some supper. And the first mate cuts the rope and Odysseus flips out and says, you idiot, if you do it at that time, all of us will be dead. And so really what I'm trying to use this analogy for is that this is one of the first descriptions of what is called a commitment device. So in other words, in order not to do that act, you need to have a commitment device. You need to enroll people in helping you. You need to tell yourself that, hey, I'm going to eat less. This is a commitment device that I'm making. So at the time that I have this temptation in front of me, I would be able to resist it. Now let's look at the fourth law very briefly. And the fourth law is make it less satisfying. And that is difficult because humans are wired for immediate gratification. I have a donut in front of me. It is sugary. It's very tasty. It's going to give me immediate gratification to eat it, and not eating it, whether it's a cookie or a donut, will help me in the future, but the future is not here. The temptation is here. The future does not have anything arguing for it, because not eating the cookie will make me perhaps not a diabetic, not obese. And so in the presence of temptation, it gets trounced every single time because humans are wired for immediate gratification. So what I want to do is to give you a strategy. Just to tell you that good habits are not immediately rewarding. Fasting will not improve your health overnight. It may take several weeks. Eating less will not make you lose weight in a day. It may take several months. Calorie restriction will not drop your blood pressure right away. It may take months of practice. So in order for these good habits to be fostered, create an immediate reward. And this is how I want to propose, and this is how I do it. So when I eat less or continue fasting, I make a small deposit in an account. This is my immediate gratification for eating less, so that this behavior is fostered. And over time, I see that this habit be reinforced by the money growing. And for me, it's buying a bicycle. For my friend's daughter that I just mentioned, she may make a pact with her father saying that every time she practices these good habits, that he will deposit $100 in her account. I mean, I'm just making that number up. So this is what I propose, that I want you to consider, with all these techniques that I have told you, to eat when you're eating, to eat when you're up till 70% full. So in other words, I want you to get up from the table when you're hungry. Now this is going to be very difficult because ghrelin is raging, it's not come down. It's uncomfortable to get up from the table when you're still hungry. But practicing that is knowing that you're doing something good for your health, and also the knowledge that ghrelin takes about 20 to 60 minutes for it to go away. And at times when you're fasting, avoid the cues so that your fasting would be promoted. Use all the knowledge that we have acquired today to deal with cravings. Formulate a commitment device, just like Odysseus did when he was going through the island where the sirens were, so that in the time of temptation, that commitment device will help you not give in. And finally, make eating less and fasting. In other words, getting up, like today, if I get up from the table 70% full and 30% empty, in other words, I get up from the table hungry, I'm going to put $5 in my account to get a new bicycle that'll give me pleasure down the road. So I want to ask myself, did I meet my objectives? The objectives that I laid out today was that, is calorie restriction an important health practice? And I'd like to tell you that it is. I hope that I gave you some idea about the biology of hunger and why we are designed to overeat. And I'm not sure whether I met with the last objective about the practical framework to create a better habit to achieve the goals that I outlined.
Another interesting talk, I thought, Paul, and lots to look into and so on. One point I was interested that I hadn't really thought about was that he said fasting reduces cravings. Is that did I get that right?
Yeah, so it looks like it's relating to the level of ghrelin. So as we know, ghrelin's a hormone that can drive the sensation of hunger and appetite and essentially eating behavior. And as he showed, that with prolonged fasting, ghrelin levels were actually able to be lowered. So it looks very plausible from that fasting can be one method of actually controlling appetite, ironically.
So when we talk about fasting, there's obviously all sorts of different types of fasting. Do we draw a distinction here between sort of a prolonged fast and intermittent fasting, or what's the data show us?
Well, I guess the interesting thing is that for what's considered fasting for a lot of people would only be eating to hunger, depending on the diet you're on. So let me explain. So if somebody was only eating 2 meals a day, that's often what we call having a daily fast. They're obviously skipping one of the traditional 3 meals a day. Whereas in my patients who are consuming ketogenic diets, and if I ask them to only eat when they're hungry, they will very, very often fall into a pattern of only eating twice a day. And from the outside, that looks like they're fasting, but to them, they're just eating when they're hungry. So this there's a little bit of arbitrariness about defining what is fasting and what is not fasting. So I tend to think that fasting, more correctly speaking, should be the deliberate omission of a meal when you actually do have physiological desire to eat. But many, many people on ketogenic diets reduce their eating frequency, especially when they're in a rapid weight loss phase, when their body's able to draw upon their fat stores for abundant energy. They find that many of these patients will often only eat once a day and they'll be perfectly satiated. And I guess consistent with that, their hunger levels are going to be quite well controlled, which probably does relate back to some of what Nadir has just talked about with ghrelin levels and more prolonged fasting.
If you're only going to eat 1 meal a day, do you have a sort of a preference for when that should be? Do you think it makes a difference?
Look, I don't have a strong preference. I know certain other authorities in the area will recommend that it should be a breakfast meal or an evening meal, but if you're only eating 1 meal a day, I don't think it particularly matters when it is, for my mind. One thing I will note is that in people who are very, very insulin resistant, the diabetics, that there is a tendency for some people to have reactive hypoglycemia. And if that is you, and that basically means that in the hours after a meal, that your blood sugar level will actually crash. if that's happening to you and it's an evening meal, then that will likely lead to sleep disturbance. So for that measure, for people very insulin resistant or who suffer reactive hypoglycemia, having your one meal of the day in the evening may not make a lot of sense, or you may want to have it earlier in the evening to give time for that to pass.
All right. And 2 meals a day, again, not fussed about when. I mean, I think what a lot of people are doing these days is skipping breakfast and having a sort of a late morning or a lunchtime sort of meal, and then having an early evening meal, getting it into that sort of 6 or 8 hour window. What do you think of that regime?
Oh, look, I mean, we all know that there's potential benefits of time-restricted eating. I guess one of the interesting things to note is that a lot of the metabolic benefits that we have from fasting, so people following the 5-2 diet or so on and so forth, is the same benefits that we see from people on ketogenic diets. So as Nadir pointed out there, that when people go on caloric-restricted diets, we see improvements in their blood glucose, we see improvements in their insulin. And these are both benefits that we also see in ketogenic style diets. So I think that fasting offers more benefit to people who are not eating healthy diets and who have poor sugar levels and who have poor insulin levels. And then I think if you're eating a healthy ketogenic style diet, I think there's far, far less benefit, if any benefit, to be obtained from deliberately depriving yourself of food.
Yeah. Very interesting. All right. So what's next?
Well, we have Nick Norwitz, who is well and truly a rising star in this field. So he's an incredibly smart guy. He's got a PhD from Cambridge, or was it Oxford? But he is now about to start medicine at Harvard Medical School. Very smart, very deep thinker, very analytical, and he's absolutely going to be a heavy hitter in the years to come.
Well, hello everyone, and thank you so much for coming to this presentation entitled Ketogenic Diets for Alzheimer's Prevention. Subtitle, Don't Push the ApoE4 Boulder, by me, Nick Norwitz. So first, a little bit of background on me and my disclosures. I received my PhD and my DPhil from the University of Oxford in ketogenics and neurodegenerative diseases. I'm a certified metabolic health practitioner with the Society of Metabolic Health Practitioners, and I'm pursuing my medical doctorate at Harvard Medical School, the class of 2025. As for my disclosures, my major disclosure for the purposes of this presentation is that I myself am an ApoE4 homozygote, which basically means I do have skin in the game with respect to this topic. I'm also on the board of advisors at a company called KetoKind, although I'm unpaid, and I'm co-author on a ketogenic cookbook, the New Mediterranean Diet Cookbook, from which I do stand to gain royalties, although I'm committed to sending all of these royalties to nutrition education and research. So, without further ado, I want to show you a clip that you may be familiar with to help frame what I'm going to talk about. So, here's that clip. So, aside from hoping that India would get you pumped up for the little adventure we're going to go on, the reason I wanted to show you that boulder rolling down a hill clip is because that's how I think about Alzheimer's disease. I think about Alzheimer's disease as a boulder rolling down the hill. And once the boulder gets rolling, there's really little you can do to stop it. No matter how hard you try, maybe you can slow the boulder, But to stop it is pretty ambitious, and to push it back up the hill is almost impossible. So really the goal for Alzheimer's disease, the holy grail, prevention, is to not push the boulder down the hill in the first place. So the next question are, what are the boulder pushers? What are the things we want to address so that we don't push the boulder down the hill, so that we don't start the vicious cycles that precipitate Alzheimer's disease? Well, not surprisingly, those are metabolic factors and lifestyle factors. Those are the things we want to address. And specifically, I'm going to be talking about nutrition and ketogenics. But just a little bit more in terms of framing statistics. Currently, there are about 5 million cases of Alzheimer's disease in the United States, and case prevalence is on the rise. By mid-century, that number could as much as triple to 14 million cases in the United States alone. And in parallel with that is an increase in the economic burden of Alzheimer's disease. So right now we're spending $1 billion per day on Alzheimer's disease and diabetes each, actually. But by mid-century, we could be spending 1.1 trillion per year, or $3 billion per day, on Alzheimer's disease, which is an unsustainable economic burden. So even setting aside the unimaginable human burden, it's unsustainable economically. We need to address this. In terms of what population is most important, well, although only 20 to 25% of people, which is not a small amount, carry ApoE4, 40 to 65% of patients with Alzheimer's disease are ApoE4 positive. So if we could reduce risk in this population, it would have a massive effect on overall prevalence of Alzheimer's disease. I would argue, perhaps selfishly, that ApoE4 is the population we really want to focus on when it comes to risk reduction in Alzheimer's disease. As for how much ApoE4 increases risk, well, on the population level, ApoE4 increases risk 2 to 3-fold if you have one copy, and as much as 15-fold, 12 to 15-fold by some estimates if you have 2 copies. And these patterns, they hold on a global level as well, as you can see here. Just a little bit more background. What is ApoE, ApoE4? Well, ApoE, it's a gene and a protein. The ApoE gene codes for the ApoE lipoprotein, which you can show here. It's lipidated. It's bound to lipids. And in ApoE4, which is one of 3 forms of ApoE, this cysteine is modified to an arginine. And what that causes is a pinching of the ApoE4. So there's a domain interaction. The ApoE4 domains interact, and this changes structure, it changes function, and therefore, on the population level, increases Alzheimer's risk by 3 to 15-fold. But, and this is really important, that relationship, that increased risk with ApoE4 does not hold across the globe. So for example, in Nigerians, there are individuals or populations in which ApoE4 does not confer an increased risk of Alzheimer's disease. So in this study, 20.5% of control subjects who did not have any dementia had ApoE4, whereas around 17% of patients with AD, Alzheimer's disease, had ApoE4. So that's actually a lower number, although it wasn't actually statistically significant, suggesting in this population, ApoE4 is not associated with increased Alzheimer's risk. Now, you could just brush this off as a weird genetic linkage thing, but that seems unlikely because if you look at comparative populations with similar genetic backgrounds, as they did in the Indianapolis Abidan study, they find that individuals of African descent, so similar genetic backgrounds, if they lived in Africa, in Western Africa, the increased prevalence of Alzheimer's disease, the increased incidence over a certain time frame, was half as much as Africans living in America. So you can see in the African American population, new cases of Alzheimer's disease over a certain time frame were 2.52% of persons, and in the African population, it was only 1.15%, corrected for age, suggesting that again, in people living in Western Africa, because presumably of lifestyle factors, ApoE4 is not associated with increased Alzheimer's risk. So takeaway, lifestyle matters. Lifestyle is in part mediating the effect of ApoE4 on Alzheimer's disease. And this isn't the only epidemiological data that suggests this. You can look at other populations like Mediterranean populations, and you see the same thing. So in carriers of ApoE4 who are Southern Italian, so again, same genetic background, if they live in Southern Italy, they have an odds ratio of 1.21 of leaving into extreme old age, which is actually above 1, so presumably good. Extreme old age being above 99 years old for women and above 95 for men, which suggests a life without Alzheimer's, because once you get diagnosed, your median survival with Alzheimer's is only 3 to 6 years. So if you have ApoE4 and you're Southern Italian and you're living in Southern Italy, you have a great chance of living a long, healthy life. But if you're ApoE4 and Southern Italian and you move to the United States, or you live in the United States, you are much more likely to die early or not live to be into extreme old age. So again, all things being equal, if people lived in the United States and had ApoE4, extreme longevity was 71% less likely. Odds ratio 0.29 in the United States versus 1.21 in Southern Italy, which is pretty astonishing. And this, coupled with the Nigerian study and RCTs that I'm not going to show, but in older populations, basically show us or confirm ApoE4, it is not a causative genetic variant. There are a few that contribute to about 5% of cases of Alzheimer's disease, APP, PSEN1, and PSEN2, but the vast majority of cases of Alzheimer's disease are not caused by genetics. However, ApoE4 is a risk allele. It does not cause Alzheimer's disease, but it interacts with lifestyle factors, boulder pushers, as I'll introduce, to precipitate Alzheimer's disease. So returning to the boulder pusher analogy, ApoE3, it's kind of the baseline risk. We have these metabolic factors, these lifestyle factors that are boulder pushers. How is the situation different in ApoE4? Well, you still have the same boulder pushers in ApoE4, except some of them are amplified, and there might be other boulder pushers. Getting the boulder closer to the edge in ApoE4, meaning you have a little bit less wiggle room. So another way to phrase this is, you're probably going to hear that number, 88% of people are metabolic unhealthy. I'm sure over the course of this conference, somebody's going to say that. Well, if you're in the 88% and you have ApoE3, maybe you can get away with it. But you have a lot less wiggle room. You're pretty close to the edge when you have ApoE4. You cannot get away with being in the 88%. Basically, you really need to focus on these boulder pushers, on neutralizing them so you don't push the boulder down the hill so you can prevent Alzheimer's disease. That's what I'm going to talk about. I'm going to talk about these extra boulder pushers. And fortunately and excitingly, there is so much new cool data coming out in top journals like Cell, Science, and Nature just in the past couple of years, talking about the metabolic how of Alzheimer's disease, how ApoE4, this lipoprotein, this metabolism modifying protein, increases Alzheimer's risk, again, by modifying metabolism. So if you get nothing out of what I'm about to say, because I'm going to bounce around, I'm going to say some things that might go over some people's heads. I hope you just get from this my level of enthusiasm and optimism, because the trajectory we see with Alzheimer's disease is so disheartening. And yet when you start to look at the data just in the past couple of years, this is becoming an area of intense interest. And the amount of data that's just come out in a short period of time is giving us so much more information about, again, the metabolic how of Alzheimer's disease. And I think that is the basis to generating, bottom-up mechanism-informed prevention approaches, which is kind of what I'm going to be talking about. That little, well, you'll see. So again, scope. I'm going to be talking about mechanism, new science in top journals, and prevention, neutralizing the boulder pushers. I'm not going to be talking about symptomatic relief. There's a lot of data on that. That is the stronger data, but those are the data that have been talked about and I'm not going to go after. So just as a case in point, though, this was a study published again this year because so much more data is coming out showing a ketogenic diet significantly improved in Alzheimer's disease, activities of daily living, and quality of life, and with a trend towards improvement in cognition as compared to a low-fat diet. So this is the Phillips et al. Study. You can look that up. But what I'm going to be talking about is prevention, the boulder pushers. With that said, I want to give a 4-hour presentation on this. At some point, I probably will and record it. Right now, I'm going to be talking above the tip of the iceberg. There is so much more. This is all related to Alzheimer's disease and metabolism from papers I've published on it. And I'm just going to be bouncing around, but just know there is so much data coming out on ApoE4. In fact, there was a paper this year on ApoE4 and how it interacts with COVID-19, SARS-CoV-2. So we can talk about that in the Q&A if you're interested. But I think it's such an interesting and exploding area. So one more thing I'll say before I jump into the boulder pushes, I promise this is the last thing, is, again, I'm going to be jumping around a lot, not going over all the data that back the models I'm going to show. So it's going to seem more speculative than I think it actually is. I think there is actually more support. That said, I lay out a lot of the logic behind what I share in this paper, which was published in Nutrients a couple months ago in April, where we talk about precision nutrition for Alzheimer's prevention in ApoE4. This is like microglia, astrocytes, neurons, parasites, blood-brain barrier, and stuff. I did this in collaboration with the Alzheimer's Prevention Clinic at Cornell. So if I start losing you and you just want to, go on mute and go do something else while I bore everybody else, I won't know the difference, and you can read this paper later. With that said, I do want to get into some of the mechanisms. So to start, first boulder pusher is blood-brain barrier dysfunction. And to talk about blood-brain barrier dysfunction, I want to talk about this paper that was published in Nature in 2020. It's actually one of my favorite studies of the past couple of years by Montagny et al. And what they did in this study, it was a human study. They took 245 people and they subjected them to DCE MRI to look at blood-brain barrier breakdown and amyloid and tau levels. So amyloid and tau are the basic pathologies associated with Alzheimer's disease. Those are the two you really think about when you think Alzheimer's disease. And what they found, interestingly, was that even precognitive impairment, so clinical dementia rating score is 0, in ApoE4 carriers, there was an increase in blood-brain barrier breakdown. You can see that here and quantified here. An increase in blood-brain barrier breakdown independent of amyloid tau pathologies. That's really interesting. Blood-brain barrier breakdown was elevated in ApoE4s independent of amyloid and tau. Now, the important question we should ask is this clinically meaningful? Well, it turns out, yeah, it is. So what they did next is they broke people down into baseline groups based on the degree to which they have blood-brain barrier breakdown. They measured this by a cerebral spinal fluid marker, soluble platelet-derived growth factor beta. But basically, they took individuals with high blood-brain barrier breakdown marker and low blood-brain barrier breakdown marker. So high blood-brain barrier breakdown was blue, and low blood-brain barrier breakdown was gray, and they tracked them for 2.5 to 4.5 years over time. And what they found was that increased blood-brain barrier breakdown at baseline predicted cognitive decline on a mental status exam, specifically in ApoE4 carriers, and again, independent of amyloid and tau pathologies. And what this is telling us is it's showing us blood-brain barrier breakdown is a novel and independent boulder pusher in ApoE4 carriers that contributes to cognitive decline, a whole new pathway, which is really interesting. The next thing we want to know is, what is the mechanism behind this pathway? And there are transgenic mouse data that inform this. So this is a paper that went hand in hand with that Montagny paper. This is by Bell et al., also in Nature. And what they showed using ApoE4 transgenic mice is this is the pathway that contributes to blood-brain barrier breakdown. So ApoE4, it's unable to inhibit this protein LRP1, which I'm going to talk about a lot, so remember it, LRP1, which leads to elevated levels of this protein CYPA, elevated NF-kappa B, or inflammatory transcription factor activity, and increased expression of this protein MMP9. MMP9 is a gelatinase enzyme that breaks down the blood-brain barrier. So what they also found in this paper is inhibiting any component of the pathway, inhibiting CYPA, NF-kappa B, or MMP9 was sufficient to protect against blood-brain barrier breakdown and protect against cognitive decline. So the next question we want to ask is how? How could we inhibit, the activity of this pathway? Because that predicts a protection against blood-brain barrier breakdown. Ketogenic diet. So this study shows a ketogenic diet in mice can significantly reduce MMP9 expression. Now, I do want to admit, big caveat here, this particular study was a mouse model of colon cancer. I'm choosing it just because it provides the most illustrative graph for a time-restricted presentation. But it's, I think, pretty plausible to suggest that ketogenic diets would generally decrease MMP9 activity, not just because of these data showing a ketogenic diet does decrease MMP9 activity, but also because the pathway was HDAC mediated, NF-kappa B mediated, and we have other data suggesting that ketogenic diets are anti-inflammatory. They're HDAC inhibitors, and they quiet inflammation and NF-kappa B activity. So there's good reason to believe ketogenic diets could, inhibit MMP9 expression and protect against the blood-brain barrier. So it seems plausible that a ketogenic diet could neutralize this new boulder pusher that came out of this 2020 data, protecting the brain against cognitive decline in ApoE4 carriers. That's pretty exciting. Moving on, I want to talk about endosomal dysfunction. And I'm actually going to use LRP1 from this last paper as a bridge, just because all of these things are interrelated. So LRP1, I said I talk about it a lot. It's a receptor. It inhibits this pathway. And like a lot of receptors and transporters on cell surfaces, it gets recycled through endosomes. So endosomes are organelles. There's an endocytosis, the receptor, the LRP1 that ends up in the endosome, and then can be transported to lysosomes, drop things off for degradation, or be recycled back to the top or the cell membrane. And when there's dysfunctional endosomal recycling, you can have lower levels of surface membrane proteins like LRP1 or others, like insulin receptor, which I'll talk about later. So in this study by Prasad et al. In PNAS, they looked again at human brains. So they did a post-mortem analysis from a large microarray data set. And what they found was that in the ApoE4 brain, there is a downregulation of this protein here, NHE6. And NHE6 is an endosomal protein that leaks protons. And because it would leak protons, it would decrease the acidity of endosomes. And so that suggests in an ApoE4 context, ApoE4 endosomes are going to be more acidic or lower pH. And that's exactly what we find. So in these, this was astrocytes from ApoE3 or ApoE4 transgenic mice. ApoE4 increases acidity or decreases pH of endosomes. And what this does is causes endosomal dysfunction, trapping receptors like LRP1 inside the cell. So you can see surface LRP1 levels are decreased. And that leads to dysfunctions that can contribute to Alzheimer's disease. So the one they looked at in this paper was amyloid clearance. LRP1 helps clear out amyloid from the brain. And as you can see, a decreased level of NHE6 contributes to acidification of endosomes, decreased LRP1 levels, and decreased amyloid clearance in ApoE4. Again, the takeaway, ApoE4 leads to endosomal acidification and the entrapment of LRP1 receptor, leading to impaired amyloid clearance. And, again, these things are related. LRP1 inhibits this pathway, so you might have more activation of the blood-brain barrier degrading pathway. Moving on, how is this effect mediated? How does ApoE4 protein contribute to changes in NHE6 and endosomal dysfunction? Well, it has to do with histone deacetylases. So we can see very clearly here from this same paper is that histone deacetylase 4, which modifies gene expression and increases NHE6, decreases NHE6 expression, is much more active in ApoE4. So you can see here the blue is the nuclei, the DAPI stain, and in ApoE4, you have a lot more HDAC4 translocation to the nuclei, more HDAC4 activity. So what you want to do is inhibit HDAC4. How do you do that? Well, you can do that with HDAC4 inhibitors, obviously. So here, sorry, it's a little small. This is NHE6 expression. This red column is ApoE3. This blue column is ApoE4. And here are the broad spectrum HDAC4 inhibitors. And what's showing is that they recover NHE6 levels to restore endosome function. The ones they focus on were TSA and SHAA. But I want to point out this column here. This is SBUT, sodium butyrate. Sodium butyrate or beta-hydroxybutyrate, they're also HDAC inhibitors, HDAC4 inhibitors, which I can show you here. So butyrate is very similar to beta-hydroxybutyrate, and both butyrate and beta-hydroxybutyrate, they have the same HDAC inhibiting activity as the other HDAC inhibitors, as you can see here. So the data in this study might be, relatable to ketones. And I'll show you data to support that. But what do they find? Well, when you have an HDAC inhibitor, TSA or SAHA, sorry, I'm very dyslexic today. They found that, HDAC inhibition restores endosome pH, reduces acidity, restores surface LRP1 levels, and restores LRP1 function, in this case, amyloid clearance. So, I'm putting a lot of pieces of the puzzle together. I was predicting to you, okay, because ketones are also HDAC inhibitors, they should also restore endosomal function and restore LRP1 levels. That's a lot of leaps of faith, right? That said, if you go into the literature, again, new literature just from 2020, and ask the question, does BHB also restore, say, LRP1 levels? Well, it turns out, yeah, it does. So in this, this was an in vitro blood-brain barrier model, brain-like endothelial cells, or BLECs. They showed that, just like TSA and SHA restore LRP1 levels, ketones, BHB, restores LRP1 levels. Thus, HDAC inhibition and beta-hydroxybutyrate, they both restore LRP1 levels, and this can help restore amyloid clearance and endosomal function. But this is only the tip of the iceberg. Because while I focused on LRP1 as a case in point, endosomal function, it's a core pathology of Alzheimer's disease. So other proteins like ABCA1, which is involved in ApoE lipidation, insulin receptor, which is involved in cerebral insulin resistance, they're also trapped in endosomes. And this is associated with ApoE4. I'll talk a little bit about insulin receptor later. So the endosome entrapment model can explain increased blood-brain barrier breakdown, altered amyloid efflux and increased plaques, changes in lipid function, dysfunctional lipid transport, lipotoxicity, and cerebral insulin resistance. I think that the endosome model is one area ripe for exploration where we'll see more research in the coming years. But what we do know is that, consistent with the model I put forth, ketones can restore at least LRP1 levels. So it's a hypothesis. There's actually more data too to support this hypothesis. Again, this is all just from the last couple of years. So I'll kind of go through this quickly because I'm a little bit rambly, but let's take this protein, for example, PICOM. So PICOM, which stands for phosphatidyl inositol binding platform assembly protein, it's a master regulator of endosome function. PICOM influences endosome function, and PICOM mutations are actually themselves associated with Alzheimer's disease. And functionally, PICOM is related to receptors that get cycled through endosomes like LRP1. So people have speculated that a core defect in PICOM can cause endosome dysfunction, and this is associated with Alzheimer's disease. And so what in this paper they did is, using human iPSC-derived astrocytes, they found that increasing PICOM expression completely rescued endocytic dysfunction in ApoE4, which is pretty exciting. These results suggest that increasing PICOM dose uncouples the presence of ApoE4 from its detrimental effects on endocytosis. How does this relate to ketones? Well, maybe ketones can, they increase LRP1. Would they increase PICOM, which would predict improved endosomal function? Heck yeah. So in this paper, ketone bodies significantly enhance protein levels of LRP1, PGP, which are again cycled through endosomes, and PICOM, described to be involved in amyloid clearance. So again, what we see here is that ketones increase levels of a master regulator of endocytosis, which is dysfunctional in ApoE4. Summing it up in just this little model, it's theoretically possible that ketogenic diets could increase PICOM levels to help restore endosome function in the ApoE4 context, restoring LRP1 levels, PGP levels, ABCA1 levels, and insulin receptor levels, and more. So another boulder pusher in the books. It's feasible that ketogenic diets can help restore endosomal functions in ApoE4 carriers, which is pretty cool. Moving on, a favorite topic, I think, of some of the people listening, we'll talk about cholesterol and energy metabolism. So this is a cool paper that came out this year in Cell Press and Neuron. It was in vitro data and ApoE4 transgenic mice about cholesterol metabolism, which is hot in the keto sphere, and energy and microRNAs, weirdly enough. So for those of you who don't know, microRNAs are small non-coding RNAs that inhibit mRNA translation into protein. So they inhibit protein expression at the translational level. This paper was quite complicated, but I want to bring it down to earth a little bit by building on Dave Feldman's lipid energy model. So if you guys aren't familiar with this lipid energy model, that's a shame. You need to learn more about it. That is a request from me, please, because it's so cool, and I love Dave. But Dave, proposes this energy model of boats in the bloodstream, whereby ApoB particles, specifically the LDL lineage, the VLDL-LDL lineage, functions to transport triglycerides, little lightning bolts, and cholesterol from the liver to peripheral organs around the body as a form of energy transport. So the triglycerides are the energy, and the cholesterol is coming along for the ride. In analogy to that, I want to talk about not ApoB, LDL as boats in the bloodstream, but ApoE lipid particles as boats in the brain. So, like LDL particles, ApoE particles carry cholesterol. That's the plus side in Dave's model, and that's the plus side in my model. Here's cholesterol. ApoE particles carry cholesterol around the brain. They also carry microRNAs. Now, what are the microRNAs doing? So, well, I guess first question, where is ApoE carrying its cargo from and to? Well, astrocytes, or support cells in the brain, they're the main producers of ApoE, and they're the main producers of cholesterol. They're the thing that produce most cholesterol for neurons. So astrocytes produce ApoE containing lipoprotein particles that contain within them cholesterol and microRNAs and ship them over to neurons. So we know the cholesterol is being delivered to neurons to be incorporated into membranes. What are the microRNAs doing? The microRNAs are actually inhibiting cholesterol synthesis at the by inhibiting the expression of cholesterol-producing enzymes at the translational level. So this is a figure from the paper, and each blue square is a different microRNA inhibiting that protein's expression. So this is the rate-limiting enzyme, HMG-CoA reductase, and you can see all the microRNAs that target it for decreased expression. And now I do want to emphasize here, this is not decreasing brain cholesterol production overall, but shifting the burden of cholesterol synthesis from neurons to astrocytes. And thinking energetically, this makes a lot of sense. Why would it make sense to shift the burden from neurons to astrocytes? Well, one, cholesterol synthesis, it's a very energetically expensive process. So it makes sense to try to relieve the metabolic demand on neurons so neurons can do other things like express memory genes. In addition, acetyl-CoA is a precursor to cholesterol. So de novo neural synthesis would deplete a Krebs cycle, a TCA cycle substrate, which is needed to produce energy. Also, acetyl-CoA is needed to acetylate histones and alter gene expression or increase gene expression. And these aren't just things I'm coming up with randomly. This was in the paper and supports the model that I'm going to show you. But the bottom line I'm trying to express with this slide is it makes energetic and adaptive sense to shift the burden, not reduce cholesterol synthesis, but shift it from neurons to astrocytes. So, astrocytes, they send, I'm first starting with ApoE3. So this is baseline. This is what should be happening. That ApoE3 particles, or ApoE particles, they carry the cholesterol and the microRNAs to neurons. In carrying the microRNAs, those microRNAs, as we know, they decrease cholesterol synthesis enzymes. And you can see that here. So like HMG-CoA reductase, when you have the microRNAs, you decrease the cholesterol synthesis enzymes. This leads to an increase in the acetyl-CoA pool, as I alluded to, leading to an increase in histone acetylation, and you can see that here. Here's histone acetylation, and an increase in memory gene expression. So again, ApoE particles, they deliver microRNAs, supplying cholesterol, which neurons need. Relieving the cholesterol synthesis burden on neurons, you can increase the acetyl-CoA pool. You also have more energy. You can increase histone acetylation, and you can increase memory gene expression. How does this situation differ in an ApoE4 context? Well, in ApoE4, actually delivers less cholesterol for whatever reason. I don't even know why, but ApoE4 particles, they deliver less cholesterol. And so it would also make sense that they're not going to want to inhibit cholesterol synthesis as much because the neurons still need cholesterol. So they deliver fewer microRNAs. And you can see that here. ApoE delivers fewer microRNAs and less cholesterol, leading to a smaller decrease in cholesterol synthesis enzymes. So fewer microRNAs in ApoE4. This is ApoE4 versus ApoE3 ratioed, and then a smaller decrease. So this column is ApoE3, this column is ApoE4. So a smaller decrease in the ApoE4 context, meaning that there's going to be a depletion of the acetyl-CoA pool, meaning there's going to be less histone acetylation, meaning there's going to be worse expression of memory genes in an ApoE4 context. How does this relate to ketones, or specifically the ketone body beta-hydroxybutyrate? Well, if you think mechanistically, beta-hydroxybutyrate is perfectly situated to address all the nodes in this pathway. So, for example, BHB we talked about how we showed data showing it can improve LRP1 levels. And LRP1 is actually the thing that helps mRNAs get delivered to neurons. So although there might be fewer microRNAs, it can help the efficiency of delivery of the microRNAs are there. So that helps. It also is a direct precursor for acetyl-CoA. It has been shown in studies to boost the acetyl-CoA pool. So it could, intervene at this stage of the pathway, providing more substrate for histone acetylation. And it's an HDAC inhibitor, further increasing histone HDAC activity and increasing histone acetylation to promote memory gene expression. And it's an energy substrate. So even though the energy burden on neurons might not have been relieved as much, it gets more energy now from BHB. So there's lots of different ways that ketones could affect this pathway. Again, this is speculation, but this is 2021 data. So, maybe I'm laying out some areas of exploration. But again, these mechanisms are plausible and they're very interesting. So that's one more boulder pusher in the books. One more way a ketogenic diet could help prevent Alzheimer's disease by neutralizing a specific boulder pusher in ApoE4. Next boulder pusher, vascular defects. This was also 2021 data and in Neuron, so Cell Press, by Yamazaki et al. And this is an interesting paper because they did an ApoE4 transgenic mouse model, but a conditional expression model. So they only expressed ApoE4 or ApoE3 in vascular mirror cells. So they would be only affecting vascular function. What did they find? Well, there was decreased cerebral blood flow, no surprise. And this was sufficient to cause a decrease in long-term potentiation, which is the basis of memory, and a change in behavior. So these data are showing that vascular defects associated with ApoE4 are sufficient to, really contribute or cause in this model features of impaired memory and behavioral manifestations that would be associated with Alzheimer's disease. And this is a whole field or subfield that's being explored. Sidney Strickland or Rockefeller is really the big name in this field, talking about how vascular defects are a core early pathology of Alzheimer's disease. Some people think there are always vascular defects in Alzheimer's disease, and there's a lot of overlap between vascular dementias and Alzheimer's disease. And it's interesting to look at some of the trials for addressing Alzheimer's symptoms or slowing disease progression, because they inevitably have really high rates of hypertension. So 70% hypertension in this trial, which is not cherry picked. Just I went for the finger trial because it was the one that I had on hand. That's ridiculous, 70% hypertension. Now, it's no surprise, I think, to anybody listening here that our society is basically structured for vascular dysfunction. If you think about the way we eat, the high glycemic carbs contribute to insulin resistance, along with the snacking, also insulin resistance. that decreases nitric oxide levels, which impairs vascular function. Also, the high fructose corn syrup, the fructose generates uric acid, also decreases nitric oxide, more vascular dysfunction. It's a high glycemic carb. We get the glucose excursions causing endothelial damage, and round and round and round. Sedentary lifestyle, stress, cortisol, all these things. And to address vascular dysfunction, really it's again, holistic lifestyle intervention, but we do have pretty good data suggesting low clean, low carb diets can improve vascular function. I won't carry the burden of talking about all of that, but if you're interested in that topic, I'd refer you to some of the work by Dr. David Unwin. Another one of my role models, I remember listening to a presentation by him this past summer where he was looking at low carb diets in diabetes and showed that low carb diets were about twice as effective as SGLT2 inhibitors for hypertension and diabetics, which is pretty cool in my opinion. So one more boulder pusher. Clean, low-carb diets, or a lot of interventions, to be perfectly honest, could address vascular defects that underlie Alzheimer's disease, and in particular in an ApoE4 context where the gene itself or the gene variant can exacerbate vascular defects. Again, get less wiggle room if you're ApoE4. Moving on, microglia. So microglia are the resident immune cells in the brain, inflammatory cells, that contribute to Alzheimer's disease. Inflammation in the brain contributes to Alzheimer's disease. And I want to relate this to the standard amyloid cascade hypothesis, which you probably all know about, in which Alzheimer's amyloid contributes to neurofibrillary tau tangles. These are the two main pathologies associated with Alzheimer's. But there's a lot of question of what links amyloid to tau. And one of the things that links amyloid to tau, there are several, is microglia, these inflammatory immune cells in the brain, and specifically NLRP3 inflammasome activation in microglia. So what you see here in this graph, this is from Alzheimer's disease mouse model. And what you see here on the y-axis is AT8. It's a marker of phosphorylated tau. So this. And this APP mouse model is going to have increased amyloid. But what you find is if you knock out the NLRP3 inflammasome, it neutralizes the effect. So there's no linkage between amyloid and tau, suggesting that microglia and NLRP3 inflammasome activation help link amyloid to tau, which contributes to neuronal dysfunction. And, no surprise, ApoE4 can kind of exacerbate this, push the boulder closer to the edge, where ApoE4 makes microglia more inflammatory. It can help activate microglial NLRP3 activity. So the goal should be to help, decrease inflammation in the brain, which you can do through a clean keto diet, but I'll get to that in a minute. This is just this is human data from the Freiberg study that was the opening slide of this boulder section. So in this study, they took 154 autopsy brains, actually from the Framingham heart study population. And they were looking at activated microglia. This is IBA1, a microglia marker, and associating with tau pathologies. And what they found was that specifically in ApoE4 people, the red line, there was a correlation between microglial activity and tau pathologies. There was a trend, it looks like, in the ApoE4 negatives. It was much stronger than positive, suggesting a goal, probably in everybody, but specifically in ApoE4 carriers, at least should be to quiet microglia, calm them down, decrease inflammation by inhibiting the NLRP3 inflammasome. And as many of you may know from the famous 2015 Yeoman et al. Data, ketones inhibit NLRP3. But I'm not going to show that data, probably because a lot of you have seen it. Instead, show new data from Shippey et al. And this was a brain model, Alzheimer's model of Alzheimer's disease. Sorry, a mouse model of Alzheimer's disease. I think all Alzheimer's models of Alzheimer's disease are Alzheimer's disease. And what they found is that BHB ketones inhibit NLRP3. So you can see here also, BHB in the amyloid mouse model decreased microglial activity. And this, again, new data from 2020. This is again saying ketones probably or plausibly can neutralize a boulder pusher in ApoE4, which is cool. Now, the moment a lot of you have probably all been waiting for, insulin resistance and insulin receptor. So This is the oldest study I think I'm actually showing, which is saying something because it's a 2017 study, but it was published in Neuron and Cell Press. It's a great study by Zhao et al. It was an ApoE4 transgenic mouse model looking at insulin signaling, and what it showed was that ApoE4 traps insulin receptor, you can see here, inside cells because it creates endosomal dysfunction, tying back into the beginning. So just as a review, this is the insulin signaling cascade where insulin binds to receptor tyrosine kinase, activates insulin receptor substrate, PI3K, PDK1, AKT. But I want to focus on this protein, which you might not heard as much about, GSK3 beta, glycogen synthase kinase 3 beta, named because it phosphorylates glycogen synthase and changes glycogen storage. But this protein, in my opinion, its name underrepresents its importance, especially in the brain. So GSK3 beta is really important in the development of Alzheimer's pathologies. So both amyloid and tau pathologies. GSK3 beta, it changes how amyloid precursor protein is cleaved, promoting toxic amyloid oligomer production. It also can help increase levels of BACE1, beta secretase, which helps, again, produce toxic amyloids. And another name for GSK3 beta is tau kinase 1, because it's one of the principal tau kinases that phosphorylates tau, making hyperphosphorylated tau neurofibrillary tangles. Again, bottom line, GSK3 beta contributes to the major pathologies associated with Alzheimer's disease. And just because it's such a bad guy in the brain, I'm now stereotyping it, I had to throw in a little subtle joke in one of the papers I published. I don't know if this looks like anything or anybody to you. I don't know if we have any Game of Thrones fans, but I couldn't help it. Anyway, maybe that joke was lost on some people. I hope some people got it. If you get it, I love you. More to the point, what they showed in this study was that in the ApoE4 context, mice were much more vulnerable to increased GSK3 beta activity, insulin resistance, induced by an obesogenic diet. So you can see here high-fat diet, which is a high-fat, high-sugar diet, caused PGSK3 beta over GSK3 beta is inhibition of this protein. So lower levels mean less inhibition, more activity. And we can see that in the ApoE4 mice, but not the ApoE3 mice. The obesogenic diet, the standard American type diet for mice, led to a decreased inhibition of GSK3 beta, meaning that you're going to get more amyloid and more tau. So just summing it up in a little graphic, more social media media references, a trash diet like sucrose, Lodex, which is a carb, lard, and soybean oil, it's like pork rinds and Coke for mice, contributes to insulin resistance, the activation of GSK3 beta, and then amyloid and tau pathologies and Alzheimer's disease. There's a lot more I could say on insulin resistance in the brain and ApoE4. It's just such a wide topic. I'm just going to throw some things out there. HOMA-IR score, so higher indicating more insulin resistance, leads to decreased or is directly correlated with decreased cerebral glucose metabolism. And also increased insulin resistance is associated with worse cognitive functions. Hyperinsulinemia, which goes hand in hand with insulin resistance. So if you're insulin resistant, you're going to have high insulin levels, and insulin competitively inhibits this protein here, insulin degrading enzyme, which degrades amyloid. So insulin degrading enzyme, it degrades amyloid and insulin, but if you're insulin resistant, there's more insulin, and it competes with the enzyme, so less amyloid gets degraded, which then starts a vicious cycle, leading to more GSK3 beta activation, also more insulin resistance, and spiraling down. This is the part of the path where the boulder is rolling down the hill, and you get a vicious cycle. So let's not push the boulder. Furthermore, if you're eating a diet rich in sugars, you're going to get more advanced glycation end products. And ApoE4, it binds advanced glycation end products much better, about 3-fold better than ApoE3. Again, ApoE4, it exacerbates the damage of unhealthy lifestyle choices. So it's unhealthy for everybody, but ApoE4 just multiplies that effect. How do we address insulin resistance or prevent it? Well, we know what effect, a clean low carb diet can have. For a lot of people, it can put insulin resistance in the grave. Anyway, that was a lot. Just summing up, coming back to this model, this boulder down a hill model. The goal is not to push the boulder down the hill. Don't be indie running. And what we found through exploring the mechanisms, and I don't have clinical data on this in part because, we're never going to do these 20, 30-year clinical trials that need to be done. But also, I specifically chose to focus on new data coming out in 2020 and 2021. So this is all new. I'm just trying to set up a framework for why this makes sense mechanistically. And what we found is that clean ketogenic diets, they can potentially protect against the pushers of blood-brain barrier dysfunction, endosomal dysfunction related to LRP1, ABCA1, which I didn't even get to talk about, insulin receptor, improve cholesterol and energy metabolism. That was that model with Dave's boats in the bloodstream and my brain in the bloodstream, or boats in the brain. Vascular defects, activated microglia calming neural inflammation, improving or protecting against insulin resistance. It's all very interesting and very plausible. Now, very obviously, what I provided here is speculation. I 100% admit that. But what are our options for true prevention? Because there are no true prevention trials, nor do I think will there ever be for a disease that starts decades before symptoms manifest. Epidemiology just shows us that lifestyle factors will be protective. It doesn't tell us which we should actually implement, especially with respect to nutrition. It doesn't allow us to draw conclusions about what to eat. So all we really have with respect to prevention in nutrition is informed speculation. And for people like myself, living at high risk for Alzheimer's disease, people across the lifespan from this baby to this man, mechanism-informed speculation, and these will be my last words, mechanism-informed speculation. It is speculation, but it's far better than just a shrug. Thanks for listening.
Thanks, Nick. Paul, look, ApoE4 has almost been a death sentence previously, but it's clearly not, not that way.
No, and what I often say is that genetics is not fate. And while we do know that for the average person leading the average lifestyle, carrying ApoE4 can increase your risk of Alzheimer's disease and dementia, it doesn't have to be like that. And Nick just presented two very neat studies. So one of my favourite ones is when they took a group of ethnic Nigerians living in the city of Indianapolis, and they compared them to an identically similar group of Nigerians living in a city called Ibadan. And these two cities were historically linked by the slave trade. And they had the same rate of ApoE4 carriage. And incidentally, it's the highest rate of ApoE4 carriage of any population in the world. And they found that the population living in Nigeria had 2.5 times less risk of Alzheimer's disease. So it really goes to show the impact of lifestyle. So, and in Southern Italy study, they actually found that if they had ethnic Southern Italians living in Italy, they had a very good chance of living to a ripe old age, what they call extreme old age. But if they were living in a similar city in America with poorer metabolic health, as we know that, of US adults, only about 12% of US adults are actually metabolically healthy, then their chances of living to a ripe old age were way down. So I guess the key thing to remember is that if you do have ApoE4, it's not a death sentence. It doesn't necessarily consign you to developing dementia, but it is really, really important that you take care of your metabolic health. It's more important for you than for most people.
Yeah, absolutely. We all need to be metabolically healthy, but particularly if you're ApoE4. So, fascinating. It's certainly not as all gloom and doom as people have led us to believe, but you've got to be metabolically healthy. All right, what do you got for us now?
Well, we have one of my good friends, Dr. Pran Yoganathan, who's going to be presenting on the, I guess, the evolutionary history of the gastrointestinal tract, the gut. I've seen him present before on this topic. It's absolutely fascinating. He does an incredible job, and it's going to be a cracker of a lecture.
Thank you very much for joining me today to discuss the topic which I've titled The Human Gut. My name is Pran Yoganathan. I'm a gastroenterologist, hepatologist, and diagnostic and interventional gastroenterologist in Sydney, Australia. I've always had a interest in the human gut and the origin of the human gut, or the evolutionary process that shaped it. And it is fantastic to be given the opportunity to talk about this today. So when I started this talk, I started off with the concept or the question of what is the meaning of life, and not from a philosophical perspective, but rather from the perspective of what is the basic purpose or meaning behind how and why we exist. And the human gut, or the gastrointestinal tract, is intimately tied in with this, because we understand that the basic purpose of the human digestive tract is to take food in its undigested state and to break it down into its fundamentals, which is the amino acids, the carbohydrates or the starches, and also the fat, to provide the substrate required for the human body to be optimized, to function optimally. Now, how each species of animal reaches this is quite different, and the way they enlist their microbiota to help them with the task that digestion involves is also extremely different. Why does this matter? This matters because the differences in digestive physiology are important. They allow us the determination of a diet that is appropriate to that particular species of animal, and how broad the range of foods an animal can eat. So just on the slide here, we've got, and I hope this projects, we've got a few animals that we would classically look at as pure herbivores, such as the kangaroos and deer, and even animals like the giraffe, actually consuming foods that are other animals. Essentially, they're displaying some aspects of carnivory in their behaviour, and they do this when essentially there is an element of nutrient starvation. And we see here some photos of the chimpanzee eating another monkey, and this is not an uncommon behaviour seen in these sort of creatures in what we have classically thought to be herbivores. So they do this in times of nutrient stress to ensure that they achieve the nutrient requirement. And we see the same thing in reverse here. We see a lion consuming grass. And this, I've taken this excerpt out of a video, but to be fair, the lion ends up vomiting out most of that at the end of the video, and doesn't look overly impressed with what he's consumed. And of course, we see this commonly with our domesticated dog. They do tend to eat some animal, to eat some plant-based food as well. So a very simple digestion fact is the fact that we've got to acknowledge that no mammal on this planet is evolved to be a universal digester of all foods. For instance, just to put that in a very practical perspective, a human cannot exist on the diet of a sheep, and a koala cannot exist on a diet of any of these other species either. So the question is, what are we supposed to eat? What are we humans evolved or built to do? Now, that's a very confusing topic. But if we were to look at our biggest search engine and ask that question, we end up with a state of confusion. All you need to do is type in red meat to know that there is many schools of thought as to whether that is good or bad for us. If you were to type up which diet is best, that's another confusing situation. And of course, with the rise of the plant-based movement, which seems to be quite popular, the search engines seem to be quite plant-based centric in terms of what they're promoting. So fundamentally, we end up with confusion. So nutrition in med school, and if we were to look at our doctors as kind of the pillars for understanding health and wellness, well, you end up with a problem, because as this meta-analysis shows, that most medical students leave medical school, the vast majority, in fact, without a good understanding of nutrition, nutritional science, and what constitutes a healthy diet. Most do not feel confident to prescribe that type of diet or a diet to their patients, which is interesting, given that we do feel that most chronic illness, of course, is driven by a lifestyle, in particular diet. So then do we look to our dietitians and nutritionists? And I guess we could, but the problem is the vast majority that I've had experience with, I can't speak for all of them, of course, but tend to fall back to this food pyramid that we know so well, that we've understood over the last 4 decades to be the pillar around which a healthy diet apparently should be built. However, I'm not sure that this pyramid is constructed from perfect evidence, and I think some of or a lot of our chronic illness that we do see now is perhaps we've led people to eat down this very closed pathway. So what we end up with is a state of confusion as a population. I do genuinely think we as a species are confused as to what we are best suited to eat. So as a gastroenterologist with a pragmatic approach to medicine, I wanted to reverse engineer the problem. I wanted to look back and see what it is that we're built to do. And if we could figure that out, perhaps we could work out what it is that we're supposed to eat. To simplify the discussion, let's look at a broad range of digestive tracts in the animal kingdom. So we've got the ruminant foregut fermenters, such as the cattle and sheep, often called the ruminants. Now, these animals use their foregut or proximal upper part of their gut to do the vast majority of their digestion. We've got the non-ruminant foregut fermenters, such as the kangaroos, colobus monkeys. Now, these animals lack the complex ruminant stomach, which is a four-chamber stomach, but have a very, very large, capacious upper gastrointestinal tract to allow for the fermenting. We've got the hindgut fermenters, such as the horse. These animals have a huge capacity in their hindgut, which is the colon. And then we've got animals that are the midgut or autoenzyme dependent digesters. These animals are not primarily fermenters, and these are humans, pigs, and practically all carnivores and rodents. So really, what we are, just to simplify it, we are very adaptable digesters, and species such as pigs and humans that rely primarily on this non-bacterial enzymatic breakdown of food in the foregut, i.e. we're not dependent on fermentation, we're adaptable because we also gain nutrition from hindgut fermentation. But with the hindgut fermentation, this is always a partial bargain. And the reason for this is that we utilize the species of bacteria that exist in our hindgut to help us with that fermentation process, as in our digestive tract, excluding the bacteria, is unable to harness these foods for any sort of energy. So we have to utilize the microbiome, and vast majority of our microbiome exists in the hindgut, of course, and we utilize them to ferment foods such as non-absorbable carbohydrates and even protein species that we can't absorb, although it is rare that protein ends up in the colon. But it is a partial bargain, as the bacteria themselves have to utilize the fuel created as components of food for themselves, and they give us a little bit. It is important to realize that the human digestive tract is actually relatively small. It is a very, very small stomach, highly acidic, with a very long, large intestine built for absorption, huge surface areas. We've got these villus structures that essentially little finger-like projections through the lining of the small bowel that enhance surface area for absorption, where enzymes are created. Additionally, we've got our pancreas and our biliary system, which enhance absorption. The really key feature is the fact that our large bowel is actually extremely thin-walled. It's very thin-walled and short, very similar to the pig and the dog. The orangutans and the primates often tend to have a very thick, capacious, large bowel, which allows for fermentation. And you can see this with animals such as the kangaroos, which are the non-ruminant foregut fermenters. They've got a very, very thick, large-walled stomach. The sheep and the cows, which are the ruminants, tend to have the four-chambered stomach. The horse, which is a very, very hindgut dependent digester, tends to have a large hindgut, and koala tends to be very, very similar. So with humans, pigs and dogs, we tend to have a very similar gut, which is very small bowel dependent and not so dependent on the large intestine, of course, with a very acidic stomach. Let's look at ruminants. These animals, such as the cow and the sheep, they tend to have a very, very complex stomach, which is where they do most of their digestion. In fact, it's very interesting. The four stomachs of the ruminant tend to have different functions. They use different species of bacteria there to be able to extract energy from their foods, a very inefficient method of doing it. Now, what's interesting in these animals, when you feed them excessive amounts of grain, which is, of course, how a lot of the feedlots do it to allow for the marbling or the increased fat composition within these animals, which make them, of course, more palatable, as we humans desire that taste of fat. These animals can end up with something called grain overload, which is essentially lactic acidosis and dysmotility of the gut, where the gut stops moving and they develop gut distress, and it can be fatal unless treated very early. So grain in these animals, when it's overdone, is problematic. And I'll come back to that issue a bit later on. So just to kind of summarize, we've got these autoenzyme digestives such as the pig, the human, the lion, the rat, and basically any carnivore. And as I've pointed out, we rely on this very complex system of plumbing through the gastrointestinal tract. And included in that gastrointestinal tract is the fact that we rely on liver and pancreas and gallbladder to help us supplement these enzymes that are proteolytic or lipolytic. They help break down or break down starch. They help us break down the three macronutrients into their basic constituents to allow for enhanced absorption. So let's look at primate. We're a species of primate, and in humans, as a primate, the colon only represents about 20% of the total volume of the digestive tract, whereas in apes, especially the greater apes, it's about 50%. Now, the sizable colons of these huge, large-bodied primates permit fermentation. This is fundamentally machinery that allows for these animals to use low-quality plant fibers to allow extraction of energy in the form of short-chain fatty acids. Humans, amongst this primate species, are relatively poor because we are autoenzyme-dependent omnivores. We are not great at digesting uncooked plant fibers. So question is, are we a carnivore or an omnivore? We've figured out we're not a herbivorous species or a species of herbivore. Are we a carnivore or an omnivore? The answer is we lie on the spectrum. The answer is not simple. It's not black and white. We are very, very similar to a pig, a very similar omnivore to us, and a dog, which is a carnivore capable of consuming an omnivorous diet and has a reduced cecum and a short colon. So this is what we are, a carnivorous species of ape, which is capable of consuming an omnivorous diet that has a reduced cecum and short colon. So we fundamentally, I think, are best described as cookinivores, as in we rely on cooking and food preparation and preservation techniques, and we should be classified as a species based on this. So let's think a little bit further and look at a bit of history. And Winston Churchill said, the farther backwards you could look, the farther forward you are likely to see. A very wise comment. Without being able to prepare and cook foods, some of the major nutrient sources that we as humans use now will not be readily available. The most obvious is grain. which only became a common food for us humans about 10 to 30,000 years ago with the development of the ability to grind, to create flour, to utilize that for cooking grains, which is actually a very poor accessible, is very poorly accessible to access any nutrients as a food source. It now, grain accounts for about 70% of our dietary intake in our modern society, which is stunning. It's quite obvious that cooking shaped the human society and human physiology, and it was an important enabler for us humans to evolve larger brains, beginning with Homo erectus about 2 million years ago. There has been no species of humans in recorded history that have lived without cooking. Okay, that is a fact. As I mentioned, we also use other methods such as storage, prolonged marination, grinding, so forth, to help prepare the foods. Cooking changes the palatability and the digestibility and texture of foods, of course, and it removes toxins. Raw food diets, these have been popular in the last few decades. They have a major disadvantage in history because of infection, basically. Now that infection's a bit less of a problem, these sort of diets have taken off. Even if we ignore the problem of infection, we are less adapted to consumption of raw versus cooked foods. Modern humans on all raw food diets tend to be underweight. They tend to suffer chronic energy shortage, and a lot of them do tend to have issues related to their reproductive function. Also, raw food diets, I mean, from a palatability perspective, are less rewarding, and they also demand too much ingestion time for us humans to satisfy the demands of this energy-hungry brain. Cooking, there is no doubt, increases energy gain and increases the bioavailable energy from our carbohydrates and protein-rich foods. It also increases the availability of some nutrients, in particular the vitamin A precursor, beta-carotene. So in terms of detoxifying, gastric acid and proteases within our gut kill most bacteria in our food, which can usually overwhelm defenses. Salmonella, Staphylococcus listeria, these are all major public health issues, but definitely cooking helps us to detoxify this at a grander or in a more effective way. There are some thoughts that there are loss of nutrients and disadvantages of cooking with toxic compounds such as acrylamide, furan, acrylamide, but I'm not. I remain unconvinced by this. There's also talk of advanced glycation end products. These occur in particular in fast food settings where proteins and fats are cooked in the presence of sugars at high temperatures. This doesn't occur in nature, of course, amongst, say, the hunter-gatherers, but very, very popular way of preparing fast foods. And this has been shown to contribute to diabetes and cardiovascular disease. Processed food in the human diet. This is important. Now, processing is a way of preparing and preserving food that transforms food so it's more digestible. So we use all these methods, which we've already spoken about. However, in the last 150 years, the processing methods have changed completely. So we've gone from grinding, pounding, fermentation, drying, salting, cooling, and burying to now heat sterilization, microwaving, mechanical refrigeration, irradiation, and vacuum packing. And there's no doubt in the future that we will develop more of these techniques. Let's look at digestion of grains, and you saw what grain overload did to cows. Let's talk about grains. So grinding of grains in humans started only about 30,000 years ago. And the evidence comes from the starch grains in the surface of grinding stones, which have been found in our fossil records. In the absence of grinding and cooking, grain starches would not be accessible as a human food source. That is a fact. So it's very interesting because birds lack these cellulases as well. So what some species of birds do, they carry little stones within the muscular part of their stomach called the gizzard, and they use these stones within their stomachs to grind seeds to make seed starches available to their digestive enzymes. In terms of the advantage of grain for us humans, it definitely freed time for development of technology, food, and technology and culture. There was food abundance as what was perhaps not an optimal food source, however, a steady food source. It allowed for easy food storage as it would store better, and it allowed for efficiency of digestion of processed food. So we could essentially settle to build civilizations. And that was one advantage. To touch very briefly on fermentation, which is another method that we've utilized. Fermentation is interesting. Alcohol in itself provides an energy source by conversion to triglycerides. Humans probably first ate fruits for which fermentation occurred naturally, as in it dropped on the ground, and the bacterial species and the yeast species would have rotted these foods and created an alcohol-based substance, which our species probably enjoyed through the utilization of or through the consumption of these foods, and additionally it served as an energy source. However, being the ingenious species of ape that we are, we learned to control that fermentation process and decide, and we could create alcohol, which we primarily used for pleasure rather than an energy source. Let's touch on fiber briefly. This is an important slide. Fiber is often confused as to what its function actually is. We utilize something called soluble fiber, which is what psyllium husk, which is a very common fiber supplement that's used in modern societies. So fibers that are soluble as opposed to insoluble, these can be fermented by our hind gut, our colon, to produce something called short-chain fatty acids, which is the butyrate, propionate, and acetate as well, which are fundamentally ketones. Now, these ketones are utilized by the colonocytes, which are the cells that line the gut. And if enough ketones are produced in excess of what the colon requires, this can be absorbed via portal vein circulation and distributed into the systemic circulation, although you do have to have an optimal microbiome to be able to do that. Now, it's very interesting. Fiber is essentially touted as this very important substance or a nutrient, but it's not a nutrient. It is not something that we ourselves can use, but our microbiome uses it, in particular soluble fiber. It accounts for maintenance energy in a very, very low percentage in humans. Now, let's look at dogs, for instance. In dogs, which are a highly carnivorous species, of course, short-chain fatty acids account for 2% of our fuel. In humans, it accounts for 6 to 9%. And in pigs, which are a very similar omnivore to us, it accounts for 10 to 31%. And in horses that are very dependent on hindgut absorption or short-chain fatty acids, it accounts for 46% of a horse's energy. So on that spectrum, you can see where we lie. And fiber, I don't think, is a source of us being able to obtain nutrients. As you can see, where does the rest of the 90% of our fuel come from? So it's a surprise to me that this pyramid that we look at pushes the concept of fiber greatly. It really pushes that concept of a high fiber diet, and a lot of our dietitians and doctors, of course, push that concept, and it's seen in this sort of food pie as well, as in a very similar way. The problem with this, we end up with a state of protein dilution, and essentially I don't think we're consuming enough protein. So we end up with this vicious cycle where we've said the food pyramid's the way to go, and that saturated fat is bad and high fiber is essential. We've also pushed that narrative in the last few decades of red meat causes disease. So we end up with this protein dilution in the diet, which leads to issues with satiety, as we can't reach that level of satisfaction, which allows us to then overeat these hyperpalatable foods, which we find ourselves surrounded by. And we end up with this state of energy excess, which is what I think obesity is. And this was quite elegantly described by Simpson Rubenheimer in their seminal paper, which is termed the protein leverage hypothesis. And has also been quoted a number of times in journals such as Obesity. So just to step back a bit, we as humans carry a very, very low pH value, a very acidic stomach, which is actually in the same spectrum as almost these birds of carrion that eat foods that are rotting. So it tells you where we've spent most of our years of evolution. I do think we've spent a lot of our 4 million years from a fruit-eating, tree-dwelling primate to fundamentally an apex predator, but a lot of that was spent scavenging as we made our way up through the food chain. So really, what we are is a primate built for nutrient density, and that is reflected, again, to repeat what I've said before, or to echo what I've said before, in our small bowel. And you can see our small bowel length compared to our primate cousins is enormous. And you can see our colon has really shrunk because we became less dependent on hindgut-based absorption and fermentation. And that leads to something called the expensive tissue hypothesis, which echoes what I say, which is that a higher quality diet led to a smaller gut, which then led to a larger brain, which allowed for more complex foraging behavior, which was a positive feedback loop as it allowed for higher quality foods. So essentially, as the gut shrank, the brain increased in size. So when we look at this in our time scale, like when we first gained control of fire 2 million years ago, we spent the next few million years fundamentally eating the same way, pre-agriculture. Now, 9,000 to 15,000 years ago, we start introducing grains in the diet. What drove this is difficult to know, potentially climatic shifts, potentially a change in the animals around us. There was massive megafaunal extinction, which initially was thought to be seconded over hunting, but this is unlikely to be the case. In more recent reports, we think a cataclysmic event called the Younger Dryas event potentially wiped out a lot of these animals. So potentially we were forced to adapt grains as our staple. But as I've pointed out before, grains allowed us to settle, adopt a steady food source, which allowed us to build civilization, and this is why we find ourselves in the state that we are in now with all these technological advancements. So I guess it was important in our journey. However, a few things have occurred in that last 9,000 years. We've and especially with the Industrial Revolution, we've developed modern flour about 200 years ago. We then, about 40 to 80 years ago, we developed industrial agriculture with pesticides, hormones, mechanization. And in the last 30 years, we've developed chemical manipulation of foods. And then we started developing prepared and fast foods and separation between forest and farm, of course. And today we've fundamentally lost the plot. We've got globalization, foods out of season. We've got significant genetic manipulation. Where really the foods that we consume now 50 years ago would have been very, very different, not just in taste, but in terms of nutrient profile too. The concept of the Paleolithic diet is rubbished by a lot of modern medicine. However, some older papers, and I think this paper was done in the 80s, showed a marked improvement in carbohydrate and lipid metabolism in diabetic Australian Aboriginals after they reverted back to their traditional lifestyle, which is, of course, a very meat-heavy diet with more complex or with less sedentary behaviours due to the foraging required, of course. With regards, just to very quickly touch on it, plant versus animal source protein, there's no doubt plants contain amino acids, but the question is, can our digestive tract, which has evolved a very finely tuned system, can it access them? I don't think it accesses them as efficiently. And I think the metabolic fate of amino acids derived from plant and animal proteins are quite different. Also, the different structure of plant protein versus animal source protein makes them resistant to breakdown by our gut. And I think plant-based sources contain very tough cell walls of fibers that impede the access of enzymes to proteins and induce a decrease in their protein digestibility, of course. There's also a lot of anti-nutritional factors found in plant proteins, such as phytic acid, protease inhibitors, tannins, lectins, oxalates, and many more, of course, which we don't tend to find in animal source proteins. So just to end what has been a relatively long lecture here, is just with some final points. We've been on a 4 million year journey. We came from this fruit eating ancestor to where we are now. And I think we have our large brains to thank for where we are now. This wasn't created by accident or evolved by accident. It was brought on. This large brain was brought on due to shrinkage of our gut, brought on by a very nutrient-dense diet. We've kind of confused ourselves recently and kind of enslaved the masses to this modern-day diet that we've that we find ourselves on. So, as a primate species that initially scavenged, hunted, we've also learned to cook and farm, build civilizations. We've built the concept of money, and unfortunately, we've demonized nutrient-dense foods, and we've demonized things like saturated fat, which forever have been our primary energy source. And of course, we've demonized animal source proteins, and there appears to be a war on red meat at the moment. In addition to doing that, we've built an environment geared towards making money from hyperpalatable foods. So we have a species that is nutrient-starved, surrounded by energy-rich hyperpalatable foods, a recipe for disaster. And this is reflected by, this is just a photo here of some hospital food, which is a reflection of the modern day food pyramid, which is, as I've pointed out, problematic. We've got supermarket stores with these heavily processed foods, which makes up a bulk of what they serve. And we've got issues at every turn with our food environment, and it is a very confusing food environment. I think if we look back at our past, that allows us to understand what we are. And what we are is a very adaptable species geared towards nutrient-dense foods. Thank you.
Great talk. I always said the comparative anatomy was interesting. I've always thought it was the length of the gut that made the difference, but Pran tells us it's actually the gut wall.
Well, I guess it's the length as well, but when he described how easy it was to perforate the bowel wall on doing a colonoscopy in a human, it's literally millimeters thick, compared to, say, the colon of a herbivore, which would be impossible to penetrate with a colonoscope. It really talks to the functional difference in the colon as well. So in herbivores, it's a very thick muscular with a lot more substance to it, and in humans, it's obviously something that the body puts a lot less resources into it. So I found that interesting. So normally we think about the lengths of different parts of the gastrointestinal tract as conferring the functional differences, but it's also the thickness of the walls as well.
I guess that explains why medical indemnity for a gastroenterologist for humans is a lot more expensive than for animals, because he's more likely to perforate the bowel.
I don't know how many vets are going out there doing a bowel screening program, but I've got a friend I'll ask.
Very good. What else did you take out of that talk, Paul?
Well, it was interesting. I mean, this whole concept that humans are actually cocinivores, which basically means that we actually derive a lot of our nutrition out of food through food preparation techniques. And I guess that's something which our large brains gives us the capacity to do. So that was a new concept to me, and I quite like that. But at the end of the day, the thing that I took home was that our guts appear to have evolved to have diets of certain foods, things like saturated fat-rich meats, for instance. And it now seems that we're blaming a pandemic of modern disease on ancient foods. And that's just really illogical.
Oh, maybe it's some of those modern foods that might be able to blame.
Who would have thunk it?
Amazing, amazing. All right, what do you got for us next?
Well, we've actually got my good friend, Dr. Doron Sher, who I've worked with for a number of years. He's an orthopedic surgeon.
Patient man. He must be a very tolerant man.
I believe he's in a support group with you. So, look, he's going to present a fascinating story. So, I guess, we chat a lot, and, I deal with a lot of athletes, and we treat athletes very different to members of the general public in general. So, we're all about recovery and nutrition-dense foods and good protein quality and things like that. And I guess Doron said, well, can I take these concepts that you do for athletes to help with their recovery, and can I apply it to my surgical patients? I mean, so the thing is, I won't spoil the surprise of what he's going to talk about, but it'll be an interesting talk.
Great. Looking forward to it.
Hello, my name's Doron Sher. I work in Sydney, Australia, where we have a fantastic healthcare system. I'm a knee and shoulder orthopaedic surgeon. I specialize in sports surgery, joint replacement, and reconstructive surgery, and I also treat a lot of work-related injuries. I have a very wide range of patients, from young fit athletes all the way through to elderly patients who are much more frail. But regardless of the patient's age, the principles of healing remain the same. My involvement with low-carb eating started many years ago when I was trying to help my overweight knee replacement patients lose weight to delay or avoid surgery. Together with Dr. Paul Mason, we started a metabolic weight loss clinic and have seen great success helping patients lose weight, reduce their inflammation, and improve their health. But a healthy diet is not just good for people to lose weight and improve their metabolic health. It can also facilitate recovery after someone has had an operation. A great example of this is a knee replacement. It's one of the best operations we do in terms of providing pain relief and getting people going again. But the first few weeks is pretty tough to get through, so every little bit that we can do to make it easier helps. My patients that have lost weight and restored their health seem to breeze through the operation much more easily than those who are metabolically unwell. There is strong evidence that the complication rates are much higher in patients who are obese. Well, when we think of hospitals, we think of a place that you go to get healthy. They are where you go when you're sick or you're injured. You go in with a problem and you come out healed. We shouldn't be getting sicker while we're in hospital. And yet, in this day and age, with all the information available on the harmful effects of sugar, the one thing you can be guaranteed of is that you'll be fed sugar in hospital. This is a constant uphill battle for those of us trying to change the system. Let me take you through a surgical day. So, you, the patient, are given instructions not to eat and drink for a specific period of time. This is really important to make your anesthetic safe. We don't want any of your stomach contents ending up in your lungs while you're under. You have your operation. All goes well and you wake up in the recovery room. There's usually some pain, but this is well controlled by painkillers. Unfortunately for some people, the painkillers make them feel a bit sick, but this is far less common with the modern drugs these days. The staff in the hospital know that you've been fasting, so as soon as you're properly awake, they want to give you something to eat. Solid food can be a bit difficult to stomach right after an anesthetic, so they give you something you can suck on. The problem is that what they give you is frozen sugar. While it's nice and cool and refreshing, what do you think it's going to do to your blood sugar? A huge number of our patients these days have insulin resistance and diabetes, and spiking your blood sugar is definitely not optimal when it comes to wound healing and avoiding infection. So you go out of recovery and you go back to the ward where you're typically offered a white bread sandwich and a fruit juice, again guaranteed to spike your blood sugar. So here you are as a patient. You've spent time under anesthetic. You're now lying in bed resting, which basically means you're in a catabolic or breakdown state. That means you're losing your valuable muscle protein, which you desperately need to recover from your operation. Now, this is a picture from a different hospital. In this one, you get an icy pole, fruit juice, biscuit, sandwich, and an ice cream. But luckily, the ice cream is gluten-free, so that makes it much better. Then I go see the patient the next morning, and this is typically what I find on their bedside table. They've been snacking on overnight. Soft drink and chocolate. Once more spiking the sugars and creating inflammation in their bodies. The hospital breakfast is then served with more fruit juice and breakfast cereal. And what's worse, diabetic meals contain a minimum of 30 grams of carbohydrate per meal. I now have a conflict. I want my patients to be eating so that they don't lose their energy, but I don't want them eating something which is going to spike their blood sugar. I also need them to activate protein synthesis, but so far, nothing that they have eaten after their surgery is capable of doing this. We'll talk more about this soon. It's well documented that high blood sugars lead to more wound infections. Infection after surgery is a very serious issue. If you're lucky, you might just end up with a few weeks on a drip, but often 3 or 4 operations can be required to get rid of a serious infection. I wonder why we don't treat our patients like our elite athletes, who under expert care often seem to have superhuman recovery. Let me tell you, when I first approached the hospitals about this topic about 5 years ago, I was basically told that as a doctor I wasn't qualified to provide nutritional advice and that the dietitians decided on the patient's meals. Well, I'm very pleased to report that things have changed, and in the private sector at least, as a doctor, I can specify what food I want my patients to have. But more importantly, as a patient, you can now choose what food you want to eat, and I'll come back to this. Let's talk about muscles. There are 2 basic types of muscle, smooth and skeletal. An example of smooth muscle happens in the background like your heart, where it's just beating away and you don't have to tell it to do anything. Skeletal muscles move your bones and joints and require instructions to do so. As a tissue, skeletal muscle has a unique ability to grow in size in response to exercise. On the other hand, too much rest or immobility will lead to muscle wasting. Here you can see the massive difference in the quadriceps bulk following surgery and the subsequent period of enforced rest. This is an athletic individual who started with fantastic muscle bulk at the beginning, but has ended up with a much smaller thigh. Now, what about somebody elderly and frail who was already struggling to walk upstairs before the operation? How do you think they're going to go with their period of enforced inactivity? Let's look at a muscle cell under a microscope. You're going to see a striped pattern, otherwise known as striations. This pattern is formed by a series of basic units called sarcomeres, and they're arranged in a stacked pattern throughout the muscle tissue. They're repeated throughout the muscle, and there are thousands of sarcomeres in each muscle cell. Muscle is a specialized tissue which can change its length. So it can contract or shorten or lengthen, and it's the change in length of the proteins in the sarcomere that causes the muscle to change its length. From a microscopic level to now look at the muscle at a macroscopic level, we can see that each muscle is a whole organ made up of tiny individual muscle fibers, labeled here as a myofibril. Within the muscle are blood vessels, nerves, and connective tissue. Looking at one close up, we can see it's long and cylindrical, and it's largely made of protein. Obviously, the unique thing about muscle compared to other body tissues is its ability to change length. In other words, to contract or shorten. And of course, the action of contraction and relaxation uses energy in the form of something called ATP. Now, as I mentioned, skeletal muscles don't just contract by themselves. Rather, they need a signal, usually originating in the brain, which travels along nerves and stimulates the release of chemicals called neurotransmitters, which then are the ultimate signal for a muscle to contract. Intuitively, everyone knows that muscle is made of protein. In actual fact, we often refer to meat, which is muscle, as protein. But what actually is protein? The basic building block of a protein is called an amino acid. As we all know, if you join many glucose together, you form a complex carbohydrate. Well, joining many amino acids together eventually forms a protein. If you join two amino acids, you get something called a peptide, and then if you have about 300 amino acids to 1,000 or so, that's called a protein. The proteins fold in a special way to give them a particular biological activity. Now, while these are very diverse and found all over the body with lots of different shapes and functions, I'm going to focus on skeletal muscle. This is a list of the major amino acids and the way they're referred to as either a three-letter or a single letter, depending on how you're writing them out. If it's a very long polypeptide, then usually just the single letter abbreviation is used to save space. Now, amino acids serve multiple roles in the body. They can form neurotransmitters so that the cells of our nervous system can communicate. They can make hormones essential for healthy function of our endocrine system. They can even do things like relax blood vessels, and in the case of nitric oxide, improve circulation. Importantly, as far as postoperative recovery of my patients is concerned, amino acids form the building blocks of muscle and stimulate synthesis of that muscle in the first place. Now, I think most of us have heard of essential amino acids. While all amino acids are necessary for life, some are not able to be made in the body. And for these amino acids, it's essential that we consume them, hence their name. The one that I particularly want you to notice is leucine in the top left-hand corner. I want to take a minute just to mention two things which are critical when it comes to protein regulation. They are mTOR and leucine. Now, mTOR stands for mammalian target of rapamycin. You need to think of it as the amino acid sensor of the cell. So simplistically, mTOR is activated when conditions are right for cell building, and mTOR activation results in muscle growth. So in order to grow and divide, cells must increase production of proteins, lipids, and nucleotides. This is known as anabolism, and also suppress breakdown pathways such as autophagy, which is known as catabolism. I'm not going to spend any more time on mTOR other than to say mTORC1 plays a central role in regulating all of these processes, and therefore controls the balance between the anabolism and catabolism in response to environmental conditions. Now, the main driver for mTOR is the amino acid that I mentioned previously called leucine. Leucine is essential, meaning that we have to eat it to get it into our bodies. The main sources of leucine are animal proteins such as meat, fish, chicken, and dairy, but it's also found in other things like tofu and navy beans. Resistance training also does stimulate mTOR. But why is leucine so important? It seems that leucine is a bit of an on-off switch when it comes to protein synthesis. So when there's enough leucine, mTOR gets activated and protein production gets going. So if your meal has less than 2 grams of leucine, then as an adult, you will not get a metabolic response to build muscle. Having 3 grams is better than 2 grams, but having 5 grams or more does not really seem to be any better than having 3 grams. That is, it's not a dose-response curve, it's more of an on-off switch. So in a nutshell, if you eat protein at a meal which does not reach this leucine threshold, then what you eat can't be used for muscle building. So it's really excess calories. So if amino acids are the basic building blocks of muscle, how do we get them into our system? Because proteins are too large to be absorbed by our intestines. Well, the proteins need to be digested or chopped up. Some of this occurs in the stomach under the action of a chemical scissor, which is an enzyme which is assisted by the acidic environment. The proteins are then broken into smaller chunks called polypeptides by pepsin, which we saw earlier. Once the polypeptides reach the intestine, different enzymes begin to work on them to break them up and absorb them so they can be absorbed into the bloodstream. Remember that the major source of amino acids is actually reusing the stuff in the body, so not all of it needs to be ingested. So let's focus a bit more on skeletal muscle. As you can see from this simplified diagram, the interactions take place at multiple levels, only some of which can be directly influenced by us. When a protein's been around for a while, it tends to get damaged. This is particularly the case when blood sugar is high, and we know that damage by AGEs or advanced glycation end products leads to the protein being broken apart and recycled. There is also the normal process of autophagy, which again most of you will be familiar with, which is a bit like a routine service of your car. But in this case, the amino acids are broken down to their simplest level and reused again to make protein. So the maintenance of skeletal muscle mass is dependent on the balance between the rate of muscle protein synthesis and protein degradation. Protein is made in little factories called ribosomes. Their main function is to convert genetic code into an amino acid sequence and to build protein polymers for amino acid monomers. The number of these units and the efficiency of the units determines how much protein is made. So the next logical question is, how much protein do we need to eat to get the amino acids to survive? This slide is from a talk given by Don Layman, where he emphasizes the point that the recommended dietary intake is actually the minimum intake needed to keep you healthy and allow normal growth and development. This is by no means the desired intake if you're trying to build or maintain muscle mass. You also can't think of protein in terms of a percentage of your overall food intake, because if you're running at a calorie deficit in order to lose weight, the amount of protein intake will fall as the overall calorie intake falls. The problem is that you still need the same amount of protein in your body, or the body will start to lose lean body mass and muscle. The graph also shows you a very wide range of safe protein intake, as high as 200 grams of protein, which would equate to about a kilogram of steak, which would be very hard for anybody to consume. Already this weekend, we've seen an athletic young individual by the name of David Dykman who consumes about 4 grams of protein per kilogram of lean body mass, and he is in robust health. The blue X that you see is where most North Americans are in terms of their protein intake, well below the safe level. Now, building muscle is not a straightforward process. It requires the interaction of various enzymes and hormones. As an adult, there also seems to be the on-off switch with the leucine, only when the critical amount of amino acids are present in our system. As a child, however, hormones drive growth much more strongly, and even quite malnourished children will continue to grow reasonably well. And this is under the influence of IGF, growth hormone, and insulin. As you know, we tend to develop insulin resistance as we get older. This applies across all of our tissues, and in skeletal muscle this is the case as well, requiring more insulin to drive muscle growth as we age. This is why as adults, the hormone drive is less effective and requires other drives like leucine and mTOR to be involved. So where is this knowledge about amino acids and protein taking us, you ask? That's a great question. The body is in a constant state of flux, breaking down damaged or old proteins and making new proteins. The more time in the synthesis or making phase, the more lean body mass we have, and the more time in the breakdown phase, the less lean body mass we have. As a general rule, in the body, you either use it or lose it. The same applies to bone mineral density. At rest, protein breakdown exceeds protein synthesis. You may have heard the term of a negative protein balance. If your goal is to massively build muscle, then eating regularly and exercising regularly are very important. If you're just an average person, then the timing of the meals and the number of meals is far less important. We also need to keep in mind that if people are trying to lose weight, they will need to restrict their calorie intake, break bad eating habits, and improve their overall health and inflammation. Fasting is a very powerful way to do this and is far more important than worrying about optimal muscle building. Technically, while you're sleeping, you're fasting, and during this time you'll experience some muscle loss. Don't worry, organs like the liver keep working while you're sleeping, so the same rules don't apply there. The negative side of muscle loss is far outweighed by the benefits of sleep, so waking yourself up to eat or exercise is a very bad choice. Muscle loss will also occur with prolonged fasting, where you do get some loss of lean muscle mass. How much you lose also depends on how much other energy stores you have available in your body to burn, as the body will choose to burn glucose and fat before it burns muscle. Adding exercise to fasting, that is, not adding amino acids or muscle building blocks, but just exercise, has only a small impact on the amount of muscle lost. What that means is exercising while fasting does not fully counteract the losses, but it does counteract some. You will still be in a mildly negative protein balance, despite exercise being an anabolic stimulus. On the other hand, if you stop fasting and eat protein during the meal, you will now achieve a positive muscle balance, which counteracts any fasting losses. It also allows less loss of lean muscle at rest than you would experience without eating protein. If you then add resistance training to the mix, you can make more muscle than you started with. So it makes sense that the best combination of muscle building is exercise and having amino acids present at the same time. Now, I mentioned to you that you need insulin to make muscle, so some people interpret that as a need to eat carbohydrates with their protein. The amount of insulin actually required is very small, and extra carbs are definitely not needed when you're eating whole foods. A couple of years ago, we were involved in the nutritional testing of various meat products. We were actually looking at the difference between grass and grain-fed, pasture-raised, etc., but the results took us by a little bit of surprise. The carbohydrate content of the meat was as high as 19% in some samples and as low as 3% in very young animals, but on average it was about 12%. Now, if you think about the picture of muscle that I showed you having other structures and having glycogen, not just pure protein, then this does make sense. We know that you get an insulin spike eating protein, which is less than that of eating carbohydrates, and this to me explained why it was happening. It also meant that extra carbohydrates were not needed when eating protein for muscle building. This is even more important if you're metabolically unwell, when even a sniff of carbohydrate will put you into a fat storage mode. We also know that for most animal proteins, you will need to consume about 30 grams of protein to get 3 grams of leucine, because leucine is about 8% of most animal proteins. Remember, 20 grams of proteins is not a 20-gram steak, but about 100 grams steak, fish, or piece of chicken. One of the most common questions with protein relates to kidney disease, and to understand this, you need to know that patients with kidney failure are put on a low-protein diet. For these patients, restricting their protein does make them live longer, but it wasn't the high protein which caused the kidney disease in the first place. To my knowledge, there are no data linking high-protein diets to the development of renal disease, and certainly there are none in the quantities of protein intake we're talking about today. Now, backing away from the science a bit and coming to what I do on a day-to-day basis, we know that patients get muscle wasting after surgery. We also know that the most important event in the process of skeletal muscle recovery is the upregulation of the anabolic processes, followed by an increase in muscle mass and subsequently recovery of muscle performance. We know that muscles that experience atrophy during unloading are more susceptible to injury when they are reloaded and reweighted. This has very important implications when I'm trying to get a patient back to work or back to sport. So I want to share with you now my experience dealing with postoperative patients and how I've made some changes for the better. It is an ongoing process, but I can report good progress at many hospitals. So now when my patients are admitted to hospital, they're given a food menu. This menu still contains all the sugar-containing options, but you don't have to choose them. In the past, if all you chose was the protein, you got a tiny serve of the protein with the expectation that the rest of the plate will be filled with the other rubbish that was available to you. Now, if you choose the protein, you can actually ask for a double or triple serve, which will not only provide satiety for you, keep your blood sugar low, but also get you to the point of reaching your leucine threshold to start building muscle to aid your recovery. Breakfast no longer has to be toast and cereal. Lunch no longer needs to be sandwiches, and dinner no longer needs to be rice or pasta. Adding a full-fat yogurt, cheese, bacon, salmon is a great way to kickstart your day. You can have chicken or tuna for lunch or even a salad, and then meat for dinner. Never be scared to get your family members to bring in the type of food you like as well. If you're used to eating only once or twice a day, that's fine, but then just try to time your physiotherapy session for about half an hour after you've had your protein meal. This will turn the leucine switch on, activate mTOR, and kickstart your muscle building process. So in summary, eating protein is safe. We do need to eat a certain amount of protein each day to build our lean muscle mass. If you want to recover from surgery and build your skeletal muscle, stay away from carbohydrates and fats and stick to protein combined with strength training. Just being in hospital does not mean you should lose control of your food choices. My job as a surgeon doesn't just stop once the wound is closed. Together, we need to get you to heal, to recover and restore optimal function in the shortest possible time. Thank you for listening.
Well, they're certainly right about hospital food. Every time I visit someone in hospital, I just get horrified. I had a friend recently who was in hospital, type 2 diabetic, and every meal was just full of sugar. And there are dietitians employed by the hospital to design these menus, and I just don't get it.
Look, it's actually quite bizarre, but I think there are movements changing. We obviously know Gary Fettke's story and the trouble he had with hospital dietitians. But when Duron went, actually, I guess he was did it quite astutely. But he was able to bring the dietitians on the side, and he didn't really have too much pushback at all. So he's now in the situation now where his patients can get protein-rich food. And it wasn't just a matter of saying, oh, well, we'll just drop off the toast and you can have a single egg. It's like, no, these guys might need 3 or 4 eggs. They can have a whole egg roll. They can have, proper sized meals that are nutrient dense, full of protein and low sugar for those people with, glycemic control issues. So this is fantastic. And I'm really hoping that his patients recover better because of it.
Yeah, I'm sure they will. Let's hope that more hospitals and more dietitians come on board. All right. Well, Paul, perhaps you'd like to introduce Joan Ufland, our next speaker.
Yeah, so Joan is actually a world authority on addictive eating. And I guess that's something that we often don't think about enough in the low-carb world. We always talk about macronutrients this and macronutrients that, but the simple fact is there's a lot of underlying subtext to eating behaviours. And I think Joan can provide some really interesting insights.
Look forward to it.
Hey, everybody. Dr. Joan Ufland here. I am so honored to be joining you at Low Carb Down Under. I appreciate the invitation. Here's my disclosure slide. I am the CEO of Food Addiction Reset, which is a training and support company. And I am the lead author and editor of the textbook for the field, Processed Food Addiction Foundations Assessment and Recovery. I'm often asked to talk about how practitioners can deal with processed food addiction. So I put together this presentation for you on that very topic. we're going to talk today about how complicated processed food addiction is, how it is so difficult to put into remission, and how to look for the right kind of support for either yourself or your patients or clients. It's very specific, the things that need to be present in order to put a complex addiction into remission. I would recommend learning more about the tobacco experience. We know that in the 1980s in the United States, the tobacco industry bought 3 big processed food companies, Nabisco, Kraft, and General Foods. And within 10 years, childhood obesity had risen 50%, from 10% to 15%. And within 20 years, overweight and obesity in the United States went from about 45% to over 70%. So knowing that this is an addiction, addictions hyperactivate reward centers in the brain. They control behavior. They turn off the braking system by pulling blood flow away from the rational frontal lobe, and they're incredibly destructive. I know that many of you are frustrated because you know the answer. You know that low carb, clean food plan, clean eating is the answer. And yet your clients, your patients, your friends, your neighbors, even yourself, we're dying. So in the United States, every day, 1,800 people die from diet-related diseases. That's 2 million people every 2 years. The World Health Organization has told us diet-related diseases are the leading cause of preventable death around the world. Why? It's because of the addiction business model that was developed by the tobacco industry and brought to the processed food industry. It's the 5 A's of an addiction business model. It's lots and lots of advertising. It's affordability. It's young age of onset. It's adding addictive substances, hiding them in the product, like sugar, fat, salt, in processed foods, like nicotine, hidden in cigarettes. Availability. So as they were taking out the vending machines for cigarettes, they were putting in snack and soda machines. It's a diabolical business model. It's used for alcohol, for vaping, now for cannabis, certainly for tobacco. The pharmaceutical companies used it to market opiates to doctors. It's an established business model, and it was brought to processed foods beginning in the mid-1980s. So once you know that the barrier, this invisible wall between you and the people that you want to help, is in fact an addiction, a severe addiction in traumatized people, then you know that the once a week office visit is not going to help, the weight loss approach is not going to help, the lectures, the ridiculing, the counting macros, all of those things are not part of overcoming a severe addiction. So today we're going to see what is. And yes, I know the list is long. I'm going to talk about 20 different factors, but I'm also going to tell you from the viewpoint of a food addicted person. This is my wonderful friend, Jamie Morgan, who lost 200 pounds from 400 to 200 and has kept it off. And through the mechanism of understanding how to manage an addiction. So let's get started. So the first thing to start thinking about here is a complete support equals success. Incomplete support equals lack of success. So if you have a patient or a client or a friend or a family member or even yourself, and you don't have successful, consistent, long-term control over food, you know that you are trying to overcome a severe addiction with a program that is too weak. There's something missing from your program, and that's it. It's not because you're lazy or because you're self-sabotaging or because you lack willpower. It's because you're in an incomplete program. And you can use this presentation as a checklist. If you're looking at programs, ask these 20 questions. If you are in a program that's not working, look around. Are they missing some of these 20 elements? I'd like to say that you could get away with 10 or 15 of these elements, but you will see why even one of these elements missing can lead to failure to gain control over your food. But just remember, it's not you. It's the program. This addiction is highly complex because it starts very young, because you have addiction merchants operating in the environment, because all the people around us are addicted. It's just a very tough addiction. It's very complicated. It does require a lot of skills. It does require the skills of really building a new life, like many addictions do. But this one involves a lot of different substances, and it's used in every social occasion. So it does require an extraordinary amount of skill acquisition in order to beat it. Just remember that if you have tried 84 programs, you've spent tens of thousands on these programs and they haven't worked, it is not you. The program was incomplete, it was weak, it was missing key elements. And I hope by the end of this presentation, you will stop blaming yourself. If you're a practitioner, that you will stop blaming yourself for not being more effective with your patients. And if you are a patient yourself, for not being more successful with control over food. So that's what we're doing. We're finding out how to fix your support to make yourself successful. Here are the skills where I've divided them into 5 categories. Knowledge of research. You have to understand how the brain is working in order to protect it from toxic messaging and toxic stimulation. You need to know how to manage food in a culture where everybody around you is eating processed foods. You need to know how to manage lapses because they are inevitable. How do you pick yourself up again? How do you avoid blaming yourself? How do you avoid the pain that often accompanies a lapse so that you don't stay stuck in the lapse? You need to know how to create stress-free environments because stress activates the addicted brain cells. People think they're stress eating, they're not. They're addictively eating and the addiction was activated by stress. And this is a very cool thing to figure out. And you need the right leadership and the right resources. So let's look at these 5 categories. Research. Why do you have to have research? You have to be research-based because if you don't know the research, if you're not explaining the science to members, they cannot believe what they have to do. Have to understand the role of big tobacco. Otherwise, the self-blame is so severe, the pain will perpetuate the addiction. Key is understanding how conformance drive works, the role of mirror neurons, and that this is a lifetime commitment. That as soon as you leave your program, the food industry is waiting there to re-addict your brain. So let's talk about what does it mean to be research-based. have to be looking at studies for what to do, for guidance in what the program is suggesting. Otherwise, you have these individuals who might have an individual experience and they want to generalize from their individual experience, which is just not possible. You can't expect that one person's experience is going to be so similar to what you need that their experience is going to lead you out of this. This addiction is too complicated for that. That might work for a single addiction like alcoholism, where there are not hundreds and hundreds of factors that need to be overcome in very precise ways, but also very personal ways. It just won't work. Science shows us what's really going on. We do have thousands and thousands of studies showing what is going on in the brain in response to cues. So your members need to get guidance that works. Now, this is from my colleague, Jamie. I asked her, so what does it mean to you to have a science-based program? What if we were not using research to give you ideas about what to do? She says, I would be hopelessly lost in the cycle of self-blame. We're going to come back to this self-blame again and again. Self-blame, shame, and guilt. Always thinking I was the problem. After all, that's what I heard from my health professionals. When you blame yourself for failing, quote unquote failing, which is what a lapse is taught to be, a failure, the pain of that self-blame, self-stigmatization, self-loathing is so intense that it will keep you in the lapse. It will keep you looking for the numbing effect of processed foods. So over and over again, you will see your program. This is an essential component of a program because it relieves the patient, the client, or yourself from self-blame. It puts the blame where it belongs, on the addiction created by the tobacco industry. Okay, this is huge. We teach this all the time, and it immediately relieves guilt. Oh, yeah. I remember big tobacco got 2/3 of American adults to smoke. And now it has, 2/3 of Americans of all ages are overweight or obese. It is essential to recover from overeating, from eating the wrong things, from the compulsion. It is essential to be aware of what the tobacco industry, now all dressed up as processed foods, is doing. What is the stimulation of the addiction? How is the addiction reinforced? These are very sophisticated scientists who have created these addiction models. So recovery requires very focused, defensive, protective actions against these corporations. Great programs. Now just check for this. Before you refer to a program, check this out. Are members of that program learning about the impact of addictive advertising and product formulation? If they don't know about these things, they're fighting blind. They don't know who they're fighting, and they don't know how to fight. So this approach, teaching people, understanding the corporate tactics here, does relieve the members from toxic self-blame. This is so crucial that you know where this loss of control over food came from. And the other thing about knowing that this is spread by big tobacco is that people will stop pursuing things that don't work, which drive them deeper and deeper into self-blame, self-hatred, pain, and perpetuation of the compulsive overeating. So I asked Jamie, I said, well, what do you think it would be like if you didn't know about these corporate addiction practices? And she said, well, I would go on assuming it was my laziness or lack of willpower that makes me lapse. She wouldn't know that she needs to defend herself against these corporations, so she'd continue to lapse and blame herself. This is so crucial. The program must engage conformance drive. We're going to come to a finding of cognitive impairment. You cannot teach somebody with an addiction. Like, you can't teach an alcoholic to stop drinking. You have to put that alcoholic or whoever's addicted to whatever in a community where a different part of the brain that's not impaired can be activated. And that's the mirror neuron network. It looks like conformance drive. People want to fit in, they want to belong, they want to copy. It's a natural human instinct. And that is what changes behavior. So you've got to have people who know how to engage conformance drive in their members. Because the easiest way to get control over food is to copy somebody else. To learn is to never succeed. But you can copy and gain experience and get clearer and build skills. But you can't just sit down and read a book, because we know there are thousands of diet books languishing without an impact. So successful programs have successful members. This is how you know you're in the right program. You go and people are talking about success. So I remember going to a support group once. I sat down, there were about 20 people in the room. They went around sharing. Everyone was struggling except one person. I couldn't wait to get out of there. I knew that if I stayed there, my conformance drive would have me copying failure, because that's what everybody in the room had. So this is easy to find out. Just go to one meeting and hear how many people are successful. Most members are struggling. You will struggle. Your patients will struggle. Ask, 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 ask. Don't assume. Oh, everybody goes to this group. Everybody goes to this system. Everybody goes to this program. Ask. We've just gotten statistics, for example, that 85% of people, Weight Watchers fail. And so they're just in that cycle, failing and coming back. It's just a diabolical business model. So ask, do not ever send a patient to a program that is not primarily successful. So I asked Jamie, I said, what would happen if you didn't have successful people to copy? And she said, I wouldn't be able to develop my own new behaviors, mindsets, and habits. I can't do that on my own. The program has to be for a lifetime. Please, please, please stop sending your patients to 8-week boot camps or 6-month workbook programs. As soon as the program is over and the person is back out into normal, westernized, and increasingly the world life, they will be bombarded with addiction triggers. The corporations are using a model called the surround market model. And that is, first they addict the brain cells by hiding lots of sugar, fat, salt in the food. And then they surround those sensitized brain cells with constant stimulation, provocation, activation. So the program has to be for a lifetime. The addiction is embedded in childhood. So the tobacco industry was not allowed to market cigarettes to children, but nobody has stopped them from marketing sugar, fat, salt, which is more addictive than cocaine. We do have good evidence for that. And the addiction is now very, very deeply embedded. That means a lot of the reward centers are reacting with this flood of cravings, neurotransmitters that end up controlling behavior. Behavior is not being controlled in the frontal lobe. Blood supply has been pulled off by the addiction. The frontal lobe is not getting enough blood supply to pay attention, learn all the things that you think are happening. Well, I gave you that food plan. Yeah, but the patient didn't have enough frontal lobe capacity to read it, understand it, and follow it. So that solves that mystery right there. And the program has to be affordable. You can't send somebody to a $5,000, coaching program or a $50,000 residential program. That's not a lifetime. It has to be something that the person can afford or the insurance company will pay for a lifetime. The food industry is out there relentlessly stimulating us. Short-term programs just can't keep us safe enough. So I asked Jamie, I said, what if your program came to an end? And she said that the momentum, habits, connections, and resources I had developed would end too. I would go back to feeling isolated and alone, without direction and depressed. It is the program. So we see this in research all the time. It doesn't, the researchers, it took them a long time to figure this out, but now they do recognize, they do a 6-month study, their study participants do great, lose a lot of weight, gain control of their food, they end the study, they check back at the end of the year, and they've all regained the weight. Well, why? Because it was the community of the study structure that was keeping them safe. It was the ability to copy either a leader or other members of the study that was keeping them with control of their food. The study ends and they go back out into mainstream culture and boom. Of course, now they're back, they're subjected to that corporate surround marketing and they go back to lapsing. Okay, so now let's talk about meal management. Meal management requires lots of time. It takes a long time to get meals organized. You need the freedom to talk about what's going on with you all the time. You need to not be forced to eat any foods, and you need to be celebrating a broad range of victories, not just food victories. So time and training in meal prep. You've got to go and find out what are the expectations of the program that you're sending your patients to, or that you're going to yourself. If they expect you to you hand them a food plan and they start following it, that is a dangerous program. That will traumatize your patients. There is a withdrawal process. It's 4 to 8 days. There are bumps even in the 20 days, 30 days out. People are lapsing. And if you're in a program that says lapsing is not okay, you have to go to the back of the room. You are traumatizing. You are sending your patients to a program that is traumatizing. It takes a long time to eliminate a long list of different addictive substances. All kinds of sugars are highly addictive, more addictive than cocaine. Processed fats are addictive, flour is addictive, gluten's addictive, excessive salt is addictive, dairy is addictive, caffeine is addictive, and then food additives. You've got to give people a long time to get through that list. And meal prep is sometimes something that they haven't ever done or haven't done in a long time. Just the process of getting groceries into the house, it can take weeks, even months, for somebody to figure out how to do that. But in the meanwhile, you're lifting them up, you're encouraging them, you're pointing out their strengths, you're pointing out their victories, and they are engaged to the point where they can stay for the number of months it takes for them to get their food organized. The depth of the trauma and the depth of loss over control, the depth of the loss of cognitive function is missed And when you miss that, you humiliate the patient by asking them to do something that they are not able to do, which is like start to follow a food plan. Members need training to personalize their meal plans. We teach a lot of rotation of foods so that you eat a different protein each day of the week. You eat a different fruit, a different vegetable, a different fat, starch if you're using starch, so that people can learn what clean foods they're allergic to. This is key, because eating an allergic clean food can send you into a lapse. And we say all unprocessed food plans are welcome. Not everybody can handle any one particular food plan, whether it's keto, paleo, low carb. Not everybody is suited to one of those food plans. And so this is so key. Please, please, please ask before you send a patient into a traumatizing situation. Ask, how long do you give your members to get their food organized? And do you treat them like second-class citizens while they are getting their meals organized? And the only answer that works is there is no time limit. We will be with them, supporting them, cheering them on for however long it takes them. That is the only acceptable answer. All right. You've also got to look at the food plan of whatever you're sending your patient to. Every food plan I've ever seen has addictive substances on it, and you've got to ask for their food list, like what is excluded. And if you see things like gluten, or you don't see excessive salt excluded, then your patient is being asked to get control of their food while they're being given addictive substances, and that does not work. So I asked Jamie, I said, if you were pressured to organize your meals too quickly, what would that do for you? She said, I would feel overwhelmed and decide that it wasn't worth doing anything at all. So I've seen this. People come in and they want to quit. Well, why? Why do you want to quit? Because I'm not eating clean. Well, give yourself some time. Oh, I'm allowed to have time? And then they can stick with it. People will say, now that I am in control of my process, I can stick with it. Nobody's pushing me. Under those circumstances, I can stick with it. It takes months. It takes years. They need to be able to feel secure, feel celebrated, and be in the process, or maybe not even started yet. We recently had a member tell me that they had been in the program for 5 months before they could actually start working on their food. They had to know that this program was going to treat them with respect no matter what before they could start the very scary process of changing out their food and eliminating these old friends. So Jamie went on to say, I can't stand the thought of failing again, so I might as well not even try. If you set the bar too high, that person will know right away that they're going to fail and they will quit. Why should they try? This is also crucial. Many programs tell their members that they're not allowed to talk unless they're eating in some very particular way. A must-have is that members are always cherished and respected no matter what. I have heard of programs, I've had people come and talk to me about these programs where you're not allowed to talk for 90 days if you've taken a bite of something. That is draconian, not necessary, mean, traumatizing, humiliating. Make sure that you are not sending your patients to a program like that. Members need to be able to talk about whatever, whenever. Now, we do have some restrictions, where they can't talk about religion, sex, politics, body shape, medical procedures, supplements, or medications, or specific foods, because those are stressful to other members. So we do have some limitations, but if somebody needs to talk about one of those things, then they can come to one of our leaders. Silencing a member is humiliating. All topics are relevant. You know, it's just like a program that doesn't let you talk about relationships is not going to work. Relationships are big triggers. Stress is a big trigger. Jobs are big triggers. So if you're in a program that says you can only talk about food, just say thank you very much and move on. So I said to Jamie, what if you weren't allowed to talk when you needed to? She said, I would be the darkest, saddest version of myself. I would be alone, separated, ashamed, feeling like no one can know or relate to my darkest food secrets. You've got to be able to talk. So ask that question. Are there some circumstances under which members are not allowed to talk in meetings? This is shocking, but you've got to ask this question. Will my patient be forced to eat foods that they don't like or that they're allergic to? Patients have to have control over food. A shaming program overrules food preferences. Like I remember somebody asking me about, they wanted to go to a residential program. Their insurance company had approved the expense, and they wanted to make sure that the program would respect their desire not to eat processed foods. So, you know, I gave them the food list and make sure that you're not going to be required to eat these foods. So the facility agreed. The person showed me the email. No, we won't make you eat anything. Well, that was good for 1 week out of a 5-week program. And then in week 2, they started manipulating her. Well, we did it your way for this week. Why don't you do it our way for this week? Let's at least take turns. Isn't that fair? So they started guilting and manipulating her and shaming her to get her to eat processed foods. Processed foods are incredibly, incredibly destructive. Make sure before you send somebody to a program that they're not going to be shamed if they don't want to eat processed foods. Members' preferences need to be respected. Members need to get training in research about foods, what processed foods do. So I said to Jamie, if you were forced to eat foods that you didn't like or that you were allergic to, she said, well, maybe I'd do it for a few days, maybe even a few weeks, but then I would fall off the wagon again. Or maybe I'd hang on for even longer, white knuckling my way through and being miserable. The point of going into recovery is to be happy. If you're having to hang on because you're being forced to eat provocative, stimulating, addictive substances, you're not getting better. That's miserable. You've just got to ask whether there are any foods that your patients will be required to eat. All victories are celebrated. This is a very subtle thing. A must-have is recognition, and there are 140 diseases associated with processed foods. But there are programs out there that only reward abstinence and weight loss. And so they're not sufficiently motivating. I mean, we talk about all kinds of mental, emotional, physical, behavioral, relationships, jobs, energy, activities. We talk about all the things that get better when you're in recovery from a severe addiction. It's a very, very joyful place. Processed foods harm us in over 100 ways. So you've got to ask, what are your criteria for celebration? And if they start talking about abstinence, you are in the wrong place. As we know, abstinence can take years. Lapsing is normal. Or if they're celebrating consecutive days, consecutive months, consecutive years of abstinence, you're in the wrong place. You need to be able to talk about blood work numbers and energy and all the other, just dozens of things that get better. So I asked Jamie, I said, if you had to ignore most of your victories and only talk about abstinence and weight, what would happen? And she said, I would begin defining myself by whether I was abstinent that day, week, month, or not. I would lose motivation from focusing on the wrong thing. And I would also add here that we define ourselves as wonderful, healthy, vibrant, capable, energetic. And if you have lost all those self-definitions, all that power of that self-identification is lost. If you're just narrowed it down to a number on a scale and whether or not you've had, an extra bite of something or other, that's a sad existence. You really want to be aware of all your power. Lapse management. Oh my goodness, this is so important. You have to have realistic expectations for when lapsing is going to stop. You have to be able to manage cues in order to manage lapsing. You have to be free from self-blame to understand what builds up to and causes a lapse. If you are in a program that thinks that you should stop lapsing immediately and be abstinent, you just keep going. That's a mean program. That's a traumatizing, brutal program because it doesn't work that way. So you're being gaslighted. Your patients are being gaslighted. Oh, yeah, you're lapsing, so you're a failure, and I don't want to work with you anymore. That actually happens. We have these amateur guides who have one definition: are you abstinent? If you can remain abstinent, I will work with you. If you lapse, I'm going to fire you. Very, very traumatizing, because we have great research out of Harvard, John F. Kelly, showing that drug and alcohol addiction can take 5 years, 8 years to stop lapsing. So the point now is to keep them lifted up when they lapse. When you lapse and you've stumbled and it hurts, the last thing you want is a program that's going to squash that person by saying, you failed. No, you want a program where the leader is going to say, I'm sorry, this is so hard. I know how much that hurts. I've been there too. Let's just talk about getting you back on your feet. And do you have some clean food in your house? And I am going to be there with you, at least virtually. This is supportive. This will move the person out of the lapse, especially if your leader is trained to say, it's not your fault. You didn't ask to have this addiction. You didn't ask to be given an addiction as a small child to a lot of different substances. I'm sorry, this is so hard, but I am going to help you. I'm going to stay right here with you. Just ask what happens when people lapse in the program. So it's a lot of compassion. The leaders have to be trained in compassion, and you've got to really reduce the emotional impact of the lapse. People, if they go into self-blame, self-hatred, it's so painful they will just keep eating. But if they have a kind person who can look them in the eyes, even over a screen, then that hurt person can get back up. They can treat themselves with kindness. You've got to ask, what happens if somebody lapses in your program? We say lapses are only as upsetting as a mosquito bite. Yeah, you work like heck not to be bit by a mosquito, but if you are, you put some lotion on it and you carry on. So we're working very hard to take the emotional, the self-blame out of a lapse. So I asked Jamie, if you were expected to stop lapsing on an unrealistic schedule, she said I would lapse more often because I would be stressed. I would stop trusting my body's ability to heal and recover on its own schedule because I was too stressed from trying not to lapse. You're putting a burden on the person that is too heavy for them to carry. Cue management. A must-have is training in cue management. Why? Because cues are why people relapse. So if you don't know what a cue is, how to avoid it, how to train your brain not to react to it, you're going to be lapsing. And I've never seen a program that teaches cue management. You need plenty of time to get this skill of cue management, and you need to be in a program that's teaching it. We do teach it. And you need to get help for household members that are triggering you. And this is something I've never seen another program teach, is how to cue household members. No fighting, no pushing, no manipulating. Just keep the house free from toxic cues and replace those toxic cues with healthy cues. So I asked Jamie if she didn't know how to manage cues, what would happen? She said I'd still be blaming myself, my lack of willpower, or my childhood issues for losing control around certain foods, food environments, or events. In other words, she'd be looking at the wrong cause and she wouldn't be making progress. Okay, this is huge. We've got to stop the self-blame for lapses. A must-have is assurance that lapses are not your patient's fault. A traumatic program blames the member for lapsing. I had a member tell me the other day that in a program where she was told that she lapsed because she's spiritually bankrupt. You know where that sent her. That sent her right into the food. So you've got to like really work on this self-blame concept. Lapsing is normal. We're going to fight like heck to understand why it happens. We're going to back up the process and look at the cueing. But the key thing is to realize it is a force outside yourself. It is these Harvard-trained addiction scientists that these corporations hire. That is why you're lapsing. The cueing, the triggering, the stimulation, the reminders, the surround marketing, that is why you're lapsing. So you train slowly in how to stop lapses, of course, by teaching people how to stop the cueing. You get scientific explanations. You don't get this hocus pocus. Oh, you're self-sabotaging. It's like witchcraft. It's like witch doctors. It's just something that somebody made up. But when you are working from research, you see, okay, the cue occurs, the addicted brain cells become hyperactive, they pull the blood supply away from the frontal lobe, which means you've lost your braking system. And so let's work on neutralizing cueing and avoiding cueing. It's friggin' miraculous. Especially if you're in a group of people who already know how to do that, then the new member just hangs out, listens, does a lot of listening, and just visual contact with people who know how to do this. Boom, they're doing it. Conformance drive is incredible. And we get people all the time in the world. So they lapse, they say, I give up, I can't get this. I say, no. You just need more time. You will get this. The lapses become shorter and they become less frequent gradually over a long period of time. And once they get that picture, then they can stick with it long enough to reprogram enough brain cells that they can begin to get control. So I asked Jamie, I said, what if you blamed yourself for lapses if you didn't know? She said, I give up because I feel like there's no way out of the lapse cycle, so why try? And a lot of patients give up. They get sick all over again because they don't know how to stop the lapsing. All right, stress-free environments, absolutely essential Because as we said, stress activates the loss of control, the addiction. You need an immersion program. You need to be able to find support between meetings. You need to be able to talk about any problem, and you need your own control over your time and what actions you're ready to take. So frequent online meetings for immersion. It took hours and hours of food industry, advertising, availability, affordability, hours of immersing you in their addiction business model. It is going to take hours of immersion in a clean environment with clean eating, clean thinking people in order to reprogram enough brain cells to consistently have control. It's got to be online. Like, you can't go for years and years, physically get dressed, get in your car and drive somewhere. You need to be able to flick on your program. Like, we're up to 15 hours a day of live. Like, there's a real person there. 15 hours a day of Zoom programming. We're around the world, so we are just, we're not too far from a 24-hour-a-day programming, so that our members can turn on Zoom, go to our main Zoom room, and somebody will be there to help them 24 hours a day. Inadequate support is support that's too hard to reach. Meetings are an effective way to halt cravings because they release oxytocin, which is very, very calming. It's like the community neurotransmitter. We know dopamine, serotonin, cannabinoid, and opiate pathways are not working because they've been downregulated by the addiction, all these different substances. So we can go to a different calming substance in the body, which is oxytocin, which is activated by community. So that is one of the key things. We also have a big archive of videos. So if there doesn't happen to be anything live on in that moment, they can go into the archives and get a video and get that conformance drive, the oxytocin release, calm down, stop the addicted brain cells from controlling the brain, and avoid a lapse. So this is, the meetings have to be very, very frequent in order to be able to accommodate all kinds of schedules. So I asked Jamie, I said, if you didn't have a lot of meetings to go to, what would happen? She said, I'd feel locked into one option. And when life happened or stress quit, I'd find an excuse not to go. That's how your patients are thinking about in-person meetings. It's got to be easy to connect between meetings because cravings can hit anytime. We are subjected to this surround marketing, this surround stimulation of cravings. It can hit any time. So like our programming now starts in the UK, but it's the middle of the night in the United States. And when we started that meeting, we were so surprised to see North Americans showing up at that meeting in the middle of the night. Well, they had woken up. They had insomnia. They were so grateful that in the middle of the night, they could get to a meeting. It made it easier to go back to sleep. So you've got to be able to connect really 24 hours a day. Inadequate programs make you sit alone with stress, which leads to lapses. We never know when a stressor is going to hit. We need to be able to connect with somebody between meetings. And I know some of you physicians out there are trying more intense availability of services. So you have these systems now. You have people in your office where if a patient is having a craving, they can call in. It's not enough. It's not enough. It's not fair to say to a patient, well, just call me. We'll work it through. The craving will stop. No, because I can tell you as soon as they hang up the phone, 15 minutes later, that stressor could be back and they're too embarrassed to call again. But you can anonymously flick on a Zoom screen and be in a meeting and that will work. That's enough people. That's enough conformance engagement. You need the conformance engagement is most effective with 5 like-minded people or more. That's when you get the greatest mirror neuron activation. That's what you need. So I asked Jamie, I said, what would happen if there weren't somebody to talk to between meetings? She said, well, I'd be left to my own devices, thoughts, excuses, and rationalizations, and all of those lead me right back to my addiction. You just don't want to be alone with your addiction. The brain, the part of the brain, those clumps of addicted brain cells are just too powerful. It does change over time. You can retrain those brain cells. It just takes time. So craving prevention. A must-have is training in craving prevention. People need education about all the many ways to calm the brain and stop a craving. It's not just spirituality. It's not just mindfulness. It's not just deep breathing. You need lots of different ways, and there are. Research shows there are many options. This is something that each member has to personalize to themselves. So if you go and you ask this program, what is your craving prevention? How do you teach people to stop a craving? And they say, oh, well, prayer and make a phone call. And that's not enough. That's not enough. That doesn't work for everybody. So we need you need the opportunity to personalize a craving prevention program. So I asked Jamie, if you didn't have a personal craving management program, what would it be like? She said, I would be moving through life controlled by my cravings. I would think that if I were craving, I was failing and the program was failing me. That's what happens if you don't have effective a personal array. 10 things that you like to do. Sit down and work not a crossword puzzle, but a jigsaw puzzle. Go out and sit under a tree. Go for a walk. Pet your dog. Take your dog with you. Get on a Zoom screen with like-minded people, healthy, successful, like-minded people. And you've got to give them control over their time. As soon as you tell somebody they have to do something, they're stressed and the addiction is activated. This is quite counterintuitive, but the more space, the less pressure you put on a highly addicted, traumatized person, the more likely they are to gain security, gain trust, gain confidence, and be able to create one doable step and then another doable step. They're going to be taking hundreds of steps, and they have to do it under their own steam. You have to say, I respect you. Of course I respect you. You know when you're going to be ready to do something, and I'm going to be right here waiting, and we're going to have a fun time while your brain sorts it out. Until your brain, your voice of wisdom says, I think I'd like to try that. But we're going to have a nice time while that's going on. We're not going to expect anything of you. We're going to be giving you lots of company, lots of security, lots of comfort, and that turns out to be what works. Kindness, compassion, understanding. They've had a really bad time. And they deserve just to have people who really like them and want the best for them on their schedule. So weak programs, programs who don't know how to create this foundation, build skills, they're trying to, crush their patients with rules and deadlines and goals. No, don't do that. Don't do that. Don't send your patients to that kind of program. So we are looking for easy ways, doable steps, and that is what works. So I asked Jamie, if you didn't have control over timing, I'd feel forced and rushed and stressed by other people's agendas, timelines, and experiences. I would be consumed with fear of letting somebody down. Those are perfect circumstances for lapsing and failure and the promulgation of diet-related diseases. Leadership and resources. Your leaders have to be expert. You cannot beat this very, very complicated addiction with amateurs. Your program has to be strength building, stress-free, and you've got to be working with visions, not goals. And you have to be focused on cognitive restoration. Expertise includes knowledge of the science that explains why people are doing what they're doing. You're demystifying, you're demythifying, you're taking the blame off the person. Your leaders have to know the basic research on what is happening in the brain in response to these corporate addiction business models. So amateurs, I'm sorry, they waste time and they frustrate everybody, and it leads to self-blame and failure. It's just a complex, severe addiction. Now, alcoholism in the 1930s, which is where these 12-step support groups started, you could use the 12-step model on that. One substance, very homogeneous group, lots of ability to copy, and that program was adequate for that circumstance. But this is very, very different. This addiction is very, very different. Personal experience versus science, it's not going to help. So I said to Jamie, well, if you had to depend on amateur leaders, what would be happening? I would be confused. I'd be skeptical, and I would be misled. I would be failing and blaming myself. It's like you wouldn't go to an amateur for cancer treatment. This is a really complicated mental illness. You cannot expect an amateur to deal with this. So leaders need to be maximizing strengths and reframing negative thoughts, because these patients have the trauma of repeat failure. They need to be built up. So leaders need to be able to recognize dozens and dozens of strengths and speak them back to members. These programs that dwell on character defects, they encourage the person to think of themselves as weak. You have to think of yourself as powerful. If you're going to beat these PhD addiction scientists, the surround marketing, the multiple addictive substances hidden in your food, my experience is that members have to see themselves as very powerful, very capable, very smart, very skilled. You're not going to do that if you're spending a lot of time, dwelling on their defects. No. So ask them, how do you deal with building up the strengths of your members? Or are you spending a lot of time talking about character defects? Just ask. So I said to Jamie, if you were required to dwell on your character defects, I'd be depressed, self-deprecating, and anxious every time another defect popped up. And she told the story of being in a group where she was lapsing frequently. And instead of getting training, instead of getting encouragement, instead of getting skill building, instead of getting demystifying explanations, her coach in that environment said, well, we just haven't dealt with your defects yet. Ask, please ask, before you send somebody to a program. Are you going to be digging up their character defects? Just don't do it. Environments have to be stress-free. Stress activates the addicted brain cells. It must be a calm and recovery environment. You can't have these weird, stressful requirements. Like I was in a program for about 24 hours where I had to wake up with sleep disruption, which leads to relapsing, and make a phone call. I had to call somebody and tell them what my plan was for my food that day. That's weird. It's damaging. it's destructive, it's misguided, it's traumatizing. So make sure that, just like ask about the rules. And if there are things that are not constructive, keep going. That's not a program for your patients. And those rules can be capricious. Like I had a member once tell me that she had to confess that she'd eaten a kernel of popcorn. And she got fired by her sponsor. She had to go back to the back of the room. She had to be publicly humiliated by taking a new chip. And oh gosh, please just ask about these things. Unworkable advice is stressful. And training, you got to make sure that training and detaching from other people's dysfunction is offered, because other people's dysfunction can just wind up a traumatized, addicted person very quickly. And again, personalized. What's most important to that patient? What do they want to work on first? It's why, like our program, we don't have steps. We have long lists of things that people can work on, but they tell us, I need to fix this relationship before I can start working on my food. Okay, what is it about the relationship? Like, he just says mean things to me. Okay, we can do boundary setting or we can do detaching. What would work better for you? Oh, I would like to be able to detach. Okay, we've got some exercises that you can do for that. So if you were in a program where, nope, step one, got to get off the processed foods, you've got to make these meals. Step one, make the meals, get abstinent. That will traumatize your patient. Don't do that. Okay, so I asked Jamie, I said, if your recovery program were stressful, and oh my goodness, she'd been in a whole bunch of them. She said, I'd be trying to fit in, but the stress would send me further into my addiction. Pretty soon I'd be eating again without knowing why. This happens every day to literally hundreds of thousands of people who are in traumatizing support groups. Visioning. So once you set a goal or a deadline, that person is sunk. All they can think about is, I'm going to fail. They have failure trauma in their past, and the stress of that sends them right into the foods. So visioning is quite different. We do a lot of exercises where, like, the last line is, and this is the person I became. Or, this is the person I want to be. This is how I envision myself. When you are doing that, you're actually teaching the brain to become that person. And they do. I noticed it really early on, that when people describe themselves and they identify with that description, and they're around people who are already like that, it's shockingly easy for them to achieve goals. You can't use the goal word, you can't use the deadline word. Just let them generically, from the bottom up, create these visions in their brain, because you are retraining brain cells through that process. So I said to Jamie, if you had to set goals and meet deadlines, well, they would hang over my head, dominate my thoughts, detract from the peace and joy I feel when I can go at my own pace. So ask, how do you guys deal with deadlines? How do you deal with expectations? Do you have deadlines? How do you set goals? And if they roll out their deadlines and their goal setting, keep going. Your patient will be stressed out by that. Cognitive restoration. We talked a lot about how the addiction pulls the blood flow away from the frontal lobe, and you have lost cognitive function. This is attention, learning, decision-making, memory, impulse control. It's why we have epidemics of those things, because in the United States, 67% of the calories consumed are processed foods. So people just generally have these addicted brain cells that are pulling blood flow away from the frontal lobe. And when a brain cell doesn't have blood flow, it's not firing. So you can't pay attention, you can't learn, can't make decisions, can't remember things, and can't control impulses. So be in a program that's aware of this. Ask them, what do you do for cognitive restoration? Like we are teaching the science. We're not teaching it by just explaining it and expecting somebody to understand and remember. We're teaching it because we explain it again and again and again and again, and it just becomes absorbed easily by our members. So this is, we also work hard to replace television with our own program. Television dumbs people down. Our programming, which we deliver over Zoom, lifts people up. It's interesting. We're talking about very fascinating aspects of disease. And just by listening, people do improve their attention span and their learning, decision-making, impulse control, and memory, because those are the cells that are being activated in an interesting conversation, and not by television, not by mainstream media, which is all about violence and people doing mean things to each other, eating disordered actors and actresses. That is actually making the addiction worse. So this is so crucial, because if you don't understand cognitive impairment, the program is not creating doable steps. They have their own idea about what the patient should be able to do. They make steps that are too big, and the patient quits because they are being set up for failure. So Jamie says, if I were being given tasks that were beyond my cognitive ability, I feel overwhelmed and stressed out and frustrated. I judge myself on why my brain wasn't working the way it was supposed to. Okay, so here we go. We're finally at the summary. But can you see why each one of these 20 is a must-have? If you're missing one of these, you have opened the door to very painful self-blame on the part of that member. That is the avenue to failure. It's the pain of not understanding. So let's just whip through this. You just use this like a checklist. When you're evaluating a program to send your patients to, just ask these 20 questions. Are you research-based? Do you teach the addiction business model? Do you engage conformance drive? Is it for a lifetime? Does the patient have time to organize? Can they talk about whatever they need to, whenever they need to? Do you force them to eat particular foods? Do you understand all the victories? Do you understand and do you teach that lapsing can take years to stop? Do you give them training and cues? Do you release them from self-blame? Do you give them the opportunity to immerse themselves in the program? Do you make it easy to connect? Do you teach them how to stop cravings? Do you give them control over their time and pacing? Are your leaders trained? Trained in the science and trained in compassion? Do you build strengths, or are you dwelling on character defects? Is the environment stress-free? Do you use envisioning and not deadlines? And do you help with cognitive restoration? Are you aware of that? Now you know. These people are they're just so traumatized, and they're so sick from the poisonous processed foods. They just need to be lifted up again and again and again and again. And it works. And then you get to be the hero. So thank you very much. I appreciate, I know this was a long, very dense presentation. I just want to say a big thank you to Paul Mason for inviting me. And there's our contact information. Our website is www.processedfoodaddiction.com. There are lots of free resources there. It's a website for practitioners and for individuals alike. And please email me. I love getting emails. Email gethelp@foodaddictionreset.com. Thank you so much.
Well, one of the fascinating things in modern life, Paul, is the fact that people have lost the art of cooking. They've forgotten how to cook, or maybe they never learned how to cook. There's a whole generation of people out there who don't seem to know how to cook.
And I think that's interesting because, as Joan said, one of the 20 must knows is actually how to prepare your food. And I know this is a personal passion of yours. So with your Defeat Diabetes program, you actually went and got some MasterChef contestant to go and do some instructional cooking videos. So even on things like just making scrambled eggs or omelets or things like that, things that are seemingly simple, these are culinary skills that are both valuable but often unknown by many.
Well, I think all we see on television now is sort of, Master Chef, and chefs cooking amazingly complicated, incredible meals. And in a way, I think that almost puts people off. They sort of think, oh, this cooking's too hard. So what we've tried to do in the Defeat Diabetes program is just go back to basics and teach people how to cook really simple food, but really well and really tasty. So things like eggs and meat and a bolognese sauce and so on. So, basic sort of stuff that I'm not sure people pick up along the way, and I don't know where they're going to learn that.
So well, I guess home economics really isn't taught in schools anymore.
No. Well, my son got taught it, but he's still bloody hopeless. So anyway, all right. Let me introduce the final. Let me introduce the final speaker, and we're very looking forward to this. Belinda Fettke has done a lot of work digging deep into the conflicts of interest in the nutrition world, and she's got a fascinating story to tell. I'm looking forward to hearing it.
As the incidence of type 2 diabetes continues to escalate with the force of an approaching tsunami, it's imperative to find lifestyle interventions to protect those in its path. This issue deserves a Bill of Rights. People deserve to know that type 2 diabetes and its subsequent life-threatening complications are entirely preventable. According to the International Diabetes Federation, in 2019, over 416 million adults were living with type 2 diabetes worldwide. We know health is a prerequisite for human, social, and economic development. It's imperative we protect it. Type 2 diabetes was described by Dr. Pran Yoganathan as a debilitating, multi-system, non-communicable disease, robbing people of their health and their independence. Type 2 diabetes affects everything from an individual's mental health, their eyesight, kidney and cardiovascular disease, and the risk of stroke. Not to mention the loss of sexual function, with the very real risk of non-healing ulcerations of feet and lower limbs, with amputation becoming a long-term consequence. The IDF estimated healthcare expenditure in 2019 exceeded $700 billion. After decades of simply band-aiding sick care, believing that type 2 diabetes was a chronic progressive disease. Imagine the joy of empowering people to take back control of their health, using food as medicine. How disappointing, then, to find the ACLM has published this much-needed Bill of Rights, with supporting resources and educational material as an exclusive document rather than an inclusive one. Incredibly, the conclusions from the majority of the cherry-picked references do not support the bite-sized claims in the American College of Lifestyle Medicine's position statement. There are inherent flaws of epidemiology and a healthy person confounder. Positive studies have been omitted from the low-carb discussion, and recommendations of commercially produced soups and shakes. But most concerning is the declaration of no conflicts of interest, despite deep personal beliefs. Where is the acknowledgement that an ancestral diet, which includes animal proteins and fats, is not only a safe option in managing type 2 diabetes, but being used successfully to put it into remission? Where is the acknowledgement that an ancestral diet, one we evolved to eat, is nutritionally complete, focusing on nutrient density and food quality with minimal processing, sourced fresh, seasonally and locally? Sounds a little like American College of Lifestyle Medicine's Dietary North Star, to which humans should strive. But then when you look closer, you see it's an eating plan based predominantly on the biblical Garden of Eden diet. It's vegetables, fruits, whole grains, legumes, nuts and seeds, which they claim is rooted in science. It's essentially a high-carbohydrate, low-fat diet, and apparently time and space do not allow a full review of the evidence. But we can say with reasonable certainty, animal protein is detrimental to health. Reasonable certainty, because time and space did not allow for a full review of the evidence. But hey, animal protein is detrimental to health. Is the demonization of animal protein and fats simply an undeclared bias because the authors are either ethical vegans or adherents of the biblical Garden of Eden diet, in keeping with the teachings of the Seventh-day Adventist Church? Fruit, nuts and seeds constitute the diet chosen for us by our Creator. It's important to understand that the authors and facilitators involved in the American College of Lifestyle Medicine's Diabetes Bill of Rights, their type 2 diabetes position statement, and the accompanying online course for health professionals published in 2020, claim the health benefits of cereals, grains, nuts and soy as the gospel truth, while simultaneously casting strong doubts on meat eating, even suggesting animal protein and fat are the cause of type 2 diabetes, cardiovascular disease and cancer. Therefore, a Diabetes Bill of Rights is a big call because it's virtually impossible for them to consider the health benefits of a low-carbohydrate diet, let alone a low-carbohydrate diet that includes animal proteins and fats, as an option in reversing type 2 diabetes. So when they claim you have the right to be given accurate, complete and unbiased information about type 2 diabetes, prediabetes and insulin resistance, I would argue religious beliefs deny a well-rounded discussion of all the dietary options available for the remission and reversal of type 2 diabetes. The following discussion will help determine the inaccuracies and the bias of the American College of Lifestyle Medicine's high-carbohydrate, vegan dietary recommendations. To me, it's essential to acknowledge the role of low carbohydrate diets in the management of type 1 and type 2 diabetes, which have not only been downplayed, ignored, and criticised, but even dismissed by the authors and facilitators of the ACLM's position statement, the Bill of Rights, and the companion online course. If you think about it, an inclusive document looks beyond personal beliefs to offer a complete and unbiased document and to truly help to empower all people to take back control of their health. I respect each and every individual's belief and their right to choice. Discovering religious ideology and the corporate church's influence on our dietary and health guidelines was completely unexpected, as was the pro-cereal, grain and anti-meat rulebooks, which both my husband Gary and Professor Tim Noakes in South Africa appear to have come up against when reported to their medical regulators by dietitians in 2014. I'm not opposed to those who choose to be vegetarian or vegan for cultural reasons, health concerns, ethical beliefs, nor for their religious ideology. My concern is that choice is being taken away from you and I by those creating and protecting the dietary rulebooks. Taken away from people who choose to follow LCHF and keto principles and who choose to include animal proteins and fats in their diet for their health. I try to stay respectful, but I can't stay silent. Let's consider the terms reversal and remission of type 2 diabetes, because the ACLM and many other people appear to use them interchangeably. Reversal is defined as an HbA1c less than 6.5% achieved without diabetes medications. Remission is defined as an HbA1c less than 6.5 achieved without diabetes medication and maintained for at least 1 year. Imagine if the goal was normal blood glucose, and where the HbA1c is equal to or less than 5.6. There are currently 3 accepted ways to put type 2 diabetes into reversal or remission. Bariatric surgery. But this is a surgical intervention which involves operating on a healthy organ for a dietary disease with associated risks. A VLCD or a VLED, a very low calorie or a very low energy diet, where they use commercially processed soups and shakes as meal replacements. The other option is a low-carb ketogenic diet, fresh local seasonal foods that are minimally processed and providing essential nutrients necessary for good health. The recently published Abbott ebook suggests that once that target weight and glycemic control is achieved, reversal and remission of type 2 diabetes can be maintained using either a Mediterranean diet, a vegetarian plant-based diet, or a low-carbohydrate diet, with or without intermittent fasting. Dr. Russell M. Wilder understood from 1916 that diabetes was a disease of carbohydrate intolerance. And he used a ketogenic diet in the clinical management of diabetes even before its use in the treatment of epilepsy. Wilder's protocol for individualizing therapeutic carbohydrate restriction below 60 grams, combined with intermittent fasting, enabled patients at the Mayo Clinic to control their blood glucose, as outlined in his book, A Primer for Diabetic Patients. The Commonwealth Scientific and Industrial Research Organisation, or the CSIRO, is an Australian government agency responsible for scientific research, and they've been investigating the health benefits of a low-carbohydrate, higher-protein diet since 2005. They claim it's reducing the burden of type 2 diabetes, and the research results are groundbreaking. A 2018 study discovered exceptional glycemic control of type 1 diabetes, with low rates of adverse events reported in children and adults consuming a very low carbohydrate diet based on the protocols of Dr. Richard Bernstein. Dr. Bernstein was diagnosed with type 1 diabetes in 1946 at the age of 12. For more than 2 decades, he described himself as an ordinary diabetic dutifully following conventional wisdom, which was a low-fat, high-carbohydrate diet, which he says nearly killed him. Dr. Bernstein, now in his 80s, is living proof of the success of a low-carbohydrate method outlined in his book, Dr. Bernstein's Diabetes Solution, which was first published in 1997. His methods have inspired thousands of people to maintain normal blood glucose levels and reduce the risk of long-term diabetes complications. Here, the American Diabetes Association's CEO, Tracy Brown, revealed her success with a low-carbohydrate diet in an interview, talking about how seriously she takes the responsibility of being the poster child of how to thrive while living with type 2 diabetes. In a tweet, she thanked Dr. Richard Bernstein and his book, noting, "Reducing carbohydrate intake has had such a profound and positive impact on my health." After discontinuing her use of insulin and significantly reducing her prescription medication, Tracy Brown hoped she'd be able to drop her last medication by the end of 2020. I'll have to see if I can find out if she did. David Dykman is also speaking this weekend at the Low Carb All Stars. He's an incredible young man with type 1 diabetes who has used Dr. Bernstein's very low carb protocol to manage consistently normal blood glucose for 7 years. Congratulations, David. So I guess we need to define a whole food plant-based diet. The team at Diet Doctor does it brilliantly. Here they demonstrate a low-carb ketogenic version that provides all the essential nutrients, vitamins and minerals needed, without supplementation or industrial fortification. ACLM's latest resources depict their version of a whole food plant-based diet, with recommended supplementation. But look, it's completely devoid of animal protein and fats, even for children. I understand this is their belief. But where is the transparency for those who do not ascribe to the dietary teachings of the Seventh-day Adventist Church? Oh, and as an aside, as I delve into all my research, I found T. Colin Campbell, author of the China Study, claims to have coined the term whole food plant-based in the 1980s to euphemize a vegan diet and make it more palatable. So why should an authoritative, well-orchestrated rallying cry to adopt a vegan diet be of concern? Well, 3 reasons come to mind. Firstly, an undeclared perceived conflict of interest regarding the demonization of animal protein and fats based on religious ideology. Secondly, the biblical dietary beliefs of the Seventh-day Adventist Church are being pushed onto an unsuspecting public as the gospel truth, which makes me question Is medical evangelism of the Adventist health reform message being used as an entering wedge to the church a violation of medical ethics? Conflicts of interest influence people's views and in turn their recommendations. If you're dressed in purple, perhaps with a mitre, and sign yourself as a bishop, you do not need to declare your religion as a competing interest. It's plain for all to see. But if you have a religious faith that is not apparent, and you're participating in a debate or creating public health guidelines on an issue affected by religious belief, for example, nutrition, then you should declare that competing interest. From 1863, Ellen G. White, the prophetess of health, founder of the Seventh-day Adventist Church, determined the care of health was a religious duty, and she warned of the physical dangers of eating flesh meat, especially pork. She was told in vision that eating flesh meat would stir baser passions, leading not only men, but women and children to the act of self-vice, or masturbation. This was considered to be the ultimate sin known to man at that time. She also taught it's the duty of the church to actively engage in public health education, to control impure desires and baser passions. Her teachings continue to influence the advocacy of a plant-based vegan diet as acknowledged in the publication, The Global Influence of the Seventh-day Adventist Church on Diet. It was co-authored by Joan Sabat, a member of the 2020 US Dietary Guidelines Committee and a founding member of the American College of Lifestyle Medicine. The paper is an historical perspective on the ideology of the Seventh-day Adventist Church and their subsequent influence on nutrition science and dietary guidelines worldwide. Not only does it summarize years of my own research, but the authors even acknowledge some of my work. It has been clearly presented to me that God's people are to take a firm stand against meat eating, said Ellen G. White in 1863. Again and again I've been shown that God is bringing his people back to his original design. He would have us teach people a better way. No meat will be used by his people. Not only did Ellen G. White teach grains, fruits, nuts and vegetables constitute the diet chosen for us by our Creator, she also insisted, among those who are waiting for the coming of the Lord, meat eating will eventually be done away. Flesh will cease to form a part of their diet. The American College of Lifestyle Medicine is a highly influential non-profit organization with a rapidly expanding membership base across the United States, into Australia, and around the globe. Members include primary care physicians, specialists, researchers, professors, students, public spokespersons, hospital administrators, nutritionists, health coaches, public health professionals, and as they say on their website, many others. The authors of the ACLM position statement declared no potential conflicts of interest with respect to their research, authorship, and/or publication, despite their personal beliefs. They do acknowledge financial support from the American College of Lifestyle Medicine, the ACLM. an organisation co-author John Kelly MD founded in 2003, which sort of suggests it's a conflict of interest. But let's not go there. John Kelly founded the Christian Association of Lifestyle Medicine on the Loma Linda University campus. In 2004, it officially became the American College of Lifestyle Medicine. At the time, all 9 office bearers and directors were members of the Seventh-day Adventist Church. The presentation Lifestyle Medicine, Evidence-Based Medicine for the 21st Century, was created by John Kelly MD, again the lead author of ACLM's Type 2 Diabetes Position Statement, and he referenced Ellen G. White, the Bible, and the Adventist Health Reform message in his citations. The presentation not only outlines a brief history of lifestyle medicine in Genesis, but claims it was lifestyle medicine when Adam and Eve were given a vegan diet. God gave the light on health reform, and those that reject it reject God. This is what Seventh-day Adventists believe is evidence-based medicine. John Kelly also co-authored the Lifestyle Medicine Board Review Manual and spoke over and over of evidence-based lifestyle medicine, that which is found in the Bible, and through the inspired interpretations of the Scriptures by Ellen G. White, who is considered the authoritative and continuing source of Bible truth. Evidence-based lifestyle medicine is young earth creationism. It's a belief in the literal 6-day creation and that the Garden of Eden diet given to Adam and Eve is the God-appointed diet for man. Ellen G. White said, "The Bible is not to be tested by men's ideas of science." Why? Because science, falsely so called, thereby placing that which was created above its creator. Remember, Ellen G. White said God gave the light on health reform, and those that reject it reject God. Co-authors of the ACLM position statement include Seventh-day Adventist John Kelly and Gregory Steinck. Michaela Carlson is the director of the Lifestyle Medicine Economic Research Consortium, the LMERC, which was established as a joint venture between the American College of Lifestyle Medicine and the Lifestyle Medicine Institute, which is the developer of CHIP. The Complete Health Improvement Program sits under the umbrella of the Seventh-day Adventist Church's commercial arm in Australia. The Sanitarium Health Food Company. It's afforded religious charity status and as such pays no tax on income received from facilitators or participants of the CHIP program globally. So what does CHIP look like? While the Sanitarium website claims CHIP is not a mandate for vegan or vegetarian diets, their facilitator's guide shows pretty clearly what the Seventh-day Adventist Church's position is on stimulants, with meat, dairy, and eggs heading the list for the worst possible health outcomes, higher up the list than processed food or alcohol. Adventist Dr. Hans Dill was the founder of the program, and he acknowledged he is 100% vegan and CHIP is total vegan. Probably that means 100%. Up until December 2020, CHIP was endorsed by the International Nutrition Research Foundation, which was incorporated in 1989 by Hans Dill. So he was endorsing his own program. Yep. Sanitarium's CHIP sponsors and partners with many Lifestyle Medicine Society events, offering to run facilitator courses. Ellen G. White came to Australia following a vision she had where an angel told her she saw a publishing house here. Over the next 10 years, she helped establish not only the Seventh-day Adventist Church and the Signs Publishing Company, the Sydney Adventist Hospital, primary schools, and Avondale College. She also wanted to reproduce Kellogg's cereal model, founded by John Harvey Kellogg at the Adventist-owned Battle Creek Sanitarium. But this time, have the church own it. While here in Australia, Ellen G. White wrote, "The health food business is to supply the people with food which will take the place of flesh meat and also milk and butter." But I digress. Having set the scene for the pro-cereal grain anti-meat messaging, it's time to take a closer look at the so-called evidence base. The justification used to determine the dietary recommendations by the American College of Lifestyle Medicine, knowing the ultimate goal in the management of type 2 diabetes is to control hypoglycemia and prevent acute and long-term complications. This screen grab highlights the ACLM's cherry-picked studies and excerpts to create the illusion of aligning with their beliefs and suggesting a low-carbohydrate diet is not a healthy nor a safe option in the reversal of type 2 diabetes. Let's have a look at some of the references a little bit more closely. Dr. Andreas Einfeld, diet doctor, explains in this study, researchers fed mice, a keto diet for 3 days, They fed mice a keto diet for 3 days. That's basically it, he says. Reference 79. Adding more fat to a high-fat diet only exacerbates hepatic insulin resistance. Now, in mice fed a keto diet for 3 days because, incredibly, this Journal Club article simply rehashes the findings from reference 78. That's all it does. A nice repeat reward. Reference 80 acknowledges the attitude to high-protein diets is controversial. No long-term prevention studies with a high-protein diet exists. Concerningly, they state, one argument not to recommend high-protein diets in the long term is that this kind of diet may cause concern when adjusting dietary patterns to a lower protein intake when necessary. For example, regarding the development of renal disease. Well, what happens if a normal or higher protein diet avoids the complications of renal disease? Reference 81, again hinting at safety concerns of a high protein diet. The conclusion from the study suggests otherwise. Negative effects of a high protein intake could not be established. Apparently, a primary problem of most studies is the poor compliance of study subjects with the recommendation of lower protein intake. So the problem isn't the high protein. The problem is the poor compliance of study subjects who don't want to eat a low protein diet. Reference 82 sees ACLM claiming higher intakes of red meat and processed meat products have been consistently associated with the increased risk of type 2 diabetes. Well, there are 3 obvious flaws of epidemiology. The first one is association is not causation. Relative, not absolute risk, and the healthy person confounder. But let's just take a look at the results they got. So ignoring the fact that this review of meta-analysis relies on food frequency questionnaires, diet history, and a 24-hour dietary recall, which come with their own inherent flaws, the collated table clearly demonstrates the evidence of associations between red meat, unprocessed red meat, well, I'm not quite sure what the difference is, and fish and seafood with the incidence of type 2 diabetes are all very similar. I highlighted it with a nice red bar. And I don't know why red meat is more of a risk than unprocessed red meat. But anyway, there you go. Which begs the question as to why red meat has become so vilified. If anything, people should be worrying about hot dogs, especially the white bun and the sauces, the French fries doused in polyunsaturated seed oils, and the side of Coke. This is a highly processed recipe for disaster. Reference 83 sees a series of systematic reviews and meta-analysis in a study that, again, does not support the claim of higher intakes of red meat and processed meat products. In fact, red meat's not even mentioned in this article. It's about fibre. Before discussing what may or may not be a healthy dietary pattern in reference 84, it's worth mentioning the conflict of interest statement accompanying this article is illuminating. And even so, the authors concluded, we have a high certainty of evidence that type 2 diabetes is preventable by changing lifestyle. A high certainty of evidence. Changing lifestyle. But additional well-controlled intervention studies are needed to identify the optimal diet to prevent type 2 diabetes. Well, when you've got all those conflicts of interest, it's hard to work out what diet would be a good one. By the way, references 60 and 61 appear to have been ignored in the low carbohydrate section altogether. Instead, they lie obscured in the history section, where they sit without acknowledgement of their positive results. Reference 60 was actually published in October 2018, not before the invention of insulin, as the positioning within the ACLM article sort of infers. Eric Westman's findings was that the ketogenic diet substantially reduces the glycemic response that results from dietary carbohydrates, as well as improving the underlying insulin resistance. Reference 61, the effect of dietary carbohydrate restriction on lipid abnormalities was examined in 42 newly diagnosed maturity-onset diabetics. The findings, the plasma lipids reverted to normal in half of these patients after dietary treatment for just 1 month. Specialized and complex diets and lipid-lowering drugs were unnecessary in the majority of patients. I have to ask, were these two studies omitted from the low carbohydrate discussion because they didn't fit ACLM's cherry-picked narrative? The religious justification used to determine the dietary recommendations of the American College of Lifestyle Medicine's Diabetes Bill of Rights fails to provide accurate, complete, and unbiased information. When I heard Georgia Eade describe the Eat Lancet report a couple of years ago, her words really resonated with me. I see so many similarities with lifestyle medicine. It's true. The American College of Lifestyle Medicine has a seemingly endless benevolent agenda that wards off criticism. However, there is a distinct lack of transparency and a perceived conflict of interest around their promotion of exclusive plant-based diets. It's about hope and empowering people to take back control of their own health. As my dear husband, Dr. Gary Fettke, says, once you see the health benefits of low-carbohydrate, healthy fat principles, you can never unsee them. An inclusive type 2 diabetes Bill of Rights would be encouraging fresh, local and seasonal whole foods, supporting cultural diversity and food preferences, avoiding added sugars and processed foods, thereby offering the best health outcomes possible, including the remission and reversal of type 2 diabetes. Nutrition seems the only science where those who consider evolution are fringe and those who ignore it mainstream. Bizarre, said Dr. Troy Stapleton a few years ago now. There is no one size fits all. Thank you so much for having me. I loved chatting to you today and hope I've helped work through some of the issues and the misunderstandings. We need a Bill of Rights. People with type 2 diabetes need a Bill of Rights, but it has to be inclusive, not exclusive. Please be noisy with me.
Okay, good to be able to talk to the folks in the southern half of the world. Anyway, just wanted to do some updates around carnivore-related stuff and talk about a little bit of stuff we got coming up. So for those who don't know, a number of important studies have come out in the last couple of years. First of all, this 2019 study done by the Nutri-Rex organization looking at a systematic review of red meat. This was first authored by Brian Johnson, 14 panel experts, and Gordon Guyatt, as you see, is a senior author here. He is known as the father of evidence-based medicine. Basically, the results of this large systematic review on red meat showed that there is no strong evidence that suggests that red meat causes heart disease or cancer, which you may have heard before based on things like the WHO's recommendation back in 2015. This really critically looks at the evidence and shows that the evidence is insufficient to make those claims. 2020 study comes out in the Journal of American College of Cardiology showing that saturated fat, as it comes from red meat, dairy, eggs, things like chocolate, other whole natural foods, do not seem to be related or causative when it comes to cardiovascular disease. And then finally, this 2021 study, this came out the other day, looking at the relationship between red meat consumption as per randomized controlled trials. This particular systematic review, meta-analysis, looked at 17 randomized controlled trials and saw no relationship with red meat consumption and elevations in fasting blood sugar, insulin levels, hemoglobin A1C. What they did notice, or levels of insulin resistance, what they did notice, however, was that postprandial blood sugar seemed to be lower in folks that consume more red meat. And we certainly see that within the carnivore community. In fact, we have a number of diabetics with basically normal blood glucose. We even have a number of type 1 diabetics who are basically on minimal insulin, and they have very, very nicely, very flat blood glucose levels. Okay, I'll continue to make the argument that red meat is a health food. Humans have been eating it for as long as humans have been alive. This nice study done out of Tel Aviv, co-authored by Mickey Mandor, looks at early humans and show that based on a number of very, very elegant multidisciplinary analysis, that human beings primarily ate mostly a meat-based diet, if not a fully carnivorous diet, for much of his existence, which started to transition away around 80,000 years ago as access to large megafaunal game became more scarce. And this is one of the reasons why it is not appropriate to compare modern indigenous tribes, hunter-gatherers that we see today, with our remote ancestors, as likely the food supply and the food opportunities and the game that was present is much different than it is today, or even within the last several hundred, even thousands of years. We saw a huge megafaunal die-off commencing around 125,000 years ago and accelerating as humans traverse the globe. I know a lot of people will believe, or are led to believe, that climate impacts from meteors and so on and so forth, asteroids, cause the demise of much of the megafaunal population, particularly in North America. But pretty consistently, wherever humans expanded to throughout the Asia, North America, South America, and across into the South Pacific, large megafaunal animals quickly became extinct within several thousand years, whether it's due to overhunting, hunting enough of their babies. These large megafaunal animals, remember, don't reproduce very rapidly, and therefore just impacting something like 10% of the offspring is enough to basically bring down the demise of a population. Okay, in other news, just keeping folks abreast, and then we'll get into more of the carnivore-specific stuff, but, we're seeing a huge push to give up red meat or give up meat in an effort to protect the environment from global warming, and we often see numbers quoted as high as 18% of all greenhouse gases are originating from animal agriculture. This came from a 2006 study called Livestock's Long Shadow. That study has been previously revised by its authors due to significant criticisms about the comparisons that were made, and so they revised and downgraded that 18% number to about 14.5%. Remember, that's still a life cycle assessment, and that's worldwide totals. Now, if we look at the United States, and Australia probably has very similar numbers, but in the United States, according to the EPA, our animal agriculture produces about 4% of our greenhouse gases, cattle being responsible for 2% of them. Plant agriculture is responsible for 5% of our greenhouse gases, and then the combination of industry, energy, and fuel, or transportation rather, is responsible for around 80% of our greenhouse gas emissions in the United States. And again, these emissions do not account for the potential offset that soil sequestration of carbon can potentially do, and that's been demonstrated with certain types of animal agriculture. And so why is the worldwide number higher than the U.S. number? Well, first of all, the U.S. has a lot more usage of fossil fuels than most of the world. We also have to remember that if we were to roll the clock back, say 100 years or 200 years, almost all of the man-made greenhouse gases would come from agriculture because there was nothing else. So when you include, developing countries, African nations, and so on and so forth, you're going to have very high relative rates of animal agriculture contributing to greenhouse gases. Okay, another concern that's often brought up is the high water usage, particularly for cattle. Again, this is another sort of mischaracterized observation in the fact that the majority of the water that is being utilized by cattle is so-called green water, that is water that falls from the sky, basically rainwater that grows the grass. Most of the cattle's water consumption comes in the form of the grass that it eats. That is something that would occur regardless if the cows are in the field or not. The cows aren't out there doing secret rain dances to make it rain more. The rain happens whether or not the cow is there or not. Although there is a little bit of a nuance to that in the fact that if you have well-managed pasture that cows are moved frequently on, then what we see is better soil health, better water retention. And that actually affects the climate so that there's actually more rainfall in those areas. But outside of that point, the cows utilizing the majority of their water is coming from rain and grasses that they eat. And guess what? The cows, when they do the same thing with water after we get done with it, we recycle it. They respire it out, they urinate it out. I'm not sure if cows sweat or not. Maybe they do, but we sweat it out. And so the water goes back into the soil in one form or fashion or the other, and then back in the atmosphere and falls again as rain. So these water numbers are wildly exaggerated to fit a narrative. Okay, another point that is often used to try to convince people to go on a plant-based diet has to do with the ethical side of things, and certainly animals die to produce meat. That's quite obvious, but what most people don't realize or fail to account for or consider is the fact that many animals die for crop production. In fact, in Australia, it's been shown that based on studies that to grow wheat, approximately 25 times more sentient animals are killed to produce a kilo of wheat versus a kilo of red meat. And so it's also important to know that all animals eventually end up as food. You and I will end up as food for something at some point, I guess, unless we're cremated. But generally, anything that dies will be decomposed, eaten by microbes, by worms, by insects, or in the case of most wild animals. And in this study out of Pennsylvania, the University of Pennsylvania conducted a nice study looking at white-tailed deer in the U.S., and they tagged several thousand of them. They tracked them for 34 weeks, and they saw that approximately 60% of those died before they reached the age of 34 weeks, 70% of which died through predation, meaning they were eaten basically while still alive, and the remaining died of illness or injury or the exposure to the elements. That is a normal fate of a wild animal. A cow, for instance, we'll use a dairy cow in the United States. They're going to live for 9 or 10 years. They're going to be protected. They're going to be fed. They're going to be sheltered. They're going to be housed. They are going to be very comfortable for their life, and then they will be killed in a very humane fashion. Okay, that ends my PSA on why we should not be getting rid of meat and why we should be eating meat. There's some other things out there, I guess it should be noted. A lot of people talk about the healthfulness of plant-based diets, and so we're starting to see some actual studies looking at that involve sort of real-world outcomes, not just looking at whether or not it affects your LDL, cholesterol, or so on and so forth. And there's been a study looking at several dermatologic studies. In fact, 4 of them recently came out of Italy, looking at vegan skin versus omnivore skin. And in every one of those studies, we saw that the healing properties, recovery properties of the skin of a plant-based person is far less robust than the healing of people that include meat in their diet, and to include wound diastasis, or opening of wounds, or delayed healing as problems for people on plant-based diets. Additionally, a Cochrane collaboration evaluated the claim that a vegan diet is something that can mitigate, prevent, or reverse heart disease. And looking at all the data that they have on that, they found that there were no studies out there that would support that claim. They saw some things that can mildly impact blood lipids, but no actual endpoints showing actual reversal or prevention of cardiovascular disease. So those claims are basically not grounded in anything of true merit. Okay, let's talk a little bit about the carnivore diet now. Where are we at in 2021? We've been looking at people collecting data. I can say with pretty good confidence that a carnivore diet seems to be helpful for a wide variety of conditions and in a wide variety of situations, and people of different types, whether they're male, female, young, old, different ethnicities, different medical histories. A carnivore diet seems to be quite helpful in pretty much almost all situations, although it doesn't seem to be 100% effective in 100% of the people. Nonetheless, it tends to be very helpful. We have at MeatRx, we've collected, and we continue to collect these success stories, and so we now have a fully 75 pages of success stories with about 10 success stories per page, so close to 1,000 of these success stories that we've just cataloged, and there are many more that continue to come in. A number of notable people have tried with success, including Joe Rogan a couple times. He's done the diet for periods of time with great success. We've got NFL Super Bowl champions like Danny Sorensen. We've got a number of mixed martial artists and fighters that have done that, including the legendary jiu-jitsu athlete Carlos Machado. Chad Mendez, a USC fighter, has cured his psoriasis with this. We've got Georgie Karhanian, who is a Bellator fighter, who is also competing and has won fights as a carnivore diet athlete. Several rugby players, including guys like Sonny Bill Williams in New Zealand, and Quade Cooper, I believe, who is in Australia, have successfully done a carnivore diet with good result. Okay, some of the things we are finding that are interesting, and let me just clarify, when I talk about a carnivore diet, and this has been the same since I've started, I talk about it and I define it as a diet that is focused in its primary nutrition source is animal-based. This is where the focus of the diet comes from. People will either fully eliminate or dramatically limit the consumption of plant as needed, and I think that's an important caveat. You put the as needed in there, and the outcome being improved health or hopefully optimal health. And again, this is not reverse veganism. There's no ideology attached to it, which should not be done in a dogmatic fashion. Again, the goal should be to achieve health. And the problem here is defining health. And so a lot of times we like to define health based on a number of biomarkers. I tend to push back against that particular practice because I think some of these biomarkers we tend to hang our hats on tend to be somewhat context dependent, and there's some nuance to that. I'll use the example of perhaps say uric acid. We know that uric acid is associated with gout. When uric acid is high in the appropriate situation, people develop gout. Gout is an extremely painful condition that often affects the joints and sometimes the skin. We have deposition of uric acid crystals, which can be quite painful and also lead to swelling and deposits in the skin, which can be surgically removed. But that seems to be the case when other things are going on, whether there might be some metabolic dysfunction going on, chronic inflammation, there might be an immune component, there can be issues with glycemic control. That's when we seem to see gout. Remember, uric acid, as many people do not realize, is actually an antioxidant. And so we can see elevations in uric acid, and some people will postulate that elevations in uric acid can compensate for decreases in vitamin C, as they both fulfill somewhat of similar properties. And the fact that humans lost the uricase enzyme, which breaks down uric acid, and also at the same time perhaps a lost ability to synthesize vitamin C might have been a natural trade-off for that. So what we do see is that people that go on a carnivore diet that have gout often see gout go away, despite the fact that uric acid may remain elevated. And that is, again, one of these context-dependent things. And there are many things like that throughout, what I see with carnivore. Okay, another sort of interesting topic is how much protein to eat. We see a lot of people in the ketogenic space now are sort of embracing protein in a bigger way, probably thanks to a lot of the work of Ted Naiman. I've always been protein-centric for as long as I can remember, and as you guys probably realize, meat is a high-protein food, although it can be, and it often is, a relatively higher-fat food. Most people on a carnivore diet, I would say, probably get somewhere between 30 or probably 25 to 35% of their calories coming from protein, the rest coming generally from fat, and a small amount will come from carbohydrates for those people that tend to include some other things in the diet, as long as they tolerate them well. One of the questions becomes, we do start to see in some people slightly trending upwards of hemoglobin A1C and fasting blood glucose, and some people say that's perhaps a negative. Generally, those numbers don't tend to be very high, and they tend to be very stable. And so the question becomes, do we see, due to higher protein intake, perhaps better body composition, less overall fat, more lean mass, but at the same time slightly higher glucose? And is that in fact a bad thing? And the answer to that would be, I don't really know. I don't think we know. I think the sort of the very sort of primitive answer would be, higher glucose is always bad, and we should strive to have it as low as possible within reason. I don't know if that is truly true. If we look at studies on the Inuit from the 1920s, the metabolic study, they were generally regarded to be very healthy populations. They did not suffer from any of the sequelae of diabetes, and yet their fasting blood glucose was often in the 120s. They were known to consume between 4 to 8 pounds of meat a day. Probably their high caloric consumption had a lot to do with the climate they were in. Remember, if you're in a very cold climate, you need to generate a lot of body heat, and therefore you're going to need a lot more fuel to do so. So that probably contributed to that, and because they had perhaps higher blood glucose, but no signs of diabetes, no kidney disease, none of the complications of diabetes, maybe there's some room for discussion in that area. If you look at carnivore physiology, I'll use the common cat as an example. Cats tend to run high blood glucoses relative to human beings. Now, again, humans aren't cats, but that's interesting to see. And they don't seem to suffer from the consequences if they're on their natural diet, a wild animal diet, eating mice and meat. They don't, despite having relatively higher blood glucose, they don't seem to develop any complications of diabetes. But when you put in grains, as we see the common cat food, the kibble, they become very fat and very diabetic very quickly. So it may be that there's, again, other factors, even in addition to strictly blood glucose. So I think that's an interesting concept to see. The other thing is the thought that fat can have an impact on blood glucose, and I think it does. I think, particularly, and again, Ted Naiman would agree with this, that fat seems to prolong the glucose spike. So if you combine fat with carbohydrates or enough protein, you will see probably a prolonged glucose spike. Now, the spike may not be very high, and the question is that area under the curve, is it because it causes a longer spike, you get a larger area under the curve, or does the amplitude of the spike make the biggest difference? I think, again, this is a question that is still to be determined. Okay, just a final update here on what we're up to at MeatRx. This is something we've been raising money for a clinical trial. That is something that we hope to do. We're looking to raise quite a bit of money. We're looking close to $1 million. We already have around $300,000 of that raised. So we're going to continue doing that and looking for funding sources to do a true intervention trial on these meat-based diets. The other thing that I think is interesting, Harvard University has done a study. There actually have been a couple carnivore studies. I should update you guys on that. There's been a study out of Switzerland done by Dr. Peter Martin looking at small intestinal bacterial overgrowth. This was a case series of 6 patients, and all of them recovered and basically cured themselves of SIBO. So that's in the literature. There was another study out of the University of California, Merced, that was done looking at the psychological profiles of carnivores, and basically showed that the reason it was done was for health reasons, and that generally the people that did the diets became healthier. Okay, finally, I would be remiss not to mention the study that Harvard University has done and is about to publish. David Ludwig was a senior author, and Belinda Lenners was the primary author on that, and this was a survey of about 2,000 people on a carnivore diet looking at a number of their outcome measurements. I can tell you, while the study has not been published, I've seen some of the data. It looks generally pretty favorable for folks on the carnivore diet with significant improvements in almost all areas. There was a slight trend for elevated cholesterol that did occur, so that may be criticized by some, but we saw something like coronary artery calcium scan decrease on average. There were a few increases, a few decreases, but the overall net trend was towards a decrease in calcium scores, as well as several other things. Some of the notable things that were communicated with me was that looking at assessment for potential nutrient deficiencies did not seem to occur, and whether or not someone included organ meats or not did not seem to have a bearing on that, and whether or not someone chose to eat conventional versus fully grass-finished meat did not seem to have a difference on outcomes. So this is stuff that I've seen in my data. I've got data on about 12,000 people doing a carnivore diet, and those are the same sort of results that we've seen. So very interesting stuff. I would like to just make a plug for what we're going to be doing. I think that one of the frustrations I have with the medical care, the healthcare system in the United States and perhaps in other parts of the world is it's very much top-down and often driven by pharmaceutical companies, and what we do is we see a drug developed often with the main motive of it being profitability, and whether it helps people and how much it helps people seems to be almost a secondary concern if we look at things as they seem to stand here in 2021. I think we can do things better. I think we can do things the other way around. We're going to be looking at going from the bottom up, talking to people, see what works for them, compiling data, using powerful artificial intelligence tools to figure out what actually works. And again, these are going to be lifestyle measures, diet, exercise, sleep, other things, and start to work from the other direction, have a new paradigm. So more to come on that. You guys will hopefully be able to participate and learn about that in the near future. All right, it's been great talking to you guys. I hope you guys have a great conference. See you later. Bye-bye.
It's interesting, isn't it, Paul, how strongly held personal beliefs can really lead to what we call cognitive dissonance.
Exactly. I mean, once you form a belief, it's so much harder to upend it. And we've known this in cognitive science for years. I mean, I think Daniel Kahneman, the 2002 Nobel laureate, I think he coined a term, paraphrase, that it's utterly preposterous how strongly we hold our beliefs in the face of very little evidence. And it's just human nature.
It seems to be particularly strong in the nutrition world, though, doesn't it?
Oh, it absolutely does. And I mean, somebody like Tim Noakes knows this all too well. If you actually have a read of his one of his books, when he's sort of detailing his experience with the trial in South Africa, he went into his whole discovery of low-carb nutrition thinking that all he had to do was explain the science to people and people would see it like him and they'd say, oh, okay, haven't I been a silly Billy? I've been wrong. I've been looking at it the wrong way. Okay, time to now move ahead. This is what the science is showing. But what he actually found was that the amount of evidence you need to present to overturn a belief is many orders of magnitude greater than what little thought bubble it took to form the belief in the first place.
Absolutely. Yeah. It really sums up the whole issue that we've got in nutrition, doesn't it?
Well, it is. It's informed by opinion and not by evidence.
And I think that's been one of the features of this weekend, the amount of evidence that has been presented that enables us to make a scientific and make a decision based on science rather than on anecdotes and so on. So yeah, it's been fascinating. I think it's been a really successful 2 days. So yeah, great weekend.
Yes, well, I think it's probably time to almost wind it up now. But look, it's I'm incredibly grateful for everybody who's actually donated their time, their effort, their intellect to actually participate. So we've been quite blessed with people from all around the globe. And as you know, we've got Carl Franklin in the background here producing it all and making it all work. So as much as we talk about the importance of sleep, I think we're making him do pretty much 48 hours straight. So Carl, we'll make it up to you, buddy.
Great job.
But yeah, I think, look, I do owe a special thanks to you, Peter. We have, both of us have spent a lot of time reviewing, spending time on the conference, Q&A panels, so on and so forth. You have been absolutely instrumental in helping pull this conference together. So I truly thank you.
No, I must admit I've enjoyed every minute of it. I've enjoyed all the talks and particularly our discussions. And while we're on a mutual admiration society, congratulations for putting this together. I mean, I think those of us who've worked on conferences know how much work it takes to put something like this together. It's not just a matter of writing out a program and sending out an email or two, but a huge effort. And I think you've been rewarded by a fantastic conference. So congratulations to you. Thanks to all the speakers, and thanks to all those who've given up their time to have a look. I hope you've enjoyed it.
Thanks, Peter. And I think with that, we'll sign off. Over and out.